Good morning to all. So we are going to discuss how to take psychiatric history. So we are covering the session in introduction, learning objectives, aim of the history taking, setting of the interview, duration of the interview, general principles of interviewing, elements of history taking and recording, techniques of history taking, and closing the interview. How to close the interview. So begin with introduction. So history taking in psychiatry is as similar as history taking in medicine, and it is somewhat different because psychopathology or pathology in the psychiatric examination is somewhat different, and it is similarly more or less like the history and examination done in the other subjects. So basically there are four types of professionals. One is biological and phenomenological oriented professionals who aim to discern the symptomatology, the psychopathology like delusions and hallucinations. Other one is cognitive behavioral approach, focus on identifying cognitive distortions and underlying assumptions or inference of the cognitive distortions. The professional with psychodynamically orientation uh, focus more on the indication of unconscious conflicts in the mind. Behaviorists investigate hidden patterns of anxiety and association between the stimuli. So, therapeutic listening necessitates an acute awareness of the narrator's perspective, along the capacity to harmonize the patient-centered approach with a focus on the disease. The learning objective of this session will be identifying the significance of history taking, the fundamental principles governing history taking, and diverse components of the history taking process, and various techniques and models of interviewing the patient. The preliminaries are: first one is the components of the psychiatric interview, like how to begin the interview, how to open the interview itself as a whole, and how to close the interview. So one skill which is required in psychiatric assessment is active listening, because most of the psychopathology is reflected in the speech of the person, which is reflection of the thinking in the mind of the patient. And doctor should monitor the content of interaction, what patient or doctor say to each other, the process of interaction, what the patient doctor may not say but clearly convey in many other ways, like non-verbal communication. So assessor should be sensitive to the effects of patient background, the culture of the patient, the environment of the patient, and psychology of the patient. The more that doctors understand themselves, the more secure they feel, and the better able they are to modify destructive attitudes. Increased flexibilities in communication or assessing leads to responsiveness to a subtle interplay between doctor and patient, and it increases the tolerance in the incidence of uncertainty which may come across through the assessment of the patient. So what are the aim of history taking? Aim of history taking primarily is the making a diagnosis which is based on the criteria, and this follows the identifying and labeling the patient's problem, predicting the course of the illness, how the illness will progress in the meantime, and the prognosis or outcome of the illness, whether it will be bad or good, ensuing the treatment decision on the basis of assessment and on the basis of diagnosis. So actually a psychiatric interview is about assessing the biopsychosocial aspects of the patient, which means the biological aspects, the psyche of the patient, and about the social environment in which the patient is living. So in first interview, the you can say that first impression is the last impression. So first session of the interview should be like that. uh, it will uh, it will make a good image or get good image of patient physician relationship, and which can greatly affect the effectiveness of the treatment outcomes. Now we will talk about the setting of the assessment. The setting can be a psychiatric inpatient unit, medical or surgical inpatient unit when you will get the referral from medicine or surgical side. Emergency rooms, outpatient departments, etc. can be the setting. So For an ideal interview room, this should be a somewhat relatively soundproof room, and furnishings and the decor should be pleasant and not distracting to the patient, so a smooth interview and assessment can be followed. Interviewer's chair and patient's chair be of relatively equal height, so one can communicate effectively with each other. The two should be seated approximately 4 to 6 feet apart, and there should not be any desks between the assessor and the assessee. So the desk between two can act as a psychological barrier, so desk should be not there or should be removed. The therapist should dress professionally and be well groomed. Distractions should be kept minimum, like no telephone or beeper interruptions should be there. And if any call comes in between the interview or assessment, one can ask the patient to take the call. So the thing should be set as such that the time has been set aside just for the patient, and it is the only his privilege to get your time. Now, duration of the assessment. An interview is an ongoing process, it is not cross-sectional process. The assessment may go on to the further 2 to 3 sessions for initial making a diagnosis or establishing a management plan. So the typically initial interview lasts between 45 to 90 minutes, and in case of medically compromised patients and acutely disturbed or hostile or violent patient, the duration can be reduced to 20 to 30 minutes or even less to implement the management plan early to curb the problem. Clinicians must acknowledge that the history gathering during these interviews is seldom complete or entirely accurate. So it's an ongoing process. The remaining information can be gathered in further sessions, and even the diagnosis has been made. The further follow-ups is also require a mini school assessment or assessment of the progress of the illness and outcome of the illness, and how the things are going. So now coming to the general principles of assessment. So first of all, you have to introduce yourself and greet the patient by name. Reassure privacy and confidentiality. Put the patient at ease, for example in L-shaped position, and there will be no intervening desk, not directly in front of each other. This means the one can both can sit in a 45-degree of angle, so there will be a space for silence, and the patient have to think of some situation, and they have to think on revealing the or going back into the memory to take the time. So direct eye to eye contact shouldn't be there. There should be a space for silence also. Suitable distance, as we have discussed earlier, will be uh, maintained, and in case of geriatric patient, this can be the distance can be less also, because the geriatric patient are somewhat they have sensory deprivation. They may be using hearing aid or visual aid, so one can have a less distance, and in case of aggressive patient the distance can be increased, for example up to the 15 to 20 feet of distance. Be supportive to the patient, be attentive to the patient, and be non-judgmental and encouraging. Judgment may be verbal or non-verbal. Explain the purpose of the interview and expected time is what the expected time is needed for the assessment. Observe the patient's non-verbal behavior and avoid excessive note taking. For example, in case of persecutory delusion, the patient may become apprehensive in such circumstances because of their delusional belief. They may think that the excessive note taking is against them, and they may become guarded or may not come up with their problems openly. So next point is with whom you will start the interview, like the patient or the relative, and if both are the informant or any of one is informant, the source of information should be mentioned in the summary, and rate the adequacy of the obtained information. If the obtained information is adequate enough to make a diagnosis or management plan, and if needed, opine on the need of more details in further sessions. Determine the reliability of the informant. How reliable are the informant? We will discuss later in next slides. One question is, why did they come with a relative? And this may indicative of some sort of illnesses which may be psychotic. In case of psychosis, insight is absent, so most of the patients come with their relative. And in case of neurosis also, they may come as a social support. Start with the open-ended question, then be more specific. Open-ended questions are like if you ask a patient regarding the breakfast he had in the morning, this will give a very less sorts of words, and patient be reply in a one or two or words or sentence. And if you ask the routine of the patient, daily routine of the patient of the day, then this will be more fruitful, and then this will give more comprehensive answer. So you can make out if the patient is having coherency or irrelevancy in the speech or not. Closed-ended questions are required when time is lacking or a specific piece of information needs to be obtained. Consent for the interview. Do take the consent for the interview, and it is an essential part. Privacy and confidentiality is also important. It should be indicated at the beginning that the things will be private and confidential, except for the situation where it is needed, like in forensic examination and disability evaluations. These are less confidential. If a person intends to harm another person or themselves, this is also have to report to the appropriate authorities and to warn the potential victim. So these type of information and evaluation are less confidential. If you are interviewing the patient alone and he had come with family members, then the things can be discussed with both the patients and family member after the patient's consent has been obtained. Fully informed about the recording. If you are doing a video recording or audio recording, they should be fully informed and how the recording will be used in the future. Patients should be informed of the use of one-way mirror. In some scenario, one-way mirror room is used to teach the trainees how to proceed with the assessment and interview. In such a situation, one should inform that we are going to use the one-way mirror room, and you will be observed by the trainees. In general principles of assessment, respect and consideration is also a very important aspect. Do respect the patient, and they should be treated with respect, and one should be considerate of the circumstances. The patient may come with various circumstances like non-compliance and long-standing psychiatric illness. So considerate, one may feel offended, so be considerate for the circumstances, and do not get bothered or offended with the situation. And try to reduce the stigma. You very well know that psychiatric illness have a stigma in the society. One should attempt to decrease the distress because of the stigma. Rapport and empathy is also important. Rapport can be defined as harmonious responsiveness of the physician to the patient and the patient to the physician. So this is a bi-directional communication which is harmonious between the two. If you are asking the question and patient cooperating and responding appropriately in interview and in examination also, so a good rapport reveals the good outcome, and it is the making of the diagnosis will be easier. So a whole psychiatric interview should be patient-centered, which means the patient's early life experiences, his family, his education, occupations, his religious beliefs and practices, and hobbies, relationships with each other, and even the losses should be taken in consideration. Genetic and biological variables are also important. So patient should be seen as a whole, not as the patient is having psychiatric problem or he is having only psychopathology. So to develop rapport, one can exercise 6 strategy to develop a good rapport. Like first one is putting patient at ease and pacify the patient for what we are here. We are here to help and we are here to solve the problem. Finding patient's pain and expressing compassion is also helps in developing good rapport. Evaluating patient's insight and become an ally. Showing expertise to an extent is also good in developing rapport. Establishing authority as a physician or a therapist. Balancing the roles of empathetic listener, expert and authority. So do not become a total empathetic listener or totally expert or totally an authority. Balance the role of all these aspects of your assessment. Do take care of the safety and comfort. Both the patient and the interviewer must feel physically safe, and in case of hostile and violent patient, the assessor should take care of himself or herself also, and for the safety of the patient also and the environment. While doing assessment of psychiatric patient, have a clear obstacle-free exit path. In such a situation of hostility, one can flee and ask for the help. Psychotic or confused patient may feel threatened and needed to be reassured that we are not the threatening person. We are here to help them. In case the things goes beyond the boundaries, one can terminate the interview if the patient becomes more agitated and threatening. So two terminologies also used during the assessment, which is known as transference and counter-transference. The transference is the feeling which the patient have towards the physician, which for which he is having for the another person in his life. For example, if the person is having a good image of father, then that image can be thoughted upon the physician. Or this transference can be negative or positive, both. One can have a good image of the assessor, one can have a negative image of the assessor in case of uh, delusional delusional thinking. One can see the assessor as a threatened person. Counter transference is something which the emotional reaction to the patient from the doctor side. So doctors can also have a transference like feeling, which is called as counter transference, and most of the time these counter transference are negative in case of the doctor's view. So when you feel like developing counter transference with the patient, and it goes beyond and cannot be tackled upon, so one can shift the patient to the another therapist or another assessor to look upon the situation. So there are four models of doctor-patient relationship. One is the mutual participation model, which is known as the best model, and it is most appropriate model for chronic diseases. In this model, treating physician and patient are responsible for therapeutic process. Though, so they both of them are agreed upon the therapeutic process and the management plan. The active passive model is treating physician is responsible of the therapeutic process regardless of the patient cooperation, and this is most appropriate method for the emergency situation. The guidance cooperation model is like teacher student relationship, parent child model. In this model, treating physician is responsible of the therapeutic process and the patient cooperates totally with the therapist. So decision may not be satisfactory to both the parties in this model. This is the most commonly used method in medical practice, in which the patients are totally dependent on the therapist for all the doings, like uh, the choosing the drug and all. The fourth one is friendship model. In it is also called a socially intimate model, and in this model may arouse the boundary issues between the therapist uh, and the patient. Now talking about the interview skills and techniques. Some techniques are used in interviewing, which are which facilitates the interview, and the things goes in a good manner. So one is reflection, and in reflection, a doctor repeats to a patient in a supportive manner something that the patient has said. So the doctor repeats the word of the patient, what the complaints he is coming with. So this is the reflection. Facilitation: doctor helps patient continue the interview by providing both verbal and non-verbal cues. So this is facilitation. So interviews is facilitated by the verbal and non-verbal cues like head nodding and uh, giving agreement voice. Silence and empathy. Silence is also important. We have already discussed the sympathy and empathy. Sympathy is emotional acknowledgement of the other people's distress, and empathy is emotional acknowledgement plus understanding the reasoning behind the distress. So what the basic difference is: sympathy is somewhat the situation in which for example, a patient has lost financially, but uh, the therapist can have sympathy because he has lost, but he has not experienced that loss. The therapist has not experienced that loss. In empathy, empathy is the emotional acknowledgement when the therapist had also experienced such a situation for which the patient requires empathy, like loss of father. So if the therapist lost his father and the patient is talking about losing his father in the assessment, so the if the assessor has the sympathy, this is called as empathy actually. Confrontation mean to point out patient something that the doctor thinks the patient is not paying attention to, is missing, or is in some way denying. So if the patient is not attentive towards some sort of information, so one can confront to gather that information, or if any information is missing or the patient is denying about some uh, problem in the life, like drinking pattern of alcohol, the amount of alcohol, usually they deny that much of amount of alcohol consumption. So one can confront to gather the real situation. Clarification is attempt to get details from the patient about what they have already said, and attempt should be made to clarify the vagueness of the chief complaint. So clarification can be sought if the things are not clear, or vagueness of the chief complaints. Interpretation is most often used when doctor states something about a patient's behavior or thinking that a patient may not be aware of. So interpretation can be made out of the conversation, so for which the patient is not aware of. One therapist can or assessor can interpret the situation by circumstantial evidences or otherwise. Summation is periodic summarization of what a patient has said thus far. So in total interview, in the intervening period, one can summarize or summate the discussion they had till that time. So this is called as summation. Explanation is explanation of treatment plans to the patient in easy understandable language and allow patients to respond and ask questions. So explanation should be provided if question has been asked from the patient side. Transition is transition from one topic to another, is also a part of interview skill, and it describes a transition across different areas of history structure, and the transition should be smooth and non-interrupted. For example, you are going from history of present illness to past illness, so transition of conversation from history of present illness to past illness should be smooth and non-interruptive. Self-revelation: limited, discreet self-disclosure by physician may be useful in certain situations, and physicians should feel at ease and should communicate a sense of self-comfort. Though the placement of boundaries is still pivotal, so limited information of self should be revealed and can be, or if some aspect is being correlated with their self life, should be in a limited fashion. Reassurance and advice is also important. Reassure the patient about the beneficial effect of the management and treatment, and advice obviously be given. There are some obstructive techniques, those techniques which can hinder your assessment, and the things may not clearly expressed by the patient. So what are those obstructive techniques of interview skills are? The excessive use of closed-ended question. So do not use closed-ended question, as we have already discussed that closed-ended question will lead to a smaller form of answer and will not give a big and a vast picture of the situation. For example, do you have friends? This will give only one answer. Compound questions, do not mix more questions in one go, like how did you feel, what did you do, or what your father does. So do not ask in a one go. Excessive why questions are also not important and can create obstructions in the assessment, and more information cannot be gathered. So why question should be avoided. Judgmental question, that like do you know that yelling only make matters worse. So don't make judgmental questions which may hinder the assessment progression. Minimize patient concern. Minimizing patient concern. So patient having panic attack may think that this attack is related to myocardial infarction, or he might be having a heart attack, and he is very concerned with that panicky situation. And as a therapist and as a expertise, we know that the panic attack is not a situation, lethal situation. So, but patient concerns is not, cannot be minimized. Patient have the concern, you have to give the importance to the symptomatology. Premature advice is also a hindrance in assessment. Do not give premature advice before knowing the situation in detail. Premature interpretations are also like that, making interpretation before knowing all the aspects of that pathology or that situation. Do not interpret in between the assessment. Abrupt transition is also not advisable. Ambiguous non-verbal communication, like looking at your watch, turning away from the patient, yawning, refreshing the computer, and other things should be uh, uh, removed from the assessment part. Elements of history taking and recording. Now we will discuss the structure of history taking, the subheadings under which the history is to be recorded and to be taken. So first is the identifying data. Identifying data includes the patient name, age, gender, his education, occupation, and marital status, race or ethnicity, socioeconomic status, and area of residence. Source of referral should also be coded. Like a source of referral also indicate many things, like if the patient came alone, the probability of neurotic illness is more. If the patient is coming with the relatives and too many relatives, may indicate the violent situation, or the patient is having psychotic illness. And if the police personnel or authorities are coming with the patient, this may show that the patient might maybe coming for forensic assessment or disability assessment. So source of referral is also important part of the assessment. The source and the reliability. Source of information should be recorded if the source of information is more than one person, then all the source to be recorded, like patient, relatives, authorities, notes of the patient, diary of the patient should also be coded. And reliability of those sources should be indicated in the case sheets, like coherency of the person who is depicting the history, how consistent he is in uh, his statements, whether he is caring or not to the patient. Adequacy of information should also be noted, and whether the person is living with the patient or not is also important. Now coming to the chief complaints. This should be patient's complaint, and ideally in their own words, in their own verbatim. For example, I am sad, neighbors are trying to harm me. The question should be asked like, what brought you in to see me today? This is a open-ended question, and this will give more information, more uninterpreted information. And another example is, tell me about the issues you have been experiencing. This will also to elicit the chief complaints. in our setup, the common chief complaints in OPD settings are like मन उदास रहता है, नींद नहीं आती है, घबराहट बेचैनी रहती है, नशा संबंधी शिकायतें हो सकती हैं. In case of maniac patient, the chief complaints be like ज़्यादा बोलता है, बड़ी बड़ी बातें करना, गुस्सा करता है, ज़्यादा एक्टिव रहता है. In case of obsessive compulsive disorder, it may be like बार बार हाथ धोना, लॉक चेक करना. In case of psychotic illness like schizophrenia, the complaints may be of suspiciousness, शक करता है, नहाता धोता नहीं है, या अपने में ही रहता है, या बाहर बिना मकसद के घूमता रहता है, बड़बड़ाना, अपने आप से मुस्कुराना. So all these chief complaints are common chief complaints in OPD settings. In emergency setting, in a study, this has been found that suicidal ideation and attempt were in the case of 39% of psychiatric patient, psychotic symptoms in 14% patient, substance abuse in 12%, behavioral issues in 10% patients, depression in 10% patients, anxiety were the complaints in 9% patients, and medical problem in psychiatrically ill patients were in the 4%, and homicidal ideations in 0.4%. So while assessing the history, or while taking the history of present illness, one should consider few points in the mind, which we will discuss in next two slides. Is the narrative should encompass the progression of symptoms observed in the current episode only. One should not consider the past illness or the incident which happens far away before the illness to be considered in current episode. There should be temporal correlation between the precipitating factor also, which should be the part of the current episode, and one should talk about the current episode for all the things in chronological manner, and one should record the nature, onset, severity, and the progression of the symptoms in the timeline history. Furthermore, any change in the interpersonal relationship between family members, behaviors of the others and the patient, if any change in the personal habits of the patient, if there is any change in the physical health of the patient due to the psychiatric illness, biological functions like sleep, appetite, sexual functions should also be recorded, and the degree of socio-occupational impairment due to the illness. Additionally, absence or presence of stressor should be recorded, which may encompass circumstances related to home, related to work, educational settings, legal challenges, medical comorbidities, and interpersonal conflicts. Equally significant are the factors that may mitigate or intensify the symptoms, such as pharmacological treatment. If the patient is on treatment from another psychiatrist for the last few months or few weeks, and he came now to you, and the symptoms may be diminished because of the pharmacological treatment, this should also be taken into account. Social support can also intensify or dilute the symptomatology, like good social support. In case of good social support, symptoms are not that much intensified, and maybe intensified in case of poor social support. Coping mechanisms of the person is also important to to give weight to the symptoms intensity. Variations throughout the day in the symptoms also taken in the account. If we are doing the evening clinics, the morning worsening of symptom in case of depression would not be seen in the evening time. So this part is also important. One thing is, ascertain the reason behind the current consultation. The patient may be consulting because of some sort of reasons, like if he is not getting well, or he is having certain kind of side effects because of the previous treatment, or because of the poor financial condition. He may come to you, he cannot afford the private institution because of the financial reason. So reason may be more than one, or maybe many, so should be recorded. Identify the precipitating and maintaining factor in the illness. Precipitating factor which precipitates the illness, like stressor, maybe a financial loss or loss of loved ones, and it may be a substance abuse also. In maintaining factors which maintains the symptoms and hinders the outcome of the treatment or management plan, which maintaining the illness, like interpersonal conflicts, like substance abuse, should also be noted. Any treatments administered in the current episode, if the person was in follow up some another therapist, so nature of intervention should also be recorded, and specific modalities employed should also be recorded, like whether the patient was treated by means of drugs, by means of psychotherapies, or by means of electroconvulsive therapy. So specific modalities should also be noted. Evaluate the adequacy of these treatments. These treatments should was given in adequate amount or adequate period of time should be noted to label the patient as a treatment resistant or not. Incorporating a psychiatric review of system which which enlists a series of symptoms of various psychiatric disorders that can be also screened upon the review system of psychiatry. Furthermore, documenting a negative history is also important. In negative history, what we do is, if the person is having certain sort of symptoms, like symptoms of psychosis, like delusions, hallucinations, and oddities in behavior, so these set of symptoms may be found in other psychiatric illnesses also, like pervasive developmental disorder or other non-organic psychotic disorder. So one has to take the history, negative history of related symptom which may be found in other illnesses first, and secondly, rule out all other psychiatric diagnoses, like obsessive compulsive disorder, depressive disorder, if the person is having manic features. So one can have the schizoaffective disorder instead of schizophrenia. So related disorder are also checked. The third one is neurological disorder. If the person is having any sort of um, seizure disorder or having any sort of head injury in in the current episode, and like. Furthermore, document the history of medical illnesses in the current episode, like diabetes, thyroid dysfunctions, tuberculosis, preceding history of fever, and so on. So common psychopathology which one will find in the history of present illness may be suspiciousness, hearing of voices, visualization of things which are not there, withdrawn behavior, apathy in case of psychotic illness, low mood, easy fatigue, lethargy, anhedonia means lack of interest in all the pleasurable activities, poor concentration, suicidal tendencies in case of depressive episode, over talkativeness, expensive behavior, hyper religious activities, reckless behavior, repetitive behavior in case of obsessive compulsive disorder, anxiety and panic in case of anxiety related disorders, intellectual deficits, socially deviant behavior in case of personality disorders, hyperactivity in attention in case of attention deficit hyperactivity disorder, whether it is adult ADHD or childhood ADHD, qualitative behavioral impairments in case of pervasive developmental disorders should also be taken into account. So one can see that all these things can happen with a normal person also, like sad mood or some withdrawn behavior for some time, lack of interest for a shorter period of time, hyper religious activity for a shorter period of time. One can have anxiety to a actual situation. So these behavior can be found in a normal people also, because we are not devoid of emotions, we are not devoid of behaviors, we are not uh, devoid of anxiety. So establishing a behavior as a psychopathology needs some qualities and requirements, which can be the thing should be in excessive amount. If someone is having anxiety, that should be excessive, uh, that should be long lasting, that should be for the most of the time, for the last few weeks, and that should be uh, irrational to the situation, like anxiety because of no reason, depressed mood because of no reason. So these features defines the psychopathology. It should be distressing to the patient, it should impairing in occupational or other aspect of life like sexual performance. In case of delusion, the thinking should be false. One have to prove false. The thing is false. This is non-correctable. It is not in the context of socio-cultural background and not in the context of intellect of the patient. In case of hallucination, this should be without external stimulus, and the things are not in the influence of the substance. In case of substance intoxication, the picture may be of a psychiatric disorder or psychiatric illness. So one should explore symptoms by in keeping in mind these points, that these points should be fulfilled to say the behavior or thinking as a psychopathology. Now coming to the past psychiatric illness, all the psychiatric illness in the past should be recorded, and their treatment, whether the treatment was taken on OPD basis or whether the patient was hospitalized, and what was the situation which precipitated the need for hospitalization, support groups were present or not, other form of treatment such as vocational training, occupational therapies were implemented or not, psychotherapies were implemented or not. Medication and other modalities such as electroconvulsive therapy or alternative treatment should also be carefully reviewed. And one should explore what was tried, the molecule which was tried, whether it was SSRI, SNRI, first generation antipsychotics, second generation antipsychotics, how long was the treatment given, and what doses these were used in past psychiatric episode. Also note why these were stopped. If in case of non-compliance, why were the treatment was stopped, either by the patient himself or the family himself or by the therapist. The response to the medication should also be noted, and modality already said. Whether there were any side effects of the drug which need to be keep in mind for in the management of current episode, or it may be a cause of non-compliance. So other reason for non-compliance should also be noted. If the patient was suicidal and having suicidal or self-harming tendencies, so lethality history should also be taken into account of the past episode, like past suicidal ideations, intent of these thoughts, whether the patient was having any plan or not, attempt were done should be reviewed, including the nature of attempts, perceived lethality of the attempts, or other death preparations like buying ropes, buying poisons, or collecting other things to for by virtue of which the patient may harm himself. Violence and homicidal history should also include any violent action or intent. History of non-suicidal self-injurious behavior should also be recorded, like parasuicidal behavior. Now come to the past medical history. So past medical history is also important part of assessment, which is not the part of as we have discussed in the negative history, that negative medical history. So past medical history may be a potential cause of mental illness, like long-standing diabetes or more co-occur with the depression, and that medical history may pose as a comorbid or confounding factor. This may confound the symptomatology. So and the past medical history also may dictate potential treatment options or limitations. If the patient having the history of diabetes, so one should take care of metabolic syndrome, the drugs should be used which do not cause the metabolic syndrome, and like the past medical history may precipitate a psychiatric disorder like recently diagnosed HIV, may precipitate depression. Hyperthyroidism may present as anxiety disorder, and the metabolic syndrome as we have discussed. In the past medical history, major medical and surgical illnesses and conditions as well as treatments, both past and present, should be recorded. Reaction to these illness and coping skills used during the past episodes should also we noted it is important to pay special attention to the neurological illnesses like seizures, head injury, and pain disorders. Non-psychotropic medications like over-the-counter medications, sleeping aids, sleeping pills, herbal medications, alternative medications should also be reviewed in past medical history. Now come to the family history. Many psychiatric illnesses are familiar and the genetic load should be taken into note. How much is the genetic loading? Psychiatric diagnosis, medications, hospitalization, substance use disorder and lethality history, if they are in the family, should be covered. There appear to be a familiar response to medication. The family history is also important, that the familiar response of medication is seen. For example, if one drug is effective in the family person for the same illness, may be similarly effective in the your patient also. A family history of suicide is a significant risk factor for the suicidal behavior in the patient itself, so it's also be ruled out and asked in the family if someone is having history of self-harming behavior or committed suicide. Family traditions, belief, expectations may also play a significant role in development, expression and course of the illness. So tradition, beliefs and expectation is also an important part of assessment. Also, the family history is important in identifying potential support as well as stressful situation in the patient's life. If the person is having a good family support, then it's a good prognostic factor. If the someone is having interpersonal conflicts with the patient, and that should be addressed to find the better management. Parents' age, consanguinity, illness, and if the patient died, mention the age and cause of the death should be noted, and patient's age at that time of the death of the parent should also be identified. Psychiatric illnesses in other first and second degree relatives like siblings, grandparents, uncles, aunts, nephews, and nieces should also be taken into account for making the genetic load. Positive history of psychiatric illness, drug abuse, homicide, suicide, substance abuse is also important in the management of the patient and should be noted. Relationship, if any interpersonal conflict with the family member or cordial relationship between the family members should also be clear cut and defined. So after of history of present illness, past illness, medical history and family history, now coming to the personal history. The personal history examines the various phases of the patient's life and starts with the early childhood, and then the history of middle childhood, then the later childhood and adulthood. Now we will discuss the various aspects of personal history in the detail. The early childhood. The early childhood history comprises of prenatal history and mother's pregnancy and delivery. So point to be noted are length of the pregnancy, spontaneity and normality of the delivery, if any history of birth trauma, whether patient was planned or wanted, and the history of birth defects. Feeding habit, breastfed or bottle fed, if any sort of eating problems at this time. Early development like maternal deprivation in case, language development, motor development, signs of unmet needs, the sleeping pattern of the newborn uh, child, object constancy, if the patient has developed object constancy or not, strangers anxiety, separation anxiety, toilet training has been done or not, at what age it was started, attitude of the parents, feelings about it. Symptoms of behavioral problem like thumb sucking, temper tantrums, tics, head bumping, rocking, night terrors, fears, bed wetting, bed soiling, nail biting, and masturbatory habits should also be noted. Personality and temperament as a child, whether a child was shy, was restless, overactive, withdrawn, studious, outgoing, was timid, athletic, friendly patterns of the play, of the patient at this age. Reactions to the siblings is also noted in the personal history of early childhood. In the middle childhood, early school history is important. Feeling about going to school, early adjustment to the school, sex identification, and this may lead to sexual identification like gender identity disorder, and conscience development, punishments at school, and attitude towards it, social relationship with the peer group, attitude towards the siblings and playmates. In later childhood, peer relations should be noted. The number of friends, closeness to the friend, he was leader or follower, social popularity of the patient at that time, participation in group or gang activities, idealized figure at that time, patterns of aggression, passivity, anxiety, or any kind of antisocial behavior. In school history, how far the school from the home of the patient, adjustment to the school, and the relationship with the teachers. Favorite studies or interest should be noted. Particular abilities or assets should also be noted. Extracurricular activities in which the patient was appearing or participating in the extracurricular activities. Sports, hobbies, relationship of problem and symptoms to any school period should also be considered. Cognitive and motor development, learning to read and other intellectual and motor skills, if the patient is having any difficulty, or the patient has extra classes are needed or extra time was needed to learning to read or other intellectual activities. Minimal cerebral dysfunctions, learning disabilities and their management was done at that time, and the effect of these management on the children development. Particular adolescence emotional or physical problem at that time like nightmares, phobias, masturbation, bedwetting, running away from the school, delinquency, smoking, drug and alcohol use, weight problems, feeling of inferiority are also important. Religious background like strict, it was strict religious background, liberal or mixed type of religious background with possible conflicts. Relation of the background to the current religious practice should be compared. In the later childhood, psychosexual history should be noted like early curiosity, infantile masturbation, sexual play with the peer group, acquiring of the sexual knowledge, attitudes of parents towards sex, any kind of sexual abuse if taken place, onset of puberty, feelings about it, kind of preparation for the puberty, feelings about menstruation, development of secondary sexual characteristics, adolescent sexual activities like crushes, parties, dating, petting, masturbation, wet dreams, and attitude towards them should be noted. Attitude towards some same and opposite sex, like the patient was timid, shy, or aggressive, need to impress, was seductive, or sexual conquest should be noted. If any kind of anxiety towards the same or opposite sex should also be noted. Sexual practices like sexual problems, homosexual and heterosexual experiences, paraphilias, and promiscuity is important. In adulthood, occupational history, consider the choice of occupation, training, ambitions, conflicts, relations with authority, peers and subordinates, number of jobs and duration of jobs, change in job status, current job and feeling about it is important. Social activity, whether patient has friends or not, is patient withdrawn or socializing well, social, intellectual and physical interest of the patient, relationship with the same sex and opposite sex, depth and duration and the quality of human relationship should be considered in social activity. If the patient is from military background, then general adjustment to the duties, combat, injuries if having any, referral to the psychiatrist, the reason, type of discharge from the services, the veteran status, etc. should be noted. The value systems, whether children are seen as a burden or a joy, whether work is seen as a necessary evil or an avoidable chore or an opportunity, current attitude about the religion, belief in heaven and hell are important to know about the patient's personal history. In adulthood, now coming to the adult sexuality, premarital sexual relationships, age of first coitus, sexual orientation, marital history in terms of common law marriage, legal marriages, description of courtship or role played by each partner, age at the marriage, any case of family planning and contraception, name and ages of the children, attitude towards raising children, problem of any family members, housing difficulties, if important to marriage, sexual adjustments, extramarital affairs, areas of agreement and disagreement, management of money, and role of in-laws in the family should be noted. Sexual symptoms like of sexual psychosexual disorder like anorgasmia, impotence, premature ejaculation, lack of desire should be taken into account. If these are there, should be managed accordingly. Attitudes towards pregnancy and having children, contraceptive practices and feeling about them is to be noted. Sexual practices like paraphilias, coital coital techniques and frequencies should be noted in adult sexuality. Now coming to the pre-morbid personality. Pre-morbid personality is the personality which was present before the onset of illness. The behavior, the traits were present before the onset of illness, to compare with the change in the behavioral pattern during the current episode. So the things which should be look in the pre-morbid personality are prevailing mood, social skills, hobbies, impulsivity, for example in relationship, in decision making, in eating and in sexual behaviors. It is often marked by the follow of sensation of regret or not, the feeling of guilt was there or not. Planned actions like drifting, criminality and serial killing are not a impulsive behavior, so should not be considered. Coping mechanism in the life, attitude to self like self appraisal, performance, satisfaction with the life, past satisfaction with past achievements, and dealing with the past achievements and failures, and what is the view of future. Moral and religious attitudes and standards present pre-morbidly. Prevailing mood and emotions, reactions to stress, ability to tolerate frustration and disappointments, pattern of coping strategies in the pre-morbid period, personal interest, habits, hobbies and leisure activities, and interpersonal relationships before the onset of illness. And more is the and one more point is the fantasy life. If the patient is having history of substance abuse, substance use and abuse or addictions should be noted carefully, and the points should be noted in terms of reason for start, perpetuating factors, if there is there any temporal correlation with the current psychiatric illness, routes of use, oral or intravenous. If the route is intravenous in management part, do look for the HIV infection or hepatitis B infection in case the syringes are shared by the peer group. The frequency and amount of the use, history of quit in the past, whether it was supported or unsupported, whether it was done or managed on the basis of OPD or in the IPD, and what about the withdrawal symptoms in the previous period of abstinence. Road traffic accidents if occur any due in the influence of substance, legal issues due to substance use, or any kind of medical problems like hepatic failure or something else in and substance to substance basis. Now come to the closing of interview. The closing of interview, the last 5 to 10 minutes of the interview are very important, and patient often keep important issues or question until the end of the interview, or having at least a brief time to identify the issue is helpful. So if there is there is to be another session, that should be apprised to the patient. We will talk more in the next sessions to assess and for the evaluation. And opportunity to ask a question should also be given to the patient if anything has been missed or not looked upon. If the interview was to be a single evaluation session, then a summary of the diagnosis and options for the treatment should generally be shared with the patient. If it is a not a single session, the patient will be seen again, then the professionals may indicate that they can work further on the treatment plan in the next session. So last of the interview, part of the interview is the closing of the interview. It should be closed swiftly. Now, summary of this session is we have learned about the general principles of interviewing, models of interview. We learned about the techniques of interview and the hurdles in the interviewing assessment, the demographic profile in history taking, the chief complaints, history of present illness, including the negative history, history of past illness, history of medical illness, family history, personal history, pre-morbid personality, history of substance use, if any, and closing the assessment. Thank you. Good afternoon to all of you. We are going to learn about the mental status examination for psychiatric illnesses. In introduction, mental state examination is a cross-sectional examination at one point of time. It is systemic documentation of quality of mental functioning at the time of assessment or interview. It is just equivalent of physical examination in medicine. Psychiatric examination, which is mental status examination, is somewhat different, and physical examination as well equally important in the psychiatric patient to rule out any organicity or other comorbid physical illnesses. It serves as a baseline for future comparison and to follow the progress of the patient. It's an observation of patient's feeling, thoughts, perception, and behavior during the interview. Grossly, mental status examination is divided into the following parts. One is general appearance and behavior, consciousness and orientation, attention and concentration, affect, speech, thinking, perception, memory, intelligence, judgment, and insight. Few school of thoughts combine the speech and thinking, and they think that the speech is the reflection of what the thought is going into the mind. But speech has different dimensions also. Some keeps it separate. In general appearance, we used to look for approach, whether the patient is voluntarily approaching or involuntary. The voluntary approach signifies something. It is more towards of neurotic illness, and involuntary approach in case of psychotic patient. One should look for gait, whether the patient greeted or not greeted the examiner. This also signifies the some sort of neurotic and psychotic illness. Body build is defined as ectomorphic, mesomorphic, endomorphic build or cachexia build in case of severe physical illness. Grooming includes self-care, including personal hygiene regarding the clothes, hair, and nails. Postures, gestures, facial expression during the interview is also noted. Any abnormal movements we will discuss further in the detail regarding all the aspects of general appearance. The type of eye contact, signs of chronicity like weight loss, state appropriateness, signs of substance abuse, signs of physical harm, and other signs like eroding of tooth enamel in case of bulimic patients, attitude of the patient, psychomotor activity, and whether the rapport has established or not. In gait abnormalities, we have lots of gait abnormalities. We will discuss one by one. First is antalgic gait. The antalgic gait is gait that develops usually to avoid the pain while walking. Antalgic gait may occur if the patient is protecting an injury to foot, ankle, knee, hips, or pelvis. Usually, the stance phase on the affected leg is shorter. Because the patient attempts to remove affected leg from weight bearing, therefore note and compare stance phase of the two legs. Decrease walking velocity. Observe if the hand is supporting the painful area. This is antalgic gait. In ectatic gait, the abnormal gait is due to poor sensation or lack of muscle coordination. Ataxia is a neurological sign consisting of lack of voluntary coordination of the muscles and usually found in the lesion of cerebellum, impairment in cerebellar function, and it may be due to drinking alcohol. The patient's gait lacks balance, may appear irregular, jerky, weaving, and staggering. Parkinsonian gait, it has short steps, wide base of support, steps are shuffling. It is also known as fascinating gait and is the type of gait exhibited by patients suffering from Parkinson's disease. And it looks like the patient is trying to catch the center of gravity of own body. The steps are short and the patient is unable to control the inertia of movement. Caesar's gait, one leg is crossed in front of other like walking on the catwalk. It is due to spasticity in the thigh adductors. Caesar gait is form of gait abnormality primarily associated with spastic cerebral palsy. That condition and other like are associated with an upper motor neuron lesion. Hemiplegic gait, it is due to cerebrovascular accidents and it is unilateral. On the affected side, one would see internal rotation of the shoulder, flexion of the elbow and the wrist, flexion and adduction of the hip, flexion of the knee. Arms are flexed, adducted and internally rotated. Leg on the same side is in the extension with plantar flexion of the foot and toes. These are the other gait which is due to musculoskeletal system involvement and not due to the directly involvement of CNS. One is arthrogenic gait, stiff hip or knee or ankle due to stiffness, laxity or deformity. Trendelenburg's gait, this abnormal gait is due to gluteus medius weakness or paralysis. Lurching gait due to paralysis or weakness of the gluteus maximus. Psoatic limp gait due to psoas muscle spasm and or edematous and or inflamed psoas bursa. Contracture is found in lower limbs and it is due to pathology of nerve or joint, peripheral nerves and joint. Steppage gait is a high stepping gait. It is a neuropathic gait and abnormality characterized by foot drop due to loss of dorsiflexion. This is about the build. You can have an idea with the pictures, the kind of endomorphic build uh, and mesomorphic and ectomorphic build. Ectomorphic means somewhat lean and thin body. Mesomorphic is in between the endomorph and ectomorph. The observation of grooming includes observation of self-care, including hygiene regarding the clothes, whether kempt or unkempt, whether clean or dirty, hairs are kempt or unkempt, and regarding the nails, whether these are trimmed or not. But keep in mind the socio-cultural and economic status of the patient and the current weather of the. Facial expressions can be of surprise, fear, disgust, contempt, anger, sadness, and happiness. One should observe for the facial expression. Posture during the interview. Observing a patient's posture and gait can provide additional information about their mental and physical well-being. The posture can be closed, slouch, or open. Closed or slouch posture may indicate a lack of confidence or emotional distress. Looking for any signs of postural instability which may suggestive of any neurological illness or physical issues. These are the pictorial depiction of posture in case of depression. You can see one is having a stooped posture. In manic phase, the one is having upright posture with boastfulness. In mask-like faces, the facial expressions are minimal or there is no facial expression to the stimuli. In catatonia, awkward posturing is seen for many hours. The person can remain in one posture, which may be awkward. In gestures, gestures are movements or position of the body that express an idea, opinion, emotion, or intention. Gestures can be made with different parts of the body such as hand, arm, head, or face. Gestures can be used to help communicate, emphasize speech, or show attitude or sympathy. In the picture you can see the gestures of surprise, sadness, happiness, fear and anger. In hand gesture you can see the thumbs up gesture, the handshake, finger to lip, thumbs down gesture, clapping hands, pointing fingers, high five and peace sign. Observe for the gestures also. Now coming to the abnormal movements, these abnormal movements can be seen like ataxia we have already discussed, chorea, dystonia, functional movement disorders, multiple system atrophy, myoclonus, restless leg, tardive dyskinesia, tic, tremors, mannerism, stereotypies and catatonia. We will discuss one by one. The chorea cause brief, irregular, rapid, involuntary movements. The movements typically involve the face, mouth, trunk, arm, and legs. Chorea can look like exaggerated fidgeting and sometimes described as dancing. The most common genetic chorea is Huntington's disease. Dystonia involves involuntary muscle contraction that cause twisting, irregular postures, or movements that occur again and again. Dystonia may affect the entire body or one part of the body. If the entire body part is involved, opisthotonus may be seen. The most common type of dystonia in adult is cervical dystonia, which is around the neck. The neck muscle contracts involuntarily. This causes the head to pull to one side or to tilt forward or backward. The head may also shake, known as tremor. Functional movement disorder. This condition may look like any of the movement disorder, but it's not caused by neurological illness. Functional movement disorder are categorized under dissociative or conversion disorders, previously known as hysteria. Multiple system atrophy. When multiple systems are involved, uh, like cerebellar system, extrapyramidal system, and autonomic functions. This multiple system atrophy, also called as MSA, causes people to lose coordination and balance and become slow and stiff. It also causes changes in speech, loss of control of the other bodily functions, and it sometimes shares symptoms with Parkinson's disease. Myoclonus are very quick, jerky movements of the muscle. Progressive supranuclear palsy. It's a rare nervous condition that causes problem with walking, balance, and eye movements. There is loss of balance and falling backward tendencies. Neck stiffness is there. The patient may show difficulty in swallowing, difficulty with eye coordination and focus. Slow or slurred speech may be seen, and rigid facial muscles. Restless leg syndrome. This movement disorder causes aching, itching, or creeping feelings in the legs while relaxing or lying down. The feeling often goes away with the movement. It is also known as Willis-Ekbom disease, characterized by uncomfortable sensation that begin while resting, particularly when the patient is going to sleep. It is relieved with the movement. Worsening of symptoms are seen in the night time. Tardive dyskinesias. This condition is caused by long-term use of neuroleptic medications, which are antipsychotics, can also be caused by metoclopramide. Tardive dyskinesias cause involuntary movements that occur over and over. Symptom includes grimacing, eye blinking, and other movements. Now the tics, you can correlate with the movie Hitchcock. The tics are voluntary movements, but they are caused by an involuntary urge to make the movements. Tourette syndrome starts between childhood and teenage years, in which the tics are seen. The Tourette syndrome can be of various type on the basis of type of tic is present. It can be of simple motor tic type, simple vocal tic type, complex motor tics, or complex vocal tics type, or mixture of the motor and vocal symptoms. Tremors can be divided into the followings. Postural tremor. A postural tremor occurs when holding a position against gravity, such as keeping your arm or leg outstretched. Intentional tremor. An intentional tremor occurs during the targeted movement, such as touching your finger to your nose or picking up some object from the table or doing some task like eating food. Task-specific tremor occurs while performing tasks that require skills such as handwriting or playing an instrument. Kinetic tremor. A kinetic tremor occurs during voluntary movement of a body part such as moving your wrist up and down. Isometric tremor occurs when voluntary contract a muscle, you voluntarily contracts a muscle but don't otherwise move your muscle or limb, such as when you make a fist. So this is isometric tremor. Others are mannerisms. Mannerisms are repeated movements that appear to have some functional significance. For example, saluting. The saluting has a functional significance, but it is out of the context the patient is expressing this movement. Stereotypies are repeated movements that are regular and without obvious significance. Unlike mannerisms, for example, rocking to and fro. Rocking to and fro does not have any functional significance like mannerism, like saluting. Catatonia is a state of increased muscle tone that affects extension and flexion and is abolished by voluntary movements. So catatonic symptoms can be seen in catatonia or in the case of severe depression. Now come to the eye to eye contact. Eye to eye contact can be described as good, fleeting, avoided, intense, unwavering, no eye to eye contact, or sporadic eye to contact. Eye to eye contact. In other words, no eye to eye contact, which is intentional, which can be unintentional. Glance can be conscious or unconscious. Glance and a half, double glance, or the gaze. The signs of substance abuse may be observed in general appearance. The physical signs may be poor coordination, slurring of speech, shaking or tremors in the hands, dilated or constricted pupil, bad breath, rapid weight gain or loss, lack of concern for personal hygiene and appearance. In case of alcohol, one can see for icterus, spider nevi, uh, fetor hepaticus is peculiar odor in case of liver failure, palmar erythema, gynecomastia, clubbing of fingers, hepatomegaly, splenomegaly, or itching of the legs may be found in case of alcohol use disorder. Physical harm signs is also important during the assessment in case of child abuse or domestic violence, or in case of self-inflicting injury in case of bipolar disorder and suicide due to depression. In case of child, look for eyes, cheek, side of face, mouth, shoulder, genitals, knees, skull for injury fractures, ear for any kind of pinch or slap, neck for bruising, upper and inner arms for bruising and grasp marks. Similarly, chest, back, buttocks and thighs for the signs of abuse. In case of eating disorder, one should look for eroding of tooth or enamel due to induced vomiting by this patient after having a heavy meal or meal. So eroding of tooth may be seen in case of eating disorder. Now coming to the behaviors, both the quantitative and qualitative aspect should be noted. Level of activity should also be noted, which is known as psychomotor activities. Oddities in behavior like apathy, disinterest in interview, being guarded or suspicious, smiling without any reason, muttering to self, etc., if present, should be recorded. Attitude toward the examiner, whether the patient is cooperative, uncooperative, authoritative, guarded, evasive, or indifferent towards the examiner. Level of activity is also known as psychomotor activity. Psychomotor activity can be increased or decreased. In case of psychomotor agitation, where psychomotor activity is increased, the person is very restless and motor activity is increased too much. The patient talk rapidly and loudly and are often difficult to interrupt. It is often seen in psychosis like schizophrenia, mania, or delirium and agitated depression. The retardation is a very slow in response. The patient speaks slowly and walks slowly and may continue to sit in one posture. It is seen in depression in some case of schizophrenia. Now coming to the consciousness. Consciousness is a state of awareness of the self and the environment. Alertness is awareness of the environment. It can be observed as impaired attention span, clouding of consciousness, fluctuation in level of awareness in case of delirium, somnolence, stupor, lethargy, fugue state, or coma. The various conditions associated with altered consciousness can be dream, hallucinations, hypnotic state, during meditation, during sleep, and states induced by the psychoactive substance. Consciousness is a state of awareness of the self and environment. So, altered type of consciousness may include lethargy, confusion, delirium, stupor, and coma. Orientation is observed in the terms of time, place, and person, whether the patient identifies the day or the approximate date and the time of the day correctly. If in the if in a hospital, whether the patient knows how long he or she has been there, whether the patient behaves as though oriented to present. For place, whether the patient knows where he or she is, uh, the name of the building, the floor of the building, the city, state, and country can be asked in case of orientation of place. Orientation to person, whether patient knows who the examiner is and the roles or name of the person, relatives with whom the patient is in contact. So orientation is disturbed in case of delirium. Delirium is a constellation of symptoms due to any physical illness, and it is presented with or disorganized thinking, fluctuating mental state, acute mental status changes, inattention, psychomotor disturbances, acute disturbance in cognition. Now, attention and concentration. Attention refers to the capacity to focus our interest or consciousness on a specific aspect of objective world. Whether patient is responding correctly to the stimulus given by the examiner. This is judged by the digit span test. There is a series of random numbers are presented at the rate of 1 per second, and patient is asked to repeat the presented sequence with progressive increase in the difficulty. For example, examiner may ask, I am going to say some numbers, listen carefully, and when I am through say them right up, when I am said them, sorry. So examiner has to present the numbers in a sequential way and increasing manner, and the patient has to repeat those number current continuously in correct manner. So one have to see up to what number the patient can retain the attention. Concentration. This is the conscious effort of a subject to maintain attention on a specific stimuli over a sustained period. Now the patient is attentive and giving attention to your stimulus, and the patient remain attentive for a sustained period of time is concentration. Clinically, it is tested by serial subtraction test, The standard is 100 minus 7 test. One should start with 100 and counting backward by 7, or in case of lower education, one can go for minusing 3 from 100. One can ask to tell the alphabet in backward sequence starting with Z. Name of the months of the year backward starting with, for example, December, and in the sequence in backward fashion like December, November, October. Now, affect refers to emotional state as judged by external reaction like laughter, crying, anger, fear, and non-verbal behaviors. Affect is dynamic and transitory. It changes with the situation, thought process, and external environment. Mood, on the other hand, refers to a more pervasive and sustained emotional state that colors the person's perception of the world, and thus the affective response. The basic difference between affect and mood is affect is used in terms of shorter period of time or cross-sectional point of time, and mood is for the uh, longer period of time in life of the person. So it can be compared with weather and climate. Weather is for the immediate situation and climate is over the period of a year. So I will repeat this slide. Affect is the perceived emotional state observed by the examiner, which can be said as a sign. The type of affect are broad affect, flat affect, blunted, restricted, inappropriate, and labile. The intensity, the strength and conviction of the patient's displayed emotions. The range, the range is defined as the variety or high and lows of the emotion displayed by the patient. Stability, how consistent the patient's emotion change with the flow of conversation. Appropriateness, whether the patient's emotional expression matches with the content of their speech. And relatedness. So, relatedness is the feeling of patient that can be related by the examiner. The one can relate with the emotional expression of the patient. In the types of affect, we discussed about the broad affect. Broad affect can be divided further into happiness, a positive emotional state characterized by joy, contentment, and satisfaction. Sadness, a negative emotional state characterized by feeling of grief, loss, or disappointment. Contentment, a state of satisfaction and peace, free from conflict or wanting. Anger, an intense emotional response associated with feeling of irritation, frustration, or rage, with internal, vague, and without external stimuli. Fear, an emotional response triggered by the perceived threat or danger, often accompanied by sense of unease or anxiety. In types of affect, there is restricted affect, also known as constricted affect, is characterized by reduced range of emotional expression. So restricted and constricted are used uh, inversely for to define the restriction of range of the affect. The signs of restricted affect are reduced range of emotional expression, difficulty conveying emotional verbally or non-verbally, emotional detachment or unresponsiveness. Blunted affect is a significant reduction in intensity of emotional reactions commonly observed in various psychiatric conditions. A flat affect is characterized by lack of emotional response and a severe reduction in emotion. Individuals with flat affect often maintain the neutral or expressionless phase regardless of the circumstances. This emotional stability is notable in its near total absence of any significant signs of emotional reactivity, which is whether positive or negative. So, flat affect can also be defined as mask like faces. In inappropriate affect, people with inappropriate affect may laugh during times of sadness or show sign of distress during the joyful events. So the expressed emotion is reverse of the content of thought. These incongruent emotional responses can be confusing, may lead to social difficulties and misunderstandings. It is crucial to understand that inappropriate affect is not a deliberate act. Labile affect is characterized by rapid and unpredictable shifts in the emotional state. Individuals with labile affect may experience extreme highs and lows, transitioning from laughter to tears or joy to sorrow without any apparent cause or in response to a minor event or trivial events. Shallow affect is characterized by reduced emotional experience commonly observed in individuals with psychotic symptoms. People with shallow affect may exhibit a lack of emotional response in situations where most individuals would experience intense emotions. So now we will try to understand by the figure or by the graph what is affect, what is range, and how it is shifted, what is the intensity. So in case of psychiatric disorder, we have four major type of affect on the basis of classified disorders in classificatory system. So one can have cheerful affect, second is anger irritability, third is sadness, and fourth one is fear and anxiety in case of anxiety disorders or otherwise presence of anxiety in other illnesses like schizophrenia and depression. Now look at the white circle, and on the circumference of white circle there are four lines for the four dimensions. This is the euthymic state. If we will consider the circle as a normal emotional reactivity, so one will show all of the emotions in equal amount at the point of time. If you will discuss or talk with the patient, having conversation with the patient shows the equal amount of fearfulness, cheerfulness, anger, irritability to the stimulus and sadness to the stimulus. This means the patient is in euthymic state and range is also within the average limit. So we will consider this circle as an average range of all the emotions in four dimensions. Now what happens in elated mood? You can see there is a red circle. Now the patient started showing less of anger, irritability, and less of sadness, less of fearfulness, and shows cheerfulness most of the time during the interview. And the intensity of elatedness or cheerfulness is surpassing the threshold of normal range. If you find such a situation, one can say the patient is in elated state of emotional expression. So range is increased. You can see the green double arrow. The range is gone upward from the circumference of the circle. It is more intense to the trivial matters or in the absence of external stimuli. This is the shifting towards anger irritability and intensity is increased. If it is shifted towards anger irritability and uh, the circumferential line will be at the white circle, then intensity would be in the normal range and shifting towards anger irritability will be there. So intensity is increased and shifting is done because other kind of emotions are not being expressed during the interview as much. Similarly, this is for sadness. You can see the shifting and increased intensity. In anxiety disorder, it is shifted towards fear and anxiety. So range is shifted and intensity is increased. What happens in restricted, constricted, shallow or dull effect? More or less these words are what you can say synonymous to each other. The restriction, constriction, shallowness, dullness defines the same thing more or less. You can see the patient shows emotions in all the directions, but the intensity is decreased. For the stimulus, the person is not showing that much of intense cheerfulness, that not much of anger, irritability, that not much of sadness, and not much of fearfulness up to the normal range. So from all the directions, intensity is decreased, but there is no shifting towards any type of emotion. This is called as restricted affect or constricted or shallow or dull affect. What is flat affect? Flat affect, you can say it's a mask-like face. The constriction is so intense that it reduced to minimal facial expression or no emotions. No. This is a mask-like face. Mask cannot have emotional reactivity, so one can relate to that. Now coming to the speech, what we used to see in the speech is quantity or rate of production, whether the speech is pressured, whether there is a push, speech is slowed, or quantity or rate of production of speech is average. It can be defined in the terms of average, increased and decreased also. Pressured speech means the pressure of speech is so much that one cannot interrupt or stop the person uh, to stop. The push of speech is the person is over talkative, the rate of production is high but can be stoppable. We can stop that person by interruption. In quality, rhythm, articulation, uh, like dysarthria, stuttering should be observed. Accent and dialect should be observed. Volume and tone of the speech should be observed. Whether the speech is coherent, continuity is maintained, spontaneity is there or not. In thought, we have four parts: the form of thought, also known as formal thought disorder, content of thought, possession of thought, disturbance of stream of thought. In disturbance of stream of thought, again, it is measured in form of pressure of thought, poverty of thought, thought block. Thought block means sometimes the stream of thought is interrupted suddenly. In poverty of thought, the patient does not have much of uh, words to say. He will say monosyllables or content of speech is very thin. In formal thought disorder, which is defined as the grammatical and logical connection in thinking, whether what the patient is saying, whether it is grammatically correct or it makes some sense or not. The abnormalities can be irrelevant speech, the answer that is not in the harmony of the question asked. For example, if one has asked, "What is your name?" The answer is, "I had gone to Delhi on that day." The name was asked, but the answer is entirely different for the stimulus. Incoherent, loosening, or derailment of speech. In incoherence, sudden shifting from one topic to another topic occurs abruptly, and in severe form of derailment or sudden shifting is known as incoherence. Example of incoherence is like, "Oh, I am going to beach because the sun and the sand, it's like when the cat jumps over the moon, and I have this teal shirt that really reminds me of the blueberries." So there is lots of disconnection between the sentence and inside the sentence and between the two sentences. So one cannot make out what the patient is going to explain or say. Flight of ideas. It is continuous flow of increased speech with quick changes of topic. Changes are based upon associations, play on words, or distracting stimuli, but ideas are not well connected. Okay, there is some kind of connectedness in flight of ideas in comparison to derailment or disorganized speech. For example, oh, it was great. I went to a market, and you know, markets are fascinating because of the stock market. It is like the roller coaster. Speaking of the roller coaster, I remember the time we went that amusement park, but amusement park are nothing compared to the cultural festivals in Spain. Did you know the Spain? So you can see there is a connection of theme between the sentences. For example, in one first part there is connection of market, in another part is there is connection of roller coaster, and in further is of amusement park. So this is flight of ideas. In circumstantiality, speech with too much detail, which is indirect and slow to reach the point. One will ask the question, but the patient reaches to the question asked after giving unnecessary details. So, in this example, the question were asked like, "Why were you late for the meeting?" He gave the unnecessary details of the morning, and finally he gave the answer, "Because of the minor accident on the way, I was late." And so, unnecessary details are involved in reaching to the question. Tangentiality is they never get back to the original point. For example, a person A asked, "How was your trip to the mountains?" The question was, "How was your trip to the mountains?" He said, "The mountains, oh, I saw the most amazing bird the other day. You know, birds always remind me of the time when I used to collect bird feathers as a kid. Feathers are so interesting. Have you seen those documentaries about the rare birds? They show such a rare species and talk about the habitats." The question is not answered, you know, while the answer has to be given in between this paragraph. You know, how was your trip to the mountain? So it goes like a tangent. The next one is word salad, refers to jumble of words and phrases that lack of coherence and meaning. For example, the person A asks, "What did you do yesterday?" The person B replies, "Sky run, elevator moon, hoped ice cream because Tuesday weather fast." So, word to word incoherence is there. There is not even half formed sentences or fully formed sentences. Within one sentences, there is so much of derailment. This is known as word salad. Neologism is creation of new word, often nonsensical word that are not understood by others. Here is an example. What did you do just last night? I was frizzling all evening before the sunflicks started. So, frizzling and sunflick is a neologism which is not found in the dictionary, and the patient must have their own meaning to these words. Clanking is word chosen based on the sound instead of meaning. For example, how are you today? I am fine, feeling divine. Oh, what a sign, let's dine on a shrine. So there is rhyming in the answer. Perseveration is persisting response to previous stimuli when new stimulus has been presented. So person will respond with the same answer for the different questions asked is perseveration. Verbigeration is a condition characterized by meaningless, compulsive repetition. For example, what do you like to do in your free time? So there is repetition of time, and the clear word many a times. So this is verbigeration without any further stimuli. Echolalia, you all know, is an involuntary repetition of words or phrases spoken by the examiner or others. Blocking is abrupt disruption of speech mid-sentence or before the idea is finished. Patient loses their thought while answering or speaking. Now come to the third part, which is known as content of thought. Content of thought can have obsessions, delusions, phobias, grandiose ideas, magical thinking, suicidal ideations, overvalued ideas, and depressive cognitions. In obsessions, Obsessions are intrusive, unwanted, repetitive, same few thoughts, image or urges that come to the mind repeatedly and are hard to control. This can be of various types like contamination. There is fear of germs, dirts and other substances leading to the intense fear for contamination. Doubt obsession, persistent concern about things not being done correctly or completely, such as wondering if door is locked or if the oven is turned off or not, whether the gas knob is turned off or not. This thoughts run repeatedly in the mind of the person. Symmetry obsession, need for things to be in a particular order or symmetrical because anything else feels not right or uncomfortable. Harm obsessions, fear about causing harm to oneself or others, either directly or indirectly. Forbidden thoughts, disturbing thoughts or mental images of taboo topics such as violence or sexual contents. So general questions to elicit obsessions are to find out the frequency and intrusions, like do you feel how yourself having repeated and intrusive thoughts that are hard to control, or one can ask how often do these thoughts occur throughout the day, which shows frequency. Impact on daily life should also be noted. How do these thoughts affect your daily routine or activities? Nature of thoughts would also be uh, elicited. Can you describe the nature of these repeated thoughts or images? Are there certain themes that you have in your intrusive thoughts or which tends to follow? Attempts to ignore or suppress, whether this resistance is present or not. Do you try to ignore or suppress these thoughts? If so, how do you do it? What is the method? Does trying to push these thoughts away make them come back even stronger? Obsessions has related compulsions also. If the person is having fear of contamination, then repeated hand washing may be seen, and rituals can be there to resist those thoughts. Onset and triggers to be asked: when did you first start experiencing these intrusive thoughts? Are there specific situations or triggers that seem to bring on these thoughts? Distress and interference because of the obsessions, like how distressed do these thoughts make you feel on a scale of 1 to 10? Do these thoughts interfere with your relationships or work? One can scale on the intensity on the Y box scale also. There is a specific question to elicit obsession. For example, for contamination concerns, do you often worry about being contaminated by germ or dirt? Do you feel an intense need to wash or clean things repeatedly? For doubt and checking, do you frequently worry that you might have left something incomplete or undone? Do you feel compelled to check things multiple times, like doors, knobs, appliances, locks, uh, and maybe the account book also? Symmetry and orderliness, do you have a need for things to be perfectly arranged or symmetrical? Do you get distressed if the things are out of order or not aligned properly? For harm and safety, do you often have unwanted thought about harming yourself or other unintentionally? Forbidden or taboo thoughts, do you have intrusive thoughts or images that are violent, sexual, or otherwise disturbing? Religious or moral concerns, do you worry excessively about doing or thinking something that goes against your moral or religious beliefs? So there are various different content in obsession which should be looked for. Now the delusion. So delusion can be of various types. Delusion is a belief that is firmly held on inadequate grounds, that is not affected by rational argument or evidence to contrary, and that is not conventional belief that the person might be expected to hold given their educational, cultural, and religious background. This means there is a belief, there is a belief which is false belief or without any evidence, no, and it is not affected by the argument which is given by the examiner, and the patient cannot be shake from the belief, and it is not in the context of his educational, cultural, and religious background. So delusion can be of many types. One is delusional mood or atmosphere, delusion of intuition or autochthonous delusion, delusional perception. Should I explain all these delusion in detail? No. Huh. Delusional memories, delusion of persecution, delusion of infidelity, jealousy delusion, also known as Othello syndrome, commonly found in uh, alcohol abuse. Erotomania, delusion of love, which is also known as fantasy lover syndrome, or de Clermont syndrome. Nihilistic delusions are usually found in the severe depression. Hypochondriacal delusion may also be there. Capgras syndrome, which is known as hypofamiliarity syndrome, is characterized by belief that a close acquaintance has been replaced by an identical imposter. Fregoli syndrome is known as hyperfamiliarity syndrome, involves the erroneous identification of unfamiliar individual as someone familiar despite a lack of physical resemblance. The Cotard syndrome, found in the depression, the syndrome of intermetamorphosis, marked by the delusional conviction that others have undergone significant transformation in both physical and psychological identity, resulting in a complete different person. There are many more delusions which are not discussed here. Now, how to elicit delusion? It's a very tricky situation to elicit the delusion. So, one can go by general inquiry, like, can you tell me more about recent experiences or thoughts that have been in your mind? The second is, have you had any unusual or surprising experience lately? Belief exploration. Do you sometimes feel that things others cannot see or understand are influencing you? Do you ever have beliefs or thoughts that other people find hard to understand? This means the delusions are basically not having evidence, or it is not true for the situation. So family members also recognize that these are unnecessary thoughts. So one can explore in this way. Like, do you ever have belief or thoughts that other people find hard to understand? Persecution or paranoia. Do you ever feel that people are out to get you or harm you in some way? Do you think anyone is watching or following you? For grandiose delusion, do you believe you have special abilities or power that others do not have? Have you felt that you are destined for a greatness or have a special mission? So one can elicit grandiose delusion in that manner. For control and influence, do you feel that your thoughts or action are being controlled by someone or something else? Do you believe someone can read your mind or that you can read others' mind? For reference, do you sometimes feel that ordinary events or subjects have special meaning just for you? Do you think that there are hidden messages or signs specifically meant for you in the everyday life? So these are the directly hitting questions. So one should not go by this. If you have found in the history such kind of symptoms and patient is not depicting during the interview, one can probe in this way to elicit the delusion. One should not hit directly to the patient. If the patient is giving cues, so one should go by the parallel means by not approaching directly. So here are the some tips to elicit content of delusions. Patient may spontaneously give a hint. You should not uh, hit the directly to the content. Patient may be come up with the uh, expressions like people, relative, specific person is plotting, acting against him and her. So it is indicating of persecutory delusion. One can catch the hint and go further for exploration. Another example is people relative specific person is mixing something oblique tablets or poison in his or food. This also goes for persecutory delusions. I have lots of money, assets, power. No one can beat me. This shows the grandiosity of content of thought. Nothing better can happen. People are bad. All people are selfish. These three content shows the helplessness, nihilism, and hopelessness, nihilism, and helplessness of the content of thought. So while eliciting the delusion, the examiner has to prove the thoughts are not true on the basis of evidence, and that cannot be corrected by reasoning. One has to give the reason to the patient that how and why and how such a situation can happen when situation is actual the situation is like that. So one can confront like this. They have to show that the content is not aligned with the socio-cultural background. In the socio-cultural background, so many thoughts, verbs, and proverbs, and so much of uh, thinking is there in the society, which is normalized thinking for that society. That thought cannot be considered as delusion, and not in the context of occupation, intellect of the patient. No, that should not be related to the occupation of the patient and the intelligence of the patient. Another point is try not to deviate from psychopathology from your side until satisfactorily exercised, and if the patient got deviated, in case draw the attention back the patient to the topic. Yeah. Try to hold, if you have gotten cue, and try to hold the patient at that content and try to explore on the points of definition of delusion, whether these are false or cannot be corrected, are not aligned with socio-cultural background, and not in context with the occupation and intellect of the patient. So one has to explore all these aspects of the definition of delusion. If attention cannot be get back, then move on to the what the patient wants to talk about, or you can move on to the another psychopathology which was expected to present in the MSc, which is found in the history of present illness. In perception, there are four pathology. One is illusion, we all know about it, hallucinations, depersonalization and derealization, formication. Formication is the feeling of bug crawlings under or on the skin. In hallucinations, we can categorize these hallucinations into five types on the basis of five senses. It can be auditory, visual, tactile, olfactory, and gustatory hallucinations. Hallucinations are also categorized according to complexity, whether these voices are elementary or complex, according to sensory modality, as already has been said, according to spatial features like second person, third person, echo della pensée, or extra campaign. Second person is when the single voice is commenting upon the patient, commanding to the patient, or having conversation with the patient. The third person is more than two voices are talking about the patient, is a third person hallucination. It means in case of second person, the patient is the first person and voice is the second person. In third person, the patient is the first person, the first voice is the second person, and the another more or second or more voices are third persons. Autoscopic hallucinations contains reflex hallucinations, hypnagogic hallucinations, hypnopompic hallucinations. In psychiatric illnesses, auditory hallucinations are more common type of hallucination, uh, and characteristic of hallucinations are they should be vivid and clear, involuntary in nature, the localization should be external, full sensory experience should be there, and conviction of reality of voices should be there. On this point, one should ask about the hallucinatory experience with the patient. Vividness means true hallucinations are vivid and clear, appearing as real perception. And for the patient is a real perception. If he is listening to the voices, he is actually listening to the voices. Although it is not there in the environment, we know, but for the patient it is real. They are often as lifelike as any genuine sensory experience. Involuntary in nature, they occur without any voluntary effort or control. Patient cannot control those hallucinatory experiences. External localization, the true hallucinations are perceived as originating from the environment outside of the mind, and outside of the mind is outside of the body also. And if the voices are coming from the body part of the patient itself, then also considered as coming from the external environment. If the patient says that the voices are coming from my right hand, so this is also external environment. If patient says that the voices are running in my mind, then it is internal. That should not be considered as hallucination. These hallucinations engage the same sensory pathways as real perception. For example, hearing a non-existent voice would use the same auditory processing as hearing a real person speak. So if one says that the hearing of voices are the voices are there, but I am hearing those voices from my eyes. No. The explanation should be the voices are actually coming from the same root as the real voices are coming. Conviction and reality, the person experiences a true hallucination often believes it to be a real and authentic experience. It can be challenging to distinguish the hallucination from actual sensory input. So conviction is strong. Sometimes the voices seem to speak the patient's thought as he is thinking them, or to repeat them immediately after he has thought them. Is known as echo della pensée. Hallucination of dark figures are sometimes called Lilliputian hallucinations. Hallucinations of deep senses may be experienced as feelings of viscera being pulled upon or distended, or of sexual stimulation or electric shock. So these are the hallucinations of deep senses. Autoscopic hallucination is experience of seeing one's own body projected into external space. The experience is accompanied by conviction that person has a double, is known as doppelganger. Some methods that can potentially elicit hallucinations include sleep deprivation, sensory deprivation. In case of blindness or hard hearing of loss, one can experience hallucinatory pictures or hallucinatory voices in absence of psychiatric illness also. Hypnosis and suggestion can also elicit hallucinatory experiences. Meditation and trance states, one can have hallucinatory experiences. Substance use, neurological conditions like epileptic seizures, migraine can sometimes bring about hallucinatory experiences. In aura of both epileptic seizure and migraine can also have hallucinatory experiences. Extreme stress or trauma can also elicit hallucinatory experiences. So here are some key questions to be asked in case of hallucination. The general exploration is, have you been seeing or hearing things that others around you do not seem to notice? The voices and the figures you are seeing, whether these are being also seen by your parents, your relatives, or people around you. Do you ever smell or taste things that aren't there? Have you felt unusual sensation on your skin inside your body that you can't explain? For auditory hallucinations, do you ever hear voices when no one is around? Can you tell me about the voices you hear? What do they say, and do they ever talk to you or about you? So these questions are exploring the various aspects of the auditory hallucinations. For visual hallucination, have you ever seen any object, people, lights that others do not see? Who or what you have seen? Does these visions seem real at the time you see them? So while assessing the patient for auditory hallucination, one should ask question in a manner that one will establish all the features of hallucination, that it's a real perception, it is coming from the same process, it exists in the objective space, uh, it is not heard by the others, it is clear and vivid. So questions should be framed in such a manner that hallucination can be definitely said. Similar questions for olfactory, gustatory, and tactile hallucinations. So dimensions to cover in questioning for hallucinations are frequency, the duration, context and trigger, content and theme of the hallucination, impact on functioning, insight and response, and associated features should also ask, which are associated with the hallucinations. Now coming to the memory, it has three parts: immediate memory, recent memory, recall, a list of words. Immediate memory asks the person to repeat a series of number or objects which are unrelated with each other. Start with 2 or 3 digits and gradually increase the length. For example, say number 741 and ask the patient to repeat them, and remind him that you will ask these three numbers or objects after few minutes. For recent memory, ask about the recent events, like inquire about what the person had for breakfast or what they watched on the TV last night. Now you can do the recall. After this much of time, few minutes are gone, you can ask for recall the numbers or the objects you have given initially. Remote memory asks about past events, questions about the person's childhood, schooling, previous jobs, can help test long-term memory. For example, what was your first job? Where did you go to school? Constructional ability is important in cognitive dysfunctions like dementia. Draw a simple shapes can be given to the person on a piece of paper and ask them to draw a simple shape like a square or clock with numbers. This assesses both memory and visuospatial skills, which is impaired particularly in case of dementia. Then one should ask for intelligence. In intelligence, there is three parts: general fund of knowledge, simple arithmetic calculations, and abstract thinking. In general fund of knowledge, one can ask for the name of current CM, PM, name of the neighboring states, countries, name of the rivers, fruits and vegetables as per the current weather, etc., which are common for general fund of knowledge. Simple arithmetic calculations like 4 plus 1, 15 minus 8, 3 into 5, 12 divided by 3. These are the simple calculations. One can uh, give more simpler for the illiterate person, and for somewhat more tough questions for highly educated people. It's a clinical judgment what kind of calculation you should give to the patient. Abstract thinking is the ability to deal with concepts and to make appropriate inferences. Inability to comprehend abstract thought is termed concrete thinking. So concrete thinking is opposite of abstract thinking. It can be tested by asking similarities between two objects like apple and orange. Proverbs can also be asked, which are common and simple. If the patient does not know the proverb you have asked, you can ask the patient to tell the proverb he knows, and you can know the interpretation of the proverb. Judgment is judged by three dimensions. One is personal, second is social, third is test judgment. In personal judgment, you can look for hygiene of the patient, taking care of the belongings, taking care of the illness, maybe physical also, and suicidal tendencies. For social judgment, behavior during the interview, behavior in the ward with the other patients and with the ward staff, and behavior with the in the family, behavior with the family members and relatives and neighbors can be asked to judge the social judgment. For test judgment, the patient predicted response and behavior in imaginary situation. For example, one can ask what she would do in case of the fire in this room. Okay. So judgment is assessed by scenario and placing obstacles. If the patient gave answer, you asked the answer. You asked the question. You smelled smoke in house and you are highly suspicious of fire eruption. What are you gonna do? If the patient answered, I am going to call the fire department, of course. You must then place an obstacle. Like let's say you didn't have a phone with you. So what will you do now? So ideally, one should impose 3 to 4 obstacles to test the test judgment. The another question may be, what is the thing to do if you find an envelope in the street that is sealed, stamped, and addressed? The envelope has a seal, is being sealed and stamped and having address on it. So what you gonna do? The last one is insight to be checked. The definition of insight is the patient's self-awareness regarding their emotions, behavior, and potential underlying factors contributing to their psychiatric condition. So this is for psychiatric condition, not for the physical condition. And it is regarding self-awareness of the emotions of the patient, behavior of the patient, and potential underlying factor which contributing to their physical psychiatric condition. This is graded as 1 to 5. The first is complete denial of illness. This is lack of insight. Slight awareness of being sick and deny at the same time, and needing help but refusing care. It is partial insight, grade 2 insight. Awareness of being sick but blame it on others or external factors or an organic factor. Awareness that illness is due to something unknown in the patient. Okay. Okay. The third one is, the fourth one is intellectual insight. Fourth one is known as intellectual insight. Admitting that the patient is ill and that symptoms or failures in social adjustments are due to the patient's own particular irrational feelings or disturbances without applying this knowledge to future experience. He knows he is ill, he knows his symptoms, he acknowledges these symptoms are due to mental illness or behavioral problems, but without applying this knowledge to future experiences. What happens in true emotional insight? Emotional awareness of motives and feelings within the patient and the important people in his or her life, which can lead to basic changes in behavior. So what happens in true emotional insight is the patient applies this knowledge to the future experiences. In another word, one can say the patient knows about his illness and he knows that he is having some mental problem or behavioral problem. He says that I need treatment. I need psychiatric treatment or psychological treatment. And in future, he remains compliant to the management part and the lifestyle changes which are being told to them. For example, in case of alcohol dependence, no, if the patient is in follow-up, he is in the counseling session, he is doing things to avoid situation which can trigger the alcohol intake again, like change of the friend circle, no, doing meditation, changing of the job if it is possible, the person is doing such and such things and he remains abstinent, one can say that the patient is having true emotional insight. If the same patient does not follow up, does not come in follow-ups, he does not change his lifestyle, he does not do the things which are being told, but he knows that I am ill, this is harmful to me, then this is the intellectual insight. Okay. Alternative classification of insight may be full complete insight, partial insight, or poor insight, uh, which can be conventionally used clinically. But in standard, we have 5 levels of insight. In summary, we have learned about the journal appearance and behavior regarding the consciousness and orientation, attention and concentration, affect, speech, thinking. Thinking has 4 parts: formal thought disorder, content of thinking, the speed of thinking, and the possession of thinking. Perception, we talked about the hallucinations, memory, intelligence, judgment, and insight. So thank you.
Swaleha Mujawar. I'm the assistant professor in Department of Psychiatry. And before going on to classification, we have to understand what is health, what is mental health. So before understanding what is mental health, let us first go to what is health. ठीक है? तो health means what? यानी आप में और patient में क्या difference है? रॉन्ग आंसर कोई है नहीं, बताओ क्या क्या, व्हाट डू यू अंडरस्टैंड बाय हेल्थ? वेरी गुड. तो बॉडी फंक्शंस अगर अच्छे हो, नॉर्मल हो, और यस वेरी गुड, तो नो स्ट्रेस, नो इलनेस. और तो जनरल क्वेश्चन है कि हेल्थ से क्या मतलब? फिजिकल हेल्थ, एक्सरसाइज वगैरह हम अगर अच्छे से कर पाओ तो यस. यस, फूड, डाइट. ठीक है, चलो बाकी लोगों को चुप बैठना है. चलो बाकी भी और क्वेश्चंस है जो मैं पूछूंगी. तो whenever we talk about health, yes, एक तो एज डॉक्टर्स हमें लगता है कि हेल्थ यानी बस कोई डिसीज नहीं है तो वो हेल्थ है. तो दैट इज जस्ट अ हाफ डेफिनेशन, या वो पूरा एक्सप्लेनेशन नहीं है. हेल्थ मीन्स कि हाँ, हमें कोई डिसीज नहीं है, कोई इलनेस नहीं है, बट लाइक यू सेड फिजिकल फिटनेस भी होना चाहिए, एनर्जी वाइटैलिटी होना चाहिए, ऑल्सो बॉडीली फंक्शंस ठीक होने चाहिए, बट ऑल्सो साइकोसोशल वेलबींग एंड गुड सोशल रिलेशनशिप्स. तो जब भी हम हेल्थ की के बारे में बात करते हैं, फिजिकल हेल्थ बट ऑल्सो मेंटल हेल्थ. सो फॉर अ फुल डेफिनेशन ऑफ हेल्थ वी नीड अ गुड मेंटल हेल्थ और अ गुड मेंटल फंक्शन ऑल्सो. तो मेंटल हेल्थ हमेशा याद रखना, इट इज द पार्ट ऑफ द डेफिनेशन ऑफ हेल्थ. इसीलिए हमको एक स्टिग्मा छोड़ना है, एक स्टिग्मा ब्रेक करना है कि मेंटल हेल्थ जो है वो कुछ तो अलग ही है, कुछ तो ऊपर का है जो फिजिकल हेल्थ में नहीं आता है. तो रिमेंबर, मेंटल हेल्थ इज अ हेल्थ. एंड व्हेन वी लुक एट द डेफिनेशन, तो व्हाट इज मेंटल हेल्थ, इसमें आपको क्या समझ में आता है? हेल्थ के डेफिनेशन से भी कंपेयर कर सकता है, बट व्हाट इज मेंटल हेल्थ? नो स्ट्रेस, वेरी गुड. और नो डिप्रेशन, एंजाइटी, नो ओवर ईटिंग, यस वेरी गुड. सो नो, ओके, ठीक है, गुड गुड. सो सी, डिफाइनिंग मेंटल हेल्थ इज अ लिटिल मोर डिफिकल्ट. फिजिकल हेल्थ को डिफाइन करना फिर भी इजी है. मेंटल हेल्थ का डेफिनेशन थोड़ा सा मुश्किल होता है, और मुश्किल इसलिए भी होता है कि साइकेट्री में नॉर्मल कौन है ये डिसाइड करना. जैसे बहुत सारे मेरे फ्रेंड्स है स्पेशली पूछते हैं कि आप डिफरेंशिएट कैसे करते हो कि पेशेंट कौन है. जैसे इट्स अ वेरी कॉमन सेइंग कि पागल कभी बोलता नहीं कि मैं पागल हूँ. तो दैट इज वाई दिस इज अ चैलेंज कि इन साइकेट्री व्हाट इज नॉर्मल, हु इज नॉर्मल. तो ये थोड़ा सा अलग हो जाता है. जैसे फिजिकल में या मेडिसिन में आप जाओ तो ठीक है, डेंगू पॉजिटिव है, मलेरिया पॉजिटिव है तो डेंगू है. बट इन साइकेट्रिक इलनेसेस वी डोंट हैव अ टेस्ट कि हम कुछ सीटी एमआरआई में देखे और बोले कि हाँ आपको स्ट्रेस है, आपको डिप्रेशन है. तो ऐसे हम कुछ एक आर्बिट्री लाइन पे चल रहे हैं, और बहुत स्किल और बहुत ज्यादा एनर्जी और एफर्ट लगता है एक डायग्नोसिस तक पहुंचने के लिए. तो दैट इज व्हाई अंडरस्टैंडिंग व्हाट इज नॉर्मल इज इम्पोर्टेंट. सो देर आर फ्यू वेज टू डिस्क्राइब व्हाट इज नॉर्मल. तो अलग अलग लोगों ने अलग अलग अटेम्प्ट किया है कि साइकेट्री को डिस्क्राइब करें. तो एक तो बहुत ही साइंटिफिक वे ऑफ लुकिंग एट नॉर्मल इज स्टैटिस्टिक्स. तो हम 100 लोगों को लेते हैं, 100 लोगों को मेजर करते हैं. फॉर एग्जाम्पल आईक्यू हो गया, तो हम इंटेलिजेंट क्वेश्चन देखते हैं 100 लोगों का, और देखते हैं कि कितने लोगों का एक्सट्रीम्स पे है, कितने लोगों का बीच में है. तो मोस्ट जब भी हम कोई भी स्टैटिस्टिक्स करते हैं तो एक ये बेल शेप्ड कर्व आता है. मोस्ट लोगों का आईक्यू 100-110 के बीच में होता है. जो जिनका थोड़ा ऊपर होता है आईक्यू उनको हम जीनियसेस बोलते हैं या हाई आईक्यू बोलते हैं. जिनका लो होता है उनको मेंटल रिटार्डेशन बोलते हैं. तो वी आर यूजिंग स्टैटिस्टिक्स टू डिफरेंशिएट बिटवीन व्हाट इज नॉर्मल एंड व्हाट इज एबनॉर्मल. तो ये तो एक वे है डिस्क्राइब करने का. दूसरा वे है सोशल नॉर्म्स. तो कुछ कुछ बिहेवियर्स होते हैं जो सिचुएशनल होते हैं, जो सोसाइटी के अकॉर्डिंग होते हैं, और अगर आप वो बिहेवियर से अलग जाते हो तो फिर हम उसको एबनॉर्मल बोलते हैं. जैसे अभी क्लास चल रही है, ठीक है, तो क्लास में आप लोग सब ऐसे चुप बैठे हो, बट ये सेम चुप अगर आप पार्टी में जाके बैठोगे तो लोग सोचेंगे अरे इसको क्या हो गया. ठीक है, या पार्टी में डीजे बज रहा है, म्यूजिक बज रहा है, वहां आप डांस कर रहे हो, दैट इज फाइन. यहाँ डांस करोगे तो डेफिनेटली कुछ साइकेट्रिक प्रॉब्लम लगेगा. तो जो सोशल नॉर्म्स होते हैं, जो सोसाइटी के अकॉर्डिंग हमें बिहेव करना होता है, उस बिहेवियर को अगर फॉलो कर रहे हैं तो नॉर्मल है, नहीं कर रहे हैं तो एबनॉर्मल है. देन कम्स द डेली फंक्शनिंग. तो एवरी डे हम अलग अलग स्ट्रेसेस से आते हैं. वर्क का स्ट्रेस हो गया, लोगों से मिलने जुलने का हो गया, किसी ने कुछ छोटा मोटा बोल दिया. तो वो डेली के स्ट्रेसेस से उनकी फंक्शनिंग कितनी इम्पेयर होती है या नहीं होती है. समझो किसी ने डांट दिया या किसी फ्रेंड के साथ झगड़ा हो गया, तो वो क्लास में बैठ के कर पा रहे हैं फोकस, या क्लास में फोकस नहीं हो पा रहा है. तो दैट इज डेली फंक्शनिंग. ठीक है, ये सब काफी आर्बिट्री डेफिनेशंस है. नथिंग इज लाइक हार्ड एंड फास्ट. एंड एक मेंटल हेल्थ करके भी हाँ एक डेफिनेशन आती है. तो जो हेल्थ का हम डेफिनेशन ले रहे हैं उसी को मेंटल हेल्थ में एक पीरियड ऑफ टाइम के लिए डाल देते हैं. तो दैट इज मेंटल हेल्थ. देन अडेप्टेशन एंड एडजस्टमेंट. जैसे बहुत सारे आप लोग हो जो हॉस्टल्स में रह रहे हो, घर से दूर रह रहे हो पहली बार, तो पहले घर के एनवायरनमेंट में थे, अब हॉस्टल के एनवायरनमेंट में हो. तो एनवायरनमेंट को चेंज करना, एनवायरनमेंट से अडेप्ट करना, ये सब भी नॉर्मल इसमें आता है. अगर नहीं अडेप्ट कर पा रहे तो हो सकता है कुछ एबनॉर्मल हो. इफेक्ट ऑन अदर्स. तो वही है कि सिर्फ आप खुद पे नहीं पर बाकी लोगों पे भी क्या इफेक्ट कर रहे हो. स्पेशली साइकेट्री में दूसरों पे इफेक्ट भी काफी इंपॉर्टेंट है. जैसे अगर किसी को फीवर आता है तो हाँ उसको फीवर होगा, बाकी कोई इफेक्ट नहीं होगा. पर साइकेट्री में बाकी लोगों में भी अफेक्ट होता है, स्पेशली अगर कोई डेंजरस हो. बहुत कम साइकेट्री के पेशेंट्स वायलेंट होते हैं, बट हाँ अगर वायलेंट होता है तो दूसरे लोगों पे भी इफेक्ट पड़ रहा है. तो दिस इज व्हाट इफेक्ट ऑन अदर्स मीन्स. एंड ऑलवेज रिमेंबर, जैसे मैंने बोला कि साइकेट्री में बहुत कुछ हार्ड एंड फास्ट नहीं होता है कि ये कट ऑफ है, ये अगर है तो पॉजिटिव है, ये अगर है तो नेगेटिव है। साइकेट्रिक इलनेसेस जो है एक कंटिन्यूम पे होती है। तो ये कंटिन्यूम में यू कैन सी ऑप्टिमल मेंटल हेल्थ है और कोई सिम्टम्स नहीं है मेंटल इलनेस के, तो हाँ हम बोलेंगे ऑप्टिमल मेंटल हेल्थ विदाउट एनी मेंटल इलनेस। कभी कभी सीरियस मेंटल इलनेस के साथ भी अगर पेशेंट्स थेरेपी पे हो, अगर पेशेंट्स ट्रीटमेंट पे हो, तो भी उसका मेंटल हेल्थ ऑप्टिमल चलता है। उसको देख के आप बता नहीं पाओगे कि वो एंटी डिप्रेसेंट्स पे है, एंटी साइकोटिक्स पे है। तो देन द पेशेंट इज ऑप्टिमल मेंटल हेल्थ विथ मेंटल इलनेस। हाँ, अगर कोई ट्रीटमेंट नहीं चल रहा है तो देन इट इज पुअर मेंटल हेल्थ विथ मेंटल इलनेस। कभी कभी मेंटल इलनेस होने की जरूरत नहीं होती है। कभी कभी हम स्ट्रेस्ड होते हैं या हम डिप्रेस्ड होते हैं बिकॉज की एनवायरनमेंट खराब चल रहा है, जैसे किसी की डेथ हो गई या अनएम्प्लॉयमेंट हो गया, डिवोर्स हो गया। तो ये सब में आप एक डेफिनेशन में नहीं आ रहे हो या एक डायग्नोसिस में नहीं आ रहे हो मेंटल इलनेस के, पर फिर भी आपकी मेंटल हेल्थ पुअर हो सकती है। और जब वो खराब कंडीशन खत्म हो जाती है तो आप फिर नॉर्मल भी हो जाते हो। तो दिस इज ऑल्सो एरिया ऑफ कंसर्न, बट इसका ट्रीटमेंट अलग होता है, इसका अलग होता है और इसका अलग होता है। तो ऑलवेज रिमेंबर कि पेशेंट्स किसी भी प्रकार में आपके पास आ सकते हैं। सर जरूरी नहीं है कि कुछ एक डिप्रेशन का आपने एक पेशेंट देख लिया तो वो वैसा ही होगा। These are the different forms in which the patient can present to us, and because ये इतने different forms होते हैं इसीलिए classification बहुत important है। क्योंकि patients अगर इतने different types के आपके पास आ रहे हैं तो you need to organize the patients, you need to put them in some type of classification। तो एक तो मैंने बताया कि क्यों क्लासिफिकेशन इंपॉर्टेंट है, क्योंकि एक कंटिन्यूम पे चल रहा है। पेशेंट्स कैन प्रेजेंट विथ वेरी वेरी डिफरेंट थिंग्स। व्हाट आर द अदर इम्पॉर्टेंट ways या व्हाट आर द इम्पॉर्टेंट रीजंस फॉर विच वी क्लासिफाई? थोड़ा डिफिकल्ट क्वेश्चन है, हेल्थ वाला इजी था इसीलिए फर्स्ट वाले का आंसर दे देते तो बेटर होता। तो ये वाले तो डिफिकल्ट है। एनीवे तो देखो मेंटल इलनेसेस अलग अलग वेज में प्रेजेंट हो सकती है। स्लीप एपेटाइट चेंजेस, एक्सट्रीम मूड स्विंग्स, डिप्रेशंस, हेलुसिनेशन, डिल्यूजन, अनहेल्दी कोपिंग, इमोशनल आउटबर्स्ट, ये सब डिटेल्स में हम सब्सिक्वेंट लेक्चर्स में पढ़ेंगे। पर यही है, इससे मैं बस ये बताना चाहती हूँ कि मेंटल इलनेस कोई एक टाइप का नहीं होता है। अलग अलग पेशेंट्स आपके पास अलग अलग साइंस एंड सिम्टम्स के साथ आएंगे। तो आपके पास अगर एक क्लासिफिकेशन हो कि हम ये डिफरेंट साइंस एंड सिम्टम्स के परम्यूटेशंस एंड कॉम्बिनेशंस को कोई एक क्लासिफिकेशन में डाल पाए तो आपके लिए भी इजी होगा। नहीं तो साइकेट्री समझ में नहीं आएगा, नहीं तो समझ में नहीं आएगा कि पेशेंट को है क्या और हम इसके साथ करें क्या। तो दैट इज वाई एक तो है कि डायग्नोसिस के लिए क्लासिफिकेशन बहुत इंपॉर्टेंट है कि यू कैन रीच वन डायग्नोसिस एंड पेशेंट भी फिर खुश होता है कि हाँ मेरे साथ ये प्रॉब्लम है। पेशेंट और डॉक्टर को अब पता चल गया है कि प्रॉब्लम है। तो नेक्स्ट हम आते हैं कि प्रॉब्लम कितनी सिवियर है, लो है, मॉडरेट है, बहुत सिवियर है, इंपॉर्टेंट है, क्रिटिकल है। तो यूजुअली अगर बहुत सिवियर होती है तो इम्पैक्ट पेशेंट पे बहुत होता है, अगर लो है तो फिर कम इम्पैक्ट होता है। ठीक है, और डायग्नोसिस और उसकी सिवियरिटी इम्पॉर्टेंट क्यों है, क्योंकि उसी से हम फिर ट्रीटमेंट बताएंगे। ठीक है, अगर पेशेंट को ज्यादा सीरियस कंडीशन नहीं है तो फिर हम सिर्फ सेल्फ हेल्प बोल सकते हैं कि आप कुछ रिलैक्सेशन टेक्निक्स कीजिए, कुछ घर जाके सेल्फ हेल्प हम बुक्स हैं, एप्स हैं, वो यूज कीजिए, उससे हो जाएगा। थोड़ा मॉडरेट है तो साइकोथेरेपी भी दे सकते हैं कि एक साइकोलॉजिस्ट के साथ पेशेंट बात करेगा, कुछ सेशंस लेगा। लेकिन अगर बहुत क्रिटिकल है, बहुत सिवियर है तो हमें मेडिकेशंस भी देनी पड़ सकती है। अ लॉट ऑफ टाइम्स वी यूज अ कॉम्बिनेशन ऑफ ऑल ऑफ देम, बट the diagnosis and the severity will decide what treatment can be given. ऑल्सो साइकेट्रिक इलनेसेस लंबी चलती है, तो हमेशा रिलेटिव्स का कंसर्न होता है, पेशेंट का कंसर्न होता है कि दवा कितने दिन खानी पड़ेगी या थेरेपी कितने दिन लेना पड़ेगा। तो इसीलिए प्रोग्नोसिस कि बीमारी कितनी बड़ी है, कितनी देर तक चलेगी, कितने दिन में ठीक होगा। तो प्रोग्नोसिस मीन्स द फ्यूचर कि फ्यूचर में इस इलनेस को लेके क्या क्या हो सकता है, क्या क्या कर सकते हैं। तो दैट इज प्रोग्नोसिस। सो दैट इज व्हाई क्लासिफिकेशन इज important because it helps us in diagnosis, it helps us in telling about the severity, then what treatment to give, and हम रिलेटिव्स को पेशेंट्स को क्या प्रोग्नोसिस बताए, ये भी उसमें एक आइडिया आ जाएगी। ठीक है, तो अब समझ में आ गया कि क्लासिफिकेशन क्यों इंपॉर्टेंट है। अब मोस्ट साइकेट्रिक इलनेसेस जो होते हैं उनमें बायो साइको सोशल मॉडल है। ठीक है, पुराने जमाने में ऐसा लगता था कि हाँ स्ट्रेस की वजह से साइकेट्रिक इलनेस हो रहा है या उसमें कोई फिजिकल प्रॉब्लम या बायोलॉजिकल प्रॉब्लम नहीं दिख रहा है इसलिए साइकेट्रिक इलनेस है। बट अभी वो चेंज हो चुका है, अभी बहुत सारे फिजिकल हेल्थ प्रॉब्लम्स की वजह से साइकेट्रिक प्रॉब्लम्स होती है एंड वाइस वर्सा ऑल्सो। सो अ लॉट ऑफ बायोलॉजिकल फैक्टर्स आर इन्वॉल्व लाइक जेंडर, जैसे डिप्रेशन फीमेल्स में ज्यादा होता है बिकॉज ऑफ हार्मोनल इश्यूज और नंबर ऑफ इश्यूज। बट फीमेल है मेल है, कोई फिजिकल डिसेबिलिटी है, कोई फिजिकल हेल्थ प्रॉब्लम है लाइक डायबिटीज, हाइपरटेंशन, कैंसर, कोई न्यूरोकेमिस्ट्री में प्रॉब्लम है, तो आपके ब्रेन के अंदर कुछ कुछ केमिकल्स होते हैं जैसे डोपामिन, सेरोटोनिन, ये भी आगे पढ़ेंगे। बट बेसिकली ब्रेन के केमिकल्स कम ज्यादा होने की वजह से भी साइकेट्रिक इलनेस होती है। फिर स्ट्रेस रिएक्टिविटी, जेनेटिक वल्नरेबिलिटी, बहुत सारे इलनेसेस लाइक स्किज़ोफ्रेनिया, बाइपोलर, ये जेनेटिक होते हैं, ये ना फैमिली टू फैमिली वो ट्रांसमिट हो सकते हैं। ठीक है, फिर साइकेट्रिक में वही आता है बिहेवियरल, पर्सनालिटी, कोपिंग स्किल्स कैसा है उस पर्सन का, सेल्फ एस्टीम कैसे है, इमोशंस कैसे हैं। सोशल में आता है एजुकेशन कि उस पेशेंट का अगर एजुकेशन कम है, अंडरस्टैंडिंग कम है, तो हो सकता है स्ट्रेसेस को भी वो इतने अच्छे से ना झेल पाए। सोशल सपोर्ट, पीयर रिलेशनशिप, फैमिली बैकग्राउंड, सोशो इकोनॉमिक स्टेटस, ये सब चीजें भी साइकेट्रिक इलनेसेस पे बहुत इफेक्ट करती है। तो अब इतनी सारी चीजें हैं तो इन्हें क्लासिफाई करना और ज्यादा जरूरी है। तो क्लासिफाई करने के लिए बहुत सिंपल यूज किया है कि बायोलॉजिकल है या साइको सोशल है। तो अगर बायोलॉजिकल मेंटल इलनेस है तो उनको हम बोलते हैं ऑर्गेनिक इलनेसेस। ठीक है, ऑर्गेनिक यानी बॉडीली या बॉडी से निकलता जो है। और ऑर्गेनिक साइकेट्रिक इलनेसेस में एक आते हैं ऑर्गेनिक डिसऑर्डर्स। तो ऑर्गेनिक में कैंसर हो गया या एंडोक्राइन लाइक हाइपोथायराइडिज्म हो गया। तो पेशेंट को डिप्रेशन हो रहा है कैंसर की वजह से या हाइपोथायराइडिज्म की वजह से, तो उसको प्योर साइकेट्रिक इलनेस नहीं है, ये फिजिकल इलनेसेस की वजह से उसको साइकेट्रिक इलनेस हो रहा है। तो दैट इज व्हाई इट इज नोन एज ऑर्गेनिक। और जितने भी हमारे एडिक्शंस आते हैं, जो ड्रग्स पेशेंट्स लेते हैं, वो फिर सब्सटेंस यूज डिसऑर्डर में आते हैं। तो उसमें अल्कोहल हो गया, ओपियोइड्स हो गया, कैनबिस हो गया, तो ये सब भी आते हैं साइकोएक्टिव सब्सटेंस यूज डिसऑर्डर्स में। ठीक है, तो ऑर्गेनिक में हमारे पास हो गया है कोई मेडिकल इलनेस या कोई सब्सटेंस की वजह से। ठीक है, अब आता है फंक्शनल। तो फंक्शनल यानी पेशेंट को कोई भी मेडिकल प्रॉब्लम नहीं है या पेशेंट कुछ सब्सटेंस एडिक्शन में नहीं जा रहा है, तो फिर पेशेंट को क्या क्या हो सकता है। तो दो ब्रॉड टर्म्स हैं, साइकोसिस और न्यूरोसिस। ठीक है, साइकोसिस का मतलब होता है कि पेशेंट को टच विथ रियलिटी है या नहीं है। ठीक है, जो मैंने बोला कि पागल को पता नहीं होता है कि वो पागल है, तो दैट इज द साइकोसिस, कि उसे पता ही नहीं है कि कुछ इलनेस है या उसमें कोई प्रॉब्लम है। तो साइकोसिस में आते हैं स्किज़ोफ्रेनिया, मूड डिसऑर्डर्स, अदर साइकोटिक डिसऑर्डर्स, ये हम पढ़ेंगे सब्सिक्वेंट हर एक टॉपिक पे लेक्चर होने वाला है, तो ये तो हम डिटेल में कवर करेंगे। न्यूरोसिस में आपके मोस्ट स्ट्रेसेस आ जाते हैं। जैसे साइकोटिक पेशेंट जो है वो कभी आके बोलेगा नहीं कि मेरी मदद करो या मुझे कोई साइकेट्रिक इलनेस है, पर न्यूरोटिक पेशेंट्स आके बोलेगा कि हाँ मुझे बहुत स्ट्रेस है, जब भी मैं एग्जाम में बैठता हूँ तो दिल की धड़कनें तेज हो जाती है, मुझे पसीने आने लगते हैं, हाथ पैर कांपने लगते हैं। तो ये पेशेंट को खुद पता है कि उसको कोई प्रॉब्लम है, तो दैट इज योर न्यूरोसिस। तो इसमें हमारे फोबियाज आ जाते हैं, ऑब्सेसिव कंपल्सिव डिसऑर्डर्स, लंबी लिस्ट है न्यूरोसिस की भी, ये भी हम पढ़ेंगे। पर दिस इज अ वेरी ब्रॉड क्लासिफिकेशन कि आपके पास साइकेट्री ओपीडी में या साइकेट्री वार्ड में जितने भी पेशेंट्स हैं उनको हम ऐसे क्लासिफाई कर सकते हैं। ठीक है, ये तो स्टार्टिंग का क्लासिफिकेशन था, फिर इसको बहुत रिफाइन करते 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 हम फिर आए इस पे। तो अभी जो है दिस इज द करंट एंड द लेटेस्ट क्लासिफिकेशन। तो करंट क्लासिफिकेशन चल रहा है ICD-11 एंड DSM-5। ठीक है, मैं बताती हूँ क्या है। ICD-11 जो है ऑल ओवर द वर्ल्ड फॉलो किया जाता है, ठीक है, पर DSM-5 जो है वो सिर्फ नॉर्थ अमेरिका में होता है। तो अमेरिकन ने अपना खुद का क्लासिफिकेशन निकाला है, दैट इज DSM-5, और बाकी पूरे वर्ल्ड में तो ICD-11 यूज होता है। ICD-11 जो है वो यूज होता है बाकी मेडिकल इलनेसेस के लिए भी। तो जैसे अगर पेशेंट को डायबिटीज होता है तो डायबिटीज का भी ICD क्राइटेरिया है, लेकिन DSM जो है वो सिर्फ साइकेट्रिक इलनेसेस के लिए, बिकॉज दैट इज मेड बाय द अमेरिकन साइकेट्रिक एसोसिएशन। ठीक है, तो आप जैसे देख सकते हैं इस पिक्चर में एक साइकेट्रिस्ट बैठा है, उसके पास सारी पुरानी बुक्स भी हैं। तो DSM का फुल फॉर्म होता है डायग्नोस्टिक एंड स्टैटिस्टिकल मैनुअल ऑफ मेंटल डिसऑर्डर्स, दिस इज द फुल फॉर्म। और DSM जब पहली बार आया था तो DSM-1 था, देन 2, 3, 4 TR, 5, अभी 5 का भी TR यानी रिवाइज्ड वर्जन होता है वो, बट करंट DSM is your DSM-5। एवरी फ्यू इयर्स वो लोग देखते हैं कि हाँ मेंटल इलनेसेस में कुछ कुछ चेंजेस आई हैं या कुछ कुछ रिविजन्स हैं, तो वो फिर निकालते हैं। तो DSM-5 इट इज अ डायग्नोस्टिक टूल, ऑल कैटेगरीज ऑफ मेंटल इलनेसेस जो है वो उसमें आते हैं। मई 2013 में ये निकला है, लास्ट पब्लिश हुआ है, और उसमें लिस्ट हैं कुछ सिम्टम्स के, कुछ स्टैटिस्टिक्स के। तो जब भी हमें कोई डाउट होता है कि इसका डायग्नोसिस क्या है, हम DSM-5 देखते हैं या ICD-11। ठीक है, और DSM में बहुत अच्छी क्लासिफिकेशन है, एक्सियल क्लासिफिकेशन। उन्होंने 5 एक्सेसेस दिए हैं। तो फर्स्ट एक्सिस पे आते हैं आपके साइकेट्रिक इलनेसेस। ठीक है, लेकिन कोई साइकेट्रिक इलनेस का पेशेंट है, हो सकता है उसको कोई मेडिकल इलनेस भी हो, कोई अस्थमा हो सकता है, कोई गैस्ट्राइटिस हो सकता है, इंडिपेंडेंट ऑफ द साइकेट्रिक इलनेस। तो उसको हम एक्सिस 3 पे डालते हैं। एक्सिस 2 इज योर पर्सनालिटी डिसऑर्डर्स। एक्सिस 4 अगर कोई साइकोसोशल या एनवायरमेंटल फैक्टर्स हैं, एंड एक्सिस 5 इज योर फंक्शनिंग, कि आपका डेली फंक्शनिंग कैसा होता है। तो अगर आप ये 5 एक्सिस पे पेशेंट को क्लासिफाई कर दो तो आप कुछ मिस नहीं करोगे। जैसे हमने देखा था बायो साइको सोशल मॉडल था, तो दैट इज व्हाई ऑल दीज 5 एक्सिस विल कवर योर बायोलॉजिकल, तो बायोलॉजिकल पार्ट यहाँ पे कवर हो गया, साइको सोशल पार्ट यहाँ पे कवर हो गया। ठीक है, तो दिस इज योर एक्शियल क्लासिफिकेशन या 5 एक्सिस क्लासिफिकेशन बोलते हैं फॉर साइकेट्रिक इलनेसेस। अब आते हैं ICD-10 और 11 पे। तो ICD-10 चल रहा था, अभी लेटेस्ट में ICD-11 भी आया है। तो ICD इज योर इंटरनेशनल क्लासिफिकेशन ऑफ डिसीजेस, और ICD के कोड्स होते हैं। आप जैसे यहाँ पे देख सकते हैं सारे मेंटल इलनेसेस को उन्होंने एक एक कोड दिया है। तो अ लॉट ऑफ टाइम्स हम जल्दी में होते हैं, फाइल में जगह नहीं होती है, पूरा डायग्नोसिस लिखने से बेटर है कि हम कोड लिख दें। जैसे F10 है, F10 का मतलब होता है अल्कोहल डिपेंडेंस या अल्कोहल एडिक्शन। तो अगर कोई अल्कोहल एडिक्शन का पेशेंट आता है तो हम फाइल पे बस अगर F10 लिख दें तो सबको समझ में आता है कि दिस इज अ अल्कोहलिक पेशेंट। तो हर जो जैसे अगर डिप्रेशन है तो डिप्रेशन इज F32, ठीक है। F30 से मूड डिसऑर्डर स्टार्ट होते हैं, 31 कुछ है, 32 डिप्रेशन है, 33 रिकरेंट डिप्रेशन है। तो ऐसे करके कोड्स हैं। तो इससे बहुत एक साइंटिफिक अप्रोच होता है, कोई कंफ्यूजन नहीं होता है डायग्नोसिस में। और जैसे मेंटल डिसऑर्डर्स के कोड्स हैं वैसे डायबिटीज, हाइपरटेंशन, हर एक के कोड्स हैं। और वो कोड अगर लिख दो तो उसी में हमको डायग्नोसिस पता चलता है। तो दीज आर योर ICD-10 कोड्स। और ICD-10 और 11 में कुछ कुछ चेंजेस हुई है। यूजी के लेवल पे या अंडर ग्रेजुएट लेवल पे इतना आपको ना भी पता तो चले, बेटर है। बट बस ये देख लेना कि थोड़े थोड़े चेंजेस होते रहते हैं और हम अपडेट करते रहते हैं हमारे क्लासिफिकेशंस को भी, ठीक है। तो अब जो भी हमने पढ़ा उस पे से भी कुछ MCQs डिस्कस करते हैं, जो नहीं भी पढ़ा उस पे से भी MCQs कर ही सकते हैं। तो ये तो काफी सिंपल है। मेंटल डिसऑर्डर्स आर ट्रीटेड बाय ऑल ऑफ द अबव, ठीक है। तो उसमें जरूरी नहीं हो कि सिर्फ फार्माकोलॉजिकल हो या सिर्फ हॉस्पिटल जाना जरूरी नहीं, थेरेपिस्ट, ऑल हमने देखा था ट्रीटमेंट में तीनों चीजें आती हैं, ठीक है। विच ऑफ द फॉलोइंग इज पार्ट ऑफ द बायोसाइकोसोशल मॉडल ऑफ मेंटल डिसऑर्डर्स, ठीक है। तो सोसाइटी, इनहेरिटेड ट्रेट्स, ये सब मिलके एक बायोसाइको सोशल मॉडल आता है, ठीक है। आप लोगों के एग्जाम्स में भी ऐसे ही MCQs आएंगे। तो इफ यू जस्ट पे अटेंशन क्लासेस में तो ये आपको इतना ज्यादा डिफिकल्टी लगेगा नहीं करने में, ठीक है। तो विद दिस थैंक यू सो मच फॉर लिसनिंग। अगर किसी को कोई डाउट्स है, कुछ पूछना है।
Good afternoon, everyone. I'm Dr. Ritika Singh. I'm senior resident in the Department of Psychiatry. So we'll be covering the one part of substance-related disorder. Substance-related disorder in itself is a very huge topic, and each subtopic requires a lecture of its own. So we'll be covering one of the very important aspect, which is called alcohol. Okay. So these are the headings under which the topic will be covered: introduction, epidemiology, etiology, clinical features, evaluation management, conclusion, and references. So, introduction part. When we talk about substance related disorder, it refers to the conditions which are caused by repeated use of psychoactive substances, okay, which lead to, now this important, clinically significant impairment or distress. Okay, psychoactive substance along with alcohol, there are many other substances which we'll see what are they. So they cause a harm in such a way both your physical and mental health is going to get compromised, and distress can be seen in your physical health, mental health, your occupational life, your personal life, and professional life. Okay, and these substances have the quality to fundamentally changes, to bring the change in brain's chemistry and function. It will bring changes in neurotransmitter balance. It might bring change in some structural form in the brain, which can cause wide range of mental health symptoms and physical health symptoms. So these are the kind of substances which are used commonly for abuse: alcohol, marijuana, certain hallucinogens, opiates, cocaine, inhalants, methamphetamines, and prescription medication. One substance is missing from here, which is very commonly used in India, which is nicotine. Okay, nicotine is one of the most commonly used substance in India. So when we talk about alcohol, alcohol in itself is a CNS nervous system depressant. Okay, you might be little surprised क्योंकि जब भी कोई आप देखो किसी ने अल्कोहल लिया है तो वो थोड़ा सा हाइपर एक्टिव हो जाता है स्टार्टिंग में। इसका मतलब ये नहीं है कि वो आपको एक्टिवेट कर रहा है. In reality, alcohol is CNS depressant, which will bring about changes in cognition, behavior, and motor function. And you have the psychoactive substance present in alcohol is ethanol. You all know that, and it is because of this substance the dependence producing properties and every other changes in brain chemistry or in bodily functions are caused. So when we talk in low doses, alcohol induces euphoria, sociability and relaxation. So might have seen the people around you कि थोड़ा सा अगर स्टार्टिंग में अल्कोहल लेते हैं तो थोड़े फ्रेंडली ज्यादा हो जाएंगे, आपसे खुश होकर बात करेंगे. बट एज सून एज द हायर डोजेज आर टेकन, उनको कॉग्निटिव इम्पेयरमेंट होगा, उनको मोटर डिस्फंक्शन होगा. इन हाई डोजेस पेशेंट कैन इवेंचुअली फॉल अनकॉन्शियस और पास आउट हो जाएगा. ठीक है. सिमिलरली सब्सटेंस यूज डिसऑर्डर की जो डेफिनेशन हमने पढ़ी थी, उसी में अब हम अल्कोहल यूज डिसऑर्डर जोड़ देते हैं. सो पैटर्न ऑफ अल्कोहल यूज विच लीड्स टू सिग्निफिकेंट इम्पेयरमेंट और डिस्ट्रेस. ऑलराइट. बोथ DSM-5 एंड ICD-10 के डायग्नोस्टिक क्राइटेरियाज में हैं, डायग्नोस्टिक गाइडलाइंस में ये आते हैं. ठीक है. DSM-5 में सब्सटेंस रिलेटेड एंड एडिक्टिव डिसऑर्डर्स में, और ICD-10 में मेंटल एंड बिहेवियरल डिसऑर्डर ड्यू टू साइकोएक्टिव सब्सटेंस यूज, F10. आगे बढ़ने से पहले जस्ट बी अवेयर ऑफ फ्यू ऑफ द कॉमन टर्मिनोलॉजीज जो हम अल्कोहल यूज में यूज करते हैं. ठीक है. अब्यूज का टर्म है कोई भी सब्सटेंस अगर आप ले रहे हो, साइकोएक्टिव सब्सटेंस सेल्फ एडमिनिस्ट्रेशन में, जो कि अपने मैनर ऑफ यूज, जो कि बी इट मेडिकल पैटर्न और सोशल पैटर्न, उससे डेविएट कर रहा है. ठीक है. सो यूज ऑफ एनी ड्रग यूजुअली बाय सेल्फ एडमिनिस्ट्रेशन इन अ मैनर that it deviates from approved social and medical pattern. All right. Next is harmful use. Now, their harmful use, this is something you will see commonly in patients. जानते हुए कि इस सब्सटेंस से हमको फिजिकल या मेंटल कोई हार्म हो रहा है, उसके बाद भी कंटिन्यूस यूज रहता है. ठीक है. पैटर्न ऑफ साइकोएक्टिव सब्सटेंस यूज दैट इज कॉजिंग डैमेज टू हेल्थ. द डैमेज कैन बी फिजिकल और मेंटल. नाउ यहाँ पे actual damage has been caused and to the physical and mental health is something which is required, and despite of that the patient continue using the substance. Addiction as given by this definition is given by American Psychiatric Association. It is a treatable chronic medical disease which involves complex interaction among brain circuits, genetic, environment and individual's life experience. So what does it say? एक तो कि ये आपका मेडिकल कंडीशन है. इट इज नॉट अ हैबिट, इट्स अ मेडिकल कंडीशन व्हिच कैन बी ट्रीटेड, एंड इट इन्वॉल्व्स ऑल बायोलॉजिकल, साइकोलॉजिकल एंड सोशल एंड इंडिविजुअल लाइफ एक्सपीरियंसेस. People with addiction use substance in a way that become compulsive and often continue despite harmful consequences. Now, another term is intoxication. Intoxication, you all have seen an intoxicated person. होता क्या है, अभी लिया है, recent use है, थोड़े समय के लिए रहता है और वापस नॉर्मल हो सकता है पेशेंट. सो इट इज रिवर्सिबल ट्रांजिएंट स्टेट ऑफ ऑल्टर्ड कॉन्शियसनेस, बिहेवियर एंड कॉग्निशन ड्यू टू रीसेंट सब्सटेंस यूज. ऑलराइट. अब उसी के ऑपोजिट विड्रॉल में क्या होता है कि पेशेंट ने अभी या तो अल्कोहल लेना या फिर कोई सब्सटेंस लेना या तो कम किया है या फिर बंद कर दिया है. ठीक है. कभी लगातार समय से ले रहा था, उसको अचानक से छोड़ दिया, तो उसकी वजह से जो फिजियोलॉजिकल और साइकोलॉजिकल सिम्टम्स देखने को मिलेंगे वो विड्रॉल. ठीक है. नेक्स्ट इज टॉलरेंस. टॉलरेंस इज अ टर्म, इसका मतलब ये है कि आपको हायर डोज ऑफ सब्सटेंस की नीड पड़ रही है सेम इफेक्ट आने में. ठीक है. द नीड फॉर इंक्रीजिंग डोज ऑफ अ सब्सटेंस टू अचीव द सेम इफेक्ट व्हिच वाज ऑब्टेन्ड फ्रॉम द ओरिजिनल डोज. क्रॉस टॉलरेंस, वही सब्सटेंस का कोई और, मतलब उससे मिलता जुलता कोई और सब्सटेंस जिसका मैकेनिज्म ऑफ एक्शन सेम है, उसकी तरफ भी टॉलरेंस हो गया. फॉर एग्जांपल अल्कोहल और बेंजोडाइजेपिन देख लो. ठीक है. पेशेंट को धीरे धीरे अल्कोहल का टॉलरेंस हो रहा था, तो अल्प्राजोलाम का, एलोराज़ेपम का भी टॉलरेंस डेवलप हो गया. One drug can be substituted by other when tolerance to one substance lead to tolerance to another substance with a similar mechanism of action. This is called cross tolerance. Very important, dependence. Dependence में क्या होता है कि पेशेंट का एक नीड फॉर कंटिन्यूस यूज ऑफ सब्सटेंस रहता है डिस्पाइट नेगेटिव कॉन्सिक्वेंसेज. इसके साथ आपके टॉलरेंस के, विड्रॉल के फीचर्स, अगर आप सब्सटेंस यूज करो, सब कुछ कंबाइन कर दो, जब भी हमने पढ़ा है, तो डिपेंडेंस आ गया. ठीक है. A state in which individual continues substance use despite negative consequences with features of tolerance, withdrawal and compulsive drug seeking behavior. Dependence के क्या क्राइटेरिया होते हैं as per ICD-10 हम पढ़ेंगे आगे. So the definition between difference between tolerance and dependence is something जिसके बीच में आप कंफ्यूज हो सकते हो. तो tolerance क्या है कि आपका अफेक्टिवनेस कम हो गई है. ठीक है ना. और डिपेंडेंस क्या है, रेजिलियंस हो गया टू अवॉइड ड्रग विड्रॉल, कि आपको विड्रॉल सिम्टम ना आए तो उसके लिए आप डिपेंडेंस में सब्सटेंस लेते रहते हो. टॉलरेंस वेरी इंपॉर्टेंट. मैकेनिज्म क्या है, रिसेप्टर जो आपके हैं वो ऑक्यूपाई हो गए हैं, उनमें कुछ मेटाबॉलिक चेंजेस आ गए हैं, और आपका डिपेंडेंस में क्या है, फिजियोलॉजिकल या साइकोलॉजिकल रिजिलियंस बिकॉज ऑफ न्यूरो एडेप्टेशन। डोजेज टॉलरेंस में हायर डोज चाहिए होती है, डिपेंडेंस में ऑलमोस्ट सेम अमाउंट ऑफ डोज में भी इंसान लेकिन मेंटेन करे रहता है। विड्रॉल टॉलरेंस के कंपैरिजन डिपेंडेंस में विड्रॉल ज्यादा सिवियर है। ऑलराइट, नाउ लेट अस सी द एपिडेमियोलॉजी ऑफ अल्कोहल डिपेंडेंस। अल्कोहल कंजम्पशन ओवरऑल ग्लोबली बात करें तो 5.3% ऑफ ग्लोबल डेथ एंड 5.1% ऑफ ग्लोबल डिजीज बर्डन बिकॉज ऑफ अल्कोहल यूज डिसऑर्डर। सो यू माइट सी कि 5% तो है, लेकिन अगर आप पूरे वर्ल्ड की पॉपुलेशन देखें तो दिस 5% बहुत बिग अमाउंट कंट्रीब्यूट करता है। सिमिलरली इंडियन पॉपुलेशन में 14.6% है एंड ओवरऑल 20% ऑफ ऑल द इंजरीज इंडिया में अल्कोहल रिलेटेड डेथ। ठीक है, मोर कॉमन इन मेन बट राइजिंग इन फीमेल इवन इन चिल्ड्रन एंड एडोलेसेंस ये देखने को मिल रहा है। हाँ, छत्तीसगढ़, त्रिपुरा, पंजाब, अरुणाचल प्रदेश एंड गोवा फ्यू ऑफ द स्टेट जहाँ पे हाईएस्ट प्रेवलेंस देखने को मिलती है। So if you see that 14.6% आपका 16 करोड़ यूजर्स अक्यूमुलेट करते हैं इंडिया में। ये आपका एम्स का एक स्टडी हुआ था along with नेशनल ड्रग डिपेंडेंस, आई एम नॉट रिमेम्बरिंग दैट करेक्ट नेम, उसके अंडर हुआ था ये। सिमिलरली कि मेल में, फीमेल में, चिल्ड्रन में कितना डिस्ट्रीब्यूशन है। नाउ वील कम टू इटियोलॉजी। कोई भी सब्सटेंस यूज डिसऑर्डर है या फिर मेंटल हेल्थ डिसऑर्डर तो बायोसाइकोसोशल मॉडल ऑफ जो हेल्थ है यहाँ पे भी वही काम करेगा। बायोलॉजिकल फैक्टर्स की अगर हम बात करें तो you'll have जैसे कि जेंडर में मेल में ज्यादा प्रोमिनेंट है, आपका जेनेटिक प्रीडिस्पोजिशन है, हेरिडिटरी फैक्टर है। फर्स्ट डिग्री रिलेटिव्स ऑफ अल्कोहलिक्स हैव 3 to 4 times हायर चांस ऑफ डेवलपिंग अल्कोहल यूज डिसऑर्डर। अगेन आपका जेनेटिक वेरिएशन है अल्कोहल डिहाइड्रोजनेज या एल्डिहाइड डिहाइड्रोजनेज एंजाइम में। अगर वो मेटाबोलाइज जल्दी कर दे रहा है किसी के तो उनको टॉलरेंस डेवलप होने के चांस ज्यादा हैं। धीरे मेटाबोलाइज कर रहा है तो उनमें क्या बोलते हैं सिम्टोमेटोलॉजी, इंटॉक्सिकेटेड होने के चांसेस ज्यादा हैं। सिमिलरली डोपामिनर्जिक रिवॉर्ड सिस्टम, आपका कोई भी सब्सटेंस है या कोई भी बिहेवियर है एडिक्शन की तरफ जो जाता है उसमें आपका जो रिवॉर्ड पासवे वाला डोपामिन सर्च बहुत जल्दी होती है, इसीलिए आपका ब्रेन उस मेमोरी को याद करते हुए एक मेमोरी सर्किट बना लेगा कि अच्छा मुझे पिछली बार मैंने सब्सटेंस लिया था तो मुझे इतना अच्छा लगा था, तो वो मेमोरी स्टोर हो गई, अगली बार आपको वही हाई के लिए वही सब्सटेंस की जरूरत है। सिमिलरली GABAergic, glutaminergic and opioid systems, endorphin systems are also involved. नाउ साइकोलॉजिकल ट्रेट्स देखें तो जिनका इम्पल्सिव ट्रेट्स है या जिनको सोचा थोड़ा सा नोबेलिटी सीकिंग बिहेवियर है उनमें हायर लाइकली टू अर्ली ऑनसेट के और अल्कोहल डिपेंडेंस में जाने के चांसेस ज्यादा होते हैं। एंजाइटी सीकिंग बिहेवियर है या न्यूरोटिसिज्म है तो खुद को काम डाउन करने के लिए भी थोड़ा अल्कोहल यूज जल्दी ले सकते हैं। ठीक है, स्ट्रेस एंड कोपिंग मैकेनिज्म जो कि बहुत ज्यादा मूवीज या आप सीरियल्स के ज्यादा फ्लॉन्ट हो चुका है कि भैया उदास हो, दुख में हो तो शराब पी लो, भूल जाओगे चीजों को, तो दैट इज ऑल्सो सेल्फ मेडिकेशन हाइपोथेसिस और माल अडेप्टिव कोपिंग का रोल आ गया। वेरी इंपॉर्टेंट इन्वायरमेंटल क्यूज, कहीं किसी के आसपास ही बार है, घर के बगल में ही थोड़ी दो दुकान छोड़ के आपको अल्कोहल अवेलेबल है, आपकी सोशल गैदरिंग ही ऐसी जगह पे हो रही है जहाँ पे अल्कोहल इज वेरी कॉमनली यूज, इनफैक्ट फैमिली एनवायरनमेंट ऐसा है कि भैया बहुत परमिसिव है। ठीक है, तो यहाँ पे आगे सोशल फैक्टर्स में कल्चरल एंड सोसाइटल इन्फ्लुएंस कैसा है, जैसे कि यूरोपियन कंट्रीज में आपका हाई एक्सेप्टेबिलिटी है तो वहाँ पे अल्कोहल यूज भी ज्यादा होगा। सिमिलरली फैमिली एंड peer influence ज्यादा है, adolescent and young adults are influenced by social drinking norms, socio-economic status and stress, financial stress and lack of access to mental health care. Risk is also linked to high stress job and social drinking culture. नाउ विल कम ऑन टू क्लिनिकल फीचर्स, क्या क्या हो सकते हैं। आपको इंटॉक्सिकेशन में फीचर्स मिलेंगे, विड्रॉल में फीचर्स मिलेंगे और डिपेंडेंस में फीचर मिलेंगे। इंटॉक्सिकेशन की अगर हम बात करते हैं तो ड्यू टू एक्सेसिव अल्कोहल कंजम्पशन विच कैन लीड टू डोज डिपेंडेंट फिजियोलॉजिकल एंड साइकोलॉजिकल इफेक्ट्स। माइल्ड में क्या होगा, स्टार्टिंग में अगर अल्कोहल लेते हैं तो हल्का सा अच्छा लगता है, यूफोरिया से गुड फीलिंग, बोलने ज्यादा लगेगा, थोड़ा सा जो इनिबिशन होता है वो कम हो जाता है। ठीक है, सोशलिबिलिटी बढ़ जाएगी, रिलैक्सेशन लगेगा, बट हाँ कोऑर्डिनेशन और अटेंशन रिएक्शन टाइम वगैरह में डिस्टर्बेंसेस आएंगी। सिमिलरली मॉडरेट इंटॉक्सिकेशन होगा तो फिर आपको ज्यादा ले लिया तो फ्लशिंग, किसी में माइल्ड में भी फ्लशिंग दिख सकती है स्किन में, लेकिन किसी में मॉडरेट में दिखती है, स्पीच में स्लरिंग दिखेगी, इम्पेयर्ड मोटर कोऑर्डिनेशन एंड इनअप्रोप्रिएट बिहेवियर एंड मूड चेंजेस। ठीक है, सिवियर में हो गया तो आपका मार्क्ड टेक्सिया एंड कंफ्यूजन, स्ट्यूपरस कंडीशन हो सकती है, ये निस्टेगनस एंड डिप्लोपिया दो दिखने लग गया बोलेगा इंसान। अगेन आपका अल्कोहल रेस्पिरेटरी डिप्रेशन कॉज कर सकता है, हाइपोथर्मिया कॉज कर सकता है, हाइपरटेंशन कॉज कर सकता है। नेक्स्ट विल कम ऑन टू डिपेंडेंस। ठीक है, अभी हमने देखा था कि क्रॉनिक एंड कंपल्सिव अल्कोहल कंजम्पशन लीड्स टू डिपेंडेंस। तो F10.2 में कुछ पॉइंट्स हैं, उसमें से 3 और मोर ऑफ द फॉलोइंग शुड बी प्रेजेंट एट टुगेदर एट द सेम टाइम ड्यूरिंग प्रीवियस ईयर, तो हम डिपेंडेंस है बोलेंगे। ठीक है, आई विल सजेस्ट यू ऑल गो थ्रू ICD-10 टू अंडरस्टैंड कि अल्कोहल यूज डिसऑर्डर के डिपेंडेंस क्राइटेरिया क्या है। तो पहला है आपका स्ट्रॉन्ग डिजायर एंड सेंस ऑफ कंपल्शन। आपका जो अंदर की जो डिजायर है वो कंट्रोल नहीं हो रही है, आपको कंपल्सिव नेचर है ही कि अल्कोहल लेना है। ठीक है, दूसरा आ गया कंट्रोल वाला, डिफिकल्टी कंट्रोलिंग इन सब्सटेंस टेकिंग बिहेवियर इन टर्म्स ऑफ कब शुरू करना है, कब खत्म करना है, कितना लेवल ऑफ यूज, कितना अमाउंट यूज करना है। आपको पता ही नहीं है कि आप मॉर्निंग में नहीं लेना था लेकिन आप मॉर्निंग से ही शुरू हो गए। अच्छा, मैंने 1 पैक के बाद बंद करनी थी लेकिन नहीं, वो 5 पैक ले लिए। ठीक है, कम अमाउंट लेना था और बढ़ा के ले लिया। नेक्स्ट है फिजियोलॉजिकल विड्रॉल स्टेट। ठीक है, कि आपको पता चल रहा है जैसे सब्सटेंस कम कर रहे हो या बंद कर रहे हो तो आपको फिजिकली पता चल रहा है उसके इफेक्ट, ट्रेमर्स आ रहे हैं, पैल्पिटेशन हो रहा है। ठीक है, withdrawal symptoms for substance use or the same or a closely related substance with the intent of relieving or avoiding withdrawal pattern। फिर ये withdrawal state दिख रही है तो आप उसको withdrawal state को रोकने के लिए आप वापस सब्सटेंस ले रहे हो। ठीक है, ये भी आपका डिपेंडेंस पैटर्न में आ गया। एविडेंस ऑफ टॉलरेंस भी इसमें आता है कि नाउ यू आर रिक्वायरिंग हायर डोज टू गेट द सेम इफेक्ट। नेक्स्ट है प्रोग्रेसिव नेग्लेक्ट ऑफ ऑल्टरनेटिव प्लेजर। बाकी किसी चीज में ध्यान ही नहीं है, पहले बच्चा क्रिकेट खेलता था, अब उसमें अच्छा ही नहीं लग रहा है। ज्यादातर टाइम पेशेंट का इंक्रीज अमाउंट ऑफ टाइम कि सब्सटेंस लेना कैसे है, उसे कंज्यूम कैसे करना है। ठीक है, उसके पीने के बाद वापस रिकवरी होने में कितना टाइम लग रहा है उसमें जा रहा है। And sixth is persisting with substance use despite clear evidence of harmful consequences। लेफ्ट इज डिरेंज हो रही लेकिन तब भी पी रहा है, पेशेंट को दिखा दिया, समझ में भी आ रहा है लेकिन फर्क नहीं पड़ रहा है। चोट लग गई, बाइक चलाते चलाते गिर गया था, अंडर इन्फ्लुएंस चला रहा था, या फिर डिपेंडेंस की वजह से कुछ भी हेड इंजरी हो गई या कुछ भी हो गया, लेकिन फिर भी अल्कोहल यूज बंद नहीं हो रहा है। ठीक है, सो ये हो गए आपके डिपेंडेंस के। अब विड्रॉल स्टेट क्या होती है ना, विड्रॉल इज समथिंग थोड़ा सा आपको कॉशियस रहना पड़ेगा। आपके वार्ड में भी पेशेंट जो होते हैं इस स्टेज को मेंटेन करने के लिए होते हैं। अल्कोहल विड्रॉल अकर्स व्हेन chronic alcohol use is abruptly reduced or stopped। Symptoms can appear within 6 to 24 hours after last drink and may peak within 48 to 72 hours। But this is not decided कि इतने टाइम पे होगा, किसी को जल्दी भी आ सकते हैं, किसी को लेट भी आ सकता है। ठीक है, and severity depends upon duration and quantity of alcohol use। Now mild withdrawal 6 to 24 hours post last drink, tremors, hands, tongues और eyelids, ये आपके मेंशन है और जगह भी। ठीक है, तो ये ट्रेमर हल्के से जो माइल्ड विड्रॉल है वो आपका ट्रेमर्स के साथ एंजाइटी, इरिटेशन हो सकता है, नींद में डिस्टर्बेंसेस आ सकती हैं। ठीक है, कुछ जीआई सिम्टम में नोजिया, वॉमिटिंग जैसी चीजें आपको देख सकती है। माइल्ड हाइपरटेंशन, टेकिकार्डिया, ठीक है, मलेज मिल सकता है। ना मॉडरेट टू सिवियर विड्रॉल अगर आ गया तो वेरी इंपॉर्टेंट, कॉम्प्लिकेटेड विड्रॉल जहां पे टर्म है तो आपको याद रखना इसका मतलब है सीजर आया पेशेंट को। ठीक है, आप हिस्ट्री में भी देखते हो कि पास हिस्ट्री तो नहीं है कॉम्प्लिकेटेड विड्रॉल की, यानी कि पहले कभी अचानक से शराब छोड़ी है और उसको सीजर आ गया, तो दिस इज व्हाट इज मेंट बाय कॉम्प्लिकेटेड विड्रॉल। इसके बाद ऑटोनोमिक हाइपर एक्टिविटी बहुत मार्क्ड होती है सिवियर विड्रॉल में। ठीक है, इंक्रीज एंजाइटी, एजिटेशन, इरिटेबिलिटी। और उसी का ही आगे वाला फॉर्म है जिसको हम डीटी या डेलीरियम ट्रेमेंस बोलते हैं। ठीक है, सिवियरिटी से वाला आगे वाला फॉर्म। तो दिस इज अ वेरी इमरजेंसी वाली जो कंडीशन है, मोस्ट ऑफ द टाइम डीटी के पेशेंट्स को आईसीयू एडमिशन, ठीक है, और इंटेंसिव केयर यूनिट जिसको हम बोलते हैं वो लगता है। अगर ट्रीट नहीं होगा तो हाई चांसेस ऑफ मोर्टेलिटी होता है, पेशेंट डू डाई अगर आप डेलीरियम ट्रेमेंस को नहीं ट्रीट करोगे तो। ठीक है, इंपॉर्टेंट चीज याद रखनी है, 3 चीजें स्टार्टिंग की दे रखी है। डेलीरियम विद फ्लक्चुएटिंग कॉन्शियसनेस, डेलीरियम में होता ही फ्लक्चुएटिंग कॉन्शियसनेस है। मार्क ट्रेमर्स, हेलुसिनेशन, स्पेशली टेक्टाइल या फिर आपका विजुअल हेलुसिनेशन। आपको पेशेंट अपने अपने पिकिंग, स्किन पिकिंग जैसा कुछ करता रहेगा या फिर कोई थ्रेड पिकिंग करता रहेगा। विजुअल में आपको लिलिपुटियन हेलुसिनेशन कि छोटे छोटे लोग दिखाई दे रहे हैं कुछ, ये कॉमन होता है। ठीक है, प्रोफाउंड ऑटोनोमिक हाइपर एक्टिविटी, hyperthermia, severe hypertension, arrhythmias, high mortality risk if not treated। Okay, patient with alcohol dependence are also at higher risk for medical complication जैसे कि cirrhosis हो गया, liver हो गया cirrhosis, pancreatitis, neuropathy and Wernicke's Korsakoff psychosis याद रखनी है। ठीक है ना, and associated psychiatric comorbidities। बर्निकेज और कॉर्सोकॉफ में चीजें याद रखिए। वर्निकेज में आपका क्या क्या सिम्टम होते हैं? कंफ्यूजन, अटेक्सिया एंड ऑप्थेल्मोप्लेजिया। थायमीन डेफिशिएंसी याद रखनी, तभी जब भी अल्कोहल के पेशेंट होता है तो हम थायमीन देते हैं। सिमिलरली कॉर्सोकॉफ में आपका एमनेजिया, रेट्रोग्रेट एमनेजिया, ठीक है, एंटेरोग्रेट एमनेजिया एंड कन्फेबुलेशन, जो मेमोरी गैप आया उसमें कोई कहानी बना के देंगे, ठीक है, कॉर्सोकॉफ सिंड्रोम आ गया। So how you are going to evaluate the patient? So history taking in the terms of कि आपका कब onset है, क्या duration है, frequency कितनी है, कितनी quantity में ले रहा है, कोई और साथ में binge drinking pattern तो नहीं है, withdrawal के symptom है, past history of complicated withdrawal तो नहीं है, tolerance कैसे develop हुआ है, associated कोई और symptoms, comorbid psychiatric या physical illness तो नहीं है, कोई और substance तो नहीं लेता है, स्पेशली आपके पर्सनल या प्रीमॉर्बिड कंडीशंस कैसी थी, बिहेवियर पैटर्न कैसा था सब्सटेंस लेने से पहले, नोबेलिटी सीकिंग बिहेवियर या सब तो नहीं था, एंड वेरी इंपॉर्टेंट इज लीगल हिस्ट्री, ठीक है, अंडर द इन्फ्लुएंस या कुछ विदाउट इन्फ्लुएंस भी कोई लीगली किसी केस में फंसा है कि नहीं फंसा है ना। नाउ कॉन्सिक्वेंसेस लाइक मेडिकल में लिवर डिजीज, न्यूरोपैथी तो नहीं है, डिप्रेशन, एग्रेशन या सोशल लीगली ऑक्यूपेशनल इश्यूज तो नहीं है, फैमिली हिस्ट्री देखनी है कि जेनेटिक प्रीडिस्पोजिशन या कोडिपेंडेंस तो नहीं है फैमिली में, प्रीवियस ट्रीटमेंट अटेम्प्ट कैसे रहे हैं। फिजिकल एग्जामिनेशन में आपको वाइटल्स चेक करने हैं, डिहाइड्रेशन देखना है, इक्टेरिस देखना है, ठीक है, जॉन्डिस होने के चांस तो नहीं है। न्यूरोलॉजिकल एग्जामिनेशन थोड़ा कॉमन हो जाता है आपका यहाँ पे, अटेक्सिया, निस्टैग्मस, कंफ्यूजन, मेमोरी इंपेयरमेंट। जीआई में आपको अल्कोहल के साथ एसोसिएटेड हिपैटोस्प्लीनोमेगैली को चेक करना है, और सीवीएस रेसिपी भी अपने आप में इंपॉर्टेंट है। मेंटल स्टेटस एग्जामिनेशन की अगर हम बात करें अल्कोहल यूज पेशेंट में, अगर इंटॉक्सिकेटेड स्टेट में है या गलत स्टेट में आया हुआ है तो आपका पेशेंट डिसेबल्ड हो सकता है, ट्रेमुलस, इरिटेबल हो सकता है, या फिर पेशेंट आपका अगर डीटी के उसमें आया है तो डेलीरियस पेशेंट भी आ सकता है, ठीक है। साइकोमोटर एक्टिविटी डिपेंडिंग अपॉन इंटॉक्सिकेटेड स्टेट में ज़्यादा भी हो सकती है, कम भी हो सकती है, ठीक है। स्पीच में अगर हम देखेंगे तो स्लरिंग है, प्रेशर्ड है, मूड इफेक्ट अगेन डिपेंडिंग ऑन द करंट कंडीशन कैसी है पेशेंट की। थॉट में डिसऑर्गेनाइज थॉट है, डिल्यूजन है, डिल्यूजन ऑफ इनफिडेलिटी विच इज क्वाइट कॉमनली सीन विद पेशेंट्स, ठीक है, ये आपने ऑफ क्रोनिक अल्कोहल यूज। परसेप्शन में आपको बताया मैंने, ऑडिटरी, टैक्टाइल, विजुअल हेलुसिनेशन। कॉर्सोकॉफ वगैरह में आपको मेमोरी डेफिसिट और इन सब पे भी ध्यान देना है। इंसाइट एंड जजमेंट बेसिकली आपका बिकॉज ऑफ अल्कोहल यूज इम्पेयर्ड रहती है। नेक्स्ट इज योर मोटिवेशन विच इज समथिंग, आपको अल्कोहल के पेशेंट में सब्सटेंस यूज किया, बिहेवियरल एडिक्शन भी है उसके पेशेंट में, मोटिवेशन देखना है, ठीक है। मोटिवेशन के जो फेजेस हैं वो देख लीजिए। प्री कंटेम्पलेशन फेज की कोई पता ही नहीं है, इंटेंशन ही नहीं है छोड़ने की, आप रियलाइज ही नहीं कर रहे हैं कुछ चीज गलत हुई है। कंटेम्पलेशन अवेयर है प्रॉब्लम एग्जिस्ट कर रही है बट कुछ एक्शन या कुछ नहीं करना है। प्रिपरेशन में नाउ वी आर प्रिपेयरिंग अवरसेल्फ, हाँ मैं चलो डॉक्टर को दिखा के लाता हूँ, हाँ चलो मैं कोशिश करता हूँ छोड़ने की। एक्शन इज एक्टिवली आप इन्वॉल्व, डॉक्टर को दिखा रहे हो, सब्सटेंस यूज कर दूर रह रहे हो, जो जो चीजें बोल रहा है वैसे हेल्दी डाइट ले रहे हो, एंड मेंटेनेंस में उस चीज को मेंटेन करके रख रहे हो, ठीक है। उसके बाद आता है रिलैप्स विच इज ऑल्सो वेरी कॉमन, ठीक है। अगर आप लॉन्ग टर्म मैनेजमेंट पे नहीं ध्यान दोगे, पेशेंट का रिलैप्स प्रिवेंशन स्ट्रेटेजीज पे नहीं ध्यान दोगे तो ये प्रॉब्लम हो सकते हैं। ऑलराइट, कुछ स्केल है, केज क्वेश्चन है, आप लोगों ने नाम सुना होगा कि आपका डिपेंडेंस के लिए यूज करते हैं, कट डाउन, अनॉइड, गिल्टी, आई ओपनर तो नहीं है। ऑडिट है अल्कोहल यूज डिसऑर्डर आइडेंटिफिकेशन टेस्ट, सीवा स्कोर है, सिवियरिटी ऑफ अल्कोहल डिपेंडेंस क्वेश्चन है। अगेन इन्वेस्टिगेशन पार्ट आए तो आपको ब्लड इन्वेस्टिगेशन तो कराने ही है, ब्लड अल्कोहल लेवल और ब्रेथ अल्कोहल एनालाइजर, दोनों की दोनों चीजें, बहुत जगह ब्रेथ अल्कोहल एनालाइजर यूज करते हैं स्पेशली ड्राइविंग वगैरह के लिए, ठीक है। लिवर फंक्शन टेस्ट, आपका गामा जीजीटी बहुत ज़्यादा हाई हो जाता है अल्कोहलिक पेशेंट के, उसमें एएसटी एलटी रेशियो कॉम्प्रोमाइज्ड है। सीबीसी टू सी कोई अनीमिया, थ्रोम्बोसाइटोपिनिया जैसी चीज़ें तो नहीं हो रही हैं, ठीक है। इलेक्ट्रोलाइट हाइपोकैलेमिया, मैग्नीशियमिया, हाइपोग्लाइसीमिया तो नहीं है, हाइपोनेट्रीमिया तो नहीं है बिकॉज ऑफ कॉम्प्रोमाइज्ड आपका हाइड्रेशन स्टेटस, थायमीन की डिफिशियंसी तो नहीं है। देन आपका यूरिन ड्रग एनालिसिस की कोई और सब्सटेंस कोमॉर्बिड कोई और सब्सटेंस तो नहीं ले रहा है। देन ईजी, एमआरआई, सीटी स्कैन टू रूल आउट कोई न्यूरोलॉजिकल कॉम्प्लिकेशंस तो नहीं आई है। ऑफ कोर्स यूएसजी एब्डोमेन एंडोस्कोपी बिकॉज ऑफ अल्कोहल इंड्यूस आपको गैस्ट्राइटिस, गैस्ट्रिक अल्सर या पेप्टिक अल्सर ऐसा कुछ तो नहीं हो रहा है, ठीक है। इसोफेजियल अल्सर्स तो नहीं हो रहे, ईसीजी टू रूल आउट कार्डियक एनोमली तो नहीं है। डिफरेंशियल डायग्नोसिस में हाइपोग्लाइसीमिया की वजह से भी कभी कभी स्लर्ड स्पीच या इंटॉक्सिकेटेड जैसा स्टेज लगता है, ठीक है। हाइपोथायरॉइडिज्म, हेपेटिक इंसेफेलोपैथी में आप हाइपरथायरॉइडिज्म में पेशेंट थोड़ा एक्टिव हो सकता है, हेपेटिक इंसेफेलोपैथी या यूरेमिक इंसेफेलोपैथी में भी पेशेंट का बिहेवियर थोड़ा ऑल्टर्ड हो सकता है, ठीक है। डिलीरियम फ्रॉम मेडिकल कॉजेज तो नहीं है, ये रूल आउट करना है। सीजर डिसऑर्डर या ट्रॉमेटिक ब्रेन इंजरी अदर देन अल्कोहल कोई और कॉज की वजह से तो नहीं है। इरिटेशन बाइपोलर डिसऑर्डर के साथ तो नहीं है, कोई अदर सब्सटेंस यूज है, जीएडी तो नहीं है। मैनेजमेंट में अगर हम देखें तो आपका एक्यूट मैनेजमेंट करेंगे, विड्रॉल मैनेजमेंट, ट्रीटमेंट, रिलैप्स प्रिवेंशन है, कुछ साइकोसोशल इंटरवेंशन है। एक्यूट मैनेजमेंट में पेशेंट से पहले आपको पेशेंट को स्टेबल रखना है, ठीक है। तो एबीसी मेंटेन करके रखना है पेशेंट का। मॉनिटर वाइटल एयरवे प्रोटेक्शन इफ नीडेड, आईवी फ्लूइड करेक्ट करोगे, डिहाइड्रेशन अगर कोई इलेक्ट्रोलाइट इम्बैलेंस है उसे करेक्ट करोगे, थाइमीन दोगे पेशेंट को, और उसके बाद ग्लूकोज ट्रांसफर, ठीक है, डीएनएस देते हो। देन आपका बेंजोडाइजेपिन ड्रग ऑफ चॉइस फॉर आपका विड्रॉल मैनेजमेंट, लोराज़ेपाम हो गया या फिर आप डाइजेपाम दे रहे हो, क्लोडाइजेपोक्साइड दे रहे हो। डोज डिपेंडेंट होना चाहिए पेशेंट, ये डिपेंड करता है कब लास्ट इंटॉक्सिकेटेड कब था और कितने अमाउंट ऑफ अल्कोहल ले रहा था, उस हिसाब से आपको टाइट्रेट करनी है बेंजोडाइजेपिन की डोज, ठीक है। देन विड्रॉल में थाइमीन का रोल तब भी आता है। लो डोज एंटीसाइकोटिक्स स्पेशली हेलोपेरिडोल और लाज़ेपिन अगर बहुत सीवियर एजिटेशन है, एसोसिएटेड आपके जो भी हेलुसिनेशन वगैरह है वो नहीं जा रहे हैं बेंजोडाइजेपिन के बाद भी, तो आप लो डोज एंटीसाइकोटिक्स दे सकते हैं। बीटा ब्लॉकर हो गया या फिर आपका क्लोनिडिन हो गया, ऑटोनॉमिक इंस्टेबिलिटी को रूल आउट करने के लिए, ठीक है। कभी कभी आप एंटी एपिलेप्टिक्स में एज अ मूड स्टेबलाइजर एंटी एपिलेप्टिक वैल्प्रोएट और कार्बामेज़ेपिन भी दे देते हो विड्रॉल के बाद में, थोड़ा लेट रूल आता है इसका, ठीक है। और कोई को-ओकरिंग साइकियाट्रिक इलनेस है तो उसको देखना है, ठीक है। नाउ वी हैव रिलैप्स प्रिवेंशन एंड लॉन्ग टर्म मैनेजमेंट। तो आपको कुछ ऐसी दवाइयां भी देनी पड़ेंगी जो कि या तो पेशेंट का जो रिवॉर्डिंग इफेक्ट है अल्कोहल लेने का उसकी वजह से वो हाई ना महसूस हो, तो आपको जैसे ओपियोइड एंटागोनिस्ट में नैल्ट्रेक्सोन, इट रिड्यूसेस क्रेविंग एज वेल एज रिवॉर्डिंग इफेक्ट। सेम सिमिलरली एक्म्प्रोसेट का भी आपका एब्सटिनेंस में मेंटेनेंस में रोल है, ठीक है। बैक्लोफेन की बात करें, ये भी क्रेविंग कम करता है। बैक्लोफेन वैसे तो आपका कैसे क्यों क्यों यूज में आया था बैक्लोफेन, पहले किसी को आइडिया है? चलो पढ़ के आना, बताना मुझे, ठीक है। डाइसल्फिराम इज समथिंग विच इज एवर्जन थेरेपी में यूज करते हैं, ठीक है। सो जो डाइसल्फिराम है इसके साथ होता यह है कि इसके साथ अल्कोहल अगर लेता है तो पेशेंट उसको वॉमिटिंग आ जाना या उसके क्या बोलते हैं फेस में फ्लशिंग हो जाना, ये सब चीजें होती हैं। बट प्रॉब्लम ये आती है कि लोग इसको कोवर्टली देते हैं, यानी किसी का आपने देखा होगा वाइफ, बहुत सारी वाइफ कहती है कि हस्बैंड के खाने में दवाई मिला देती हूँ और तब से उसका पीना बंद हो गया। प्रॉब्लम ये आती है कि सिर्फ अल्कोहल जिसके साथ एसोसिएटेड, जैसे कोई कफ सिरप ही क्यों नहीं है, कोई और आर्टिकल है जिसमें थोड़ा अमाउंट ऑफ अल्कोहल होगा तो उससे भी रिएक्ट कर जाता है और इसके साइड इफेक्ट्स बहुत सिवियर भी हो सकते हैं, ठीक है। तो पेशेंट आइडियली इस पेशेंट से कंसेंट लेकर कि इस दवाई के हार्मफुल इफेक्ट ये हैं, आप इनके साथ अल्कोहल लेंगे तो आपको ये साइड इफेक्ट्स हो सकते हैं, और पूरा एक वर्कअप कराने के बाद डाइसल्फिराम शुरू करनी चाहिए, ठीक है। साइकोसोशल इंटरवेंशन में आपका मोटिवेशन एनहांसमेंट थेरेपी है, ठीक है। इट स्ट्रेंथन्स पेशेंट्स मोटिवेशन टू क्विट। सीबीटी में का भी रोल है, बट एमईटी या मोटिवेशनल दूसरा मोटिवेशनल इंटरवेंग है, इनको ज्यादा प्रेफर किया जाता है। फिर ग्रुप थेरेपी जैसे अल्कोहल एनोनिमस ग्रुप है, यहाँ पे 12 स्टेप प्रोग्राम होता है। एंड ऑफ कोर्स फैमिली थेरेपी टू एड्रेस की कोई फैमिलियल इशू तो नहीं है जिसकी वजह से ले रहा है, कोई कोडिपेंडेंस तो नहीं है अल्कोहल के साथ साथ, सोशल सपोर्ट कैसा है इन सब चीजों में। Then lifestyle modification and rehabilitation is very important. Maintaining a good healthy diet, regular sleep and exercise, and vocational rehabilitation and reintegration into the society. एक बार पेशेंट अगर ठीक हो गया, रिहेबिलिटेशन और reintegration से एक सोशल लाइफ सही हो जाती है, स्टेबलाइज हो जाती है, वो अपने लिए अर्न करने लगता है, एक सेंस ऑफ कॉन्फिडेंस भी लाइफ में आता है, ठीक है। Public awareness, policy intervention and community support are necessary to reduce alcohol related harm and promote healthier lifestyles. All right. So to conclude, we have seen alcohol disorder major public health problem है, social health problem है, आपका सारा बायोसाइकोसोशल मॉडल ऑफ जो मेंटल हेल्थ डिसऑर्डर है यहाँ पे कैसे काम करता है, क्या एसोसिएटेड कॉम्प्लिकेशन है, चाहे वो लिवर डिसऑर्डर पे हो, कार्डियोवैस्कुलर सिस्टम पे हो, न्यूरोपैथिक जो कंडीशंस प्रॉब्लम करती है. So evaluation and management at earliest, keeping in mind the long-term management as well as the point which should be keep in mind. Okay. With this, I'll conclude. Thank you so much. So if you have any questions, you
So good afternoon to all. So we are going to learn about the bipolar affective disorder or mood disorders Under this session, we will cover mania, depression, bipolar. So few points regarding the history of affective disorder. The first record of bipolar disorder in medical text goes back to Hippocrates in 400 to 300 BC, a doctor from ancient Greek known as father of the medicine. Hippocrates referred to deep sadness as melancholia. The word melas means black and chole means bile. So it is translated to black bile. And he believed that mania was caused by excess of yellow bile. So these are two poles in bipolar disorder. One is known as depression and another one is mania. Another Greek doctor, Aretius of Cappadocia, is recognized for introducing the idea of mood spectrum. He also identified the melancholia and mania were linked to issues in the brain, not in the bile. Both Hippocrates and Aretius distinguished between these types and argued that melancholia and mania were biological conditions rather than just psychological conditions. In 1854, Julius Farlet describes the cycles of depression and mania in his literature, Jolie Circulaire. In 1882, German psychiatrist Karl Kahlbaum defined the term cyclothymia and linking mania and depression as the part of same illness. He considered depression not as a separate illness and the mania as not the separate illness but as a spectrum of a one disorder. In 1899, Emil Kraepelin expanded on the ideas of earlier French and German psychiatrists, defining manic depressive psychosis with criteria that are still used today and as diagnosed as bipolar 1 disorder. Kraepelin also noted that manic depressive psychosis was different from dementia precox. Dementia is an illness of older age, and uh, the dementia precox word was meant for dementia which has an early onset of illness, which means precox. So he differentiated manic depressive psychosis from dementia precox because it did not lead to a mental decline. In case of schizophrenia, there is a progressive decline. In the dementia also there is a progressive decline, but this is not in the case of manic depressive psychosis. There are episodes of mania and depression, and in between the episodes there is a period of normalcy. He also described a type of depression called involutional melancholia. So a mood disorder is a mental health issue that mainly impacts the mood. It is a condition where you go through a long times of very high happiness and very deep sadness, or sometimes both. Some mood disorders also include other strong feelings like anger and irritability. Mood disorders, previously called as affective disorders, are now preferred because they describe long-lasting emotional state. What is affect? Affect is an immediate expression of emotion which one can observe at the cross-sectional point of time. But in case of disorder, this is a pervasive change in the mood. So it is called as mood disorder rather than affective disorder. By definition, mood can be defined as a pervasive and sustained emotion or feeling tone that influences a person's behavior and colors his or her perception of being in the world. So terminology used in context of bipolar disorder or mood disorder are depression, mania, hypomania, bipolar, unipolar disorder or recurrent depressive disorder, dysthymia and cyclothymia. You can see in the graph there is a period of euthymia, means all the emotions are within the normal range, and further there is a fluctuation of mood to the above side and downside, but not crossing the limit of mania and depression. And this can be considered as mixed episode where both manic features and depressive features are uh, happening together. This is another graphical representation of unipolarity and bipolarity. In unipolar depression, uh, there are only episodes of depression or dysthymia, and this can be a single episode, a recurrent episodes, or dysthymia. Dysthymia means uh, subtle symptoms of depression are present, but not up to the threshold of depressive disorder. In bipolar disorder, one can have bipolar 1 disorder, bipolar 2 disorder, cyclothymia, or unipolar hyperthymia. In bipolar disorder, one can have either manic episodes or depressive episodes also. But in unipolar disorder, there are only depressive or dysthymic episodes. Now coming to the epidemiology, incidence and prevalence. Lifetime prevalence rate of depressive disorder ranges from 5 to 17% and average is 12%. Lifetime prevalence means in the whole life, 5 to 17% of patients can have depressive episodes. Lifetime prevalence of bipolar 1 disorder is 0 to 2.4%, bipolar 2 disorder is 0.3 to 4.8%, and for hypomania, this is 2.6 to 7.8%. Among the gender, women are about twice as likely as men to experience major depressive disorder. Bipolar disorder affects men and women equally. However, men tend to experience more manic episodes, while women are more likely to have depressive episodes. When women do have manic episodes, they often shows a mix of mania and depression. In females, the abundance of mixed episodes are there. Additionally, women are more frequently rapid cyclers. Rapid cyclers means if a person is having more than 4 episodes of either of mania or depression in the whole previous year. As per the age, bipolar 1 disorder usually starts earlier than the major depressive disorder. It can begin in childhood, sometimes as young as 5 or 6 years old. Manic episodes in older people are rare instances and with an average of starting age of 30 years. In contrast, depressive disorder typically begins around 40 years of age, with half of the case starting between 20 and 50 years of age. It can also start in childhood or later in the life, but most common is the middle age. Regarding the marital status, major depressive disorder is more common in people who lack close relationships and in those who are divorced or separated. So social support is important as a causative factor of major depressive disorder. Bipolar 1 disorder is seen more frequently in divorced and single individuals compared to the married ones. But this may be due to the early onset of the disorder and the marital problems that follow after developing the bipolar disorder. In socioeconomic and cultural factors, there is no link between socioeconomic status and major depressive disorder. However, bipolar 1 disorder is seen more often in higher socioeconomic groups. People with bipolar 1 disorder are less likely to have graduated from college, which may relate to the younger age of onset at which the disorder typically starts. Depression occurs more frequently in rural areas than in the cities. The rate of mood disorder is similar across the different races. Still, there is a tendency for doctors to miss mood disorder and mistakenly diagnose schizophrenia in patients of different racial or cultural backgrounds. In etiological factors, There are mainly two types of factor. One is biological factor, another is psychological factor, and third one is social factor. In biological factors, there are biogenic amines, and out of the biogenic amines, norepinephrine and serotonin are the two neurotransmitters most implicated in pathophysiology of mood disorder. The downregulation or decreased sensitivity of beta adrenergic receptors in the brain and clinical antidepressant response in reversal is in the favor of this biogenic amine theory. Low levels of serotonin can lead to depression. Some patients who have suicidal thoughts showed reduced amount of serotonin metabolites in the cerebrospinal fluid and fewer serotonin uptake sites on the platelets. Dopamine thought to be involved as well. Research indicates that the dopamine levels might be lower in depression and higher in mania. What are the biogenic amines? Biogenic amines are norepinephrine, serotonin, and dopamine. Other neurotransmitters which are involved are choline, which help produce acetylcholine, have been found in the brains of some patients with depression during autopsy. Agonist of acetylcholine can cause tiredness, lack of energy, slowed movement in healthy people, worsen symptoms in depression, and lessen symptoms in mania. So this have been seen with the choline levels. Lower levels of GABA receptors have been seen in plasma, CSF, and brain tissue in those with the depression. Glutamate may work with the high cortisol levels to contribute to the harmful cognitive effects of severe recurrent depression. New evidence indicates that drugs blocking NMDA receptors may have antidepressant effects. Lots of neurotransmitters are involved. Other biological factor may be second messengers and intracellular cascade system. When some neurotransmitter attach on the receptor of that neurotransmitter, this is followed by a cycles of chemical reactions, which is as follows. A cascade of membrane bound and intracellular process mediated by second messenger system. Enzyme inside the cell like adenylate cyclase, phospholipase C and phosphodiesterase cause creation of second messengers like cyclic AMP and cyclic GMP. There is also growing evidence that mood destabilizing medication affect G protein and other second messengers. Now, what about the hormonal regulations? The activity of gene responsible for producing brain-derived neurotrophic factors, which is known as BDNF, decreases after prolonged stress. High activity of HPA axis is a key feature of stress. The presence of high cortisol level in depression indicates possible central issues because of the cortisol. About 5 to 10% of individuals assessed for depression may have previously unnoticed thyroid issues. Thyroid issues can be there. Lower levels of somatostatin in CSF has been noted in depression, while higher levels are seen in manic episodes. Additionally, a reduced prolactin response to a certain serotonin agonist have been observed, which is rare in premenopausal women, indicating that estrogen may play a role in the response of the drug. Now coming to the psychosocial factor, life events and environmental factors or environmental stress can be a causative factor for depression. For example, infections, especially intrauterine infections, and most implicated infection is rubella infections during the pregnancy. Maternal smoking during the pregnancy. There is 2.5-fold higher risk of bipolar disorder in offsprings delivered by planned cesarean. Climate also have role. For example, seasonal affective disorder are there seen in some patients that the episodes usually occur in a particular season, and seasonal effects supposedly influence the regulation of mood. A history of childhood trauma is common in mood disorders. Life events like bereavement, interpersonal problems, financial crisis, work related problems, failure, and job loss also have implication in development of mood disorder. Social support may trigger or alter the course of illness and the severity. In psychosocial factor, there are personality factors also. Personality disorders like obsessive compulsive personality disorder, histrionic or borderline personality may be at the greater risk for depression. Patients with dysthymic disorder and cyclothymic disorder are at risk for later developing major depression or bipolar 1 disorder. Psychodynamic factors. The dynamics of life, how the dynamics can affect the development of affective disorders uh, is expanded by Carl Abraham and founded by the Sigmund Freud. This theory involves four key points. One is disturbance in infant-mother relationship during the oral phase, uh, means the first 10 to 18 months of life, predisposed to subsequent vulnerability to depression. Depression can be linked to real or imagined object loss. Introjection of the departed object is a defense mechanism invoked to deal with the distress connected with the object loss. So this theory you must have learnt in the psychology lectures if you have gone through the uh, psychology part, and the lecture may be taken in further sessions regarding the psychodynamic factors. The fourth one is because of lost object is regarded with a mixture of love and hate. Feeling of anger are directed inward at the self. The anger directed towards the self means the person has developed self-harming tendency or suicidal tendencies. Melanie Klein viewed depression as a way of showing anger towards those we care about. Edward Bebring saw depression as arising when someone realizes that they cannot achieve their very high ideals. Edith Jacobson compared depression to a child who feels weak and helpless, suffering at the hands of harsh parent. Silvano Ariti noted that many people with depression have focused their lives on others instead of themselves. John Bowlby thought that early emotional wound and traumatic separation in childhood make a person more likely to experience depression. Now, what happens in mania psychodynamically? This is considered as a defense against underlying depression. Abraham believed that the manic episode may reflect an inability to tolerate a developmental tragedy such as loss of a parent. A manic state can happen when a harsh superego causes extreme self-criticism, which is then swapped for a feeling of great self-satisfaction. Bertram Levin saw the manic patient's ego as a being overpowered by strong desires like sex or by feared urges like aggression. Melanie Klein also thought of mania as a way to defend against depression, using manic defenses like feeling all powerful, where the person believes they are much greater than they really are. Other formulations of depression are cognitive theory given by the Aaron Beck, which has 3 points. One is views about self as a negative self-percept, about the environment, a tendency to experience the world as a hostile and demanding, about the future, the expectation of suffering and failure. Now come to the diagnosis. So we have discussed that there are two poles, one is mania, one is depression. We will start with the clinical features and aspects of depression. Depression can have single episode, which is categorized as mild depressive episode, moderate depressive episode, severe depression with or without psychotic symptoms as per International Classification of Diseases, 10th version. Regarding the stability of diagnosis of depressive disorder, 25 to 50% of patients were later reclassified as having a different psychiatric condition or a non-psychiatric medical condition with psychiatric symptoms. So in the follow up or in the future, the diagnosis may change. For example, if a person is having a first episode at this point of time, the diagnosis will be depressive episode or depressive disorder. And in future, she may have manic episode, then the diagnosis will be changed to bipolar disorder. If the person is having two subsequent consecutive depressive episodes, the diagnosis will be recurrent depressive disorder. Okay. By the time diagnosis may be changed. Now, the clinical features of depression, there are two types of features. One is core symptoms or major symptoms. Another is minor criteria. In the major symptoms, there is depressed mood, loss of interest and enjoyment or anhedonia, reduced energy leading to increased fatigability and diminished activity, marked tiredness after only slight effort is common. So these are the three main features. Out of three, one must be present to say the person is having depressive episode. The minor criteria are reduced concentration and attention, reduced self-esteem and self-confidence, ideas of guilt and unworthiness, even in the mild type of episode, bleak and pessimistic view of future, ideas or acts of self-harm and suicide, disturbed sleep, and diminished appetite. So out of these symptoms, there are three grades of severity, and the duration of at least 2 weeks is required for diagnosis. But shorter period, when usually the symptoms are severe and of rapid onset, can be diagnosed as a depressive episode before the 2 weeks also. The characteristic of symptoms are the lowered mood varies little from day to day. This means this is pervasive and long lasting and is often unresponsive to circumstances. If there is a incidence of happiness in the family, the mood will be remain low and intensified. Yet may show a characteristic diurnal variation as the day goes on. Within the day, the person can have diurnal variation of mood, having intensified lowered mood in the morning time, and by the day goes on, the mood improves by the evening. Anxiety, distress, and motor agitation may be more prominent at times. Mood change may also be masked by added features such as irritability. Irritability can mask the depressed mood. Excessive consumption of alcohol can also mask the symptoms. Histrionic behavior, exacerbation of pre-existing phobic or obsessional symptoms, or by hypochondriacal preoccupations, the symptoms may be seems masked. There are the symptoms of special clinical significance, such as lack of emotional reactivity to normal pleasurable surroundings and events. Uh, Walking in the morning 2 hours or more before the usual time, the routine may be changed. Depression worse in the morning, this is diurnal variation. Objective evidence of definite psychomotor retardation or agitation. There may be marked loss of appetite, and because of this, the person can have weight loss also, often defined as 5% or more of body weight is lost in past 1 month. Marked loss of libido may be there. We had discussed about the psychotic symptoms in depression, like severe depression with psychotic symptoms. What are the psychotic symptoms? Psychotic symptoms are classified as delusions, hallucinations, marked psychomotor retardation, agitation, and catatonia. In delusion, common themes of mood congruent delusion includes delusion of guilt, delusion of persecution, punishment, personal inadequacy, or disease may be present in case of severe depression with psychotic symptoms. Hallucinations are usually transient and limited to single words or short phrases, and generally saying things consistent with the patient's depressed mood. So mood congruency is there. Psychomotor retardation, it means that a person thinks more slowly or moves less. This can lead to noticeable delays in physical and emotional reactivity, such as in their speech and feelings. In agitation, example includes restlessness, tapping starting and ending tasks abruptly, fidgeting, pacing, hand wringing, fast talking, racing thoughts, crowded thoughts, moving objects for no reasons may be signs of marked psychomotor agitation. In catatonia, there are a set of motor symptoms like posturing, masked faces, and excitement. So catatonia is also considered as psychotic symptoms. In severity of depression, one can have mild, moderate, or severe episode. In mild depressive episode, one can have two major core symptoms of depression and two minor symptoms. In moderate, this may be two plus three minor symptoms or four minor symptoms. In severe case of depressive episode, it shows considerable distress or agitation unless retardation is marked feature. Loss of self-esteem or feeling of uselessness or guilt are likely to be prominent, and suicidal tendency may be present. We had talked about the melancholic features, melancholic depression. The features of melancholic depression characterized by severe anhedonia, early morning awakening, weight loss, and profound feelings of guilt, often over trivial events. Suicidal ideation, suicidal tendency is not uncommon in melancholic depression. It is associated with changes in autonomic nervous system and endocrine functions. Melancholia is sometimes referred to as endogenous depression, which means depression that arises in absence of any external life stressor or precipitants. There is a term called as depression with atypical features. The atypical features can be significant increase in appetite. We had learned that there is a loss of appetite, but in atypical depression, significant increase in appetite may be seen. Oversleeping or hypersomnia may be there. Latent paralysis, where your arms and legs feels heavy, may be the feature. A long-term pattern of rejection sensitivity, when you interpret ordinary or slightly negative social cues as rejection. So these symptoms have sometimes been referred to as reverse vegetative symptoms, and the symptom pattern has sometimes called hysteroid dysphoria. Clinical presentation, the patient may present with the feelings of hopelessness, worthlessness. Patient may be unable to cry, may be having suicidal tendencies. Sometimes they do not complain of mood change. They do not acknowledge their mood is low or depressed, although they are withdrawn from family, friends, and activities that can be observed by the others. Complaints of low energy, difficulty completing tasks, deterioration at school and work, and low motivation to start new projects may be the chief complaints or presenting complaints. Trouble sleeping, especially early morning awakening. Terminal insomnia is there. Multiple awakening in between the sleep may also be there. Anxiety is a frequent sign of depression and impacts up to 90% of people with depression. The patient may not present with the core symptoms. The patient may present with the symptoms of anxiety. So you have to find out whether the patient is having depression or anxiety disorder. Other vegetative symptoms include abnormal menses and decreased interest and performance in sexual activities. In children and adolescents, the features may be different from adults. The features may be school phobia. Strong attachment to parents can indicate depression in children. In teenagers, signs of depression may include low grades in school, drug use, antisocial behavior, risky sexual activity or sexual promiscuity, skipping school, and running away from the home. In older adults, depression is more frequent in older adults compared to the general population, and prevalence rate can range from 25% to near 50%. Studies suggest that factors like low socioeconomic status, losing a spouse, having a physical illness, and social isolation may be linked to the depression, which is common in the elderly people. Depression in this age group is often not diagnosed or treated properly, especially by the general doctors, because this may happen because older adults often express depression through physical symptoms. So they are more focused on their physical sign and symptoms. Ages might lead healthcare providers to view depressive symptoms as a normal part of aging. This may be the factor why the elderly people often not diagnosed or treat properly because of the depression. Now coming to the another pole, which is mania. In mania, the features may be having a very high level of energy or activity. The features you can acknowledge that uh, these features are opposite of the features of depression, like very high level of energy and activity, extremely happy or excited mood, and almost euphoric affect may be seen. Not needing much sleep yet feeling refreshed, there is a decreased need for sleep, having an inflated sense of self-worth, grandeur ideas or delusion of grandeur may be there, talking more than usual, patient may be over talkative, experiencing racing thoughts. Thoughts are flowing with a faster rate and can be observed as flight of ideas in the speech sample. Getting easily distracted, being overly focused on a specific activity, showing restless movement like pacing and fidgeting, acting impulsively, for example, excessive spending, risky sexual behavior, or unwise investments. The psychotic symptoms in manic episode may be present like hallucination and delusion, but are in the different form. Delusion are false beliefs that seem real but are not based on the reality. The patient may have paranoid delusion, may have inflated sense of their own abilities, delusion of grandeur or grandiose delusion, the inflated self of power or importance of self. Mania in teenagers. The presentation may be different from the adults. The teenager may be present with or mistaken for the antisocial personality disorder or schizophrenia. Signs of mania in this age group can include psychosis, substance abuse, suicidal attempts, difficulties in school performance, deep philosophical thinking, OCD-like behavior, various physical complaints, significant irritability leading to conflicts and other antisocial actions. While some of these signs can be found in typical teenagers, if symptoms are severe or last a long time, healthcare providers should think about the bipolar 1 disorder as a possible diagnosis. In classification of manic episode classified as hypomania, mania without psychotic symptoms, mania with psychotic symptoms, other manic episode unspecified. So this is the classification for bipolar affective disorder. In this disorder, more than one episode is present and at least one episode is of hypomania or mania. So this is classified as bipolar affective disorder, current episode hypomania or current episode manic without psychotic symptoms, manic without with psychotic symptoms, further mild or moderate depression, severe depression without psychotic symptoms, severe depression with psychotic symptoms, and the patient is having current episode as mixed or currently the patient is in remission means patient is in follow-up and is having none of the symptoms of depression or manic at the present time. What the mixed episode is, a diagnosis of mixed bipolar affective disorder should be made only if the two sets of symptoms are both prominent for the greater part of the current episode of illness and if that episode has lasted for at least 2 weeks. So as we have seen in the graph, symptoms of both depression and manic are present at the same point of time, and uh, and in the abundance equally in the numbers. Differential diagnosis of affective disorder or mood disorder, the medical disorder which may be uh, considered as having mood disorder is mononucleosis in adolescents. Markedly overweight or underweight present may have adrenal or thyroid dysfunctions. Homosexual, bisexual men, prostitutes, person with abuse of substance intravenously may present with acquired immune deficiency syndrome. In elder people, viral pneumonia should be ruled out. Cardiac drugs, antihypertensives, sedatives, hypnotics, antipsychotics, antiepileptics, antiparkinsonian drug, analgesics, antibacterial and anti-neoplastic drugs all are commonly associated with depressive symptoms, either depressive features or as a causative factor to develop a depressive episode. Neurological condition may also mimic mood disorders or associated with mood disorder as a comorbid illness like Parkinson's disease, dementing illness, including dementia of Alzheimer's type, epilepsy, cerebrovascular disease, and tumors. Temporal lobe epilepsy can mimic a depressive episode. There is a term pseudodementia, includes symptoms that look like dementia. For example, issues with speaking, remembering, and focusing. However, it usually stems from different reasons, often related to the depression. So, severe depression, which present with more of the symptoms of cognition like attention, concentration, and memory, that can be presented as dementia patient, but will fall under the diagnosis of pseudodementia. In the differential diagnosis, the differential diagnosis of a mood disorder can be an adjustment disorder with depressed mood. Alcohol use disorder often present as a depression or as a comorbidity of depression as well along with the substance dependence. Anxiety disorder like generalized anxiety disorder, mixed anxiety depressive disorder, panic disorder, post-traumatic stress disorder may present along with the depressive features. Obsessive compulsive disorder can also have comorbid depression. Eating disorders like anorexia nervosa, bulimia nervosa can also have comorbid depressive disorder. Substance induced mood disorder can be there. Schizophrenia may also present in the phase of depression, which is known as post-schizophrenic depression. Schizophreniform disorders, somatoform disorder can also present with the depressive features. So these disorder of psychiatry should also be ruled out during the assessment for comorbidity or associations. Now the course and prognosis. For major depressive disorder, the first depressive episode happens before the age of 40 in around 50% of patients. If it starts later, it is often linked to no family history, antisocial personality disorder, and alcohol problems, which is more common in the younger age. An untreated depression can last for 6 to 13 months, while treated uh, depressive episodes usually last about 3 months. Stopping antidepressant before 3 months often leads to return of symptoms. As the disorder continues, patients experience more frequent and longer episodes. The subsequent episodes will be longer and more frequent. Over the 20 years, the average number of episodes is 5 or 6 in a patient. For manic episode, about 5 to 10% of patients initially diagnosed with major depressive disorder will have a manic episode 6 to 10 years after their first depressive episode. So the diagnosis will change to bipolar disorder in the future time. The average age for this change is 32 years, typically occurring after 2 to 4 depressive episodes. The one person is having 2 to 4 episodes, then there are chances that he or she will have first manic episode after the few depressive episodes. Now the prognostic indicators for major depression. The good prognostic indicators are the milder the episode, the prognosis is good. The absence of psychotic symptoms. If ever hospitalized, the hospital stay is shorter is a good indicator. History of good social support during the adolescence or good friendship or good circle at the during the adolescent period is a good prognostic factor. Stable family functioning, generally sound social functioning for the last 5 years before the onset of illness. Absence of a comorbid psychiatric disorder is also a good prognostic factor. No more than one previous hospitalization for major depressive episode. Later age of onset. Poor prognostic factors are coexisting dysthymic disorder, abuse of alcohol or other substance, comorbid anxiety disorder, a history of more than one previous depressive episode. Uh, it is recurrent depression. Men are more likely than women to experience a chronically impaired course. For bipolar disorder, bipolar 1 disorder usually begins with depression, affecting 75% of women and 67% of men. 10 to 20% may only have manic episodes. There is no depressive episode in between. For example, the person is having 4 to 5 manic episode but has no intervening depressive episode. Manic episodes can start quickly within the hours or days but may develop after a few weeks. If not treated, a manic episode can last around 3 months. About 90% of those who have one manic episode will have another episode. So the diagnosis will change to bipolar disorder from manic episode. As the disorder continues, the time between episodes often shortens. The time gap between the two episodes shortens by the time. After about 5 episodes, the time between them usually stabilizes to 6 to 9 months. 5 to 15% experience 4 or more episodes each year and are considered as rapid cyclers. Around 40 to 50% of individuals with bipolar 1 disorder may experience a second manic episode within the 2 years of first episode. Poor prognostic factor for bipolar 1 disorder is poor job status before the illness, alcohol dependence, presence of psychotic symptoms, presence of depressive symptoms, depressive features between episodes, and being male. Good prognostic factor are shorter manic episodes, older age at onset, fewer suicidal thoughts, and fewer other psychiatric and medical issues. Approximately 7% of those with bipolar 1 disorder do not have any symptom recurrence. So this is only a 7% of person who will not have the another episode. 45% experience multiple episodes. 40% have a chronic form of disorder. Patient can have anywhere from 2 to 30 manic episodes with an average of about 9 episodes. About 40% of all patients have more than 10 episodes. So in summary, mood disorder are a type of mental health issues that mainly impacts a person's feeling in terms of sadness and happiness. They include depressive disorder and bipolar disorder. In bipolar disorder, there are bipolar 1 disorder and bipolar 2 disorder. What happens in bipolar 2 disorder is the episode of mania is not there. Instead, episode of hypomania is there. Hypomanic episode mixed with the any severity of depressive episode is known as bipolar 2 disorder. In bipolar 1, a manic episode should be there to diagnose as bipolar 1. In symptoms, mood disorder can lead to change in sleep, appetite, energy, focus, and self-worth. They arise from a mix of genetic, biological, environmental, and psychological influences. In prognosis of mood disorder, In depressive disorders, many people with depression can see great improvement with the right treatment. However, some may face repeated episodes which might need ongoing or even lifelong treatment. In bipolar disorder, the outlook for bipolar disorder is more complicated because of the cycles of mania and depression. Long-term treatment, usually including mood stabilizers and therapy, is often required. Thank you. Now we will be covering the second part of the mood disorders. We will cover in this lecture the recurrent depressive disorder, dysthymia and cyclothymia. Recurrent depressive disorder is the condition involves not the single episode of depression, rather multiple episodes which can be mild, moderate or severe in intensity. There is no history of separate episode of mood elevation or overactivity that meets the criteria for mania or hypomania. So in this disorder, only the episodes of depressive continuum will be present in the life of the person. The category should still apply if there are signs of short period of mild mood increase or overactivity that meets the criteria of hypomania right after the depressive episode, which may be sometimes triggered by the depression treatment. So hypomanic episodes may be there to diagnose recurrent depressive disorder, which are immediate after the depressive episode, may be resultant of antidepressants. The age when depression starts, along with how severe, long lasting and often it happens, can vary a lot. There is variation of involvement of age. Usually the first episode happens later than the bipolar disorder. Each episode can last from 3 to 12 months with an average of about 6 months, but they tend to happen less often. In recurrent depressive disorder, recovery typically happens fully between the episodes, but some patients, especially older ones, may experience ongoing depression between the episodes of mild, moderate, or severe depression, which may be a dysthymic-like condition. We will learn about the dysthymia in the further slides. Stressful life events often trigger episodes of any severity. In many cultures, both single episodes and ongoing depression are seen twice as often in women compared to the men. So, recurrent depressive disorder is found more in the females. To diagnose the recurrent depressive disorder, the episodes of depression should fulfill the criteria of either of mild, moderate, or severe. And we had already discussed the features of depressive episode, and it is similar in the recurrent depressive disorder for the episodes of depression. So first one is the depressed mood, second one is loss of interest and enjoyment or anhedonia, reduced energy leading to the increased fatigability and diminished activity. One may find marked tiredness after only slight effort. So these three are the core criteria, major criteria to diagnose depressive episode. The minor criteria are reduced concentration and attention, reduced self-esteem and self-confidence, ideas of guilt and unworthiness, bleak and pessimistic views of the future, ideas or acts of the self-harm or suicide, disturbed sleep, and diminished appetite. In the ICD-10, the recurrent depressive disorder is classified under chapter F33, and further it is classified F33.0 as mild, 33.1 as moderate, 33.2 is severe without any psychotic symptoms, 33.3 is severe with psychotic symptoms, and 33.4 is currently in remission, means the in-between period of the two episodes. Mild and moderate further has specifier. It can be present without somatic syndrome and with somatic syndrome. Now coming to the persistent mood disorder, one is cyclothymia, another is dysthymia. and further classified as other persistent mood disorder unspecified. So the category F34 is for the persistent mood disorder. Now coming to the dysthymia. Dysthymia meaning ill-humored was first used in 1980. Before that, many people now seen as having dysthymia were considered to have depressive neurosis or neurotic depression. Dysthymia is different from a depressive episode which we used to find in depression single episode or in the recurrent depression. The people with dysthymia often say they have always felt depressed. Most cases starts early in the childhood or teenage years, and by the time individuals are in their 20s. There is also a less common late onset type found in middle aged and older adults, and it is identified mainly through community studies, because these patients does not usually uh, try to find the medical management. Dysthymia can happen as a secondary issue related to other mental health disorder like chronic other psychiatric disorder. However, it mainly describes as a mild but long lasting form of depression that lasts at least for 2 years. So 2 years criteria is required to diagnose dysthymia. It usually starts slowly, often beginning in childhood and teenage years, and can have a steady or fluctuating pattern of milder dysthymic features. Patients with dysthymia often have a family history filled with both depression and bipolar disorder. So there may be a link of uh, genetic loading in the patients of dysthymia. They have their relatives with depressive disorder and or bipolar disorders. The dysthymia diagnosed as not currently fulfilling the criteria for recurrent depressive disorder, mild or moderate severity in terms of either severity or duration of individual episodes. So basically in dysthymia, it even does not fulfill the criteria of mild depression. Sufferers usually have periods of days or weeks when they describe themselves as well, but most of the time they feel tired and depressed. Everything is an effort for them, and they express that nothing is enjoyed. They brood and complain, sleep is disturbed, and they feel inadequate, but are usually able to cope with the basic demands of everyday life. So there is no major impairment in their life, so they do not tend to seek the treatment, and they are also misdiagnosed. Dysthymia therefore has much in common with the concept of depressive neurosis and neurotic depression because of these features. In epidemiology, dysthymia is a common condition that affects about 5 to 6% of people. It is often found in general psychiatric clinics, impacting between one third and half of all the patients there. The rate of occurrence do not differ by gender, it is equally present in both the genders. However, it is more prevalent in women under 64 compared to men of any age. It is also more common among young people, those who are unmarried, and individuals with low income. Often occurs alongside other mental health issues, especially major depressive disorder, which makes it less likely for patient to fully recover between episodes. This means the major depressive episodes are there, like in recurrent depression, but the intervening period is not fully free of the symptoms. The dysthymic symptoms may be present um, continuously in between the episode, and it is also called as double depression. So one dysthymic feature and the features of recurrent depression are present, or depressive episode is present, is called as double depression. Additionally, patients may experience anxiety disorders, substance abuse issues, and borderline personality disorders. The disorder is more frequent in people who have close family members with major depressive disorder like depressive episodes or recurrent depression. The diagnostic guidelines of dysthymia. The essential feature is a very long standing depression of mood which is never or only very rarely severe enough to fulfill the criteria of recurrent depressive disorder of mild or moderate severity. It usually begins early in adult life, lasts for at least several years, sometimes indefinitely. When the onset is later in life, the disorder is often the aftermath of discrete depressive episodes and associated with bereavement and other obvious stress of the later life. This includes depressive neurosis, depressive personality disorder, neurotic depression, persistent anxiety depression, which were previously classified or or known for the uh, dysthymia-like features in previous classifications. It excludes the diagnosis of dysthymia excludes anxiety depression, bereavement reaction uh, lasting less than 2 years, prolonged depressive reaction, and residual schizophrenia, in which the few symptoms of schizophrenia are remain there even after the best of the treatment. The differential diagnosis for dysthymia is obviously depressive disorder, recurrent brief depressive episodes or recurrent depression, and double depression as we have discussed earlier. Alcohol and substance abuse may the chronic substance abuse pattern may have features of dysthymia, maybe the differential diagnosis. Now, course and prognosis of the dysthymia. Approximately 50% of individuals diagnosed with dysthymia exhibit a gradual emergence of symptoms prior to reaching the age of 25. So 50% of patients may acquire the dysthymia before the age of 25. Despite the early manifestation, many patients endure these symptoms for up to 10 years before pursuing psychiatric intervention. Those who experience symptoms at an early age are at increased risk for developing either major depressive episode or bipolar 1 disorder over the course of their illness. Research involving patient diagnosed with dysthymia reveals that around 20% transition to major depressive disorder in future, 15% uh, diagnosed as bipolar 2 disorder had changed the diagnosis of dysthymia is changed to bipolar 2 disorder in case of 15%, and fewer than 5% to bipolar 1 disorder. So the person is having dysthymic features for the long time, and they may have episodes of mania or hypomania in the future, may be diagnosed as bipolar disorder. The outlook for individuals diagnosed with dysthymia is not uniform, can differ significantly among the patients. The administration of antidepressant medication along with certain forms of psychotherapy such as cognitive and behavioral therapy has been shown to yield beneficial outcomes in the management. Overall, the prognosis is good with the treatment. The treatment of dysthymia, the first line treatment should be psychotherapies like cognitive therapy, behavior therapy, insight oriented psychotherapy, interpersonal therapy, family and group therapies. If any kind of conflict in the family which acts as a perpetuating factor for the symptoms. Pharmacotherapy, the selective serotonin reuptake inhibitors SSRIs, specifically venlafaxine and bupropion, are effective therapeutic option. Venlafaxine and bupropion also have the low switch rate proportion and can be the first line treatment choice for dysthymia. Now coming to the cyclothymic disorder. Cyclothymic disorder can be understood as a less severe variant of bipolar 2 disorder marked by alternating period of hypomania and mild depressive episodes. A chronic fluctuating mood disturbance is characterized by multiple episodes of hypomania and depression. This condition is distinct from bipolar 2 disorder, which is defined by the occurrence of major depressive episode alongside hypomanic episode rather than minor ones. So what happens in cyclothymic disorder? The episodes towards the depressive side uh, is somewhat matching with the features of dysthymia and not amounting to the condition fulfilling with the criteria of moderate depression. On the high sides, hypomanic features may be present and not amounting to the episodes of mania. Three to 5% of all psychiatric outpatient may be particularly characterized by substantial issues related to marital and interpersonal conflict. The patients usually present with the marital conflicts or interpersonal relationship issues, which may be secondary to the mood swings of the person, and later to be diagnosed as cyclothymic disorder. The lifetime prevalence of the cyclothymia is about 1%. It frequently coexists with the borderline personality disorder. Male to female ratio is 3:2. 50 to 75% of individuals experiencing the onset of symptoms between the age of 15 and 25 years. In the etiology of cyclothymia, biological factors are there. Approximately 30% exhibit positive familial history of the bipolar 1 disorder, and the pedigrees of families affected by bipolar 1 disorder frequently reveal multiple generation of individuals with bipolar 1 disorder linked by a generation with cyclothymic disorder. So in this flow chart, basically you can consider the three boxes as a three generation. So if it has been seen that the first generation is having bipolar 1 disorder and the second is having cyclothymic features, and the further generation in the pedigree may have bipolar 1 disorder, full-blown bipolar 1 disorder. So there is genetic linkage between bipolar disorder and cyclothymia is there. Around 1/3 of the patients with cyclothymic disorder later develop major mood disorder. They demonstrate heightened sensitivity to hypomania induced by antidepressants. In these patients, antidepressants can induce hypomania or manic episode. Approximately 60% shows a positive response to the lithium treatment. Lithium is a mood stabilizer. Diagnosis and clinical features. The possibility of cyclothymic disorder is considered when a patient presents with the behaviors that may resemble sociopathy, and the patients present with marital history and relationship instability, promiscuity, and prolonged irritable mood, angerness in the personality. One can think of the cyclothymic disorder. Anecdotal evidence suggests that the hypomanic states can lead to heightened productivity and creativity, but most clinicians observe that the patient tend to become disorganized and less effective in their professional and academic pursuit during these phases. So in the phase of high, one can be perceived as having heightened productivity and creativity. It's a myth, it's not true as per the larger observations. The instability usually develops early in adult life and pursues a chronic course, although at times the mood may be normal and stable for the months at a time. Short periods of normalcy may be found. The mood swings are usually perceived by the individuals as being unrelated to life events. So there is inappropriateness between the events and the mood. The diagnosis is difficult to establish without a prolonged period of observation or an usually good account of individuals' past behavior. And a good informant must be there to reveal the good psychiatric history of longer period of time. Because the mood swings are relatively mild and the periods of mood elevation may be enjoyable, cyclothymia frequently fails to come to medical attention. Mood changes, although present, is less prominent than cyclical changes in activity, self-confidence, sociability, and appetitive behavior. So mood is not a prominent feature. The things which will be revealed in the behavior is increased activity, or the decreased activity in the phase of low. The self-confidence of the person may be remain high for a longer period of time, then suddenly goes into the period of low self-confidence. Sociability may be increased in the phases of high, and appetitive behavior may be seen in the phases of high, uh, and the reverse of these behavior is seen in the low phases. In the diagnostic guidelines, as per ICD-10, the essential feature is a persistent instability of mood involving numerous periods of mild depression and mild elation, none of which has been sufficiently severe or prolonged to fulfill the criteria of bipolar affective disorder, which is also called as bipolar 1 disorder, or recurrent depressive episodes. This implies that individual episodes of mood swings do not fulfill the criteria of any criteria described under the manic episode or depressive episode, even of the milder severity. The diagnosis includes the previously known as affective personality disorder, cycloid personality, cyclothymic personality. The differential diagnoses are: patient may have seizure disorder, may have substance abuse disorder, particularly the cocaine, amphetamine, and steroids. In the personality disorders, the differential diagnosis can be borderline personality, antisocial, histrionic, and narcissistic personality. In the teenage group or earlier earlier aged population, ADHD may be the differential diagnosis. The longer period of dysthymia should be discriminated from attention deficit and hyperactivity disorder. The course and prognosis: certain individuals diagnosed with cyclothymic disorder often exhibit traits of sensitivity, hyperactivity, moodiness during their childhood period. The clear manifestation of cyclothymic disorder symptoms typically begins during the adolescent period or early adulthood. The onset can significantly impede an individual's academic performance, that should be looked upon, and their capacity to form social connection with the peers. So poor social connections may be found in the history of present illness or the past illness. In the treatment, in the biological therapy, mood stabilizers and anti-manic medications are the primary treatment option for cyclothymic disorder. Carbamazepine and valproate are said to be effective. The doses and plasma levels of these medications should match those with the which we use with the bipolar 1 disorder. These patients are more likely to have hypomanic and manic episodes triggered by the antidepressant. So antidepressants should be used judiciously, or one should try to avoid the antidepressants in the case of cyclothymia, because around 40 to 50% of those with cyclothymic disorder who receives antidepressants may experience the hypomanic or manic episodes. In psychosocial therapy for the patients with cyclothymic disorder, psychopathy should be focused on helping them understand their condition and build skills to manage their mood changes. Therapists often assist patients in addressing any harm caused to their work, the family relationship during the hypomanic episodes. Since cyclothymic disorder is a long-term issue, patient typically needs ongoing treatment, long-term treatment. Family and group therapy can provide support, education, and healing for both patients and their loved ones. So in the overview of mood disorders as a whole, disorders, often referred to as affective disorder, are a group of conditions characterized by disturbance in person's mood leading to emotional instability or mood swings. The primary category of mood disorder include depressive disorders and bipolar disorders. In depressive disorders, one will find the depressive episode, recurrent depressive disorder, or persistent depressive disorder, which is dysthymia. In bipolar disorder, one can have bipolar 1 disorder, 2 disorder, and cyclothymic disorder. In etiology and risk factors, the genetic factors, biological factors, psychological factors, and environmentals all play a role into it. In the treatment, medication, psychotherapy are available, and lifestyle changes are also found beneficial in mood disorders like regular exercise, healthy eating, adequate sleep, and stress management techniques. In conclusion, mood disorders are complex and multifaceted disorders requiring a combination of approaches for effective management. Early diagnosis and intervention are crucial for improving outcomes and enhancing the quality of life for individuals affected by these conditions. Thank you.
Okay. Very good afternoon. Okay. Let me speak. Okay. So today's class is on a very important topic. Schizophrenia is one of them. Other than schizophrenia, we'll also see two other topics which are schizotypal and persistent delusional disorder. My name is Dr. Ritika Singh. I am senior resident in the Department of Psychiatry. So we'll be moving ahead under the following headings. We'll see the introductory part overall, what are we going to cover. Schizophrenia, schizotypal, PDD, and then evaluation and management part is something which we will be seeing in common. Okay, alag kisi ka I won't be telling, I'll telling in common ki how do we manage these patients. So let us move forward. So when we talk about psychotic spectrum disorder, there is no one particular illness. The illness is divided into many other subcategories. So the sign and symptoms of these illness may be similar, but there might be difference in the severity of the sign and symptom or the time period of sign and symptoms. तो जो ये illnesses अलग अलग defined हैं, उनकी severity क्या है और किस duration तक वो expand करती हैं और वो कैसे present करती हैं, इनमें थोड़ा बहुत difference होता है. So spectrum of psychotic disorder encompasses a range of mental health conditions which are characterized by thought process disturbances, perceptual disturbances, and reality testing. Okay, how the patient is thinking, it is going to get disturbed. What the patient perceive. Perception is something when you are seeing, you are hearing something which is altered, or if it is not, the stimulus is not there, but still you're seeing or hearing something, that is something which comes under perceptual abnormality. And touch with reality of such patients are also lost. These disorders are organized in a continuum. So at one hand, we have schizophrenia in which the signs and symptoms are quite severe, like hallucination, delusions, and cognitive impairment. On the other hand, we have schizotypal and PDD, that is persistent delusional disorder. In here, the sign and symptom may not be as severe as schizophrenia, but certain deficit can be seen in every aspect of life, in interpersonal deficits or social or occupational deficits can be seen in such diseases. Let us move on to schizophrenia. So all of you are aware of the term schizophrenia. Do you know what schizophrenia is? Yes or no? Some of you know, some of you don't know. Okay. So there is no particular defined definition of schizophrenia. Okay. So when you talk about how do we define schizophrenia, it is a chronic illness, severe mental illness which affects your thought, your emotion, and your behavior. Overall, how the life functionality is going to be disturbed, what are the clinical symptoms, we'll see in the corresponding slides. Schizophrenia is quite important because it is very much prevalent in the society, very much masked by some stigmas and differentiation. So to identify it in earliest, जितना जल्दी आप इसको पहचानोगे, उतना जल्दी इसका treatment शुरू होगा. So better will be the prognosis or outcome for the patient. Okay. We'll see from historical time. In past time, psychiatric illnesses were not considered illnesses itself. They were considered maybe due to some spiritual or higher power are being at play. They might be considered possession by spirit or some divine punishment. So slowly the time passed on. Emil Kraepelin was the scientist who started thinking that this is a form of disease. He coined the term dementia praecox. Okay, which when we'll loosely translate it, it means early onset dementia. Dementia is an illness which is mostly seen in elderly people. बूढ़े बुजुर्गों में जिनकी याददाश्त चले जाती है, उनको समझ थोड़ा कम आता है, उनका cognitive जो impairment है वो आ जाता है, तो that is what dementia is. But if these symptoms similar to the symptoms like that in dementia, अगर early stages में आ जाए, तो उसने बोला that is dementia praecox, which is a psychiatric illness. Krapnin emphasized the chronic and deteriorating course of illness, that how the illness is going to deteriorate the life of the person and how the course is chronic in nature. Then again the term schizophrenia was coined by another scientist whose name is Eugene Bleuler. Okay, if you cannot remember the name of the scientist, it's okay. Okay, it's not well in that कि आपको रट्टा मारना है उसका. So the term schizophrenia in Greek means split mind. Okay, so here he also suggested certain signs and symptoms which are present in schizophrenia patient. More commonly, he inspected the presentation of the patients of schizophrenia. So he gave 4 A's. These A's are affective disturbances, association disturbances, ambivalence and autism. So these are characteristic features which can be seen in patients of schizophrenia. Like affective disturbances means affect of the patient can be inappropriate or it could be very reciprocal. Like अच्छी खुशी की बात है patient रो रहा है, कोई गलत sad news है patient हंस रहा है. Disturbance in association of thoughts. What we are thinking is not interlinked, they are trailing here and there. Then ambivalence is not able to decide what to do. Suppose he'll ask patient to shake hand, he'll keep his hand forward, then he'll take it back. He doesn't know whether he wants to shake hand or not. This is one such example, not able to decide what to do. Autism is something in which social withdrawal and everything is going to come into play. Okay. Then after moving on to after we have seen the historical background, let us see the epidemiology, that what is the prevalence. Approximately 1% of the global population have schizophrenia, whereas in India it is 1.41%, which was, there was a survey which was conducted in National Mental Health Survey. Age of onset, when you will say, it is seen quite early in males. Come and sit. Late teens or early 20s is the age defined age group for male, whereas in female it is seen in later stages of age, like late 20s or 30s, maybe late 30s, so illness can present. It is also ranked among top 15 leading causes of disability globally by the Global Burden of Diseases. So the disability which is caused in every aspect of patient's life. Okay, high unemployment rate because of the illness, social stigma and isolation, it leads to not contact the treating authority. Okay, reduced access to care, reduced life expectancy by 10 to 20% due to comorbidities or suicidal risk in patient. Okay. Now etiology, see, this is something quite important because all the psychiatric illness which you are going to see, साइकाइट्री का इसके बाद का भी जो लेक्चर होगा या इसमें भी जो और टॉपिक्स हैं, दिस बायोसाइकोसोशल मॉडल, biological, psychological and social model. This is something which will explain the etiology or causes of all the psychiatric illnesses. Okay, so it explains schizophrenia as a result of interaction between biological, psychological and social factors. Okay, there are 3 factors. So to understand how the disease is developed and how you will treat the patient, you will treat patient biologically also, psychologically also and socially also. So this is very important. Just a diagram to represent that what are biological causes, psychological causes and social causes. We will see in later slides what are they. Okay. Okay, biological factors, what do they say? See, you don't have to remember the names of genes if you cannot remember. Okay, it says ki schizophrenia have genetic predisposition. So if your family members, immediate family members have schizophrenia, the chances of having schizophrenia in that individual increases in comparison to general population, because certain genes are carried on in familial traits which are responsible for causing schizophrenia. Second, it says there are neurochemical dysregulation. There are certain hormones or neurochemicals like dopamine, serotonin, norepinephrine, glutamate and GABA. So amongst them, dopamine, glutamate and GABA dysregulation is mainly responsible for causing schizophrenia signs and symptoms. So this is just a representation. If there are monozygotic or identical twin, the percentage of having schizophrenia is 48%. Similarly, if two parents, both the parents have schizophrenia, the chances of having schizophrenia in the children is approximately 46%. Similarly, dizygotic or non-identical twins, the chances decreases in comparison. Okay. Similarly, one parent is affected, it is less in comparison to when both parents are affected. So you can see strong genetic correlation is seen in this diagram. Again, I told you that dopamine, glutamate and GABA, these are the three hormones whose dysregulation can also cause signs and symptoms of schizophrenia. Again, brain structure and functional abnormality, enlarged ventricle, reduced gray matter, neurodevelopmental factor like in utero exposure to certain infection, hypoxia or malnutrition during pregnancy can also uh, act as a risk factor for developing schizophrenia. In psychological factor, we'll see what is psychological vulnerability of the patient, how the patient handles the stress, that is coping mechanism. If there are any cognitive impairment, if there is any intellectual deficit in the patient, if any associated family conflict or trauma is there or not. If childhood trauma, social factor again quite similar, childhood trauma or abuse, social economic status is very low, poverty, unemployment or any other stressor, substance abuse, especially cannabis is very much related to initiate the sign and symptom of schizophrenia, and stigma and discrimination, which we have already read. Now, yahan tak it is clear? Okay. Now, how do you identify the patient have schizophrenia or not? There are 4 types of symptom: positive symptom, negative symptom, cognitive and affective. As the name suggests, positive symptoms are such which are very much visible to you, which are quite exaggerated, like patient might get very angry, abusive, patient might be actively hallucinating. आप देखोगे patient अपने से खूब जोर जोर से बात कर रहा है, लोगों पे शक वहम कर रहा है कि मेरे बारे में ये लोग बात तो नहीं कर रहे, मेरे को नुकसान पहुंचाने की कोशिश कर रहे हैं. Negative symptom is something नाम suggest करता है very negative, that patient is socially withdrawal, वो किसी से बातचीत नहीं करने जा रहा है, he is not taking care of himself, okay, he is very poor in communication. Cognitive, cognition से related है, poor attention, poor memory, decision making is not good in cognitive symptom. Affective symptom are something related to, you can correlate with negative symptom as well, ki effectively patient can be either very irritable or he could be non-responsive, he could be blunt also, all right. So positive symptom, hallucinations, delusions or disorganized behavior. Negative symptoms, social withdrawal, emotional bending, lack of motivation and drive, apathy, okay. Then cognitive we have, please sit properly, attention deficit, memory deficit, difficulty in concentration, poor problem solving skill. Now affective symptoms, mainly 3 kind of symptoms you should keep in mind: diminished emotional expression, incongruent emotion like I told you ki, such as laughing in a sad situation or appearing indifferent in a emotionally challenged situation, and certain mood related, maybe anxiety, irritability, anhedonia, okay. Other than that, there was a scientist called Kurt Schneider. He gave certain symptoms. These are known as Schneider's first rank symptom. Okay. He divided certain symptoms, and these symptoms are very important to know because when we see the diagnostic criteria of the disease, these symptoms have an important role in them. So he decided into 4 categories. 3 उसमें से 3 auditory symptoms है. Thought echo, third person voices and running commentary. Thought echo is something hearing one's own thought. अब कानों में आवाजें आ रही है लेकिन वो मेरी सोच जो है वो आवाजों में बदल रही है. Third person voices, hearing 2 or more voices discussing the patient. 2 लोग की आवाजें आ रही है वो मेरे बारे में बात कर रहे हैं. रनिंग कमेंट्री, जैसे कमेंट्री होती है ना किसी भी मैच में कि मेरे एक्शंस जो भी मैं कर रहा हूँ उसके पीछे कमेंट्री आ रही है किसी की आवाजों में, ठीक है. So this is auditory hallucination. Then there are 3 thought phenomena: thought insertion, thought withdrawal and thought broadcasting. नाम में ही छुपा हुआ है. Thought insertion, when thoughts are being inserted, मेरे सोच किसी और ने मेरे दिमाग में सोच डाल दी है, मेरी सोच नहीं है. Thought withdrawal, my सोच has been taken out from my brain and it has been removed from the patient's mind. Thought broadcasting, that other people can see or hear whatever I am thinking. मेरी सोच सबको पता चल जा रही है. Okay. Next is 3 made phenomena. Made मतलब करवाया जा रहा है, ठीक है. Made affect, made impulse and made volition. Made affect refers to the experiences of emotions that feel imposed or controlled by an external force. That whatever I am feeling or whatever emotions are there in me, these are not mine. ये कोई बाहर से control कर रहा है. मेरे emotions बाहर से control किए जा रहे हैं. Then is made impulse. If I am getting a sudden urge to harm someone, that is because someone else, some external force is making those impulses in me, okay. urges or impulses that feel imposed or controlled by external force. Again, made volition. Here volition में आपका action part आ जाता है. That जो भी मैं काम कर रहा हूँ, suppose मैंने हाथ मारा कहीं पे, तो वो मैंने नहीं किया, वो किसी external force ने मुझसे वो action कराया है. ठीक है, they are not acting of their own free will, but rather being compelled to act in a certain way. Then we have seen rest three phenomena in सब चीजों का. Then we have one is delusional perception, giving an abnormal meaning to a normal perception. ठीक है, suppose normally आपके मैंने एक पेन दिया, आप पेन से लिखने के लिए होता है, अभी वो नॉर्मल पेन रखा हुआ है, बट आपको क्या लगा, नहीं ये पेन नहीं है, ये रिकॉर्डर है, मेरे को रिकॉर्ड किया जा रहा है, मेरी आवाज रिकॉर्ड की जा रही है इसमें. ठीक है, नॉर्मल वो है, एक्सेप्ट करते हो नॉर्मल, लेकिन इसको एक delusional मीनिंग दे दिया है. Somatic passivity is something that external, जो भी bodily sensation है, that is controlled by the external force. Okay, these are clear. Sign and symptom ये patient में आएंगे. Okay, now these are the diagnostic guidelines of schizophrenia. You need not to remember it, just for your understanding you can see. So ICD ने दो ग्रुप में symptoms को divide कर दिया है, group 1 और group 2. So one it says कि one symptom from group 1 और 2 symptoms of group 2 should be present for at least 1 month अगर हमें schizophrenia को diagnose करना है. All the symptoms are same which we have learned in the past. Thought echo, insertion, withdrawal and broadcasting, delusion of control, influence, passivity, hallucinatory voices, persistent delusion which are culturally inappropriate or impossible. Then persistent hallucination, disorganized thought which can lead to irrelevant speech or neologism, catatonic behavior, negative symptoms and significant change in behavior like loss of interest, aimlessness or social withdrawal. Okay. तो और इन्हीं टाइप पे स्किज़ोफ्रेनिया के सब टाइप भी डिफाइन किए गए हैं ICD-10 में. DSM जो दूसरी क्लासिफिकेशन है वो ऐसे सब टाइप पे इतना नहीं एम्फेसाइज करता जितना ICD-10 करता है, और इसके बाद का जो ICD आएगा वो भी सब टाइप्स पे इतना एम्फेसाइज नहीं करने वाला. जस्ट फॉर योर अंडरस्टैंडिंग, पैरानॉइड स्किज़ोफ्रेनिया इज समवन जहाँ पे विच इज डोमिनेटेड बाय डिल्यूजन एंड हैलुसिनेशन. हैबिफ्रेनिक में डिसऑर्गेनाइज्ड बिहेवियर, पुअर सेल्फ केयर और ये सब चीजें ज्यादा मिलेंगी. कैटेटोनिक में आपका साइकोमोटर डिस्टर्बेंस है. कैटेटोनिया इज समथिंग जिसमें आपका पेशेंट को फिजिकल सिम्टम्स आपको देखने मिले. इधर द पेशेंट इज वेरी क्वाइट, ही विल नॉट टॉक, ही विल बी नेगेटिव एकदम, ही माइट attain certain body position which are uncomfortable and but he will keep on maintaining this. For example, पेशेंट ने ऐसे हाथ उठाया है, वो 10 मिनट तक ऐसे ही खड़ा रहेगा किसी उससे. ठीक है, स्टेयर कर रहा है वो ऐसे ही करता रहेगा. ठीक है, एंड कॉन्ट्ररी टू दिस इसमें एक्साइटमेंट भी हो सकता है. कभी कभी पेशेंट बहुत एक्साइटेड भी हो जाता है, लोगों को मारने लग गया, कुछ अबनॉर्मल हरकतें करने लग गया. गेटिंग इट? नेक्स्ट इज अनडिफरेंशिएटेड, जिसको किसी पे फिट ही नहीं किया सकता. पोस्ट स्किज़ोफ्रेनिया डिप्रेशन, सर्टेन डिप्रेसिव सिम्टम्स एसोसिएटेड विद स्किज़ोफ्रेनिया. रेजिडुअल स्किज़ोफ्रेनिया इज देयर, इसमें सम नेगेटिव सिम्टम्स आर persistent after the first psychotic event has happened. एंड सिंपल स्किज़ोफ्रेनिया में ज्यादातर नेगेटिव सिम्टम्स, एमलेसनेस और ये सब जो हमने देखा वही देखने को मिलते हैं, पॉजिटिव सिम्टम ना के बराबर. सिमिलरली DSM-5 ने भी यही गाइडलाइंस दे रखी हैं. ओके, देयर आर सर्टेन प्रोग्नोस्टिक फैक्टर कि कुछ सिम्टम्स, कुछ फैक्टर्स अगर स्किज़ोफ्रेनिया के पेशेंट में है तो प्रोग्नोसिस अच्छी हो सकती है, आउटकम अच्छा हो सकता है अगर ट्रीटमेंट दे. अगर कुछ सिम्टम्स प्रेजेंट है तो उसकी वजह से आउटकम बुरा भी हो सकता है. जैसे कि पेशेंट का अगर बहुत अर्ली ऑनसेट है, बच्चों में अगर आप बहुत अर्ली ऑनसेट में स्किज़ोफ्रेनिया अगर 15-16 साल में दिख रहा है तो इसका प्रोग्नोसिस अच्छा नहीं होता है. नेगेटिव सिम्टम्स हैं, मेल जेंडर है, कोई एसोसिएटेड फैमिली हिस्ट्री ऑफ स्किज़ोफ्रेनिया है, पुअर सोशल सपोर्ट है, प्रीमॉर्बिड पर्सनालिटी में पुअर कोपिंग और ये सब है तो नेगेटिव आउटकम होगा. सिमिलरली पॉजिटिव में अक्यूट ऑनसेट है, थोड़ा लेट ऑनसेट है, प्रोमिनेंट मूड सिम्टम्स आर प्रेजेंट, फैमिली हिस्ट्री में बाइपोलर का इलनेस है, पेशेंट का सोशल सपोर्ट अच्छा है और प्रीमॉर्बिड पर्सनालिटी अगर अच्छी है तो these are good prognostic factor for the disease. When we're talking about differential diagnosis is something you should be able to differentiate schizophrenia from other diseases which might have similar symptom. जैसे कि बहुत बार मूड डिसऑर्डर, बाइपोलर का नाम आपने सुना होगा, उसमें भी साइकोटिक सिम्टम होते हैं. तो यू शुड अंडरस्टैंड कि देयर इज अ डिफरेंस बिटवीन मूड डिसऑर्डर एंड स्किज़ोफ्रेनिया. इन मूड डिसऑर्डर मूड सिम्टम्स ज्यादा होंगे, पेशेंट बहुत ज्यादा मूड एक्साल्टेड होगा या फिर बहुत ज्यादा डिप्रेस्ड होगा. सब्सटेंस इंड्यूस साइकोसिस एसोसिएटेड कोई सब्सटेंस यूज होगा. ठीक है, कोई स्टिमुलेंट ले लिया या कैनबिस ले लिया. सर्टेन पर्सनालिटी डिसऑर्डर आर देयर, सर्टेन ऑब्सेसिव डिसऑर्डर विद पुअर इनसाइट, brief psychotic disorder or organic psychosis. There are certain medical conditions which can also precipitate like psychiatric illness. So you should be able to differentiate schizophrenia from it. Next, we'll move on to schizotypal. Schizophrenia is clear? Okay, ठीक है. So next is schizotypal disorder. What is schizotypal? It is basically called a personality disorder in which pervasive pattern of social and interpersonal deficit and cognitive distortions are present and along with eccentric behavior. Full-fledged psychosis like schizophrenia won't be there, but certain behavior will be quite odd. You might see the patient is behaving thoda sa oddly. He might have some, restriction when he goes out in society. He might not have very close friends. उसको बात करने में थोड़ा हिचकिचाहट होगी. वो लोगों से ज़्यादा दोस्ती करना पसंद नहीं करेगा. थोड़ा अलग रहना कोशिश करेगा. ठीक है? It is considered as a part of schizophrenia spectrum disorder, but lack full-blown psychosis. Again, 3 to 5% आपका prevalence है. More common in male. It can also co-occur with mood disorder and substance use. And patient, please don't talk. High prevalence among first degree relatives of individual with schizophrenia. If someone has schizophrenia, there are high chances कि schizoid personality disorder उसके first degree relative को हो सकते हैं. Then we are talking about what are the clinical features. Social and interpersonal deficit, discomfort in close relationship, odd belief, magical thinking, okay, which is inconsistent with cultural norm. Unusual perceptual experience including bodily illusions, suspiciousness or paranoid ideation. First row, please don't talk. Odd thinking and speech pattern, inappropriate affect, eccentric behavior or appearance, lack of close friends and confidence, excessive social anxiety that does not diminish with familiarity. Okay, so what happens कि sometime कुछ लोगों को phobia होता है कि they cannot talk or speak in public, they cannot go in public places, especially when it is not known to them. But gradually when they start to approach these places, the phobia decreases. But in schizoid personality, अब बार-बार patient जाएगा वहाँ पे तब भी उसको comfort नहीं आएगा. They won't be comfortable among the classmates itself. They won't be comfortable with their family members also. ठीक है? Just few of the symptoms: bizarre behavior, checking out. This is lack of close friend, excessive social anxiety. Diagnostic criteria, again the clinical features which we have learned, that is the diagnostic criteria. Okay, pervasive pattern of eccentric behavior and anomalies. Which are these? These can be inappropriate or constricted affect, odd eccentric behavior and appearance, poor rapport with others, odd belief, magical thinking, suspiciousness and paranoid ideation, unusual perceptual experience including somatosensory disturbances. Speech may be somehow very elaborated or vague, may not talk but make sense. Okay, these symptoms must be present for at least 2 years to make a diagnosis of schizoid personality, and they should not be attributed to any medical use condition or substance use. Again, in differential diagnosis, you should be able to differentiate schizophrenia to schizotypal from schizophrenia and schizoid personality, and avoidant personality and autism spectrum disorder. Autism का patient भी social जगह पे नहीं comfortable होता है, उसको भी social anxiety होती है, but there the communication and repetitive behavior is a problem. He won't be able to communicate anywhere autism spectrum disorder का patient. And there's another thing which is called repetitive behavior. एक चीज को बार-बार अगर touch कर रहा है, ऐसे करने की आदत होगी उसको. Especially sensory stimulation के लिए, if the patient is repeatedly moving his hand or finger, flap करता रहेगा. ठीक है? नेक्स्ट, यहां तक क्लियर हो गया. स्किज़ोटिपल, क्या डिफरेंस है स्किज़ोफ्रेनिया और स्किज़ोटिपल में? हु कैन टेल मी? बोलो बोलो, कुछ डिफरेंस है या नहीं है? क्या है? तो फुल ब्लोन साइकोसिस इज सीन इन स्किज़ोफ्रेनिया, जो ज्यादा सिवियर साइकोसिस है. ठीक है, जो थोड़ा सा ऑड एक्सेंट्रिक बिहेवियर मिलेगा, दैट इज फॉर स्किज़ोटिपल, जैसे आपने बोला. ठीक है, कुछ ऑड होगा बट नॉट टू द लेवल ऑफ स्किज़ोफ्रेनिया. ठीक है. पीडीडी, दैट इज परसिस्टेंट डेल्यूजनल डिसऑर्डर, नाम में ही छुपा हुआ अगेन डेल्यूजन है जो कि परसिस्टेंट है. ठीक है, दैट डेल्यूजन इज कॉन्स्टेंटली गोइंग ऑन. सो It is also known as paranoid psychosis. It is a chronic psychiatric condition characterized by presence of persistent non-bizarre delusions without other significant psychotic symptom. डिल्यूजन के अलावा जो और साइकोटिक सिम्टम्स हमने इससे पहले क्लिनिकल फीचर्स देखे हैं वो इतने प्रिविलेंट नहीं होते हैं या फिर होंगे ही नहीं. किसी किसी केसेस में सिर्फ डिल्यूजन होगा, कुछ और इल्यूसिनेशन, कुछ बिहेवियर एबनॉर्मलिटी, कुछ फंक्शनल एबनॉर्मलिटी होगी ही नहीं. ओके, so non-bizarre delusion, and non-bizarre means कि this delusion can be correlated with his cultural or his occupational or social significance can be given to the delusion, कि उसके होने के chances हैं. आप एक plausible meaning दे सकते हो delusion को. Delusions are typically of a single theme or a set of theme. Now because of these delusion functioning impair हो सकती है. For example, a person has just a delusion कि उसके workplace में so and so, suppose his boss is planning something against that person. अभी वो जॉब पे जा तो रहा है बट उसका डिल्यूजन फिक्स है कि बॉस कुछ गलत करने वाला है, तो वो काम ही नहीं कर पाएगा, अपने जो 100% पोटेंशियल है वो दे ही नहीं पाएगा. अपार्ट फ्रॉम दैट वो घर आ रहा है बिल्कुल नॉर्मल है, वो अपने दोस्तों से मिल रहा है बिल्कुल नॉर्मल है, किसी और के लिए वो डिल्यूजन ही नहीं है, बस अपनी वर्क प्लेस पे है, तो हिज ऑक्यूपेशनल लाइफ इज गोइंग टू गेट डिस्टर्ब. ठीक है, समझ में आया. एपिडेमियोलॉजी अगर देखें तो अगेन प्रिवेलेंस इज क्वाइट लो, मोर कॉमन इन इंडिविजुअल ओवर 40 years and old, more slightly more common in women, and it is chronic case and insidious onset. Again biopsychosocial factors you should remember, genetic history होगी, patient family history of psychiatric illness हो सकता है, possible abnormalities in dopamine and serotonin system, psychological factor like social isolation, trauma, cognitive distortion, stressful life events especially in adulthood can trigger disorder. Clinical feature, non-bizarre persistent delusion. They are fixed and impervious to reasoning. Otherwise, normal functioning in other areas of life is there. No major cognitive or mood disturbances. Mood disturbance अगर होगा भी तो it should be associated with delusion. Delusion की वजह से patient may get irritated, may get depressed. Okay, social withdrawal and irritability because of delusion. Types of delusion क्या क्या हो सकते हैं persistent delusional disorder में? Persecutory delusion, belief of being targeted by other. Grandiose delusion, having the sense of self-importance or abilities. Erotomanic delusion, belief that someone of higher authority is in love with that individual. Somatic delusion, false belief regarding the body, like my body is being infested by some parasite, or some olfactory foul smell is there, so olfactory delusions can be there. Delusion of jealousy, especially pathological or morbid jealousy we call it, believe that partner is unfaithful. इन मिक्स टाइप इज समथिंग जिसमें दोनों के जो ऊपर के जो सब टाइप है उसमें एक से ज्यादा डिल्यूजन भी हो सकते हैं. ठीक है, एंड अनस्पेसिफाइड इज समथिंग व्हिच कैन नॉट बी सब टाइप्ड इनटू अदर. दिस इन डिल्यूजंस के अलावा कुछ और है तो दैट इज अनस्पेसिफाइड. अगेन डायग्नोस्टिक क्राइटेरिया, दिस डिल्यूजन मस्ट परसिस्ट फॉर 3 months. ठीक है, एंड हेलुसिनेशंस आर आइदर एब्सेंट और नॉट प्रोमिनेंट, एंड इट शुड नॉट बी स्किज़ोफ्रेनिया से नहीं मिलना चाहिए इसकी जो डायग्नोस्टिक क्राइटेरिया है. ठीक है, एंड दे शुड नॉट बी ड्यू टू एनी अदर मेडिकल कंडीशंस. ओके, अगेन इन डिफरेंशियल डायग्नोसिस यू शुड बी एबल टू डिफरेंशिएट पर्सिस्टेंट डिल्यूजनल डिसऑर्डर स्पेशली फ्रॉम पैरानॉइड पर्सनालिटी डिसऑर्डर. सम पर्सन की पर्सनालिटी ही पैरानोया के लेवल पे होती है. ठीक है, उसमें पैरानोया हर एक डायरेक्शन में होगा, सिर्फ एक जगह पे पैरानोया नहीं होगा. मूड डिसऑर्डर, affective disorder, dementia with neurocognitive disorder, cultural or religious belief. Certain cultural and religious belief are prevalent everywhere. ठीक है, उसको delusion से confuse नहीं करना है. ठीक है. Now this is what we have learned, the clinical features and how the patient present of schizophrenia, schizotypal and PDD. ठीक है. Evaluation we are seeing, हर एक patient का psychiatric evaluation कैसा होता है. हिस्ट्री से शुरू करेंगे. आप लोग भी जब पेशेंट अगर फिजियोथेरेपी की बात करें, पेशेंट आता है तो आप पूछते हो ना कब से हो रहा है, क्या हो रहा है, वैसे ही चलना है. डिटेल अबाउट द नेचर, ऑनसेट, ड्यूरेशन, सिवियरिटी ऑफ सिम्टम. तो तीनों की अलग अलग थोड़ा कुछ ना कुछ डिफरेंसेस आप मिलेंगे. अगर आप इनके चीफ कंप्लेंट्स में जाएंगे, उसको ढंग से इलेबोरेट करेंगे कि कब शुरू हुआ था, कितने समय से है, क्या क्या एरियाज ऑफ लाइफ अफेक्टेड है. देन एसोसिएटेड बिहेवियरल चेंजेस तो नहीं है, कोई एसोसिएटेड मूड सिम्टम तो नहीं है, सब्सटेंस यूज तो नहीं है, कोई पास हिस्ट्री ऑफ सिमिलर इलनेस तो नहीं है, या पास हिस्ट्री ऑफ कोई और साइकाइट्रिक इलनेस तो नहीं है, कोई मेडिकल या सर्जिकल कॉम्प्लिकेशंस तो नहीं है that can contribute to the symptom, कोई हेड इंजरी हो गई उसकी वजह से सिम्टम आ गया. So you should all be aware of all these things. Family history of psychiatric illness is important because we saw in biological factors की genetic predisposition होता है. पर्सनल हिस्ट्री कैसी है, प्रीमॉर्बिड पर्सनालिटी कैसी थी, कोपिंग मैकेनिज्म कैसा था पेशेंट का, सोशियो ऑक्यूपेशनल रिलेवेंस कितना है पेशेंट का, बेटर वेदर ही सेफ सिक्योर्ड और नॉट, एंड अगेन केयर गिवर बर्डन एंड सपोर्ट सिस्टम. Then again in mental status examination, MSE is the diagnostic tool for psychiatric problems. Okay, how आप पेशेंट से बात करके उसके थॉट में क्या abnormality है, उसके परसेप्शन में क्या abnormality है, आपको मूड कैसा बता रहा है पेशेंट, आपको इफेक्ट कैसा लग रहा है, वो बोल कैसा रहा है स्पीच में, तो ये सब abnormality आपको MSE में मिलेंगी. Okay, so key areas to access: appearance and behavior, disheveled appearance, inappropriate dress, catatonia or agitation. Eye to eye contact, patient might not look into your eye or talk, patient might always have fleeting eye contact. Psychomotor activity might be very much, patient is agitated, so he might not sit in one place, he might keep pacing around. Okay, speech can be disorganized, like I said, if thought is not clear, what we think we speak, right? So if our thoughts are not clear, then our speech will also be not clear. We may want to speak something, but we'll convey something else. Okay, it might be incoherent. Affect, as we said, ki affective symptoms are also there in schizophrenia. Affect can be irritable, it could be blunt. Patient, you cannot figure out whether the patient is happy or sad, or it could be inappropriate. Again, thought process mein there can be derailment, there can be delusions. Okay, like we said, we see ki delusion is one of the key characteristic feature of schizophrenia also, and PDD also. Hallucination in perception part, hallucination, whether their patient को आवाजें सुनाई दे रही है कि नहीं सुनाई दे रही है. Sometimes visual hallucination can also be there. Then higher mental function में cognitive distortion, we have seen cognitive functions are also distorted in psychotic spectrum disorder. Then insight and judgment, which is most of the time impaired in patient. All right, I think your history taking class has been taken, na? Psychology history taking and examination class has been taken. So you might have read these all thing in detailed over there. Ki how do we evaluate the patient? All right. Certain diagnostic assessment tools we have. These are the scales like positive and negative syndrome scale. We apply this scale to see what are these positive symptoms, what are the negative symptoms, and there are certain rating given to these scales. If we rate these scales, uske according we can find out the severity of the illness. Suppose 20 marks का total scale है, 18 या उससे ऊपर आ रहा तो we'll say very severe, 15 to 17 आ रहा तो we'll say severe, mild, moderate, ऐसे करके we'll move on. Okay, so these are the scales. Lab investigation, of course, routine blood work, okay, to find out if any other organic cause is there or not there. Toxicology screen to find substance use. CT scan, MRI to rule out any neurological deficit is there. EEG to rule out any seizure activity is there or not. Okay, this is how we evaluate the patient. Now, when we come about treatment proper, so antipsychotic medications, everybody might have heard haloperidol or olanzapine. These are kind of medicine. They are also divided into second generation and first generation. So we commonly use second generation antipsychotic like olanzapine, risperidone, aripiprazole, quetiapine, or clozapine when patient is not responding to the above drugs, or first generation like haloperidol or chlorpromazine. What you should remember is कि there are certain side effects. बहुत बार patient won't take medication, they'll say we have side effects because of the medicines. So certain side effects of the medication, like for first generation medication, so side effects would be extrapyramidal side effect, like patient might have rigidity, tremors, face में affective blunting can be seen. Whereas in second generation, more or less you will see metabolic side effect like weight gain, dyslipidemia. But when you will give it in a prescribed dose and you will also suggest patient to follow a healthy lifestyle, or there are certain drugs which can curb down extrapyramidal side effects also, which can be added. So these symptoms can be taken control of. But see, you'll always have to manage the risk benefit ratio. Not taking medication is going to be bringing far more complication than taking medications. Okay, then there are certain adjunct medicines like benzodiazepine, mood stabilizer, and antidepressant. When we talk about psychosocial intervention, we have cognitive behavior therapy, family therapy to make family member understand the illness, because at the end of the day they are the caretaker. They have to stay with the patient. Insight oriented therapy, most of the people don't have any insight regarding the illness. So they may be helpful in patient develops partial insight. And very important, I told you about social model, social skill training, vocational training. You know, rehabilitation centers can play a role in making patient face the society in a step-by-step process. Okay, supporting employment and vocational training, assertive community training, treatment and rehabilitation program. Now, yahan tak to we have seen the main management, but what is the role of physiotherapy in schizophrenia or other psychiatric illness? So, as I told you that second generation antipsychotic might have certain weight gain ka side effect. So, crucial role in managing the overall physical activity of the patient. Okay, with addressing motor deficit, there are cognitive deficit as well as motor deficit in patient. So, to making the patient mobile again, making the patient be physically little more active can also help patient lead a very fruitful life. Okay, addressing motor deficit, poor posture, reduced fitness by inactivity or medication side effect. So these all are going to reduce the risk of metabolic syndrome. Again, patient might come in grouped in physiotherapy. कि suppose हमने अपने ward से 4-5 patient को group में भेज दिया. So this is also can act as a group activity for them. In group में you can teach them these are the exercises you can do. Even at home you can tell कि when you go home these are the exercises which you can do at your home. Relaxation technique, breathing exercises are also important in treating the patient of schizophrenia. Group physical activity session fosters social interaction, reducing social isolation and enhancing overall quality of life. So with this I'll conclude. Certain thing you should keep in mind. These all are covered under the psychotic spectrum diseases, schizophrenia, schizotypal and PDD. The only difference is how they present. Some are quite severe, some are less severe, some are severe in only one symptom criteria. Timeline is different for every disease, and disorder may severely affect emotion, behavior, thought, perception. How you lead your life is treatment is going to help you understand how you lead your life. Okay, early diagnosis and comprehensive treatment including pharmacological, psychosocial and supportive intervention can bring about a good change in the life of patients of schizophrenia and other psychotic spectrum disorder. All right, thank you. Very good afternoon. I'm Dr. Ritika Singh, Senior Resident in the Department of Psychiatry. So the topic for today's discussion is other psychotic disorders. As you all know, last time we had covered schizophrenia, schizotypal and persistent delusional disorder. So moving forward in the same categories, under the same certain symptoms are going to be the similar. We'll have other psychotic disorder, which will include ATPD, which means acute and transient psychotic disorder, induced delusional disorder, schizoaffective and postpartum psychosis. So we have 4 topics today under the one subheading. So we'll be covering these topics under the following headings. Moving on to the introduction part. So as you all know, last time also I have told you that psychosis is a term in which there are certain characteristic features, like there would be loss of contact with reality, patient would have delusions, will have hallucination, his behavior will be disorganized, he will be agitated. So a mental state characterized by loss of contact with reality, which leads to delusion, hallucination, disorganized thinking and impaired functioning. Overall functioning because of all these problems is going to be deteriorated. So psychosis is something which covers, it is a broad term which covers all of this. So apart from schizophrenia, there are other psychotic disorder which are characterized by sometime temporary or sometime persistent loss of contact with reality. So certain examples of other psychotic disorders include acute and transient psychotic disorder, induced delusional disorder, schizoaffective and postpartum psychosis. These are the topics which we will be covering one by one today. So they differ from schizophrenia. Last time also we have seen that schizotypal and persistent delusional disorder differ in terms of duration, severity and underlying causes. So are these diagnoses. Early identification and interventions are crucial to prevent complications and to ensure a better outcome. So the prognosis of the disease is not worsen if we'll diagnose it early and we'll treat it early. Starting with ATPD, acute and transient. So it is going to be acute, very short, and transient for a brief period of time. नाम से समझ में आ रहा है, acute and transient psychotic disorder. So it is a psychotic disorder which is characterized by an acute onset of psychotic symptoms. Psychotic symptom includes delusion, hallucination, disorganized behavior, which resolve within weeks or few months. And more often than not, it is associated with certain acute stressor. Maybe certain life-changing event, maybe certain financial stressor, some emotional stressor can be associated with the same. So sudden onset, brief duration, less than 1 month, and most of the cases recovery occur almost all. So when we talk about epidemiology, the global prevalence vary by region to region. Okay, it is seen that ATPD is comparatively higher in developing countries in comparison to developed country. More common in women than men, but the data is not very clear regarding this. Typically seen in young adults 20 to 40 years and higher reported in Asia, Africa as compared to Western countries, which we have already seen. So the factors or the causes, like last time we discussed biopsychosocial model of disease. This time also we'll see there are certain biological factors like certain genetic predisposition, neurochemical dysregulation, especially dopamine is one chemical, and then psychological acute stressor. In this case, acute stressor is very important. Socio-cultural pressure and substance use and sleep deprivation can be also associated with the initiation of this disease. So clinical features, the symptom appears acutely. यहाँ पे acute को define किया है within 2 weeks of time. So again we have seen the certain clinical features like delusions, which can often be persecutory or grandiose in nature. Persecutory last time also I told you, and अभी आप लोगों ने भी बताया था कि शक वहम करने लगता है, ठीक है, कि जो लोग नहीं, जो सच नहीं है उसको भी बोलता है कि मेरे खिलाफ लोग ऐसी चीजें बोल रहे हैं, ठीक है. Hallucination, you told me कि आवाजें सुनाई देती हैं जो आसपास नहीं होती है, उनकी आवाजें सुनाई दे रही है, या कोई दिखाई दे रहा है जो और लोगों को नहीं दिखाई दे रहा है. Disorganized speech and behavior, emotional instability, can be very agitated, can be very quiet, and can be very aggressive as well, physically aggressive as well. Okay, there could be a stage of confusion and disorientation in this condition. No, we'll discuss about it afterwards. Okay, I'll tell you. Duration, symptom typically lasts a few days to week but resolves within 1 month. So ICD-10 ने कुछ diagnostic criteria दिए हुए हैं. Whatever we have seen in clinical features up till now, these are going to be the diagnostic criteria as ICD-10 के भी, but language थोड़ी सी बनाई हुई है. So development of psychotic symptom within 2 weeks या less. तो 14 days या उससे कम में अगर आ रहे psychotic symptom की history है, तो ATPD के अंदर we'll classify it. Then typical syndrome of psychotic features, which we have already discussed, कि आपका delusion, hallucination, disorganized behavior. Come sit, ठीक है. Then presence of acute stressor, resolves within 1 to 3 months with complete remission expected. Okay, and it should be, अगर define कर रहे हो तो you should keep in mind कि no evidence of schizophrenia और other कोई affective disorder है, उसके symptoms तो नहीं है. कोई deliberate substance induced या organic कोई head injury या इसकी वजह से तो नहीं आया, then we will classify it into another form of disease. Okay, तो मोटा ATPD में ये याद रखना है, जल्दी शुरू होता है, थोड़े समय के लिए रहता है, एक स्ट्रेसर साथ में है, सिम्टम्स मोर और लेस जैसे आपको स्किज़ोफ्रेनिया में साइकोटिक सिम्टम्स मिलते हैं वो मिलेंगे, और बहुत जल्दी रिजॉल्व हो जाता है ट्रीटमेंट अगर सही टाइम पे मिलेगा तो, ठीक है. उसके डिफरेंशियल डायग्नोसिस में स्किज़ोफ्रेनिया, उसमें डिफरेंस क्या होगा कि लॉन्गर ड्यूरेशन, ठीक है, ये एक्यूट और ट्रांजिएंट है, स्किज़ोफ्रेनिया इज फॉर लॉन्गर ड्यूरेशन एंड क्रॉनिक कोर्स. बाइपोलर डिसऑर्डर में यू विल हैव एसोसिएटेड मूड सिम्टम्स. सब्सटेंस इंड्यूस में क्लियर लिंक टू सब्सटेंस, नो अदर कोई और सिम्टम नहीं होगा, लेकिन सब्सटेंस लेना इज द की फीचर ओवर हियर. एंड डेलीरियम इज मोर और लेस एसोसिएटेड विद सम मेडिकल कंडीशन एंड देयर विल बी फ्लक्चुएटिंग कॉन्शियसनेस, ठीक है. So how are you going to assess? सो लास्ट टाइम आपको असेसमेंट, हिस्ट्री टेकिंग और इवैल्यूएशन पार्ट बताया था. तो हियर आई विल टेल यू इन ब्रीफ कि इसमें पॉजिटिव पॉइंट्स क्या देखने कि ऑनसेट शॉर्ट ड्यूरेशन में हुआ है, ड्यूरेशन एंड प्रोग्रेशन ऑफ सिम्टम्स सडन वर्सेस ग्रेजुअल तो नहीं है, एसोसिएटेड प्रेसिपिटेटिंग फैक्टर्स सच एज स्ट्रेस, ट्रॉमा और सब्सटेंस यूज. ओके, then you have to see कोई personal या family history of psychiatric illness तो नहीं है. You have to identify any stressor, their coping abilities and social support. And in MSc, especially you will see the thought process, delusion अगर तो नहीं है, perception, mood and insight. Okay, rule out organic cause. कोई head injury का history तो नहीं है, आपको history portion में आएगा. You will have to rule out cognitive functions कैसे चल रहे हैं. All right. डायग्नोस्टिक के लिए आपको लैब इन्वेस्टिगेशन के साथ साथ अगर एसोसिएटेड ईईजी कराने की जरूरत है, सीटी एमआरआई कराने की जरूरत है तो यू कैन डू इट. बिकॉज अगर एक्यूटली कोई साइकोटिक सिम्टम्स के साथ प्रेजेंट कर रहा है तो बहुत बार वो कोई ऑर्गेनिक या मेडिकल कॉज रिलेटेड भी हो सकता है जिसमें साइकोटिक सिम्टम तो होंगे बट वो डायग्नोसिस मेडिसिन के अंडर आएगी रेदर देन साइकाइट्री के. तो ऐसे में अगर हम गलत मैनेज करेंगे ना तो पेशेंट की लाइफ थ्रेटन हो सकती है. ऑलराइट. Then scales, I have last time also told you कि BPRS है, आपके PANS scale है, तो ये सब आप देख लगाएंगे. मैनेजमेंट पार्ट में एंटीसाइकोटिक्स आप सेकेंड जनरेशन लाइक ओलैंजापीन, रिस्पेरिडोन और फर्स्ट जनरेशन हेलोपेरिडोल दे सकते हैं. बेंजोडाइजेपीन स्पेशली क्लोनाजपाम या लोराजेपाम बोथ इंजेक्टेबल और ओरल इन इनिशियल फेज टू रिड्यूस द एजिटेशन ऑफ द पेशेंट एंड टू हेल्प पेशेंट स्लीप. If a patient is presenting harm to himself or his surroundings, then hospitalization should be considered. Certain cases, acute cases of psychosis requires hospitalization. So in that case, patient के attendant लेके आते हैं patient को, and at that time, a quick and thoughtful management of patient is necessary. Monitoring follow-up, regular assessment of symptom resolution, medication adherence, and potential relapse prevention. So if you once know कि certain triggering factor हैं जिसकी वजह से इस बार ये disease आई है, तो you can address them and you can tell them how to cope up with them and how to maintain distance from certain stressing factor. Strong family and peer support is also helpful. Psychoeducating the patient regarding the illness, need of medications, need to continue medication for how long period of time, repeated follow-up, and staying away from substances is something you'll have to tell patient when you're psychoeducating the patient. Relapse prevention, identify and manage triggers, encourage stress management strategies, and provide psychotherapy if needed. So prognostic factors, if we'll see, it is seen in comparison to male, female gender have better chances of resolving the disease in a better way. Acute onset and presence of an identifiable stressor. अगर आपको पता है कि stressor की वजह से ही disease आई है, rather than बिना किसी stressor के, so there are chances कि there will be a good outcome of the disease. Okay. There are chances that this disease in future may be converted into a chronic course. It can convert into schizophrenia or chronic psychotic disease. All right. So this is about ATPD. Next, we'll move on to induced delusional disorder. So you, as a name suggests, it is induced. ये डाला गया है, ठीक है? Delusion है नहीं, डाला गया है. So in the picture also you can see there are two individuals. So induced delusional disorder is also known as Fourier-Dix. Okay? क्या बोलते हैं? Fourier-Dix. It is a rare psychiatric condition in which a delusion is transmitted from one person to another. ठीक है? So what happened? There is one primary person and another secondary person. So primary person is the one who has the psychiatric illness. He might have delusional disorder, he might have schizophrenia, but due to the close relationship with the secondary person, that person transfers his delusion and his thoughts to another person. ठीक है? So the secondary person might not have any disease, but because of how closely he is attached to the first primary person, that delusion might get transferred or induced into that secondary person. समझ में आया क्या बोलना चाह रही हूँ? ठीक है? So it is under पहले के जमाने में इसको shared psychotic disorder या communicated insanity भी बोलते थे. Communicated एक से दूसरे को communicate हो रहा है और shared because share कर रहे हैं दो लोग अपना delusion. All right? Shared delusional belief occurs in close emotional relationships, example family and partners. Secondary individual adopts the delusions of primary one. It is very rare. Shared psychotic delusion, shared delusional disorder is quite rare. Okay. Some cult might have some religious practices or some other form of practices which may or may not include this kind of delusion. Okay. Social, certain risk factors are associated with induced delusional disorder, like social isolation. So both primary and secondary person are in a close relationship and they are socially isolated from outside world. They have very strong codependent on each other, and pre-existing psychiatric illness is present in the primary person. So psychosocial factors include dependence on the dominant person, emotional closeness, and suggestibility. Suppose there are two sisters living in the same house. Elder sister has psychiatric illness. Okay, the younger sister doesn't have psychiatric illness, but they do not go outside. They just talk to each other. They have no idea what is going on in the outside world. Maybe their family relationship or dynamic is not good. उनके parents की आपस में नहीं बनती, घर में लड़ाइयाँ चलती है. फादर माइट भी सब्सटेंस यूज करते हो, आसपास का माहौल पता ही नहीं है, घर के बाहर भी अगर जाएंगी तो साथ में ही जाएंगी. तो ऐसे में क्या होता है दैट सेकेंडरी पर्सन हैज नो आइडिया ऑफ आउटसाइड वर्ल्ड, उसका कोई कांटेक्ट ही नहीं है. उसके लिए कांटेक्ट पर्सन सच्चाई सब प्राइमरी पर्सन है. सो इफ प्राइमरी पर्सन इज सेइंग कि वो इंसान गलत है तो शी बिलीव्स इट. कोई आप उसके पास प्रूफ नहीं है कि वो गलत है, अगर आप प्रूफ प्रेजेंट भी करोगे तो वो मानेगा नहीं सेकेंडरी पर्सन भी उसको. ऑलराइट. So emotional closeness and suggestibility. So biological factors like genetic predisposition to psychiatric illness, social factors, isolation from outside world, environmental stressor, family conflict, cultural beliefs. Certain cultural beliefs भी होती है जो shared की जाती है, but कभी-कभी वो cultural belief delusional level पे भी पहुंच जाती है. So that could be one of the causative factor. So when we talk about clinical features, we have primary versus secondary. Okay. So primary is inducer who has a genuine psychotic disorder, example schizophrenia. Secondary adopts a delusional belief but may not have an underlying disorder. Development of shared delusion occurs gradually over time. ठीक है, धीरे धीरे बढ़ता जाएगा, often unnoticed by the family members. Other member of family को starting में पता नहीं चलेगा, starting में लगेगा चलो उसकी जैसी बात कर रही है, उसके जैसे बोल रही है, but eventually वो उसके जैसा the secondary person will adopt all the characteristics and traits of primary person. All right. So as you can see, it is shared among the two individuals. So what you will see the behavioral changes, the affected individuals, both primary and secondary, they will start living in isolation. They will reinforce their shared delusions on each other. So अगर बड़ी बहन ने बोला जो पड़ोस वाले हैं ना वो लोग बहुत खराब है, वो हमारे घर में कुछ कुछ जादू टोना कर रहे हैं, तो सेकेंडरी वाला भी बोलेगा हाँ आप सही बोल रहे हो, वो अपने फैमिली को भी यही कम्युनिकेट करेगा कि ऐसा ऐसा हो रहा है. या अगर वो किसी दिन आपने पूछा क्या हो रहा है तो दैट सेकेंडरी पर्सन उसी कन्विक्शन से बोलेगा कि हम जो हमारे पड़ोस वाले हैं हम पे जादू टोना कर रहे हैं. Reinforcing shared delusional belief without external reality testing. It doesn't matter बाहर क्या हो रहा है, ठीक है. Anxiety, suspiciousness and social withdrawal. Secondary individual may exhibit behavior consistent with delusion such as avoiding perceived threat. तो वो अगर primary वाला बाहर नहीं निकल रहा है घर से बाहर क्योंकि उसको पड़ोसियों से डर है, तो secondary वाला भी निकलना बंद कर देगा, नहीं जाएंगे because पड़ोसी मुझे नुकसान कर देंगे. So the same behavior pattern is followed by the secondary person also. Then if you will present, it will adopt all the characteristics of disorder. She in general, अगर हम biologically बोले तो first person has the disorder, secondary doesn't. All right. So both individuals strongly adhere to their shared belief and dismiss opposing viewpoint. अगर आप लोग उनको confront भी करोगे ना, they'll say against you. नहीं आप गलत हो, हम सही हैं. ठीक है, they will bring certain reasoning of their own to stand with their point. They lack awareness of the irrationality of their beliefs and may be resistant to seek help. The secondary person often shows improvement or resolution of symptom when separated from primary individual. Though it will take time, but it is also seen कि अगर secondary person को primary से दूर किया जाए, तो धीरे धीरे secondary person का जो delusion है वो resolve होने लगता है. Diagnostic criteria same जो हमने भी clinical features पढ़े हैं. 2 or more people share the same delusion or delusional system and support one another in this belief. They have unusually close relationship. There is a temporal or contextual evidence that the delusion was induced in the passive member of the pair of group by the contact with active member. सब टाइप भी होते हैं, ठीक है। कभी कभी दो, जैसे 2 लोगों में हुआ तो फोले डीएक्स कॉमनली जिसको हम बोलते हैं, 3 लोगों में हुआ तो फोले ट्रायोस, फोले फैमिली, फोले प्लशियोर, दैट इज ग्रुप में। अगर आपको याद होगा एक बुराड़ी केस हुआ था, उसमें एक फैमिली के बहुत सारे मेंबर्स दे वर फाउंड डेड, ठीक है। तो ये सस्पेक्ट किया जा रहा था कि वो भी एक केस हो सकता है मास डिल्यूजनल या फिर आपका ये फोलियर फैमिली का। कोई कंक्लूजन ड्रॉ नहीं हुआ, बट एक सस्पिशन था कि ये शेयर डिल्यूजन डिसऑर्डर जैसा कुछ हो सकता है। डिफरेंशियल डायग्नोसिस में स्किज़ोफ्रेनिया, आपको पता है कि पर्सिस्टेंट डिल्यूजन जो होंगे इन्फ्लुएंस नहीं होगा दूसरा इंसान, ठीक है। पीडीडी में भी यही है। कुछ कल्चरल बिलीफ्स होते हैं डिफरेंशियल डायग्नोसिस में, याद रखना कि किसी किसी कल्चर में माना जाता है कि सपोजिटली कि काला कपड़ा पहनना खराब है, ठीक है ना। वो कल्चरल बिलीफ हो सकता है, वो ये नहीं कि एक पर्सन ने माना है दूसरे पर्सन भी मानेगा इसलिए मान रहा है तो डिल्यूजन हो गया, बट वो कल्चर में सब जगह माना है, वो एक्सेप्टेबल है, ठीक है। कुछ फैक्टिशियस डिसऑर्डर और मलिंगरिंग की लोग जानबूझ के दिखाने के लिए भी ऐसा कर सकते हैं, ठीक है। इसमें कन्विक्शन और चैलेंजेस के साथ डिल्यूजन कम हो जाता है। अगर आप कन्विक्ट करोगे, कुछ रीजनिंग दोगे, तो वो उस कन्विक्शन के साथ नहीं बोलेगा पेशेंट, ठीक है। देन सब्सटेंस इंड्यूस में सब्सटेंस यूज है। मूड डिसऑर्डर में आपको मूड अफेक्टिव मूड सिम्टम्स मिलेंगे। So, well, you'll take the history in this case, you will assess how close the relationship between the two individuals is and how socially isolated they are from outside world. So, these are the two important factors you will find in history. Okay. And then फिर gradually family से पूछोगे कि पहला इसका nature कैसा था secondary person का, उसके बाद धीरे धीरे over what time nature started to change. Gather input from family or caregiver to understand the influence of dominant individual and social dynamics. MSc में you will evaluate thought content for shared delusion, level of insight, emotional dependence between individual. Then again diagnostic investigation में you have to rule out कोई medical या neurological cause तो नहीं है. Separation assessment is something. Observe changes in delusional belief when the affected individual is separated from the primary delusional person. So once you separate these two people from for quite a time, this is also a part of management. ठीक है। so साइकोलॉजिकल सिम्टम्स जो सेकेंडरी इंडिविजुअल में है विद टाइम हम उसमें कम हो जाते हैं, उसको थेरेपी से हो सकता है दवाई की सेकेंडरी इंडिविजुअल में जिसमें डिसऑर्डर नहीं है दवाई की जरूरत ही ना पड़े, विद थेरेपी विद सेपरेशन फ्रॉम द प्राइमरी इंडिविजुअल ही और शी माइट रिजॉल्व टू हिज प्रीमॉर्बिड स्टेट. Then primary individual might require antipsychotic and mood stabilizer. And secondary individual may at some time, because अगर affective symptoms बहुत आ गए हैं, उसका behavior बहुत ज़्यादा खराब होने लग गया, तो short term antipsychotic short term के लिए दे सकते हैं, या फिर कोई anxiolytic की उसकी anxiety part कम हो जाए उसके लिए दे सकते हैं. Psychotherapy to challenge delusional belief and enhance insight. And most importantly, family and social intervention. You have to educate the family that इसका दूसरा सेकेंडरी पर्सन का प्राइमरी पर्सन के साथ इतना क्लोज रिलेशनशिप कैसे सेकेंडरी पर्सन को हार्म कर सकता है, हार्म कर रहा है. हो सकता है प्राइमरी पर्सन की डिजीज बहुत सिवियर उसकी हो, उसके ट्रीटमेंट में बहुत टाइम लग जाए, उसका ट्रीटमेंट हो सकता है कभी वो फुल रिकवरी ना कर पाए, अगर करे भी तो माइट बी आफ्टर एजेस, ठीक है. और तो लेकिन सेकेंडरी पर्सन इज समवन जो कि फुल्ली फंक्शनल हो सकता है जस्ट आपको सेपरेट करना है, ठीक है. So early intervention and separation and strong social support are something favorable factors. Poor prognostic factor क्या है, अगर long term से साथ में long lasting delusion है और जैसे ही वापस लेके आ रहे हैं separate करने के बाद वापस delusion form हो जा रहा है, तो this is poor prognostic factor. Done. Induced delusional disorder समझ में आया. थर्ड आपका है schizoaffective. Schizophrenia भी है, affective symptoms भी है, यानी कि mood symptoms भी है. तो दो चीजें हैं इसमें. Schizoaffective disorder is a complex mental health condition which is characterized by presence of both schizophrenia-like symptoms जैसे कि delusion, hallucinations and mood disorder, mania, depression दोनों हो सकता है. First introduced by Kassanen in 1933 as a disorder combining both schizophrenia and mood disturbances. So presence of key features है psychotic symptom independent of mood symptom, and mood symptoms are prominent for a substantial duration of illness. देखो क्या होता है ना, बहुत कुछ टाइम के लिए जो साइकोटिक सिम्टम आ जाएंगे उसमें, उसके बाद मूड सिम्टम आएंगे, ठीक है, और फिर वो मूड सिम्टम काफी प्रोमिनेंट रहेंगे. So lifetime prevalence is 0.5 to 8%. ऑलमोस्ट इक्वल डिस्ट्रीब्यूशन अमंग मेल एंड फीमेल अगर बाइपोलर टाइप का स्किज़ोअफेक्टिव है. डिप्रेसिव टाइप ऑफ स्किज़ोअफेक्टिव इज सीन मोर कॉमनली इन फीमेल्स. Depressive type is more common in older, whereas bipolar type is more common in younger adult. Age of onset, like in schizophrenia, we have seen कि age of onset in female is little later in comparison to male. Similarly, in schizoaffective also, it is quite later in comparison to male. So again, you have strong neurobiological factor in etiology, strong genetic component with evidence suggesting familiar aggregation of both schizophrenia and mood disorder. Abnormal structure and function in the brain, then neurochemical imbalance, psychological factors, substance abuse, major life events and childhood trauma. Now we'll see with clinical feature. Clinical feature में we can have schizophrenia-like symptoms, again delusion, hallucination, disorganized behavior, negative symptoms, and then you have mood disorder. Mood disorder का you can have depressive symptom, you can have manic symptom like sadness, hopelessness, anhedonia, apathy, lack of interest वगैरह ये मिलेगा. Whereas manic symptom में काफी elevated या irritable mood मिल सकता है, बहुत increase energy है, बहुत बड़ी-बड़ी बातें grandiosity हो रही है, बहुत ज्यादा ओवर स्पेंडिंग हो रही है, एक्सेसिव फेमिलियरिटी है, ये सब भी मिल सकता है. ठीक है, I'll tell you after the class. Okay. Cognitive impairment, poor executive functioning and impaired memory and attention. All right. Then we have diagnostic criteria. So F25 बोलता है schizoaffective disorder. So what are the diagnostic criteria? Presence of both definitive mood disorder, depressive or manic, and definitive schizophrenic symptoms are prominent simultaneously or within a few days of each other within the same episode of illness. Okay, यानी कि आपका जो स्किजोफ्रेनिया है और ये मूड सिम्टम है एक ही एपिसोड में होना चाहिए. ऐसा नहीं कि आपका मूड डिसऑर्डर पहले हुआ और पूरा रिजॉल्व हो गया उसके बाद आपका स्किजोफ्रेनिया हो रहा है. नो, ये एक ही सिंगल एपिसोड में दोनों चीजें होनी चाहिए. As a consequence of which episode does not match the criteria of either schizophrenia or mood disorder. It should be applied for patient who exhibit symptom of schizophrenia or affective symptom. It should not be applied in patient जिनमें अलग-अलग episode में schizophrenia और mood disorder आ रहा है. So DSM-5 ने भी यही criteria दिया है. उन्होंने बस एक चीज ये बोली कि जो delusion और hallucination है वो 2 weeks पहले होने चाहिए mood disorder से. ठीक है, एटलीस्ट 2 weeks का आपका symptom होना चाहिए स्किजोफ्रेनिया के सिम्टम्स का, फिर मूड डिसऑर्डर आना चाहिए. बाकी मोरल है सिमिलर टू आईसीडी. सो देयर कुड बी मेनिक टाइप जिसमें मेनिया के सिम्टम्स ज्यादा हैं, दे कुड बी डिप्रेसिव टाइप जिसमें डिप्रेशन के सिम्टम्स ज्यादा हैं, दे कुड बी मिक्स्ड टाइप जिसमें दोनों सिम्टम्स होते हैं. Differential diagnosis, similarly you have to differentiate it with bipolar disorder with affective symptom. आपका पोस्ट स्किजोफ्रेनिया डिप्रेशन भी एक चीज होती है कि स्किजोफ्रेनिया के बाद भी आपका डिप्रेशन आ जाता है, उससे डिफरेंशिएट करना आना चाहिए. नेगेटिव सिम्टम्स ऑफ स्किजोफ्रेनिया से डिफरेंशिएट करना आना चाहिए और बाकी कोई ऑर्गेनिक कॉज तो नहीं है. ठीक है. अगेन इन हिस्ट्री रिमेंबर कि एक ही एपिसोड में आपके स्किजोफ्रेनिया और डिप्रेशन के सिम्टम है. Assess the duration and pattern of mood and psychotic symptom, including periods of overlap and independent psychotic episodes. If psychotic symptom persists for at least 2 weeks in the absence of mood disorder. MSc में अफेक्ट पार्ट में देखोगे कोई डिप्रेसिव तो नहीं है या इलेटेड अफेक्ट तो नहीं है. मूड देखोगे पेशेंट का, थॉट में देखोगे कि आपका डिल्यूजन तो नहीं आ रहा है, परसेप्शन में देखोगे हेलुसिनेशन तो नहीं आ रहा है, कॉग्निटिव फंक्शन और इंसाइट डेवलप करोगे. मैनेजमेंट पार्ट में रिमेंबर आपका ये अफेक्टिव भी है तो इसमें दोनों चीजें आती हैं. आपका एंटीसाइकोटिक भी आएगा और आपका एक मूड स्टेबलाइजर भी आएगा अलोंग विद, अगर डिप्रेसिव टाइप है तो एंटी डिप्रेसेंट आएगा. ठीक है. एंटीसाइकोटिक में ओलैंजापीन, हैलोपेरिडोन, रिस्पेरिडोन, लिथियम एंड वैल्प्रेट आर गुड मूड स्टेबलाइजर एंड एनी मोड ऑफ एंटी डिप्रेसेंट एसएसआरआई जैसे कि एसिटाइलोप्राम या सर्ट्रोलिन है ये दे सकते हैं. हॉस्पिटलाइजेशन इफ नीडेड, अगर सुसाइडल रिस्क है, पेशेंट बहुत ज्यादा साइकोटिक हो रहा है या फिर पेशेंट रिफ्यूजल टू ट्रीटमेंट है तो हॉस्पिटलाइजेशन इज रिक्वायर्ड एंड उस टाइम पे फिर आपको एक क्विक मैनेजमेंट करना पड़ता है. टू साइको एजुकेट द पेशेंट इन ऑर्डर टू टीच पेशेंट द कोपिंग मैकेनिज्म, हाउ टू इवैल्यूएट फॉर फर्दर रिस्क, इसके लिए साइकोथेरेपीज की हेल्प ली जा सकती है. Social skill training to improve interfunctional functioning, interpersonal functioning, vocational rehabilitation, community support, regular psychiatric evaluation to prevent relapse. So good अगर प्रीमॉर्बिड फंक्शनिंग, डिजीज होने से पहले अगर पेशेंट काफी अच्छे से फंक्शन कर रहा था, एक अच्छा एजुकेटेड इंसान है, उसका सोशो इकोनॉमिक स्टेटस ठीक चल रहा है, वो उसकी कोपिंग मैकेनिज्म अच्छी है, ठीक है, अच्छा सोशल सपोर्ट है, ठीक है, वो अपने काम को लेके पॉजिटिव है, अगर ये सब चीजें डिजीज होने से पहले की जो उसकी पर्सनालिटी है वो अच्छी रही है, तो ये गुड प्रोग्नोस्टिक फैक्टर होता है कि रिजोल्यूशन सही होगा, आउटकम, अगर डिजीज हो गया ट्रीटमेंट देंगे तो आउटकम अच्छा आएगा. अगर ट्रीटमेंट से बार बार छोड़ दे रहा है, फॉलो अप के लिए सही से नहीं आ रहा है, तो दिस इज बैड प्रोग्नोस्टिक फैक्टर कि इसमें क्रॉनिक केस में चला जाएगा. डिप्रेसिव टाइप ऑफ स्किज़ोअफेक्टिव डिसऑर्डर जनरली हैज अ बेटर आउटकम. ओके, डन. स्किज़ोअफेक्टिव में मोटा मोटा ये समझना है कि स्किज़ोफ्रेनिया के सिम्टम्स भी हैं और अफेक्टिव सिम्टम भी हैं, लेकिन दोनों एक ही एपिसोड के अंदर है, अलग अलग नहीं है. आईसीडी सॉरी DSM-5 के अकॉर्डिंग कि 2 वीक्स पहले आ जाना चाहिए जो आपके साइकोटिक सिम्टम है मूड डिसऑर्डर से. ठीक है, फिर हमारा है आज का लास्ट पार्ट, पोस्टपार्टम साइकोसिस. टर्म पोस्टपार्टम का क्या मतलब होता है? आफ्टर बर्थ या आफ्टर डिलीवरी. ठीक है, सो साइकोसिस अगर पोस्टपार्टम आ रही है तो हम इसको पोस्टपार्टम साइकोसिस बोलते हैं. ऑलराइट, नाउ दिस इज वेरी इंपॉर्टेंट बिकॉज यहाँ पे रिस्क ऑफ हार्म टू बेबी हो सकता है. ठीक है, under the psychotic state, mother cannot take care of a baby, or she can have certain feelings of harming the baby. So यहाँ पे इसको it is quite necessary to manage it very quickly and in a very effective way. Postpartum psychosis is a severe mental health condition that occurs in the postpartum period, characterized by sudden onset of psychotic symptoms such as delusions, hallucinations, mood disturbances, and disorganized behavior, typically within 2 weeks after childbirth. Rapid progression and require urgent intervention due to risk of harm to self and baby. Not that common, 1 in 2 per thousand postpartum women. Recurrence rate is 30 to 50% in subsequent pregnancy if not treated. Suppose first pregnancy में patient को postpartum psychosis हुई है तो there are chances कि 30 to 50% recurrence rate है कि second उसमें भी होगी अगर आपने इसको treat नहीं किया है तो. ठीक है, ट्रीटमेंट के बाद भी चांसेस रहते हैं, बट इफ द पेशेंट इज मैनेज्ड प्रॉपर्ली, उसको पता है इलनेस के बारे में, तो थोड़े चांसेस कम हो जाते हैं. More common in first time mother, more common in developing country, higher stigma and under reporting in some region. होता है कि बहुत जगह और जगह भी होता हो, जितना हमको ये रेट मिल रहा है इससे ज्यादा मिलता हो because of stigma और under reporting और not no much awareness regarding the postpartum psychosis, so उसकी reporting कम होती है. सो बायोलॉजिकल फैक्टर्स की बात करें यहाँ पे तो थोड़ा ये समझना है कि अदर देन जो हम न्यूरोकेमिकल इम्बैलेंस और डिजीजेस में पढ़ते हैं, रिमेंबर कि इसका कोरिलेशन देखा गया है ईस्ट्रोजन एंड प्रोजेस्टेरॉन की डिसफंक्शन से. ठीक है, सडन हार्मोनल शिफ्ट्स आफ्टर डिलीवरी पर्टिकुलरली इन ईस्ट्रोजन एंड प्रोजेस्टेरॉन लेवल्स आर बिलीव्ड टू इन्फ्लुएंस द मूड रेगुलेशन एंड इंक्रीज ससेप्टिबिलिटी टू साइकोसिस. Hypothalamic pituitary adrenal axis का dysregulation has also been seen connected to mood instability. Then dopamine and serotonin and norepinephrine glutamate जो disbalance है वो you know already. Okay, जो postpartum time period होता है वहाँ पे lack of sleep, exhaustion female को बहुत होता है, तो it also leads to cognitive and emotional disturbances. स्पेशली अगर पास हिस्ट्री ऑफ कोई साइकेट्रिक इलनेस रही है या फिर पॉजिटिव फैमिली हिस्ट्री रही है, अगर आपकी फैमिली में विमेन किसी और को भी पोस्टपार्टम साइकोसिस की हिस्ट्री रही है तो देयर आर चांसेस कि आपको भी हो सकता है. ठीक है, मैं ये नहीं कह रही हूँ कि होगा ही होगा, बट प्रोबेबिलिटी थोड़ी बढ़ जाती है जनरल पॉपुलेशन के कंपैरिजन. विमेन विद द हिस्ट्री ऑफ फैमिली हिस्ट्री ऑफ बाइपोलर, स्किज़ोफ्रेनिया और पोस्टपार्टम साइकोसिस हैव अ हायर रिस्क. Certain autoimmune and inflammatory cytokines have also been said to be responsible for that, but the correct role is not been identified. Psychosocial factor, personal history of mental illness, inadequate coping mechanism and lack of emotional resilience. It can also exacerbate the psychological strain. Stressful childbirth experience और unplanned pregnancy, especially primary अगर gravida है, primary pregnancy है, तो उसमें पता नहीं होता है कि how to take care of a child. The sleep pattern, the activities of the children is unknown. It is a state of आपको फिजिकल resilient भी होना चाहिए, फिजिकली भी और मेंटली भी resilient होना चाहिए. इमोशनल फाइनेंशियल हर तरीके की नीड आपको आफ्टर अ बर्थ ऑफ बेबी होती है. ठीक है. सो इफ इट इज नॉट प्लान्ड और इफ द पार्टनर और द फैमिली मेंबर्स आर नॉट सपोर्टिव, सो the stress and coping mechanism of the female is disturbed. It can also lead to certain psychological downfall of a patient. Lack of social support, cultural expectation and pressure. Societal expectations surrounding motherhood, especially in cultures with high pressure for maternal perfection, can contribute to feeling of inadequacy and distress. Financial stress, lack of access to health care and inadequate living condition can increase psychological burden. Any history of domestic violence है, childhood trauma है, कोई recent stressful event है, that can also lead pregnancy के time पे अगर कुछ ज़्यादा stress आ गया, can lead to postpartum psychosis. So very important जो इसके psychotic symptom है, often they are related or surrounded towards baby, often related to baby. Delusions are often related to baby. Example, they might have certain urges to harm the baby or neglect the baby. Hallucination commanding harm to self or baby, disorganized thought and speech, not taking care of baby, not breastfeeding the baby. Behavioral symptoms में neglect और overprotectiveness towards the baby, या तो बिल्कुल neglect होगी या फिर overprotective हो जाएगी कि other people are going to harm my baby. This can also come. Severe mood swing, very depressive, very euphoric, very agitated, irritability, emotional lability, infanticidal thoughts and social withdrawal. Poor concentration and decision making. Mother might be exhausted but still she cannot sleep. Confusion and memory disturbances. So it comes under the ICD classification F53.1, severe mental and behavioral disorders associated with purpura. So thus क्या diagnostic criteria है? They occur within 6 weeks postpartum. Severe disturbance in behavior and perception, not attributable to medical conditions. डिफरेंशियल डायग्नोसिस में आप 2-3 टर्म्स याद रखिए. पोस्टपार्टम साइकोसिस के अलावा 2 टर्म और होते हैं, पोस्टपार्टम ब्लूज और पोस्टपार्टम डिप्रेशन. पोस्टपार्टम डिप्रेशन इज बेसिकली डिप्रेसिव सिम्टम्स होंगे, साइकोटिक सिम्टम नहीं होंगे, डिप्रेसिव सिम्टम ज्यादा होंगे. एंड पोस्टपार्टम ब्लू लेस सीवियर देन पोस्टपार्टम डिप्रेशन होंगे, उसमें भी थोड़े से आपके डिप्रेसिव सिम्टम बट नॉट टू द सिवियरिटी ऑफ पोस्टपार्टम डिप्रेशन. ठीक है. पोस्टपार्टम डिप्रेशन में आपका predominantly mood related symptoms such as persistent sadness, guilt, anhedonia and fatigue. Bipolar disorder, history of bipolar disorder और episodes of mania before pregnancy है. Schizophrenia अगर before pregnancy है, वो आपका pregnancy के time पे भी अब regulate हो सकता है. Suppose patient एक mood disorder के patient है, maintain well कर रही है जो भी दवाई चल रही है उसकी, लेकिन delivery के time पे हो सकता है sign and symptom fluctuate कर जाए, पोस्टपार्टम टाइम पे साइन एंड सिम्टम फ्लक्चुएट कर जाए, तो वहां पे जो पहले से जो दवाइयां चल रही हैं वो आपको एडजस्ट करनी पड़ती है. बहुत सारी दवाइयां प्रेगनेंसी के टाइम पे या ब्रेस्ट फीडिंग के टाइम पे सेफ नहीं होती हैं, तो उसमें चेंजेस लाते हैं. अगर पेशेंट किसी नोन केस ऑफ साइकियाट्रिक इलनेस है, उन दवाइयों को चेंज करने की वजह से भी मूड सिम्टम्स या साइकोटिक सिम्टम बढ़ सकते हैं. तो दिस थिंग्स यू हैव टू कीप इन माइंड कि ये दूसरी बीमारी से अलग कैसे है. सो जस्ट क्या बोलते हैं डिफरेंसेस, फ्यू डिफरेंसेस कि पोस्टपार्टम डिप्रेशन में आपका लो मूड है और साइकोसिस में आपका रैपिड चेंज होगा मूड का. ठीक है. साइकोटिक सिम्टम्स आर यूजुअली एब्सेंट इन पोस्टपार्टम डिप्रेशन, वे आर प्रेजेंट इन पोस्टपार्टम साइकोसिस. ओके. कभी कभी साइकोथेरेपी एंड लो डोज ऑफ मेडिकेशन से पोस्टपार्टम डिप्रेशन ट्रीट हो जाता है, बट साइकोसिस अगर है तो आपका नाइस मतलब काफी हद तक आपको रैपिड इंटरवेंशन, हॉस्पिटलाइजेशन, सेपरेशन ऑफ बेबी फ्रॉम द मदर की नीड हो सकती है. ठीक है. मोर कॉमन है पोस्टपार्टम डिप्रेशन इन कंपैरिजन टू पोस्टपार्टम साइकोसिस. अगर हाइपोग्लाइसीमिया है, एंजाइटी डिसऑर्डर है, इससे भी आपको इनको सेपरेट करना आना चाहिए. पोस्टपार्टम सेप्सिस, इन्फेक्शन की वजह से भी पेशेंट डिलीरियम में हो सकती है, तो डिलीरियम में भी फ्लक्चुएशन ऑफ कॉन्शियसनेस होता है, याद नहीं होगा कहाँ पे हूँ, कैसे हूँ, कभी पहचान रही है, कभी नहीं पहचान रही है. तो यहाँ पे आपको इन्फेक्शन रूल आउट करना है, फीवर अगर तो नहीं है, कोई यूटीआई तो नहीं है, तो ये सब चीजों को ट्रीट करोगे तो साइकोटिक सिम्टम कम हो जाएंगे। सिमिलरली पोस्टमार्टम ब्लूज डिप्रेशन है, साइकोसिस का डिफरेंस दिया हुआ है। ओके, डिटेल हिस्ट्री टेकिंग, इसमें आपका साइकेट्रिक हिस्ट्री के साथ साथ आपको ऑब्स्टेट्रिक हिस्ट्री भी देनी है, ठीक है। कोई डिलीवरी के टाइम पे कोई स्ट्रेसर तो नहीं था, विद इन डिलीवरी कोई प्रॉब्लम तो नहीं है, पोस्टमार्टम फेज में बेबी कैसा है, पेशेंट की हेल्थ कैसी है, तो ये सब चीजें भी आपको ढंग से ध्यान रखना होगा। कोई पास साइकेट्रिक हिस्ट्री तो नहीं है इस पेशेंट में साइकेट्रिक इलनेस की, कोई फैमिली हिस्ट्री तो नहीं है पोस्टमार्टम साइकोसिस या डिप्रेशन या कोई साइकेट्रिक इलनेस की। साइकोसोशल असेसमेंट, फाइनेंशियल, सोशल सपोर्ट, स्पाउस का सपोर्ट कैसा है पेशेंट का, ठीक है। इवैल्यूएट सपोर्ट सिस्टम, स्ट्रेसर एंड कोपिंग मैकेनिज्म, स्क्रीन फॉर डोमेस्टिक वायलेंस, सब्सटेंस यूज, लैक ऑफ फैमिली सपोर्ट। अगेन इन फिजिकल एग्जामिनेशन डू नॉट टेक इट लाइटली, आपका पेशेंट ऑब्स्टेट्रिक और गायनिक का पेशेंट भी है और साइकेट्रिक का पेशेंट भी है, और प्लस अभी उसने डिलीवरी करी है, तो शी हैज बीन थ्रू अ वास्ट अमाउंट ऑफ चेंजेस इन हर बॉडी। Check for signs of infection, endocrine dysfunction, neurological abnormality, general postpartum health, nutrition कैसा है, hydration कैसा है। MSc में keep be very sharp regarding कोई thoughts बेबी को harm करने को लेके तो नहीं है, okay? Evaluate insight, judgment, risk of harm to self or baby. इन्वेस्टिगेशन में रूल आउट ऑर्गेनिक कॉजेस, ऑलवेज रूल आउट ऑर्गेनिक कॉजेस, कोई इन्फेक्शन में इन्फेक्शन तो नहीं है, MRI CT स्कैन से कोई ऑर्गेनिक कॉज तो नहीं है। Hospitalization and safety measures, immediate hospitalization if the risk of harm to self or baby. Antipsychotics, atypical antipsychotics, basically they are comparatively जो safe है, olanzapine is safe, first generation में haloperidol आपका breastfeeding में भी comparatively safe है, ठीक है। मूड स्टेबलाइजर लिथियम, वैल्प्रोएट बहुत कम, ठीक है, फीमेल प्रेगनेंसी स्टेज में वैल्प्रोएट कम, लिथियम ज्यादा फेवरेबल है। ओलैंजापिन एज अ मूड स्टेबलाइजर भी काम कर देता है। बेंजोडाइजेपिन वैसे तो कॉन्ट्राइंडिकेटेड होती है आपकी, बट इफ एट ऑल नीडेड दे सकते हो लो डोज। ECT इलेक्ट्रोकन्वर्सिव थेरेपी इज वेरी सेफ, अगर पेशेंट अगर प्रेगनेंसी में मतलब साइकोटिक सिम्टम आ रहे हैं या पोस्टमार्टम भी आ रहे हैं, अगर सुसाइडल रिस्क है, कैटाटोनिया है, ट्रीटमेंट रेजिस्टेंस है। You have to also evaluate medication safety during lactation. Breastfeeding mother है, अगर suppose patient resolve कर गई है initially कुछ देर में, तो आपको ऐसी दवाई देनी है जो कि breast milk में कम डिस्चार्ज हो या फिर नहीं के बराबर डिस्चार्ज हो। Provide emotional support and psychoeducation to patient and family. Regular follow-up counseling on sleep hygiene, stress management, and gradually patient will return back to the normal activity. Early diagnosis, so strong social support, spousal support, family support, and adequate adherence to treatment. पुअर प्रोग्नोस्टिक में अगर आप डिले करोगे ट्रीटमेंट में, कोई पास्ट हिस्ट्री है साइकोटिक इलनेस की या रिकरेंट साइकोसिस की, बाइपोलर डिसऑर्डर की, या पास्ट हिस्ट्री ऑफ ये आपका पोस्टमार्टम साइकोसिस है, तो ये आपका पुअर प्रोग्नोस्टिक फैक्टर में आता है, एंड देयर आर हाई चांसेस ऑफ रिकरेंस इन सेकंड इफ अनट्रीटेड. So to conclude, we have seen 4 kind of diseases today: ATPD, schizoaffective, induced delusional disorder, and postpartum psychosis. They have certain different characteristics from each other. However, the management part में दवाइयाँ might be same, but to evaluate them and how to approach for management is different for all the patients. You have to be approaching the patient pharmacologically, psychotherapy and social support. Education and awareness is very important. You should be aware about कि ये सब बीमारियां होती है, तभी आप अपने पेशेंट्स को समझा पाओगे, या अपने फैमिली मेंबर में किसी में देखते हो तो बता पाओगे कि ओके पोस्टमार्टम अगर पेशेंट थोड़ा वियर्ड बिहेव कर रही है तो दिस इज नॉट नॉर्मल, दिस इज समथिंग विच मे रिक्वायर ट्रीटमेंट. ओके, so these are the references, and with this we'll conclude. So, very good morning. I am Dr. Ritika Singh. I am senior resident in the Department of Psychiatry. So, we'll start with the second part of anxiety disorder. Last time in anxiety disorder, we have learnt about panic disorder, phobias, specific phobias, generalized anxiety disorder. We have already prepared slides in the lecture. You can see it later on, okay? So today we'll be covering the other part, which includes OCD, that is obsessive compulsive disorder, reaction to severe stress and adjustment disorder. So as we all know, anxiety disorder, we'll be covering it under the following heading. When talking about anxiety disorder, it is a broad category. It has several symptoms. Okay, these are broad category of mental symptoms, mental health condition. They have several overlapping symptoms, but there might be few specific symptoms which will differentiate among them itself. Okay, there would be some symptoms of OCD which will be different from reaction to severe stress, which will be different from adjustment disorder. So last time also we have learned that and generalized anxiety disorder, how it is different from panic attack, how it is different from specific phobias. Okay, so on one hand we have those phobias and GAD wala part, and on another hand we have OCD, stress and adjustment reaction in clinical picture. So when we talk about the today's topic, which includes OCD, PTSD, acute stress reaction and adjustment disorder, these disorders have profound impact on day-to-day life, your functioning, whether you're talking about your academic life, whether you're talking about professional life, or your personal life, or your what we call what any part of occupation. Okay, so these disease can cause severe distress. We'll begin with OCD. So you all might be aware of the term OCD. So it is comprising of two main terms. One is obsessive and another is compulsive. Okay. Next is your disorder. So when we talk about OCD, it is a condition characterized by presence of obsessions. Now this obsession, what can it be? We'll read the definition properly, but persistent intrusive thoughts, image और urges. ऐसा नहीं कि सिर्फ सोच होगी, कुछ images भी हो सकती है, कुछ urges भी हो सकती हैं. ठीक है, and compulsion is repetitive act which we do to counteract the anxiety which we feel because of these thoughts. ठीक है, so when a disease is talked about, a patient can simply have just obsession without compulsion, or only compulsion, no obsession, or it can have both, and which is most commonly seen, like obsessive thought and then compulsion. So what is an obsession? Now see, the definition is quite important. It is persistent intrusive thought, urge or image. Okay, now it is unwanted. It is not it is coming, you're enjoying the thought. No, you don't want that thought which causes distress. And very important, it is your own thought. Patient बोलेगा मेरी खुद की सोच है, किसी दिन बाहर से मेरे दिमाग में सोच नहीं डाली. ठीक है, this is the characteristic finding you have to learn about obsession. कि persistent intrusive thought, urge or image which is unwanted, distressing and recurrent and causes significant anxiety or discomfort. The individual recognizes them as their own thoughts but find them difficult to control. All right. Now, what is a compulsion? A compulsion is a repetitive behavior, not just behavior, it could be a mental act. Mental act में कभी compulsion अपने thought दूर करने के लिए कुछ 3-4 शब्द बोल देगा या काउंटिंग कर लेगा, तो this will also come under compulsion. Okay, हमेशा बार बार चेक करना, हाथ धोना के अलावा भी compulsion के कुछ symptoms होते हैं. That an individual feels driven to perform in response to obsession. These actions aim to reduce anxiety. All right. So when we talk about what are the differences between obsession and compulsion, obsessions are recurring irrational ideas, images or thoughts, whereas compulsions are acts or behavior. Now obsession leads to compulsion and compulsion are results of obsession. Now what does obsession cause? It causes anxiety, it causes fear, it causes worry, whereas when we talk about compulsion, now if you increase the amount of compulsion, अगर बहुत ज़्यादा हद तक बढ़ गया तो it can cause some serious bodily damage. Suppose किसी को compulsion हाथ धोने का है, तो इतना हाथ धो देगा कि उसके स्किन डैमेज हो गई, उसके फिंगरप्रिंट्स डैमेज हो गए, तो यहाँ तक कंपल्शन पहुंच सकता है. ठीक है, सो दिस इज अ साइकिल कि ऑब्सेशन आया, उससे एंजाइटी हुई, कंपल्शन किया तो एंजाइटी कम हो गई, तो ये साइकिल बने रहती है. So when we talk about epidemiology, overall there is 2 to 3% prevalence in general population, whereas in India it is 0.6%. There are some clinical studies which shows the prevalence above 0.6% as well. It is the fourth most common psychiatric illness, which is equally common in males and females. But the age of occurrence in male is quite younger in comparison to female. So when we will talk about adolescent group, so you will say that boys are more affected in comparison to girls. Okay. Now, when we talk about etiology of any mental or psychiatric illness, so you should keep in mind biopsychosocial model. So they are going to be biological factors, they are going to be psychological factor and social or environmental factor. So what are the biological factors? Most importantly, you know, neurotransmitter dysregulation. Serotonin is the main culprit here. Other than this, you can have other hormones, other neurotransmitter ka disbalance as well, like dopamine or adrenaline, but serotonin you should keep in mind. Genetic predisposition, there is strong suggestion ki family studies जिसके higher risk among first degree relative of the patient. Then you have CSTC loop. अगर हम बात करें तो corticostriathalamocortical loop बोलते हैं. So there are few areas of the brain, especially orbitofrontal cortex, anterior cingulate cortex and basal ganglia. ठीक है, तो these are the areas you should keep in mind कि OCD में affected हो सकते हैं. ठीक है, OFC, basal ganglia, sometimes cingulate gyrus and caudate nucleus as well. All right. Now, what are the behavioral factors which we cause about when we talk about this could be considered in psychological or behavioral factors. So, अगर हम बात करें, आपने कंडीशनिंग पढ़ी होगी, पैवलो का डॉग एक्सपेरिमेंट देखा होगा, तो उसमें एक जो जो एक स्टिमुलाई जो न्यूट्रल है, वो भी आपका रिएक्शन प्रोड्यूस कर देता है, बिकॉज आपने उसको एक स्टिमुलाई जो रिएक्शन प्रोड्यूस कर रहा था फूड के साथ कंबाइन कर दिया बेल को, तो सलाइवेशन आ गया. तो इसमें भी ये बात करी क्लासिकल कंडीशनिंग का, जैसे सोचिए कि ओसीडी में क्या होता है कि जो न्यूट्रल स्टिमुलाई हैं उसके साथ भी एंजाइटी जुड़ जाती है, समझ रहे हैं ना. तो ये क्लासिकल कंडीशनिंग जैसा होता है. सिम्टम्स ऑफन ओरिजिनेट फ्रॉम एसोसिएटिंग सर्टेन स्टिमुलाई विद फियर और एंजाइटी. टेबल पे हाथ रखना, टेबल गंदी नहीं है, लेकिन आपका जर्म और कंटामिनेशन के साथ उसका एसोसिएशन हो गया है, ठीक है, तो यहाँ पे सिंपल टेबल पे भी हाथ रखेगा तब भी पेशेंट को एंजाइटी हो जाएगी, विच इज क्लीन. ठीक है, अदरवाइज गंदगी वाले एरिया में जाएंगे तब तो आप एंशियस होना कि भैया डर्ट और कंटामिनेशन से मुझे बीमारी हो जाएगी. नाउ दिस स्टिमुलस को अगर आपने साथ में टेबल के साथ रख दिया जो कि क्लीन टेबल है, तो ये कंडीशनिंग हो गई है. ठीक है. दूसरा, आपने वैसे ही आपने ऑपरेंट कंडीशनिंग भी पढ़ी होगी जिसमें पॉजिटिव रीइंफोर्समेंट, नेगेटिव रीइंफोर्समेंट जैसी चीजें होती हैं. नाउ व्हाट हैपेंस, एंजाइटी हुई, हाथ धो लिए, एंजाइटी रिलीव हो गई, तो ब्रेन ने क्या सोचा, अच्छा यही मुझे बार बार करना है, तो एक साइकिल बन जाती है. ठीक है. सो दिस इज वेरी इंपॉर्टेंट कि जब हम ट्रीटमेंट की भी बात करते हैं तो थॉट से पहले आपको इस साइकिल को कंट्रोल करना ज्यादा इंपॉर्टेंट है, समझ रहे, गेटिंग इट. ठीक है. So compulsion are negatively reinforced, meaning that because performing the compulsion relieves anxiety temporarily, the person is more likely to repeat in the future. ठीक है. Now this is your avoidance behavior. Avoidance behavior, आप जाओगे नहीं, public places में जाना ही बंद कर दिया, मैं अपने रूम से बाहर ही नहीं निकलूंगा. So this is something behavioral factors which are responsible. So this is just कि आपका obsession हुआ, distress anxiety हुई, एक ritualized behavior किया, आपका टेम्पररी तौर पे एंजाइटी रिलीज हुई, तो इसने रीइंफोर्स कर दिया, उस बिहेवियर ने वापस आपका कंपल्सिव बिहेवियर जो एंजाइटी रिलीज हुई तो रीइंफोर्समेंट हो गया. ठीक है. साइकोसोशल फैक्टर में अगेन अगर प्रीवियसली भी अगर किसी का माल एडेप्टिव कोपिंग मैकेनिज्म है, फाइट फ्राइट में फ्लाइट वाला रिस्पॉन्स ज्यादा है रेदर देन फेसिंग द थिंग. ठीक है. उसी के पर्सनैलिटी ट्रेट लो फ्रस्ट्रेशन टॉलरेंस है, कॉग्निटिव स्टाइल बिलीफ सिस्टम ही गलत है. ठीक है. समटाइम फैमिली एकोमोडेशन भी होता है, पेशेंट की फैमिली बहुत रिचुअल्स फैमिली के लोग नॉर्मल मानते हैं. ठीक है ना. सपोज जिस फैमिली में क्लीनिंग नॉर्मल है, अगर बच्चा ज्यादा क्लीनिंग कर रहा है तो दैट विल बी लाइक दे माइट बहुत समय तक पेशेंट के जो पेरेंट्स है वो रियलाइज ही नहीं करेंगे या फैमिली मेंबर्स रियलाइज ही नहीं करेंगे कि ये डिजीज का रूप ले चुका है. दे माइट बी रीइंफोर्सिंग इट कि अच्छा ये बच्चा तो बहुत अच्छा काम कर रहा है. ठीक है. सिमिलरली बहुत थॉट्स ऐसे होते हैं जिसके कंपल्शन में लोग ज्यादा प्रेयर करने लग जाते हैं, पूजा पाठ करने लग जाते हैं. ठीक है. कुछ ब्लेफेमस थॉट आया, कुछ गलत थॉट आया, उसको कंपनसेट करने के लिए मंदिर में बैठ गए, तो घर वाले ये भी समझ सकते हैं अच्छा ही तो बोला ज्यादा रिलीजियस हो रहा है, तो उसको पॉजिटिवली उसको देख लेंगे रेदर देन कि अंडरस्टैंडिंग की बीमारी हो सकती है. ओके, नेक्स्ट इज सोशल आइसोलेशन एंड इंटरपर्सनल रिलेशनशिप खराब है, स्ट्रेसफुल लाइफ इवेंट या कोई ट्रिगर्स है, सब्सटेंस यूज है या फिर कोई बुलिंग वगैरह हुआ है, तो वो सब चीजें ट्रिगर कर सकती है ओसीडी को. नाउ विल टॉक अबाउट द क्लिनिकल फीचर्स ऑफ ओसीडी. ठीक है, सो चार मेन तो आपको ये याद रखना है. ठीक है, पहला है डर्ट और कंटामिनेशन वाला. तो कंटामिनेशन में फियर ऑफ जर्म्स, डर्ट और इलनेस, दिस इज वन ऑफ द दिस मोस्ट कॉमन. ठीक है, कंपल्शन क्या है? एक्सेसिव वॉशिंग, क्लीनिंग, सैनिटाइजिंग. दिस इज समथिंग जो पेशेंट भी सबसे ज्यादा आपको इसी केस में मिलेंगे. नेक्स्ट सेकंड मोस्ट कॉमन इज पैथोलॉजिकल डाउट. इसमें क्या होगा? डाउट ऑब्सेशनल सेल्फ से कि मैंने ये चीज सही करी है कि नहीं करी है, मैंने ढंग से पैसे गिने कि नहीं गिने, मैंने लॉक लगाया कि नहीं आया. तो इसमें क्या होगा? रिपीटेटिव चेकिंग बिहेवियर, कि लॉक बार बार चेक करना है, सिलेंडर बार बार चेक करना है, पैसे बाद जब तक मैं 5 बार काउंट करके नहीं गिनता तब तक मेरी एंजाइटी खत्म नहीं होती है. मुझे ये लगता है कि मैंने ढंग से पैसे नहीं गिने, ज्यादा या कम हो जाएंगे. ठीक है ना. तो दिस इज पैथोलॉजिकल डाउट के अंदर जो कंपल्शंस आते हैं. नेक्स्ट इज इंट्रूसिव थॉट. दिस कुड बी वेरी डिस्ट्रेसिंग थॉट्स व्हिच कैन बी रिलेटेड टू वायलेंस. किसी को दिमाग में ऐसे सोच आता है कि मैं लोगों को देख के बस गाली बकूं, या किसी को फैमिली मेंबर को देख के ब्लेफेमस या सेक्सुअल थॉट्स आ रहे हैं, या रिलीजियस एंटिटी को देख के ऐसे थॉट्स आ रहे हैं. तो इसको कम काउंटरएक्ट करने के लिए जो मैंने बोला था रिचुअल्स, ठीक है, प्रेइंग, न्यूट्रलाइजिंग थॉट्स रेदर देन विजिबल बिहेवियर. पेशेंट बार बार सफाई नहीं करेगा, चेक नहीं करेगा, चीजें अरेंज नहीं करेगा, बट हो सकता है मन में कुछ काउंट कर ले. ठीक है, इंस्टेड ऑफ अब्यूजिंग वो 10 बार काउंटिंग कर ले, 10 तक गिनती कर ले, या कुछ प्रेयर कर ले. ठीक है, तो ये आपका इंट्रूसिव थॉट को काउंटरएक्ट करने के लिए कंपल्सिव बिहेवियर है. नेक्स्ट इज सिमेट्री एंड ऑर्डरिंग. नाउ इसमें क्या होता है? नीड्स द थिंग्स नीड्स टू बी अरेंज्ड इन पर्टिकुलर ऑर्डर. ठीक है ना. इसमें ये कुछ हद तक बिहेवियरल भी हो सकता है, किसी की पर्सनालिटी ट्रेट भी है, बट अगर ये डिजीज का फॉर्म ले रही है तो इसमें की चीजों को अगर मैंने 5 लाइन में रखी है तो 5 लाइन में ही होना चाहिए, 5 से 4 लाइन में होनी चाहिए, और वो स्ट्रेट की स्ट्रेट होनी चाहिए, आगे पीछे नहीं होना चाहिए. ठीक है, तो रीअरेंजिंग आइटम, काउंटिंग एंड परफॉर्मिंग एक्शन अ स्पेसिफिक नंबर ऑफ टाइम. ठीक है, इसके अलावा क्या क्या सिम्टम्स हो सकते हैं? आपका एंजाइटी, डिस्ट्रेस ज्यादा हो सकता है. डिप्रेसिव सिम्टम्स बहुत कॉमन होते हैं पेशेंट में. ठीक है, बिकॉज दे फील लाइक कि मोस्ट ऑफ द टाइम पेशेंट ऑफ ओसीडी को इंसाइट होती है, तो दे आर वेरी डिप्रेस रिगार्डिंग देयर इलनेस कि ये बीमारी क्या होगी, कैसे होगा. ठीक है, रिड्यूस इंटरेस्ट दिखेंगे डिप्रेसिव सिम्टम में. पेशेंट का जो ऑक्यूपेशनल एक्टिविटी है वो कम हो जाएगी, एकेडमिक परफॉर्मेंस डिक्लाइन हो जाएंगी. टाइम कंजम्पशन की अगर हम बात करें तो जो एक्ट कर रहे हैं वो बहुत ज्यादा टाइम कंज्यूम कर रहा है, आपका लाइफ डिस्टर्ब हो जाएगा उससे. ठीक है, सोशल ऑक्यूपेशनल फंक्शन, सीकिंग रीअश्योरेंस फ्रॉम अदर एक्सेसिवली, अवॉइडिंग ट्रिगर्स, लो मूड. एक होता है प्रॉक्सी कंपल्शन, एक चीज होती है, उसमें क्या होता है कि अपना तो मैं हाथ धो ही रहा हूँ, मैं घर वालों को भी उतनी बार सफाई कराऊंगा. मेरे रूम में मैं पोछा लगा रहा हूँ तो घर वाले भी जितने बार आएंगे वो पोछा लगाएंगे. ठीक है, तो वो पेरेंट्स को भी या फैमिली वालों को भी, जो मेंबर्स हैं उनको भी इन्वॉल्व कर लेते हैं. दिस इज कॉल्ड प्रॉक्सी. आपकी जगह कोई और आपका काम कर रहा है. ठीक है, सो जस्ट अ साइकिल जो सिखा रही है कि आपका काउंटिंग हो सकता है, डर्ट कंटामिनेशन हो सकता है, सिमेट्री, सेक्सुअल थॉट, वॉशिंग, क्लीनिंग, अरेंजिंग एंड सीकिंग रीअश्योरेंस. ऑलराइट, नाउ कुछ डायग्नोस्टिक गाइडलाइंस है ICD-10 की. ठीक है, तो वो क्या बोलता है उसमें? ओसीडी के लिए चीजें ये बोली है कि एटलीस्ट 2 सक्सेसिव वीक्स के लिए आपका ऑब्सेशनल सिम्टम या कंपल्शन या बोथ. ठीक है, एंड इट शुड बी अ सोर्स ऑफ डिस्ट्रेस एंड इंटरफेयर विद एक्टिविटीज. Now, obsessional symptoms should have the following characteristic. They must be recognized as individuals' own thoughts or impulse, which we have already seen. There must be at least one thought or act that is still resisted unsuccessfully, even though others may be present when there which the sufferers no longer resist. ठीक है, कुछ थॉट्स हो सकते हैं जिसके साथ पेशेंट ठीक है, मैं इसको नहीं रेजिस्ट कर रहा हूँ, अपने आप हो जाएगा काम, लेकिन एक थॉट एटलीस्ट डायग्नोस्टिक गाइडलाइन के लिए कि होना चाहिए, जिसको मैं कोशिश कर रहा हूँ रोकने की लेकिन नहीं रुक पा रहा है. The thought of carrying out the act must not in itself be pleasurable. ठीक है, मेरे को अच्छा नहीं लग रहा है, टेम्पररी एंजाइटी रिलीव हो रही है लेकिन वो मुझे खुशी नहीं दे रही है. ठीक है, इट इज जस्ट की काउंटर पार्ट कि मुझे ये करने से अपनी एंजाइटी रिलीव हो रही है. ठीक है, एंड दे शुड बी अनप्लेजेंटली रिपीटेटिव. ऑलराइट, वैसे ही DSM-5 में भी यही चीजें हैं, उन्होंने ऑब्सेशन और कंपल्शन को डिफाइन किया है. दी ओनली थिंग दे हैव यहाँ पे किया है कि जो टाइम लिमिट है उन्होंने मोर देन 1 आवर, जो भी आप एक्शन कर रहे हो, जो रिपीटेटिव एक्ट कर रहे हो. अभी डिफरेंशियल डायग्नोसिस, ओसीडी के जैसे सिम्टम और डिजीजेस में भी मिल सकते हैं. अगर हम देखें तो जनरलाइज एंजाइटी डिसऑर्डर में भी आपका एंजाइटी बहुत होती है, लेकिन यहाँ पे आपका कंपल्सिव बिहेवियर नहीं मिलेगा. ठीक है, सिमिलरली इलनेस एंजाइटी में क्या होता है कि पेशेंट रिएश्योरेंस सीकिंग बिहेवियर इसमें भी होता है कि मैं बीमार तो नहीं हूँ, इन्वेस्टिगेशन कराता है, लेकिन वो इलनेस तक ही सीमित है और इन्वेस्टिगेशन करा के पेशेंट थोड़ा सा लीव भी हो जाता है। एमडीडी में भी आपका थॉट रुमिनेशन होता है, ख्याल बार बार आएंगे, बट वो कंपल्सिव एक्ट यहाँ पे भी लैक करेगा। देन न्यूरोलॉजिकल की बात करें तो आपका जो मूवमेंट डिसऑर्डर होता है, ये टिक डिसऑर्डर या टॉरेट है, इसमें सिर्फ मूवमेंट होगा, इसमें थॉट का एसोसिएशन नहीं होगा, ठीक है, रिपीटेटिव इनवॉलंटरी मूवमेंट होंगे या सडन मूवमेंट हो सकते हैं। ऑटिज्म स्पेक्ट्रम में भी रिपीटेटिव बिहेवियर होता है, बट यू विल आइडेंटिफाई, एक तो आई कांटेक्ट अगर नहीं करते हैं, सोशल आइसोलेशन, कम्युनिकेशन स्किल्स नहीं होती है, ठीक है, ऑटिज्म में। अगेन स्किजोफ्रेनिया में क्या होता है, बहुत बार ना जो फर्स्ट पर्सन ऑडिटरी हेलुसिनेशन होता है वो भी अपने थॉट जैसे वो क्या बोलते हैं, आप उसको ओसीडी के थॉट से कंफ्यूज कर सकते हो, बट इसमें और सिम्टम्स भी होंगे स्किजोफ्रेनिया के। डिसऑर्गेनाइज्ड बिहेवियर हो सकता है, हेलुसिनेशन, डिल्यूजन्स हो सकते हैं, ठीक है ना, नेगेटिव सिम्टम्स हो सकते हैं। अभी कुछ हमारे ओसीडी से रिलेटेड डिसऑर्डर है, जैसे होर्डिंग डिसऑर्डर है, बॉडी डिस्मॉर्फिक डिसऑर्डर है, इसके बारे में हम आगे पढ़ेंगे, ठीक है। अनदर वन इज ओसीपीडी, ये पर्सनालिटी डिसऑर्डर है, ठीक है। इसमें आपका जो थॉट्स है, जो ट्रेड है, वो ईगो डिस्टोनिक नहीं है, ईगो सिंटोनिक है, पेशेंट को अच्छा लगता है वो करना, ठीक है, वो करता है बिकॉज ही वांट्स दैट थिंग्स टू बी डन। दिस इज जस्ट द डिफरेंशिएशन कि ओसीपीडी आपका ईगो सिंटोनिक है, इट्स अ पर्सनालिटी डिसऑर्डर, रिजिड अडेरेंस टू रूल्स, ठीक है। यहाँ पे कोई आपको ऑब्सेशन और ये कंपल्शन वाला बिहेवियर ऐसा सच नहीं आ रहा है, बट दिस इज हम समहाउ इनकलकेटेड इन योर पर्सनालिटी कि मुझे ऐसे ही करना है, ठीक है। अनविलिंग टू सीक हेल्प्स एंड परफॉर्म फॉर्म बिलीव दैट इन द राइट वे टू कंडक्ट टास्क। ओके, अदर रिलेटेड डिसऑर्डर जैसे मैंने बोला था, एक है आपका बीडीडी, बॉडी डिस्मॉर्फिक डिल्यूजन में क्या होता है कि अपना कोई बॉडी पार्ट नहीं सही लगता है, ठीक है, डिस्पाइट कि वो सही हो या फिर कोई माइनर एलिमेंट हो जिसको मेजरली दिया जाता है। हाई एसोसिएशन है प्लास्टिक सर्जरी से बॉडी डिस्मॉर्फिक डिसोसिएशन का, ठीक है, नोज जॉब कराना है कि हाथ कुछ नहीं दिख रहा है, लिप मेरा ठीक नहीं लग रहा है, बट इसमें जो डिस्ट्रेस होता है दैट इज नॉट इन प्रोपोर्शन टू कि अगर कोई माइनर एलिमेंट हुआ है, ठीक है। Excessive preoccupation with perceived flaws in physical appearance, which are not noticeable or appear minor to others, cause significant distress and impairment in daily functioning. Again, hoarding disorder, इसमें क्या होता है, कोई चीजें जो वैल्यूएबल नहीं है उसको रखे रखना अपने पास, ठीक है। सम अमाउंट ऑफ होर्डिंग हर किसी के पास होगा, डब्बे रख लेते हो, पॉलिथीन का बैग रख लेते हो, नॉट दैट, ठीक है। A disorder characterized by persistent difficulty in discarding possessions regardless of their actual value, which leading to clutter that disrupt daily living. कोई लोग क्या करते हैं, चॉकलेट के रैपर्स बहुत ज्यादा संभाल के रख लेंगे, देयर आई हैव सीन पीपल जो कि नेल्स अपने तक रख लेते हैं काट के नहीं, आई एम नॉट टॉकिंग अबाउट यू, ठीक है, या फिर अपने स्किन, अगर अब विंटर्स में स्किन निकल रही है तो उसको तक होल्ड करके रख लेंगे, ठीक है। तो कभी कभी रूम्स अगर देखोगे होर्डिंग डिसऑर्डर वालों में कि रहने की जगह नहीं होंगी लेकिन सामान इतना ज्यादा होगा, ठीक है। इमोशनल अटैचमेंट हो जाता है सामान से और उसको डिस्कार्ड करना मुश्किल होता है, ठीक है। Last is trichotillomania. This is also very common hair pulling disorder. Okay, तो इसमें क्या होता है कि थॉट बार बार खुद के बाल खींचने का आता है, ठीक है, लीडिंग टू हेयर लॉस डिस्पाइट रिपीटेड अटेम्प्ट टू स्टॉप, ठीक है। एंड जो भी टेंशन या एंजाइटी हो रही है वो हेयर पुल करके कम हो जाएगी। उसका साइड इफेक्ट ये होगा कि आपका बाल पैचेस आएंगे, यस, बाल पैचेस आते हैं, कितनी बार पेशेंट को कंपल्सन उसको खा ले तो पेट में आपका क्या बोलते हैं कि सॉलो कर सकते हैं, ठीक है ना, रिचुअलिस्टिक बिहेवियर में। सिमिलरली बाल के साथ साथ स्किन पिकिंग डिसऑर्डर भी हो सकता है, ठीक है ना, इसमें स्किन पिक करते रहेगा, स्किन पिक किया तो इंजरी होगी, स्कार मार्क्स होंगे, इन्फेक्शन तक हो सकता है, ठीक है। नाउ हाउ डू यू इवेलुएट ओसीडी? इंपॉर्टेंट थिंग, हिस्ट्री, फिजिकल एग्जामिनेशन, एमएससी, कुछ लैब इन्वेस्टिगेशन, ठीक है। हिस्ट्री में आप क्या क्या देखोगे कि नॉर्मल की ऑनसेट, ड्यूरेशन, प्रोग्रेशन क्या है, नेचर ऑफ ऑब्सेशन जो भी हमने पढ़े हैं चारों कैटेगरी में, किससे आ रहे हैं, कितनी बार आ रहे हैं, कितने घंटे तक आप कंपल्सिव एक्ट कर रहे हो, आपको कितना डिस्ट्रेस वो मेंटली कॉज कर रहा है और कितना आपकी साइकोसोशल लाइफ इम्पैक्ट हो गई है, ठीक है। एसोसिएटेड सिम्टम्स क्या क्या हैं और इनसाइट कितनी है, इम्पैक्ट ऑफ डेली लाइफ, वर्क, रिलेशनशिप, फंक्शनिंग, कोई हिस्ट्री ऑफ प्रीवियस ट्रीटमेंट है, फैमिली में हिस्ट्री तो नहीं है इस चीजों की, कोई सब्सटेंस यूज, मेडिकल या सर्जिकल इलनेस तो नहीं है एसोसिएटेड, ठीक है। नाउ मेंटल स्टेटस एग्जामिनेशन में जर्नली ओसीडी के लोग आपको वेल ग्रूम दिखेंगे, ज्यादा अगर आपका मोस्ट कॉमन डर्ट कंटामिनेशन वाले हैं तो दे लाइक टू कीप देमसेल्फ या तो अरेंज या फिर वेल ग्रूम, ठीक है। इन बिटवीन रिपीटेड मूवमेंट्स, या भी आप बात करोगे तो हो सकता है बिहेवियर में आपको पेशेंट का रिपीटेड मूवमेंट्स दिख जाए कि हाथ बात टच करना है, बात करते वक्त काउंटिंग करनी है, ठीक है। साइकोमोटर एक्टिविटी ओवरऑल जर्नली नॉर्मली रहती है, समटाइम वही कि आपको कंपल्सिव एक्ट करते हुए आपको डिस्ट्रेस दिख सकता है। Speech delay or interruption due to intrusive thoughts can be seen, not always, but it can be seen. Mood and affect, you'll have anxious patient दिखेगा आपको, depressive symptoms हो सकते हैं, distress हो सकता है। थॉट में अब जैसे मैंने बोला ऑब्सेशन प्रेजेंट होंगे, ठीक है। यू हैव टू फाइंड आउट कि ऑब्सेशन का जो क्राइटेरिया है कि वो मीट हो रहा है कि नहीं हो रहा है, ठीक है। पेशेंट यूजुअली एक्नॉलेज कि थॉट्स इरेशनल है। आपको डिप्रेशन के भी थॉट वाले की होपलेसनेस सेल्फलेसनेस भी मिल सकती है। परसेप्शन इज यूजुअली नॉर्मल इन दीस पेशेंट, ठीक है। कॉग्निशन ओवरऑल इट इज प्रिजर्व बट मे बी कॉम्प्रोमाइज बिकॉज ऑफ परवेसिव नेचर ऑफ इंट्रूसिव थॉट्स। इंसाइट मैक्सिमम पेशेंट्स में मिलती है, देयर आर फ्यू पेशेंट जिनमें ओसीडी में इंसाइट नहीं होगी, ठीक है। दीज आर दोज पेशेंट्स आर वेरी डिफिकल्ट टू केयर। जजमेंट मोर ऑफन देन नॉट आपका जजमेंट और क्या बोलते हैं सही रहता है, बट बिकॉज ऑफ जो स्पेसिफिक कंपल्शन है उसकी वजह से उस एरिया का जजमेंट इम्पेयर हो सकता है, ठीक है। देयर आर सर्टेन टूल्स जिससे हम आपका ओसीडी वो कर सकते हैं। वाइबॉक्स एक स्केल याद रखती है, बेसिकली रेटिंग स्केल है, नंबर देते हैं कि कितना आपका ऑब्सेशन है, कितना कंपल्शन, उससे डिस्ट्रेस कितना हो रहा है, और ट्रीटमेंट शुरू करने के बाद ये कितना कम होते जा रहा है, ठीक है। हाउ इफेक्टिव इज ट्रीटमेंट, वेदर इट इज थेरेपी और वेदर इट इज आपका मेडिकल मैनेजमेंट, फार्माकोलॉजिकल मैनेजमेंट, ओके। Other than this, we have obsessive compulsive inventory and structured clinical interview for DSM-5, right? Now, management of OCD. So it is both pharmacological, non-pharmacological. Pharmacological में OCD के लिए drug of choice selective serotonin inhibitor SSRIs, antidepressant जो होते हैं, बट ये आपके comparatively higher doses में दिए जाते हैं। नॉर्मल डिप्रेशन के कंपैरिजन हायर डोज लगती है OCD में, ठीक है। मोस्ट कॉमनली आपकी फ्लुओक्सिटिन और फ्लुओक्सामिन ज्यादा यूज होती है। बच्चों में पेरोक्सिटिन, एसिटिलोप्राम भी प्रेफर कर सकते हैं, सर्टिलिन, ये सब चीजें फिर हाई डोज में, ठीक है। Next, you have tricyclic antidepressant में क्लोमिप्रामाइन is also said to be very effective, ठीक है। तो ये दो तीन दवाइयां फ्लुओक्सिटिन, फ्लुओक्सामिन, क्लोमिप्रामाइन आपको याद होना चाहिए ओसीडी के लिए, ठीक है। इसके अलावा एसएनआरआई का भी रोल है। एटिपिकल एंटीसाइकोटिक्स का रोल है लो डोजेस में, रिस्पेरिडोन और एरिपिप्राजोल के एज एन एडजेंट ट्रीटमेंट, कि अगर जहां थोड़ा बहुत कमी रह गई है कि असर नहीं आ रहा तो ये ऐड करके अच्छा इफेक्ट देखा गया, ठीक है। नाउ वेरी इंपॉर्टेंट इज ओसीडी में बहुत इंपॉर्टेंट है नॉन फार्माकोलॉजिकल। बहुत बार पेशेंट सिर्फ नॉन फार्माकोलॉजिकल मैनेजमेंट से भी ट्रीट हो सकते हैं, ठीक है। सो व्हेन वी टॉक अबाउट, सबसे पहले सीबीटी है। सीबीटी का ही एक एक्सपोजर का ही एक आगे बढ़ के एक स्टेप में ईआरपी, एक्सपोजर रिस्पांस प्रिवेंशन थेरेपी है, तो ये आपको याद रखनी है। इसके अलावा फ्लडिंग हो सकती है, ये बाकी और भी ट्रीटमेंट है, बट एक्सपोजर रिलैप्स प्रिवेंशन यू शुड रिमेंबर, ठीक है। Now, what happens? It is a structured, goal-directed therapy that helps individual identify and modify maladaptive thoughts and behavior. In OCD, it targets irrational belief and compulsive ritual that maintain distress. So, पहले तो assessment और psycho education, patient को किस हद तक डिस्ट्रेस है, उसकी इंसाइट कितनी है, ये सब होगा। फिर पेशेंट को एक्सप्लेन करोगे बीमारी के बारे में, और थेरेपी कैसे हम प्रोसीड करने वाले हैं इसके बारे में, ठीक है। नाउ लास्ट में इसमें होता है कॉग्निटिव रीस्ट्रक्चरिंग, विच इन्वॉल्व्स आइडेंटिफाइंग एंड चैलेंजिंग डिस्टॉर्टेड थॉट्स। दो तीन चीजें याद रखना है कि एक चीज होती है ना थॉट एक्शन फ्यूजन बोलते हैं। ओसीडी के पेशेंट को क्या होता है, जो मैंने सोच लिया वो मैंने कर लिया है, गलत ख्याल आए यानी कि मैंने वो काम कर लिया। तो ये चीज पे डिफरेंस करना है कि गलत आपके दिमाग में कोई ब्लेफेमस थॉट आ रहा है, कोई वायलेंट थॉट आ रहा है, इसका मतलब ये नहीं कि आपने वो काम किया है, आपके एक्शन आपकी सोच से अलग है। तो ये सब चीजें टारगेट करती है, ठीक है। नाउ कभी कभी बिहेवियरल एक्सपेरिमेंट्स, पेशेंट टेस्ट देयर फियर इन रियल लाइफ, ठीक है। जो प्लेसेस अवॉइड कर रहे हैं जाना वहां भेजो, ठीक है। जनरल पब्लिक में भेजो, गैदरिंग में भेजना शुरू करो। कि सोचना कि मैं गैदरिंग में जाके बीमार हो जाऊंगा इज डिफरेंट देन गैदरिंग में जाके उस चीज को एक्सपीरियंस करना, ठीक है। नाउ हेल्प देम रियलाइज दैट कंपल्शंस आर अननेसेसरी एंड द एंजाइटी नेचुरली डिक्लाइंस, ठीक है। दिस इज समथिंग यू शुड कीप इन माइंड। अगर पेशेंट को भी समझा रहे हो कि जो कंपल्शन है अगर एकदम से नहीं बंद कर पा रहे हो तो थोड़ा प्रोलॉन्ग कर दो। आप उसी वक्त हाथ ना धो के 15 मिनट बाद धो के कोशिश करो। आप देखोगे कि एंजाइटी अपने आप कम हो जा रही है, आपको धार धोने की जरूरत नहीं पड़ रही है, ठीक है। now very important is ERP, नाम से वो है एक्सपोजर करोगे और रिस्पॉन्स प्रिवेंट करोगे। सिमिलरली असेसमेंट करोगे, पेशेंट को साइको एजुकेट करोगे इसके बारे में, ठीक है। अभी इसमें कुछ आप पेशेंट को कुछ रिलैक्सेशन एक्सरसाइजेस सिखाओगे, डीप ब्रीदिंग सिखाओगे, JPMR या मसल रिलैक्सेशन एक्सरसाइज, खुद को कैसे रिलैक्स करना ये बताओगे, ठीक है। फिर एक हायरार्की बनाने को बोलोगे पेशेंट को, सपोज बोलो आप ना लिस्ट बना के लाओ 5-6 चीजों की, जिसमें जो छठे नंबर में है वो चीज होनी चाहिए जिससे सबसे कम एंजाइटी होती है, और पहले नंबर में जिसमें सबसे ज्यादा एंजाइटी होती है, ठीक है। पेशेंट बोलता है कि मुझे टीवी के रिमोट से सबसे कम एंजाइटी होती है, लेकिन मुझे बाथरूम के सिंक से सबसे ज्यादा एंजाइटी होती है, ठीक है, उसको टच करने में। तो उस ऐसे करके हायरार्की बनाने को बोलोगे। और जब काम भी करेंगे तो हम लीस्ट वाली चीज को सबसे पहले पकड़ेंगे, जब तक वो अच्छे से रिजॉल्व नहीं जाता फिर हम आगे बढ़ेंगे, फिर आगे बढ़ेंगे, ठीक है। नाउ graduated exposure, systematically exposing the patient to fear situations and thoughts, ठीक है, starting with low anxiety situation and progressing to higher anxiety one. नाउ इसमें क्या होता है, पेशेंट को हो सकता है कोई हाइपोथेटिकल सिचुएशन से शुरू करो, ERP अगर हम इन वीवो शुरू कर रहे हैं लैब अपने काउंसलिंग चैम्बर में अगर आप शुरू कर रहे हो, तो रिलैक्सेशन करा के पेशेंट को अच्छे से कोई एक हाइपोथेटिकल सिचुएशन, उसमें उसको फेस करने को बोलो कि जो आपका उसका लीस्ट एंजाइटी प्रोवोकिंग स्टिमुला है, ठीक है, उसके ऊपर काम करके वहां पे आपका पेशेंट का एंजाइटी बिल्ड करके कैसे रिलैक्सेशन विदाउट कंपल्सिव एक्ट का करना है, जो डीप ब्रीदिंग आपने सिखाई, जो रिलैक्सेशन आपने सिखाई है, वो एक्ट करके अपनी एंजाइटी रिड्यूस करनी है, समझ रहे हैं, ठीक है, मोटा मोटा दिस इज हैपेंस, ठीक है। Now, response prevention, preventing compulsion or safety behavior, encourage the patient to tolerate anxiety without engaging in rituals. Teaching coping strategies for future stressor, encouraging continued exposure exercises even after symptoms are improved, ठीक है। इसके अलावा आपका फैमिली साइको एजुकेशन, फैमिली बिहेवियरल थेरेपी और ग्रुप थेरेपी भी हेल्प कर सकती है, ठीक है। दिस इज जस्ट जो भी मैंने आपको समझाया, जिस दे रखा है कि कैसे उसको एक्सप्लेन किया है। देन वी ऑल्सो हैव न्यूरोस्टिमुलेशन टेक्निक, नाम याद रख लो RTMS, ठीक है, रिपीटेड ट्रांसक्रेनियल मैग्नेटिक स्टिमुलेशन। इसका रोल देखा गया, ECT का इतना रोल नहीं देखा गया। स्ट्रेस मैनेजमेंट में आई टोल्ड यू अबाउट डीप ब्रीदिंग, प्रोग्रेसिव मसल रिलैक्सेशन, योगा, मेडिटेशन, गाइडेड इमेजरी, okay. Till here we have done our OCD. Now we'll cover two more part. I'll try to be quick. Next is your reaction to severe stress. So naam se again it is suggested how the patient is going to react in a severe stressful condition. Now physiological and psychological both responses are going to be there, which occurs after exposure to a traumatic or highly stressful event. Now this is divided into acute stress reaction or acute stress disorder, or DSM बोलता है disorder, or PTSD, post traumatic stress disorder. प्रॉब्लम, द ओनली डिफरेंस इज टाइम का, ठीक है ना। अगर विद इन 1 मंथ रहता है तो एक्यूट स्ट्रेस है, उसके ज्यादा रहते हैं तो वो PTSD में आ जाता है। सो ASR या acute stress reaction, it is immediate and transient psychological response to an overwhelming or traumatic event. It typically occurs within minutes to hours after exposure to the stressor and usually resolves within few days, ठीक है। Although the reaction is considered in a normal response to abnormal event, its severity can vary among individual. कोई ट्रॉमेटिक इवेंट हुआ है तो वहां पे परेशान होना, थोड़ा सा ऑटोनॉमिकली अराउज होना नॉर्मल है, बट द सिवियरिटी बहुत ज्यादा बढ़ जाती है ASR में, ठीक है। सो इट माइट कॉज सम फिजिकल और साइकोलॉजिकल डैमेज। इटियोलॉजी और पैथोफिजियोलॉजी की बात करें, एसोसिएटेड ट्रॉमेटिक ट्रिगर होना ही चाहिए, स्ट्रेस रिएक्शन है तो स्ट्रेस होना चाहिए, ठीक है, such as serious accident, natural disaster, assault, or any incident that poses an immediate threat to life or physical integrity of an individual. हिस्ट्री, अगर कोई साइकाइट्रिक हिस्ट्री है, ऑलरेडी डिप्रेशन का पेशेंट है या फिर डिसोसिएशन का पेशेंट है, या पर्सनैलिटी ट्रेट्स ही ऐसे हैं कि लो फ्रस्ट्रेशन टॉलरेंस है, तो ये एक्सेलरेट कर सकते हैं उस बीमारी को, ठीक है। बायोलॉजिकल HPA एक्सिस में आपका डिसबैलेंस होगा, स्ट्रेस हार्मोन्स, एड्रेनलिन, कोर्टिसोल, ये सब बढ़ेंगे, तो दीज हार्मोन्स आर आपका ऑटोनॉमिक अराउजल के लिए एड्रेनलिन रिस्पॉन्सिबल है, स्ट्रेस रिएक्शन में कोर्टिसोल हमेशा देखा गया है कि बढ़ता है। These changes prepare the body to respond to danger but also contribute to symptoms experienced. फीचर्स क्या होंगे आपके, कुछ इमोशनल और कॉग्निटिव चेंजेस हो सकते हैं, इंट्रूसिव थॉट्स एंड मेमोरीज, इंटेंस फियर, एंजाइटी, ठीक है, सेंस ऑफ इम्पेंडिंग डूम, कंफ्यूजन, डिसोरिएंटेशन फॉर अ टाइम बीइंग, ठीक है, डिफिकल्टी कंसंट्रेशन एंड फीलिंग ऑफ डिटैचमेंट और अनरियलिटी, डिसोसिएटिव सिम्टम्स भी दिख सकते हैं। बिहेवियरल में आपका क्या होगा कि कम्युनिकेट सही से नहीं कर पा रहे, रिस्पॉन्ड नहीं कर पा रहे, अवॉइडेंस बिहेवियर हो गया है, विड्रॉल बिहेवियर हो गया, लो मूड साथ में चल रहा है, ठीक है। फिजिकल में एड्रेनलिन बढ़ेगा, रैपिड हार्ट बीट, पसीना ज्यादा हो रहा है, ट्रेमुलसनेस हो रही है, ट्रेमर्स हो रहे हैं, जीआई डिस्टर्बेंसेस हो रही हैं, ठीक है। So you can have intrusive thoughts, avoidant behavior, negative mood changes, arousal and hyperactivity, dissociative symptom and difficulty to function normally. गाइडलाइंस क्या बोलती हैं ICD-10 की इसमें? There must be an immediate and clear temporal connection. Temporal correlation का मतलब होता है टाइम लिमिट, वो जब आपका इंसिडेंट हुआ है और उसका कनेक्शन जो आपके रिएक्शंस या जो आपको सिम्टम्स मिल रहे हैं, ठीक है ना। तो between the impact of an exceptional stressor and onset of symptom within a few minutes. In addition, show mixed and usually changing picture in addition to initial state of daze, depression, anxiety, anger, despair. कुछ भी हो सकता है पेशेंट थोड़ी देर के लिए सही हो, उसके बाद एंशियस हो जाए, फिर थोड़ा ठीक होके बहुत ज्यादा एग्रेसिव हो जाए, कुछ भी हो सकता है, ठीक है। बट नो वन टाइम ऑफ सिम्टम्स में प्रीडोमिनेट फॉर लॉन्गर, इट रिजॉल्व्स रैपिडली, ठीक है, विद इन फ्यू डेज कहते हैं इट शुड रिजॉल्व, ठीक है। In those cases where removal from the stressful environment is possible, in cases where the stress continues or cannot be reversed, तो आपका within 48 hours to 72 hours resolve हो जाना चाहिए symptoms. Again आपका DSM-5 के diagnostic criteria हैं। Differential diagnosis में panic attack you should know कि उसमें कोई stressful event नहीं होगा, normal event में भी panic हो सकता है। PTSD में time limit का differentiation है। Adjustment में भी कोई इतना इम्पैक्टफुल स्ट्रेस रिएक्शन और टाइम लिमिट नहीं होगी। जीएडी अगेन आपका स्ट्रेस नहीं है, मेजर डिप्रेसिव एंड डिसोसिएटिव डिसऑर्डर, ओके। अगेन यू शुड हैव द क्लियर हिस्ट्री ऑफ स्ट्रेस होना चाहिए, एसोसिएटेड सिम्टम्स होना चाहिए, फिजिकल एग्जामिनेशन यू शुड नो, एंड देयर आर सर्टेन स्केल लाइक distress scale, impact of event scale, and then you have Stanford acute stress reaction questionnaire. All right. वेरी इंपॉर्टेंट यहाँ पे आपका साइकोलॉजिकल फर्स्ट एड एक चीज होती है, ठीक है। इसमें जैसे आप फिजिकल इलनेस में फर्स्ट एड करते हो, इसमें भी वही है, आपको कुछ कुछ पॉइंट्स याद करने हैं कि आपको पेशेंट को रीअश्योरेंस कराना है, पेशेंट को कंफर्टेबल कराना है, सेफ प्लेस पे ले जाना है, उसका कॉन्फिडेंस बढ़ाना है, अगर कोई लोग उसकी पहचान के हैं तो उनसे मिलाना है जिससे कि वो थोड़ा सेफ फील करे। Supportive intervention, encourage a calm environment, facilitate brief stress reduction technique जैसे deep breathing हो गया, grounding technique हो गई, and monitor the individual for any escalation of symptom. तो this कुछ 5-7 C's है, check, assess, observe and listen, coordinate, get help, cover to safety, calm down, connect with people, competence and confidence. Okay. Then acute stress reaction short time duration का तो अपने आप resolve हो जाता है, ठीक है। तो मे बी यू माइट रिक्वायर्ड शॉर्ट टाइम के लिए कोई बेंजोडाइजेपिन लो डोज में, जिससे कि वो उस वक्त की एंजाइटी को दूर कर ले, बट सिंस बेंजोडाइजेपिन आपका डिपेंडेंस पोटेंशियल ज्यादा रखता है तो यू शुड बी कॉशियस व्हाइल यूजिंग इट। फॉलो अप एंड रेगुलर मॉनिटरिंग करनी चाहिए, बिकॉज यू हैव टू सी कहीं पीटीएसडी में तो कन्वर्ट नहीं कर रहा है, 1 मंथ के बाद तक तो सिम्टम्स नहीं रह रहे हैं, तो दिस इज समथिंग यू हैव टू कीप, ओके। नाउ नेक्स्ट उसी का ही आगे कंटिन्यूशन है एक्यूट स्ट्रेस रिएक्शन का, पीटीएसडी, ठीक है। Psychiatric disorder that can develop following exposure to traumatic event, कोई इंजरी है, असॉल्ट है, नेचुरल डिजास्टर है, कोई लाइफ थ्रेटनिंग कंडीशन तो नहीं है। It is characterized by persistent and intrusive thoughts that interfere with daily functioning, differentiating it from normal stress response. Now, etiology and pathophysiology, again आपको पता है कि कोई exposure traumatic होना चाहिए, and which should be encoded in fragmented manner leading to intrusive recollection, flashback and avoidance behavior. 2-3 चीजें याद रखो कि intrusive recollection, flashbacks और avoidance behavior देखा जाता है पीटीएसडी में। यहाँ पे भी यू शुड बी एचपी एक्सिस डिसरेगुलेशन यहाँ पे भी होता है। एमिगडाला जो आपका इमोशनल ब्रेन है, हिप्पोकैम्पस, एमिगडाला, प्रीफ्रंटल कॉर्टेक्स का भी जो थोड़ा बहुत रोल गया देखा गया है पैथोफिजियोलॉजी में, ठीक है। पोटेंशियल कॉजेस पीटीएसडी में डोमेस्टिक वायलेंस, कोई वॉर विक्टिम है, एक्चुअली जो वियतनाम वॉर हुआ था वहां से इस टर्म का ओरिजिनेशन देखा गया था कि जो भी सोल्जर्स आते थे दे हैव वेरी हार्ड फ्लैशबैक्स, उनका सब्सटेंस यूज बढ़ गया था, एग्रेसिव बिहेवियर बहुत ज्यादा बढ़ गया था, तो पीटीएसडी देन पीपल गॉट टू नो कि पीटीएसडी में जो भी वॉर वगैरह के बाद कैसे कैसे चीजें हो सकती है। इट इज नॉट जस्ट लिमिटेड टू व्हाट, बाकी जो चीजें यहाँ पे दे रखी है उसमें भी आपका पीटीएसडी दिखता है। इंट्रूसिव सिम्टम्स क्या हो सकते हैं? रिकरेंट इनवॉलंटरी एंड डिस्ट्रेसिंग मेमोरीज और फ्लैशबैक, नाइटमेयर्स ऑफ इंटेंस साइकोलॉजिकल डिस्ट्रेस अपॉन एक्सपोजर टू cues reminiscent of the trauma. You will avoid thoughts, feeling an external reminder associated with trauma. नेगेटिव ऑल्टरेशन इन कॉग्निशन एंड मूड, अगेन आपका नेगेटिव बिलीफ, मूड कम होगा, आपका कंसंट्रेशन मेमोरी में भी असर पड़ेगा। ऑल्टरेशन, हाइपर एक्टिविटी हो सकती है, रिएक्टिविटी बढ़ सकती है, वो आपको थोड़ा सा भी अगर लग रहा है कहीं पे, जैसे एक सोल्जर है वॉर से आ रहा है, अभी पहले तो उसने बहुत सारी बॉम्बिंग और ये सब देखी, गन फायर देखी, अब क्या पता एक जो ट्रक बहुत तेजी से जा रहा है वो भी उसको हाइपर अराउज कर दे, ठीक है ना। तो ये देखिए कि अराउजल और रिएक्टिविटी बढ़ जाती है, इरिटेबिलिटी, हाइपर विजिलेंस, एक्सैजरेटेड स्टार्टल, ठीक है। दीज आर फ्यू साइन एंड सिम्पटम्स। वेरी इंपॉर्टेंट, इसमें बोलता है कि विद इन 6 मंथ सिम्टम आ जाना चाहिए, बस 1 से 6 मंथ तक सिम्टम आ जाना चाहिए ट्रॉमेटिक इवेंट के बाद। अगर 6 मंथ के बाद भी आ रहा है तब भी पीटीएसडी कंसिडर कर सकते हैं, प्रोवाइडेड कोई और डायग्नोसिस ना बनी हो, कोई डिप्रेसिव सिम्टम, डिप्रेसिव डायग्नोसिस ना बनी हो, कोई जनरलाइज एंजाइटी डिसऑर्डर की डायग्नोसिस ना हो, ठीक है। Then core symptom, again repetitive intrusion, collection of the reenactment of the traumatic events in the form of memories, daytime imagery or dreams. Person may experience emotional detachment, numbing of feelings and avoidance of stimuli. Autonomic disturbances such as mood and behavioral abnormalities. Similarly, इसमें भी वही है, more than 1 month बोला गया है पीटीएस में डायग्नोस्टिक क्राइटेरिया में, ठीक है। डिफरेंशियल डायग्नोसिस जो हमने एक्यूट स्ट्रेस रिएक्शन और उसमें देखी थी, जैसे जीएडी, पैनिक डिसऑर्डर, एडजस्टमेंट डिसऑर्डर, बॉर्डरलाइन पर्सनालिटी विद ट्रॉमा हिस्ट्री, डिसोशिएटिव सब्सटेंस और मूड डिसऑर्डर, ठीक है। अगेन यू विल हैव अ डिटेल हिस्ट्री एग्जामिनेशन, कोरिलेशन विद द ट्रॉमेटिक इवेंट, जो फ्लैशबैक और जो भी हमने क्लिनिकल सिम्टम्स देखे हैं। अदर देन दैट यू शुड, कोई कोमॉर्बिड अदर साइकेट्रिक या मेडिकल कंडीशन तो नहीं है। दिस शुड बी स्टैंडर्डाइज्ड मेजर्स लाइक पीटीएसडी का स्केल अगर देखना है, ठीक है। अगेन मैनेजमेंट में पीटीएसडी में भी आपका साइकोथेरेपेटिक मैनेजमेंट पहले प्रेफर किया जाता है। ऑब्वियसली वी हैव अ रोल ऑफ एंटी डिप्रेसेंट्स यहाँ पे भी, बट यहाँ पे कुछ चीजें याद रखिए, जो सीबीटी भी कर रहे हैं वो ट्रॉमा फोकस सीबीटी होती है, ठीक है। हेल्प्स पेशेंट प्रोसेस एंड रिफ्रेम ट्रॉमेटिक मेमोरीज, इन्वॉल्व्स टेक्निक, कॉग्निटिव रीस्ट्रक्चरिंग एंड स्ट्रेच मैनेजमेंट स्किल, रिड्यूस अवॉइडेंस बिहेवियर, इमोशनल डिस्टेंस, कॉग्निटिव डिस्टॉर्शंस। प्रोलॉन्ग्ड एक्सपोजर जो हमने ईआर में पहले पढ़ा था उसी का ही एक वेरिएंट है, इसमें एक्सपोजर थोड़ा सा लंबे समय तक, ठीक है। ग्रेजुअल एक्सपोजर टू ट्रॉमा, स्टिमुलाई टू रिड्यूस फियर एंड अवॉइडेंस बिहेवियर, जैसे देखा था इमेजिनल बिहेवियर इन वीवो कह सकते हैं, या फिर एंड आपका इट विल हेल्प पेशेंट टू हैबिचुएट टू डिस्ट्रेसिंग मेमोरीज एंड रिड्यूस इमोशनल रिएक्टिविटी। EMDR इज वेरी मच स्पेसिफिक टू पीटीएसडी या ट्रॉमा थेरेपी में। इसमें क्या होता है कि फिंगर मूवमेंट्स के साथ पेशेंट को जो भी मेमोरी है उससे कैसे डील करना है, ठीक है। आई मूवमेंट डिसेंसिटाइजेशन एंड रीप्रोसेसिंग, आप पेशेंट को भी इमेजिन करने को बोलोगे, अभी आप क्या फील कर रहे हो, कैसी मेमोरी है, या जिस चीज में जो भी डिस्ट्रेसिंग इवेंट है उसको याद करके बताइए। जब पेशेंट एक जगह पे हो तो उसको आईज ओपन करने को बोलोगे और अपनी फिंगर फॉलो कराओगे और पेशेंट को बोलोगे कि अपनी आईज से इस चीज को फॉलो करो, ठीक है ना। आप हिस्ट्री टेकिंग करोगे, प्रिपेयर करोगे, डिसेंसिटाइजेशन करोगे, ठीक है, इंस्टॉलेशन ऑफ दैट मेमोरी, और बॉडी स्कैन। जब भी पेशेंट, बॉडी स्कैन का यहाँ पे मतलब है कि जब पेशेंट एक्सेस एंजाइटी फील कर रहा है तो उससे पूछो कि आपके बॉडी में क्या फील हो रहा है, और जब आई मूवमेंट करने के बाद अगर थोड़ा रिलैक्स फील कर रहा है तो तब पूछो बॉडी में क्या हो रहा है। देन और ये रीएवैल्यूएशन करते रहना, एक सेशन में नहीं होता है, मल्टीपल सेशन लगते हैं। देन यू हैव ग्रुप थेरेपी, माइंडफुलनेस वेब थेरेपी एंड सब सपोर्टिव थेरेपीज एज वेल। SSRIs, I told you already कि आपका एंटी डिप्रेसेंट सर्ट्रिलिन, पेरोक्सिटिन, फ्लोक्सिटिन, ओके। अदर देन दैट SNRI, वेनलाफेक्टिन, वेनलाफिक्सिन अगर देख सकते हैं। प्राजोसिन इज अ ड्रग जो कि आपका हाइपर अराउजल को ट्रीट करने में हेल्प करती है। शॉर्ट टर्म यूज के लिए आप बेंजोडाइजेपिन यूज कर सकते हैं, ठीक है। मूड स्टेबलाइजर अगर इमोशनल डिसरेगुलेशन ज्यादा है, इम्पल्सिविटी ज्यादा है पेशेंट में तो यूज कर सकते हैं। अगेन लाइफस्टाइल मॉडिफिकेशन, ठीक है, एक्सरसाइज, रेगुलर स्लीप हाइजीन और गुड सपोर्ट फ्रॉम फैमिली एंड फ्रेंड्स। लास्ट, कमिंग ऑन टू द लास्ट टॉपिक ऑफ टुडेज व्हिच इज एडजस्टमेंट डिसऑर्डर। एडजस्टमेंट डिसऑर्डर आपका स्ट्रेस रिलेटेड कंडीशन ही अगेन, इसमें क्या होता है, इमोशनल एंड बिहेवियर सिम्टम इन रिस्पॉन्स टू आइडेंटिफाइबल स्ट्रेसर अकरिंग विद इन 10 to 3 मंथ, ICD-10 1 month बोलता है और 3 months DSM-5 बोलता है, ठीक है, एंड इट शुड रिजॉल्व विद इन 6 months आफ्टर द स्ट्रेसर इज टर्मिनेटेड, ठीक है। इट कैन अकर एट एनी एज, बट लेकिन एडोलेसेंट और यंग एज ग्रुप में ज्यादा भेजा गया है, जिससे मेजर लाइफ चेंजेस कभी हो रहे हैं तब देखने को मिला है, ठीक है। की फीचर है आपके मालअडेप्टिव इमोशनल बिहेवियरल रिस्पॉन्स टू स्ट्रेस, इम्पेयरमेंट इन सोशल ऑक्यूपेशनल और एकेडमिक फंक्शनिंग, सिम्टम्स आर नॉट ड्यू टू एनी अदर मेंटल कंडीशन। अगेन इसका साइकोसोशल स्ट्रेसर हो सकता है कॉज, कोई भी इंटरपर्सनल कॉन्फ्लिक्ट है, जैसे कि कोई मेजर रिलेशनशिप टूटा है, डिवोर्स हुआ है, बोर्डिंग स्कूल भेज रहे हो बच्चे को, ठीक है ना, कोई जॉब इश्यूज है, फाइनेंशियल है, फेलियर है, बुलिंग है, क्रॉनिक इलनेस है, डिसेबिलिटी है, या फिर कोई ट्रॉमा है, ठीक है, माइग्रेशन जैसी कोई चीज है, तब भी हो सकता है ना। इंडिविजुअल फैक्टर्स क्या हो सकते हैं, किसी पेशेंट का लो रेजिलियंस है, हाई न्यूरोटिसिज्म है, अकेले रह रहा है, कोई सोशल सपोर्ट नहीं है, लोग समझने वाले नहीं है, या फिर पेशेंट को आप कुछ लोग बायोलॉजिकली स्ट्रेस सेंसिटिव होते हैं, उनका फ्रस्ट्रेशन टॉलरेंस कम होता है ना, ये सब चीज तो नहीं है। क्लिनिकल फीचर्स देखें तो इमोशनल सिम्टम्स हो सकते हैं, जैसे कि डिप्रेशन है, होपलेसनेस है, एंजाइटी हो सकती है, इरिटेबिलिटी हो सकती है। फिजिकल सिम्टम में बॉडी एक से लेकर हेड एक से लेकर स्लीप एपेटाइट्स, कोई भी सिम्टम प्रेजेंट कर सकता है, गैस्ट्रिक इरिटेबिलिटी के साथ भी पेशेंट प्रेजेंट कर सकता है, चेस्ट पेन के साथ भी प्रेजेंट कर सकता है। सोशली विड्रॉल बिहेवियर, रेकलेस बिहेवियर भी देख सकते हो आप, ठीक है, गाड़ी तेज चला रहे हैं, खुद को हार्म कर रहे हैं, इंक्रीज सब्सटेंस यूज, डिफिकल्टी कंसंट्रेशन, मेमोरी इंपेयरमेंट एंड इनडिसिसिवनेस कॉग्निटिव सिम्टम्स में आ गए। अगेन ICD-10 क्या बोलता है इसको, आपके 2-3 क्राइटेरिया डिफाइन किए, पहले तो इमोशनल डिस्ट्रेस एंड इम्पेयरमेंट, प्रेजेंस ऑफ सब्जेक्टिव डिस्ट्रेस एंड इमोशनल डिस्टर्बेंसेस, डिस्ट्रेस मस्ट इंटरफेयर विद सोशल फंक्शनिंग, स्ट्रेसर होना चाहिए स्पेसिफिक टू सिग्निफिकेंट लाइफ चेंज और स्ट्रेसफुल इवेंट और सच एज माइग्रेशन, रिफ्यूजी स्टेटस, एंड इट शुड अफेक्ट द इंडिविजुअल डायरेक्टली और इनडायरेक्टली, ठीक है, कोई फैमिली मेंबर के वाया भी आपको अफेक्ट आ सकता है। नाउ ये जो भी सिम्टम्स हैं आपका मैनिफेस्ट कैसे कर रहे हैं, ये सब चीजें फिर से वही सिम्टम्स जो हमने पहले देखा है। इन सम केसेस देयर कुड बी एंगर आउटबर्स्ट या वायलेंस, ठीक है, बच्चों में आपका कॉन्डक्ट जैसे सिम्टम दिख सकते हैं, ठीक है, रूल्स नहीं फॉलो करेंगे, एग्रेसिव हो जाएंगे, डिसोशियल बिहेवियर, बेड वेटिंग भी हो सकता है, ठीक है। विद इन 1 month ऑफ द स्ट्रेसर एंड आफ्टर 6 month रिजॉल्व होना चाहिए, स्ट्रेसर हटा गया है, टाइम फ्रेम ये बोलता है, ठीक है। सिमिलरली DSM के क्राइटेरिया, डिफरेंशियल डायग्नोसिस में प्लीज रिमेंबर ग्रीफ एंड बेरीवमेंट डिफरेंशियल डायग्नोसिस में आ सकती है, ठीक है, पेशेंट अगर ग्रीफ कर रहा है, कोई मेजर लॉस हुआ है, किसी कोई फैमिली मेंबर की डेथ हुई, तो उस टाइम पे भी ऐसे पेशेंट बिहेव कर सकता है, ठीक है ना। मेजर डिप्रेसिव डिसऑर्डर, PTSD और जनरलाइज एंजाइटी डिसऑर्डर, कॉन्डक्ट एंड सब्सटेंस यूज डिफरेंशियल डायग्नोसिस में। अगेन यू विल हैव टू इवैल्यूएट कि स्ट्रेसर क्या है, टाइमलाइन कितना है उसका, 1 या 3 महीने के विद इन है, इमोशनल और बिहेवियर सिम्टम्स क्या है, इसका फंक्शनल असेसमेंट करना है कि वर्क रिलेशनशिप, डेली लाइफ में क्या इम्पैक्ट हुआ है, फिजिकल एग्जामिनेशन टू रूल आउट कोई फिजिकल सिम्टम तो नहीं है, एंड MSc में आपको स्ट्रक्चरली कोई साइकोलॉजिकल स्ट्रेसर दिख रहा है तो नहीं। कुछ रेटिंग स्केल है अदर देन आपका एडजस्टमेंट डिसऑर्डर मॉड्यूल और इंटरनेशनल एडजस्टमेंट डिसऑर्डर क्वेश्चन है, इसके अलावा आप डिप्रेशन इन्वेंट्री या फिर एंजाइटी इन्वेंट्री भी लगा सकते हैं टू रूल आउट कोई और कॉजेस तो नहीं। कुछ इन्वेस्टिगेशन याद रखिए, थायराइड भी आपका मूड चेंजेस कॉज कर सकता है, कि थायराइड फंक्शन में कोई दिक्कत तो नहीं है, CBC टू रूल आउट अनीमिया रिलेटेड फटीग तो नहीं है, B12 D3 का लेवल देखो कि इस वजह से तो कहीं वीकनेस नहीं आ रही है, सब्सटेंस यूज के लिए स्क्रीन करना है। अगेन साइकोथेरेपी, CBT यूज करनी है, स्ट्रेसर क्या है उस पर कॉग्निटिव जो बिलीव्स हैं उसको चैलेंज करना है, ठीक है। ग्रुप थेरेपी कैन हेल्प, सपोर्टिव थेरेपी, क्राइसिस इंटरवेंशन थेरेपी, शॉर्ट टर्म थेरेपी है, इसमें पेशेंट को स्टेबलाइज मतलब जो स्ट्रेसर है उससे दूर करा के फिर सजेशन, रीएश्योरेंस एंड एनवायरमेंटल मॉडिफिकेशन किया जा सकता है। फार्माकोथेरेपी में कोशिश की जाती है कि साइकोथेरेपी से ही ज्यादा पेशेंट ट्रीट हो, उसके बाद एंजियोलिटिक या लो डोज एंटी डिप्रेशन भी चल सकता है। अगेन डीप ब्रीदिंग, रिलैक्सेशन, रेगुलर स्लीप हाइजीन, योगा, मेडिटेशन का रोल है। So in conclusion, we have understand all these anxiety related disorder. They have multifactorial etiology. Role of trauma is very common in most of the diseases. So you should identify and you must be able to differentiate between the three and tailored treatment and lifestyle modifications. Okay. With this, I'll conclude. These are the references. Thank you. Any questions?
Good afternoon to all. So this is your lecture on somatoform disorder and dissociative conversion disorder. The aims and objectives are to define somatoform and dissociative disorder, the historical approaches, review information regarding prevalence, onset and course, discuss current etiological findings and clinical features of all, and outlining the treatment approaches. So first we will go through the terms, somatoform, what is dissociative and what is conversion. Somatoform disorders involves the presentation of medically unexplained symptoms, which means the symptoms are there but cannot be explained by virtue of physical examination and lab investigations. Dissociative disorder involves the loss of normal integration of the identity of self, the memory of the person, perception and the level of consciousness or disturbance of consciousness. So dissociation is a mechanism whereby one part of mental functioning is split from the rest, which is memory, consciousness, perception and identity of the person. As per the ICD-10, the dissociation is it shares the common theme of dissociation and conversion, which is a partial or incomplete loss of normal integration between memories of the past, awareness of the identity of self, immediate sensations, which are bodily sensations, and control of the bodily movements. The historical approaches of somatoform disorder. In the ancient term, hysteria referred to non-fatal malady of women that included different types of bodily symptoms. So it used to occur in females mainly. So it is referred to hysteria, which the term came from the word hyster. Hyster means uterus. So it is correlated with the dysfunctions of women. And the most classic cases of hysteria is Anna O, which was written by Joseph Breuer and Sigmund Freud. Regarding Anna O, she was a young Viennese woman who reported multiple somatic symptoms which were suggested to be associated with psychological trauma of her father's illness and death. So there is a stressor and trauma which resulted into the somatic symptoms. The term conversion signifies the transformation of psychological material into somatic symptoms. The psychological happening or trauma can lead to somatic symptoms. This can be understood by a simple example. When a school going child around the age of in the adolescence period, they used to complain regarding the abdominal pain and like headache in morning when the school time is approaches, to avoid the stressor of academia in the school. So that stressor of academics is converted into the somatic symptom, which is abdominal pain. So this is a simple example. The treatment of NaO was the first described case of psychoanalysis, which was postulated by Sigmund Freud and also known as talking cure or talk therapy. Freud theorized that hysteria was the result of consciously unacceptable sexual fantasies from childhood. Sigmund Freud also has given theory of libido, which is known as libidinal theory, and which is related to the psychosexual development of the child, and the happenings were correlated with the development of child is correlated with the development of sexual characteristic over the period of time. So this theory in detail you can learn in the another lecture video in our channel in detail. So this is the overview of somatoform disorder. It appears to be physical or medical but are due to psychological factors. The symptoms may mimic a physical problem or a medical problem, but underlying there is a psychological problem. By means of lab investigations and physical examination, nothing significant will be found. Psychological disorders masquerading as physical problem. The meaning is same. People with these disorders do not consciously want or purposely produce their symptoms. No intentional or not, these are not intentional or under voluntary control. This doesn't mean that the person is creating those symptoms voluntarily. This is happening because of the underlying psychological cause or psychological trauma. This is not in the voluntary control of that person. तो कभी भी इस डिसऑर्डर के पेशेंट्स अगर मिलते हैं तो उनको कभी ये ना कहें कि इनको कुछ नहीं हुआ है, ये ठीक है, या ये नौटंकी कर रहे हैं या मक्कारी कर रहे हैं या बहाना बना रहे हैं. फॉर मेडिसिन, for physiotherapy, for other branches like anesthesia, there is no impairment seen because of these presentation, but for psychiatrists these are the disorder and have to be referred and treated. The conflict and the trauma should be addressed and relieved. People with these disorders believe their problems are genuinely medical. They believe that they have medical illness because that psychodynamics, they cannot understand why these somatic symptoms are appearing or happening. These symptoms are not due to effects of any kind of substance or alcohol, not due to another mental disorder. Symptoms causes significant distress or impairment in functioning. These disorders are also denoted as functional disorder or medically unexplained symptoms. Now, how the patient presents? They can present as having symptoms of musculoskeletal system like low back pain, generalized malaise or fatigue like chronic fatigue or fibromyalgia, GI symptoms like abdominal pain, bloating, or having diarrhea or other symptoms, gynecological symptoms, heavy or painful periods, neurological symptoms such as pseudo seizures known as dissociative convulsion, regional pain presentation like atypical chest pain or headaches. The somatoform disorders are classified in ICD-10 as follows. The chapter is F45 for somatoform disorder. Subclassification as somatization disorder, hypochondriacal disorder, somatoform autonomic dysfunction, and further subclassified as per the system involved like cardiovascular system, GI system, respiratory system, genitourinary system, and other organ. Another classification is persistent somatoform pain disorder. In epidemiology, these are the medically unexplained physical symptoms which are common in somatoform disorder, and formal clinical somatoform disorder are rare in the general community, but it is more prevalent among those who are into the medical setups, those who are the high utilizer of health services. Anxiety and depression are common in people with unexplained physical symptoms and those with the somatoform disorder. So comorbid anxiety, depression can be seen. Somatoform disorder are more common among women. In etiology, as we know that all of the disorder has some kind of biopsychosocial factors. So for somatoform disorder, the biological factors which are seen are underactivity of hypopituitary adrenal axis, which is known as HP axis, and can be the explanation of fatigue, Neurobiological models focus on how sensory and motor information is processed. So to understand simply, we got a stimuli like touch, pain, vibration. So there is a threshold for the brain or neuronal mechanism which has some kind of threshold to perceive that sensation. Uh, to perceive that sensation. If the threshold is reduced, then a smaller amount of stimuli can also create that sensation or perception of sensations. So there is neural gates mechanism theory of neural gates. The neural gates in the spinal cord can be opened or closed, determining the amount of pain the individual experiences. The more the activity in the pain fibers, more gates are opened. More activity in peripheral fibers regarding stimuli around the body, more gates are closed. So message from brain can be open or the close gates. This is theory or hypothesis which is not proven true. Another biological factor is to experience somatic symptoms as intense, noxious or disturbing, which has three elements: the hypervigilance, selecting out some sensations, intensification by cognition and affect, making them more alarming. So what these theories want to say that the normal sensations of the body, like uh, intestinal movements, are perceived as exaggerated movements of intestine and perceived as a painful condition, bloating or other symptoms of abdomen. Regarding the trauma and personality factors, patients with somatoform disorders are more likely to have experienced adverse event in childhood. One theory proposed that memory of the early trauma is contained in the emotions, reflex actions, and bodily sensations. So these childhood trauma or childhood mishappenings are turned into the bodily sensation in adulthood. Negative events in childhood may also give rise to personality characteristics that predispose the person to somatoform disorder. Childhood trauma leads to a certain kind of personality, and that personality is vulnerable to acquire the somatoform disorder. People with somatoform disorder have higher rates of alexithymia, means difficulty experiencing or expressing emotions. Failing to identify and express emotional distress may lead to increased physiological arousal. Another theory is cognitive and behavioral factors. So you have learnt about the cognitive and behavioral theory in your psychology class of learning theories. So what it says that cycle of somatosensory amplification leads to tendency to experience somatic sensation as intense and distressing. So you can see in the figure there is lots of interchangeable expressions of anxiety, depression, stress, and that leads to alexithymia, and there is somatosensory amplification which leads to somatic symptoms. Now come to the individual disorder. Somatoform disorder has many condition. One is somatization disorder. The main feature of somatization disorder is repeated presentation of physical symptoms. Physical symptoms are presented repeatedly together with persistent request for medical investigation. After reassurance, they not get relieved and they want repeated investigations, which claims to be normal, and in spite of repeated negative findings and reassurance, the symptoms has no physical basis. Onset and continuation of symptoms bear a close relationship with unpleasant life event or with difficulties or conflict. There may be unpleasant life event in the past or in the childhood. Maybe the person is having difficulties or conflicts in the current situation, and the patient usually resists attempt to discuss these conflicts and life events. They do not relate those life events with the current symptoms. Often a degree of attention-seeking behavior is present, also known as histrionic behavior, in which the person used to try to get the more attention of others towards him or her. Persistent refusal to accept the advice or reassurance of several doctors that there is no physical explanation for the symptoms. Despite of that, these persons are in trouble or having problem that should be resolved. Second is hypochondriacal disorder. There is persistent belief in presence of at least one serious physical illness. In somatization disorder, there were signs and symptoms, but there is a name of a disease, disorder or syndrome with which the person present. In this condition, after repeated investigation and examination, have identified no adequate physical explanation, which is the common feature of these stress-related disorders or somatoform disorders. Persistent refusal to accept the advice and reassurance of several different doctors that there is no physical illness or abnormality underlying the symptoms. What underlying psychological factors are there? Then is the somatoform autonomic dysfunction, which may presented with various features of systems like cardiovascular system. So cardiovascular system, also called as cardiac neurosis, GI symptoms called as gastric neurosis or nervous diarrhea. If respiratory system is involved, is called as psychogenic hyperventilation and psychogenic hiccups, which are common presentations. The symptoms are usually of two types, and neither of which indicates a physical disorder of an organ or system concern. The first type characterized by complaints based upon objective signs of autonomic arousal. Autonomic nervous system you must know, and the symptoms of autonomic hyperactivity you must be knowing. So they present with autonomic arousal. The second type is more idiosyncratic, subjective and non-specific symptoms such as sensation of fleeting aches and pains, burning sensations, heaviness in chest, head or bodily parts, tightness and sensation of being bloated or distended. These are referred by the patient to specific organ and system. So specific system is involved in this somatoform autonomic system. The person will confine to either to the cardiovascular system or to the GI system like upper GI or lower GI or to the respiratory system. Persistent somatoform pain disorder. The predominant complaint is of persistent, severe and distressing pain which cannot be explained fully by a physiological process or a physical disorder. Pain occurs in association with emotional conflict or psychosocial problems that are sufficient to allow the conclusion that they are main causative influence for the pain. The result is usually marked increase in support and attention, either personal or medical. So attention seeking behavior is also a central point for these disorders, which are secondary to their primary problems. Pain presumed to be of psychogenic origin occurring during the course of depressive disorder or schizophrenia should not be included here. Somatic symptoms may also be present in case of depression and other psychiatric problems that should not be included here, and neurological conditions also like tension type headache and migraine. The differential diagnosis for somatoform disorders are those affecting multiple organs like systemic lupus erythematosus, sarcoidosis, lymphomas, pain disorder due to physical problems, depressive disorder, schizophrenia, delusional disorder, factitious disorder, and malingering. Factitious disorder means feigning the illness for some psychological gain, and malingering is for other gains. The treatment requires a strong doctor-patient relationship, and it is the key to getting help with somatoform disorder. And it is advisable that a single healthcare provider with experience managing somatoform disorder can help cut down on unnecessary tests and treatments. So there is a doctor-patient good relationship is required, and it is advisable that one doctor, one psychiatrist or psychologist should treat these person. Multiple therapists cannot help these problems. The focus of treatment is on improving daily functioning, not on the managing symptoms. Symptoms are there for the patient, the symptoms are there, but these are not because of directly physiological problems. Stress reduction is often an important part to get better. Counseling for family and friends may also helpful when there is a conflicts between the family members and with the others, that should be resolved. CBT may help relieve symptoms associated with somatoform disorder, and CBT involves correcting the distorted thoughts, unrealistic beliefs, behaviors that feed the anxiety. You must be recollecting the lecture of cognitive behavior therapy in psychology. What is the cycle behind the cognitive behavior therapy and cognitive behavior theories? Now coming to the dissociative disorder or conversion disorder. These are subclassified as dissociative amnesia, fugue, stupor, trance and possession disorder, motor disorder, convulsions, anesthesia and sensory loss. So now learn about the dissociation first. Dissociation is a disconnection between a person's sensory experience, thought, sense of self or personal history. Dissociation is also known as a defense mechanism in which conflicting impulses are kept apart or threatening ideas and feelings are separated from rest of the psyche. So patient get dissociated from one of the aspect of himself. Someone with dissociation might feel a sense of unreality and lose their connection to time, place and identity. Several factors can play a role in the development of dissociation, and the potential causes are trauma, drug use and other medical conditions can also produce dissociation. But we will talk about the dissociative disorder which has purely psychological underpinnings. So there are two terms, dissociation and conversion. So what is dissociation and what is conversion? So conversion is conventionally applied to somatic symptoms, whereas symptoms is psychological rather than physical is regarded as dissociation. There are two kinds of presentation in this disorder. One seems to be having involvement of bodily functioning like motor symptoms, like sensory symptoms, and others are like amnesia and stupor. So what is visible by eyes are conversion. Patient fell down, patient is in stuporous condition, patient is having pseudo seizures. These are visible, so these are considered as conversion. And the thing which cannot visualize like headache, amnesias and anesthesias, these are dissociation. Epidemiology is not well established. Prevalence of dissociative amnesia is controversial, but recent estimation of 1.8% in a community sample in a study found dissociative identity disorder 1% in community but much higher in clinical samples are seen. Etiology: the dissociative disorders believed to be stress related. So some kind of stress is always behind this presentation. In psychological mechanisms, one can have distorted perceptual factors, how the person perceives for himself, herself, or surroundings, the belief system of the person, the mood swing of the person, and the personality factor, the ego defense mechanism of the person, and the coping style, how efficient the person is able to cope with the stress. So we now coming to the individual disorder. In dissociative amnesia, what happens is uh, it's a type of dissociative disorder characterized by inability to recall important personal information. मुझे कुछ याद नहीं आ रहा है, but there is no neurological basis of that. It is usually caused by trauma or stress, and people may lose memories relating to distressing or upsetting events. And these amnesias are more centered towards the difficult situations or conflicts the person is having in their life. They try to suppress their memory. Dissociative fugue is a rare psychiatric phenomenon characterized by reversible amnesia for one's identity in conjunction with unexpected wandering or travel. So these people totally get detached from their identity and themselves presents as a total different identity, which have separate emotions, separate personality traits, and separate a total of separate identity. And these people may found wandering or traveling in different situations. If you want to understand dissociative fugue, there is a movie called as Cybil, Cybil. This was a true story about a female who had this dissociative fugue or multiple identity disorder. There is a movie also in which a person, a characteristic suddenly turns into a different kind of personality. It's a South movie. That is not the true presentation, but you can relate with that movie. How a personality can change into another. एक टाइम पर वो बिल्कुल एकदम सीधा साधा सा होता है, then he becomes different kind of aggressive personality suddenly. Stupor, you all know. Stuporous condition is a condition where consciousness is lost. But in dissociative stupor, it's a rare form of stupor characterized by severe reduction or complete absence of motor, behavioral, and affective response to the environment. There is absence of these responses, but actually the person is not unconscious. कभी कभी या आपने कहीं देखा होगा या सुना होगा आपके आस पड़ोस में कुछ औरतें बेहोश हो जाती हैं. स्टूपर वही है, स्ट्रेस आया, बेहोश हो गए, हाथ पैर छूट गए, लेकिन एक्चुअल लॉस ऑफ कॉन्शियसनेस इज नॉट देयर. Trance and possession disorder characterized by a state of temporary marked alteration in state of consciousness without replacement by an with a replacement by an alternate identity. Possession is defined as an episode of alteration in state of consciousness with the replacement of customary sense of personal identity by a new identity. In the words, it seems to be complicated, but in simpler form you can understand. जब किसी के अंदर माता आ जाती है, that is trance and possession disorder. The someone is possessed by a new identity. So this is also kind of dissociative disorder, and behind this phenomena there is a certain kind of stress is there. And again, when such thing happens repeatedly, then the person started getting attention of the other persons. So to get to attention seeking behavior को sustain करने के लिए they used to repeat these kind of behaviors. Similarly, motor disorder, the motor dysfunctions are there, like loss of ability to perform bodily movements. Motor symptoms are there, but there is no biological basis of these motor symptoms, like achynesias, aphonia, apraxia, ataxia. The person present with these type of problem, but actually you will find technically there is no biological basis of these ataxia, apraxia, aphonia, and the symptoms are fleeting and patchy in presentation. Dissociative convulsion is also known as psychogenic non-epileptic seizure or pseudo seizures. The person present with mimicking motor symptoms of a seizure activity, and but not other associated symptoms which are actually due to uncontrolled firing of neurons, like clenching of teeth, tongue biting, incontinence, injury due to fall. These phenomena are not present in pseudo seizures. Similarly, anesthesia and sensory loss, the person may present with some sort of loss of sensation and kind of anesthesia, but it is not following the typical presentation in concurrence with the dermatome of that neuronal supply. Person will say that I am having loss of sensation in this area, but you will find that it is not matching with the dermatome. You know about the dermatome? What are the dermatomes? You must be knowing as a physiotherapist, no? Now, treatment. In dissociative disorder, the treatment can be cognitive behavior therapy, hypnotherapy. If there are conflicts, then family therapy can be done. If there is conflict between family members, physical therapies can also help. In case of the person is having overlaying depression and or anxiety, medications can also help. If person is having insomnia, the medications can help. Biofeedback is an alternative medicine approach that teaches people to change the way of their body functions. It's a kind of a mind-body therapy that may improve the physical and mental health in case of dissociative or conversion disorders. Now, in the summary, we have learned about the somatoform disorder and conversion or dissociative disorder. In somatoform disorder, by and large, there is persistent physical complaints without any identifiable medical cause. Pain, fatigue, or other bodily symptoms that interfere with daily life. Excessive thought, feelings, or behavior related to the symptoms, such as frequent health-related anxiety, disproportionate worry about the severity of symptoms, and spending excessive time or energy addressing health concerns. So somatoform disorder is more related with the sign and symptoms, and while conversion disorder is more related to the presentation of some kind of deficiency in physical functioning. So there is sudden physical symptoms that suggest a neurological issue or a medical issue but cannot be explained, like paralysis, blindness, speech problem, pseudo seizures. Symptoms often appear after a stressful or traumatic event and are not consciously created by the individual. This is an important point. These symptoms are not consciously created by the individual. So don't send back these patients to the home. Send the patient to a psychologist or a psychiatrist. Thank you. Good morning to all. So in the series of neurotic and stress related disorder, today we will covering other neurotic disorders. Other neurotic disorders are neurasthenia, depersonalization, derealization syndrome. So in ICD-10 classification, In other neurotic disorders, there is a chapter F48 which consists of neurasthenia and depersonalization and derealization syndrome. Let's begin with the neurasthenia. Neurasthenia includes fatigue syndrome, which is previously known as fatigue syndrome, and it excludes asthenia, burnout, malaise and fatigue, post-viral fatigue syndrome, and psychasthenia. It is also known as chronic fatigue syndrome. In ICD-10, it's a ill-defined condition of unknown etiology. Regarding the epidemiology, the precise rate of incidence and prevalence is not well known, and estimates suggest that incidence of between 0.007% and 2.8% within the general adult population. This condition primarily affects young adults, specifically those aged between 20 to 40. It can occur in children and teenagers. It does so at a lesser frequency. Women are at least twice as likely to be impacted more than men. The exact cause of disorder remains unknown. Etiology, the diagnosis can only be confirmed after excluding all other medical and psychiatric reasons for chronic fatigue. So this is a diagnosis of exclusion. No specific signs or tests found that definitely diagnose this condition. Attempts had been made to link the Epstein-Barr virus, but Epstein-Barr virus infection shows distinct antibodies and atypical lymphocytosis, which are not present in neurasthenia. Tests for other viral pathogens like enterovirus, herpes virus, retroviruses have yielded negative results in the studies regarding association with neurasthenia. Some researchers found that non-specific immune abnormalities in individuals with neurasthenia have been found, such as diminished proliferation response of peripheral blood lymphocytes. However, these responses are similar to those found in certain patients with major depression. So this is also a non-specific finding. Numerous studies indicated a disturbance in HPA axis known as hypothalamic pituitary adrenal axis and accompanied by mild hypercortisolism. Due to this, external cortisol has been administered to alleviate fatigue, although the outcomes have been mixed. Some patients shown improvement and some not. Investigations are currently exploring cytokines like interferon alpha and interleukin 6 known as IL-6 as a potential contributing factors. Increased level have been detected in brains of certain patients. MRI studies have revealed a reduction in volume of both regional gray and white matter in individuals with neurasthenia. Now coming to the clinical feature to understand what is neurasthenia or chronic fatigue syndrome. There are two main types. In one type, the main feature is complaint of increased fatigue after mental efforts. It is often associated with some decrease in occupational performance or coping efficiency in daily tasks. The mental fatigability is typically described as an unpleasant intrusion or distracting associations or recollections in the mind, difficulty in concentration, and generally inefficient thinking. In other type, the emphasis is on feeling of bodily or physical weakness and exhaustion after only a minimal effort, accompanied by a feeling of muscular aches and pains and inability to relax. So in one type there is a mental fatigue, and another type there are bodily or physical weakness, can be said as physical fatigue. In both types, a variety of other unpleasant physical feelings are also present, such as dizziness, headaches, sense of general instability, worry about decreasing mental and bodily well-being, irritability, anhedonia. Minor degrees of both depression and anxiety are all common but are not fulfilling the criteria of depressive disorder or anxiety disorder. Sleep is often disturbed in initial and middle phase, but hypersomnia may also be prominent or present. Now coming to the diagnostic criteria, there are two diagnostic criteria, one for Center for Disease Control and Prevention. The clinical features are severe unexplained fatigue over 6 months, that is of a new or definite onset, that is not due to continuing exertion, not resolved by rest, and functionally impairing. These are the main criteria. And in B criteria, out of 8, 4 must be present. For example, impaired memory or concentration, sore throat, tender lymph nodes, muscle pain, pain in several joints, new pattern of headaches, unrefreshing sleep, post-exertional malaise lasting more than 24 hours. Now look at the ICD-10 criteria. The criteria A is either persistent and distressing complaint of increased fatigue after mental effort, or persistent and distressing complaints of bodily weakness and exhaustion after minimal physical effort. In criteria B, at least 2 of the following should be present, like feeling of muscular aches and pains, dizziness, tension headache, sleep disturbance, inability to relax, irritability, and dyspepsia. Any autonomic or depressive symptom present are not sufficiently persistent and severe to fulfill the criteria for any of the more specific disorders in the classifications, like somatoform disorder, depressive disorder, or anxiety disorder. The differential diagnosis. In many regions, neurasthenia is not commonly recognized as a diagnostic category, rather put in the continuum of depressive disorders. Historically, many cases labeled as neurasthenia would now be classified as depressive or anxiety disorder in newer classifications. However, some cases align more closely with neurasthenia than with any other neurotic condition, and these instances appear to be more prevalent in certain cultures. So this neurasthenia is also found to be culture specific, and it more aligns with the culture bound syndromes. When considering neurasthenia as a diagnosis, it is important to first exclude any depressive or anxiety disorder. Key feature of this syndrome, unlike somatoform disorder, which primarily involve physical complaints and concern about the illness. If neurasthenic symptoms arise following a physical illness like influenza, viral hepatitis, mononucleosis, it is essential to document that initial diagnosis as well. Now come to the depersonalization and derealization syndrome. It is a condition where individual reports that their mental process, physical sensations, and or environment feel are altered, leading to sense of unreality, distance, or automation from themselves or from the environment. People may sense that they are not in control of their thought, imagination, or memories, but this is not amounting to delusion of control. So they are not in control of their thought, imagination, or memories, that their actions and behavior do not feel like their own, that their body appears lifeless, disconnected, and unusual. Such a feeling can be found in delusion like delusion of control or delusion of influence, but this is not pertaining to delusional thinking. And that their surrounding seems dull, artificial, or like a stage where others are playing scripted roles. So it feels like a drama or a script or a skit or play. Some may even feel as if they are observing themselves from afar or as if they are diseased. A common complaint among these experiences is lack of emotions. The number of people who experience this disorder in a pure form or isolated form is limited. More often, this derealization and depersonalization occur alongside with other conditions like depression, phobias, and obsessive compulsive disorder. So commonly, these disorders, these symptoms are part of the illness, and isolated people with only depersonalization and derealization are found to be rare. Elements of this syndrome can also be found in mentally healthy individuals, such as condition of exhaustion, physical exhaustion, sensory deprivation, hallucinogen use, or during hypnagogic or hypnopompic states of sleep. The experiences of depersonalization and derealization are akin to near-death experience that happen during moments of extreme life-threatening conditions. So, in depersonalization and derealization, the patient may describe some of these experiences or feeling as uh, they may say like this: I feel like I don't exist, lacking a true self. My mind seems clouded and if filled with cotton. I feel mechanical, almost like a robot. I know I have emotions, but I cannot connect with them. My thoughts seems foreign to me. It feels as if I am observing myself from a distance. I experience out of body sensations like a split of self. So these are the versions of depersonalization, and what they may expect it to express in derealization is: the world around me appears artificial and devoid of life. Now the person is talking about his surroundings. It is as if there is glass barrier separating me from everything else in the surrounding or environment. Object seems distorted, either too big or too small, but it is not Lilliputian hallucinations. And sounds are either too quiet or excessively loud. When we look upon the history of such a person, one may found that there is a history of childhood trauma, especially emotional abuse or neglect. Other contributing factors include exposure to domestic violence, being raised by a parent with severe mental illness, or the unexpected death or suicide of a family member or close friend. The average age when symptoms first appear is 16, with 95% of individuals showing signs before turning 25. Additionally, recreational drug use, particularly marijuana, ecstasy, and ketamine, is another recognized cause of this disorder. But in case of substance-induced this disorder, can be diagnosed only when the person is abstinent and devoid of substance use for a longer period of time and still experiencing these depersonalization or derealization, because this depersonalization and derealization can occur in influence of substance also. Differential diagnoses are major depressive disorder, obsessive compulsive disorder, dissociative identity disorder, dissociative amnesia, or any kind of conversion disorder, anxiety disorder and psychotic disorders, substance or medication induced disorders, mental disorder due to another medical conditions like temporal lobe epilepsy or partial and frontal lobe epilepsy. Suggested treatment for depersonalization and derealization disorder are psychotherapy such as cognitive behavior therapy, psychoanalysis, and psychiatric medications. However, these therapies is limited information on effectiveness, and recent research has not identified any clear evidence-based options of treatment, primarily due to shortage of randomized controlled trials. But in a study by Hunter and colleagues in 2005, conducted on 21 patients who underwent an average of 13 sessions of CBT, the result showed that there was decrease in dissociation, depersonalization, anxiety, and depression, with 29% no longer fitting the diagnostic criteria after treatment. Still, they had the residual symptoms. These improvements persisted over the next 6 months. So, in summary, neurasthenia refers to a syndrome characterized by chronic fatigue and distressing complaints of increased fatigue after mental effort or bodily weakness and exhaustion after minimal effort. It is commonly seen in medical settings and is often associated with symptoms of depression and anxiety. Depersonalization derealization syndrome, also known as depersonalization derealization disorder, is a mental health condition characterized by persistent or recurrent feeling of detachment from oneself, uh, oneself, known as depersonalization, and from one's surrounding is derealization. Thank you. Thank you to all.
Okay. So good afternoon, everyone. Today we are going to start with organic psychiatry or organic mental disorders. So I'm Dr. Swaleha Mujawar. I'm the assistant professor at Department of Psychiatry. And whenever we are talking about organic disorders, sit. Okay. So organic psychiatry again we'll be discussing under these subheadings और जो भी बातें करेंगे और जो अटेंशन पे नहीं करेंगे एंड में उनको एमसीक्यूज पूछे जाएंगे, ठीक है? एंड इन बिटवीन भी एमसीक्यूज पूछ सकते हैं, क्वेश्चंस पूछ सकते हैं, बट जिसको भी जोक्स बोलना है, अटेंशन पे नहीं करना है, एमसीक्यूज के लिए रेडी हो जाना, ठीक है? So let's start with the lecture. We'll be doing subheadings of introduction, case, clinical features, management, and then end में MCQs. ठीक है? So let's start. हमने क्लासिफिकेशन ऑफ साइकेट्री पे लेक्चर लिया था, अगर किसी को याद है. चलो ठीक है. क्लासिफिकेशन ऑफ साइकेट्री में हमने सीखा था कि साइकेट्रिक डिसऑर्डर्स दो में डिवाइड हो सकता है, ऑर्गेनिक एंड नॉन ऑर्गेनिक, ठीक है? नॉन ऑर्गेनिक में बाकी सारे आते हैं. ऑर्गेनिक के अंडर क्या क्या आता है? अक्यूट ऑर्गेनिक, क्रॉनिक, एमनिस्टिक एंड अदर्स. अब अक्यूट में यूजुअली डिलीरियम होता है, ठीक है? क्रॉनिक में डिमेंशिया. तो दीज आर वेरी बिग टॉपिक्स. आज हम एक्सक्यूज मी, आज हम डिलीरियम ही कर पाएंगे. नेक्स्ट क्लास पार्ट 2 जो है दैट विल बी डिमेंशिया. सो व्हाट इज डिलीरियम? जब भी हम कोई भी पेशेंट में डिलीरियम देखना चाहेंगे, उसके पहले थोड़ा सा अगर हम समझ ले कि डिलीरियम क्या है, आफ्टर दैट आई विल जस्ट टेल यू अ केस. आप एक बार वो केस समझ लेंगे तो आप सर्जरी वार्ड, आईसीयू, मेडिसिन वार्ड कहीं पे भी डिलीरियम का केस देखेंगे तो यू विल बी एबल टू आइडेंटिफाई वेरी इजीली. सो व्हाट इज डिलीरियम? इट इज अ ट्रांजिएंट ग्लोबल डिसऑर्डर ऑफ कॉग्निशन. इट इज इंपॉर्टेंट बिकॉज इट्स अ मेडिकल इमरजेंसी, ठीक है? इसीलिए ये इसके आइडेंटिफाई करना, इसके बारे में पता रखना बहुत जरूरी है. It is derived from Latin, which means off the track. Why is it important? एक तो increase mortality, ठीक है? डिलीरियम के पेशेंट्स में डेथ भी हो सकता है. ऐसा नहीं है कि साइकेट्री के पेशेंट्स में डेथ नहीं है. स्पेशली डिलीरियम में देर आर वेरी हाई चांसेस ऑफ डेथ. नर्सिंग केयर भी बढ़ जाती है, रिहैबिलिटेशन में भी बहुत डिफिकल्टीज होती है, और डिस्चार्ज भी काफी डिलेड हो जाता है, हॉस्पिटल स्टे बढ़ जाता है. तो इन सब वजहों की वजह से डिलीरियम तो बहुत जरूरी है और उसे आइडेंटिफाई करना भी बहुत जरूरी है. इट इज ऑफन अनरिकॉग्नाइज्ड. अगर देखा जाए तो 40% ऑफ एल्डरली पेशेंट्स विद डिलीरियम आर सेंट होम. तो ये ना ऑलमोस्ट आधे जो पेशेंट्स हैं वो अनडायग्नोज जाते हैं और बिकॉज ऑफ दैट अनट्रीटेड जाते हैं. अ लॉट ऑफ टाइम्स हमें लगता है कि ये डिप्रेशन है, बिकॉज डिप्रेशन इज वेरी कॉमन. तो मिसडायग्नोज होना, अनडायग्नोज होना, इसके बहुत चांसेस, ऑलमोस्ट 40% जो है वो अनडायग्नोज जाते हैं. तो दैट इज अ वेरी बिग नंबर. नंबर्स की बात करें तो एपिडेमियोलॉजी देखते हैं. 20% ऑफ पेशेंट्स इन जनरल वार्ड डिलीरियम का होता है. तो अगर आपके पास 10 पेशेंट्स हैं एक वार्ड में, तो 2 पेशेंट्स में डिलीरियम का रिस्क होता है. इतना ज्यादा कॉमन है. 30% होता है एल्डरली में. तो ऑलवेज रिमेंबर डिलीरियम के चांसेस बढ़ते हैं जैसे जैसे एज बढ़ता है. तो अगर ओल्ड एज पेशेंट है तो फिर 20 से वो 30% हो जाता है. 85 के ऊपर अगर पेशेंट का एज है तो 10% 3 ईयर इंसिडेंस है। 65 स्पेशली विद डिमेंशिया है तो भी रिस्क बहुत बढ़ जाता है। रिस्क फैक्टर्स हम बाद में फिर से देखेंगे। स्पेशल पॉपुलेशन में देखा जाए तो कैंसर पेशेंट्स में 88% कितना ज्यादा हाई है कि ऑलमोस्ट ऑल कैंसर पेशेंट्स में डिलीरियम का रिस्क होता है। आईसीयू में 70%, हिप फ्रैक्चर 50%, बाकी सब इसमें कम होता है। तो इसीलिए आप ऑर्थो वार्ड जाएंगे, आईसीयू जाएंगे, ऑन्कोलॉजी जाएंगे तो यहाँ डिलीरियम के पेशेंट्स आपको देखने मिलेंगे। DSM-5 के अकॉर्डिंग ये एक डेफिनेशन उन्होंने दी है। तो दिस इज अ वेरी सिंपल डेफिनेशन। डिलीरियम में देयर इज डिस्टर्बेंस इन कॉन्शियसनेस। ठीक है, कॉन्शियसनेस क्या होता है समझ में आ रहा है? कॉन्शियस यानी पेशेंट जागा है। ठीक है, तो अगर पेशेंट ड्राउजी हो रहा है या सो रहा है, आप उसको उठा रहे हो, पेनफुल स्टिमुलस दे रहे हो तो भी नहीं उठ रहा है, तो इम्पेयर्ड कॉन्शियसनेस या डिस्टर्ब्ड कॉन्शियसनेस है। और देयर इज चेंज इन कॉग्निशन और डेवलपमेंट ऑफ अ परसेप्चुअल डिस्टर्बेंस। तो एक उसको या तो मेमोरी में प्रॉब्लम्स आने लगेंगे, हेलुसिनेशंस आने लगेंगे। सो कॉग्निशन या परसेप्शन डिस्टर्ब्ड होता है। इट डेवलप्स ओवर अ पीरियड ऑफ टाइम विच इज वेरी शॉर्ट एंड इट फ्लक्चुएट्स। ठीक है, ये कुछ कुछ की टर्म्स हैं कि कॉन्शियसनेस डिस्टर्ब्ड है, कॉग्निशन, परसेप्शन शॉर्ट पीरियड ऑफ टाइम में हो रहा है और फ्लक्चुएट हो रहा है। फ्लक्चुएट का मतलब क्या होता है? हाँ, आता जाता रहता है। वेरी गुड। सो ऑन एंड ऑफ होता है कि फ्लक्चुएटिंग यानी कंटिन्यूस नहीं है वो, बीच में पेशेंट नॉर्मल भी होता है। तो हो सकता है कि आप राउंड्स पे पेशेंट को देखें तो वो एकदम नॉर्मल है और फिर जब कंसल्टेंट राउंड्स पे आते हैं तो पेशेंट डिलीरियम में होता है। तो दिस मीन्स दैट इट्स अ फ्लक्चुएटिंग इलनेस और शॉर्ट पीरियड ऑफ टाइम में डेवलप होता है। बिकॉज मोस्ट साइकेट्रिक इलनेसेस आप देखे जाएंगे तो मंथ्स और ईयर्स तक चलता है, पर ये काफी जल्दी होता है, फॉर अ फ्यू आवर्स या विद इन डेज भी होता है। तो ये तो DSM-5 का डेफिनेशन हो गया। बट आपके अंडरस्टैंडिंग के लिए थोड़ा सा और एक्सप्लेन करते हैं कि क्या क्या देखा जाएगा डिलीरियम में। एक तो है अक्यूट ऑनसेट, इट डेवलप्स ओवर आवर्स टू डेज। अब्रप्ट भी हो सकता है कि एकदम जल्दी वो डेवलप हो गया। समटाइम्स इवन बिफोर डेवलपिंग डिलीरियम पेशेंट को एक प्रोड्रोमल फेज आता है। प्रोड्रोम यानी डिसीज डेवलप होने से पहले। तो प्रोड्रोम में क्या क्या दिख सकता है? फटीग, डे टाइम सोमनोलेंस, डिक्रीज कंसंट्रेशन, इरिटेबिलिटी, रेस्टलेसनेस, कॉग्निटिव इम्पेयरमेंट। तो ये एज सच ये डिलीरियम के साइंस नहीं है, पर इनसे पता चलता है कि डिलीरियम हो सकता है, पेशेंट को डेवलप हो सकता है। तो दिस इज द प्रोड्रोम फेज। फ्लक्चुएशन हमने देखा है कि अनप्रिडिक्टेबल है, कभी भी आता है और कभी भी जाता है, कुछ ऐसे बता नहीं सकते। बट मोस्ट पेशेंट्स में इट इज वर्स एट नाइट, यानी रात के टाइम डिलीरियम उसको ज्यादा होगा। इसको हम सन डाउनिंग भी बोलते हैं, अगर किसी को ज्यादा इंटरेस्ट है तो। दिस फिनोमिना इज नोन एज अ सन डाउनिंग फिनोमिना, कि जैसे ही सन नीचे जाता है पेशेंट के सिम्टम्स बढ़ जाते हैं। तो दिस इज वर्स एट नाइट। पीरियड्स ऑफ ल्यूसिडिटी का मतलब होता है कि पेशेंट जब नॉर्मल है, ल्यूसिडिटी मींस नॉर्मल सी। तो जब पेशेंट नॉर्मल होता है तो उसको ल्यूसिड बोलेंगे। साइकोमोटर डिस्टरबेंस हो सकता है, तो या तो पेशेंट बहुत रेस्टलेस है, एजिटेटेड है, चीख रहा है, चिल्ला रहा है, बैठ नहीं रहा है, या फिर लेथार्जिक है, इनएक्टिव है, बेड से उठ ही नहीं पा रहा है। तो ये दो एक्सट्रीम्स पे साइकोमोटर एक्टिविटी हो सकती है। तो डिस्टरबेंस इन कॉन्शियसनेस जब हमने पढ़ा था डेफिनेशन में, उसमें क्या क्या हो सकता है? पेशेंट कैन बी हाइपर अलर्ट। हाइपर अलर्ट यानी छोटी सी भी आवाज होती है तो पेशेंट एकदम देखता है कि अरे क्या होगा, क्या चल रहा है। या थोड़ा सा हवा आके अगर कर्टन मूव होता है तो पेशेंट देखेगा अरे किसने लाया, क्या हुआ, हवा क्यों आ रही है। तो दे आर हाइपर अलर्ट। कभी कभी नॉर्मल हो सकता है, लेथार्जी हो सकता है, कोमाटोज हो सकता है। कोमाटोज यानी वही है कि आप पेनफुल स्टिमुलस दे रहे हो तो भी पेशेंट उठ नहीं पाएगा। लेथार्जिक यानी ड्राउजी है कि उसको नींद आ रही है, पर आप अगर उठा देंगे तो पेशेंट उठ के आपसे बात करेगा. इट इज इन बिटवीन कॉन्शियस एंड कोमेटोज बेसिकली. तो ड्राउजी भी मोस्ट पेशेंट्स ड्राउजी ही होते हैं. इनअटेंशन इज द रिड्यूस्ड एबिलिटी टू फोकस, सस्टेन और शिफ्ट अटेंशन. यानी पेशेंट से आप बात कर रहे हो पर पेशेंट कहीं और ही गुमसुम है या पेशेंट आप पे ध्यान नहीं दे पा रहा है. तो दिस इज इनअटेंशन, इजीली डिस्ट्रैक्टेबल. मैंने वही बताया कि छोटी सी भी आवाज होती है तो पेशेंट इधर उधर देखने लगता है. मे अकाउंट फॉर द कॉग्निटिव डेफिसिट. तो ये सब है कॉग्निटिव डेफिसिट. स्लीप भी डिस्टर्ब्ड होती है. तो स्लीप डिस्टर्ब्ड में क्या मतलब है? फ्रैगमेंटेशन और डिसरप्शन ऑफ स्लीप. यानी रात में वो बार बार उठ रहा है. फ्रैगमेंटेशन यानी नींद बार बार खुल रही है. और डिसरप्शन यानी वही है कि वो सो नहीं पा रहा है, डिस्टर्ब स्लीप है. अगर पेशेंट सो रहा है तो कभी कभी पेशेंट बोलेगा कि बहुत डरावने सपने आ रहे हैं या बहुत अजीब सपने आ रहे हैं. तो विविड ड्रीम्स, विविड नाइटमेयर्स. रात में वो सो नहीं रहा है पर दिन में ज्यादा सो रहा है, ऐसे भी हो सकता है. सो डे टाइम सोमनोलेंस. कभी कभी उसको लगता है जो दिन में दिन भर चल रहा है, जो दिन भर चीजें हो रही है वो ऐसे सपने जैसी लग रही है. तो ये सब चीजें अगर पेशेंट आपको बोल रहा है तो आपके दिमाग में आना चाहिए कि डिलीरियम हो सकता है. इमोशनल डिस्टर्बेंसेस, अगेन फियर, एंजाइटी, डिप्रेशन, ये सब भी पार्ट एंड पार्सल है डिलीरियम का ही. डिस्टर्बेंसेस ऑफ थॉट भी कभी कभी हो सकता है. बिजार इलॉजिकल थिंकिंग. पेशेंट कुछ भी बात कर रहा है, यानी रिलेटिव्स आपको बोलेंगे कि ये कुछ भी बड़बड़ कर रहा है, कुछ भी बात कर रहा है. तो दैट इज ऑल्सो डिलीरियम बट नॉट वेरी पैथोग्नोमिक ऑफ डिलीरियम. डिसऑर्डर्स ऑफ लैंग्वेज में स्लो स्पीड स्पीच, स्लर्ड स्पीच, वर्ड फाइंडिंग डिफिकल्टी. पेशेंट बात नहीं कर पा रहा है, आप बोलोगे कि ठीक है मुझे लिख के बता दो, तो कभी कभी डिफिकल्टी इन राइटिंग भी हो जाती है. डिसऑर्डर्स ऑफ मेमोरी एंड ओरिएंटेशन. तो पुअर रजिस्ट्रेशन, रीसेंट रिमोट मेमोरी कभी कभी खराब होती है. डिसओरिएंटेशन टू टाइम, प्लेस एंड पर्सन. तो डिसओरिएंटेशन का मतलब क्या होता है या आप कैसे चेक करोगे डिसओरिएंटेशन पेशेंट में? बहुत सिंपल है, कॉमन सेंस. डिसओरिएंटेशन टू टाइम यानी क्या होता है? आप पेशेंट को पूछ, नहीं नहीं सिर्फ टाइम टाइम नहीं. आप पेशेंट से बस पूछो, बेड साइड पेशेंट से पूछना है कि अभी क्या टाइम हो रहा होगा. ठीक है, तो वो घड़ी में भी देख सकता है या फिर अंदाजा आप बोलो कि अभी दिन है या रात है. बहुत ग्रॉस भी चेक करना है. तो ऐसे बाहर से लाइट आ रही होगी, दिन हो रहा होगा, फिर भी पेशेंट बोलेगा कि रात हो रही है. ठीक है. या उतना भी नहीं समझता है तो आप पूछ सकते हैं कौन सा मौसम चल रहा है, कौन सा महीना चल रहा है, कौन सा साल चल रहा है. कभी कभी पेशेंट ये भी नहीं बता पाएगा, वो बोलेगा 2019 है या बहुत ही पीछे चले जाएगा. तो दिस इज डिसोरिएंटेशन टू टाइम. इसी तरह से डिसोरिएंटेशन टू प्लेस क्या होगा फिर? हाँ, तो आप पेशेंट से पूछोगे कि आप अभी किस जगह हो. ठीक है, तो पेशेंट बोलेगा कि मैं मंदिर में हूँ, मैं घर पे हूँ, या मैं कोई दुकान में हूँ. है ना. आप ओरिएंट करने की भी कोशिश करेंगे कि आसपास देखिए आपको क्या क्या दिख रहा है, क्या लग रहा है कि आप कहाँ हो सकते हैं. तो दिस इज डिसओरिएंटेशन टू प्लेस. पर्सन, हाँ, तो रिलेटिव्स जो होते हैं, रिलेटिव्स को देख के बता सकते हैं कि आपके क्या है. आप ये भी पूछ सकते हैं कि मैं कौन हूँ. स्पेशली आप अगर रेगुलर डॉक्टर्स हैं उनके, तो वो इतना तो बता सकते हैं कि आप डॉक्टर है, ये नर्स है. तो दिस इज डिसओरिएंटेशन टू पर्सन. तो डिसओरिएंटेशन इज अ वेरी वेरी इंपॉर्टेंट थिंग. ये हमेशा याद रखना है. ओरिएंटेशन पेशेंट का पूछना ही पूछना है. ठीक है. परसेप्चुअल डिस्टर्बेंसेस हो सकते हैं, हैलुसिनेशंस. उसको कुछ दिखाई दे रहा है, सुनाई दे रहा है जो यहाँ पे है नहीं. तो पेशेंट बोलेगा कि वहां पे सांप है या वहां पे कोई खड़ा है और वहां पे कोई भी नहीं रहेगा बेसिकली. तो दिस इज हैलुसिनेशंस. ठीक है. तो नाउ हमने डिलीरियम के क्लिनिकल साइंस एंड सिम्टम्स देखे, तो सारे पेशेंट्स में सारे साइंस एंड सिम्टम्स होंगे क्या? नहीं ना, हर पेशेंट सेम टेक्स्ट बुक जैसा आपको दिखेगा नहीं, ठीक है? हर पेशेंट में परम्यूटेशंस और कॉम्बिनेशंस होंगे ये साइंस एंड सिम्टम्स के। तो इसीलिए जस्ट ऑर्गेनाइज करने के लिए हमने उसको 3 क्लिनिकल वेरिएंट्स में एक क्वांटिफाई किया है या डिस्ट्रीब्यूट किया है। तो वो क्या क्या वेरिएंट्स है? हाइपर एक्टिव डिलीरियम, हाइपो एक्टिव डिलीरियम एंड मिक्स्ड, ठीक है? हाइपर एक्टिव में क्या होगा, नाम से ही पता चल रहा है, ठीक है? तो रेस्टलेस, एजिटेटेड है, एग्रेसिव है, ठीक है? दिस इज 15 to 47%। हाइपो एक्टिव में वही पेशेंट लेथार्जिक रहेगा, क्वाइट, कंफ्यूज्ड रहेगा। तो इनमें डिप्रेशन मानने का बहुत हाई चांस है कि पेशेंट बेड पे ही है, कुछ बात नहीं कर रहा है, तो हमको लगेगा कि ये डिप्रेशन है। तो इट इज वेरी इंपॉर्टेंट कि आप डिलीरियम का भी ध्यान में रखिए और रूल आउट कीजिए। मिक्स्ड यानी हाइपर और हाइपो एक्टिव बोथ है, तो पेशेंट में दोनों अगर दिख रहा है तो मिक्स्ड है, ठीक है? तो दीज आर द क्लिनिकल टाइप्स या वेरिएंट्स। तो अब क्लिनिकल मिक्स्ड में दोनों रहेंगे, हाइपर एक्टिव एंड हाइपो एक्टिव, ठीक है? क्लिनिकल प्रेजेंटेशन थोड़ा बहुत समझ में आ गया कि पेशेंट कैसा रहेगा, ठीक है? तो whenever you are talking to a patient, आप जब भी पेशेंट से बात करते हैं तो आप क्या क्या पूछते हैं? हिस्ट्री जब लेते हैं, हाँ, नेम एज वगैरह हो गया, और हाँ, पहले के तो पास्ट हिस्ट्री, हाँ, वेरी गुड, फैमिली हिस्ट्री, वेरी गुड, और वेरी गुड, मेडिकेशंस, डिसीजेस। तो पास्ट हिस्ट्री पूछते हैं, पास्ट मेडिकल हिस्ट्री पूछते हैं, मेडिकेशंस क्या क्या है, फैमिली हिस्ट्री, पर्सनल हिस्ट्री। तो पर्सनल हिस्ट्री में आपका डे टू डे लाइफ आ जाएगी एंड बाकी सारी चीजें। तो ये तो जनरल है, नॉट जस्ट डिलीरियम, आप हर पेशेंट में ये चीजें तो पूछेंगे, ठीक है? तो ये सब अभी ध्यान में रख के हम एक केस देखते हैं, ठीक है? तो एक केस है मिसेस ए, ठीक है? आपको बोला गया है कि जाके ये मिसेस ए का हिस्ट्री लो। तो आपने देखा कि शी इज ड्रेस्ड इन अ हॉस्पिटल गाउन, लाइंग इन बेड, लुकिंग ओल्डर देन हर स्टेटेड एज। तो देख के लग रहा है कि बहुत ओल्ड है, बेड पे लेटी हुई है, आईज क्लोज्ड है। आप उसको उठाने की कोशिश कर रहे हैं, फिर भी उठ नहीं पा रही। फिर भी आप थोड़ा सा उठाते हैं उनको रिगरसली, तो उठ के वो जब बात करती है तो हर वर्ड्स आर स्लर्ड एंड डिफिकल्ट टू अंडरस्टैंड। तो पेशेंट क्या बोल रही है आपको समझ में भी नहीं आ रहा है। शी इज अनेबल टू रिस्पॉन्ड अप्रोप्रिएटली टू योर क्वेश्चन। शी अपियर्स टू बी पिकिंग एट थिंग्स इन द एयर। इसका मतलब है कि वो पेशेंट ऐसे ऐसे कर रही है, ऐसा लग रहा है कि वो हाथ से कुछ तो पिक कर रही है, यानी हवा में हाथ लेके कुछ कुछ पिक कर रही है। यू आर अनेबल टू असेस हर मूड, क्योंकि वो कोऑपरेट ही नहीं कर रही है, वो अपना ही कुछ कर रही है। हर अफेक्ट इज रिस्ट्रिक्टेड, शी इज कंफ्यूज्ड। जब आप उसको पूछते हैं कि वेयर इज शी, तो शी सेज कि वो किचन में है, ठीक है? वो भी क्लियरली तो नहीं बताती है, पर इतना आप समझ लो कि वो बोल रही है कि मैं अपने किचन में हूँ, ठीक है? तो ऐसा रहेगा आपका केस डिलीरियम का। जब भी कोई पेशेंट देखोगे तो ऐसे पेशेंट दिखेंगे, ठीक है? तो जब भी ऐसा कोई पेशेंट दिखता है हम कुछ स्क्रीनिंग टूल्स लगा सकते हैं। स्क्रीनिंग टूल्स है एमएमएसी, कंफ्यूजन असेसमेंट मेथड कैम, एंड एक मोका करके आता है, मॉन्ट्रियल कॉग्निटिव असेसमेंट। एमएमएसी जो है दैट इज मिनीसोटा मेंटल स्टेट एग्जामिनेशन। तो इसमें 30 क्वेश्चंस होते हैं, आपको बस क्वेश्चन आंसर करना होता है, उससे आप स्क्रीन कर सकते हैं। लेकिन फिर भी पेशेंट कुछ बोल नहीं रहा है, कुछ बात नहीं कर रहा है, समझ में नहीं आ रहा है कि पेशेंट बोल क्या रहा है, तो ऑलवेज हम कोलैटरल इंफॉर्मेशन का मतलब है किससे लेंगे हम? वेरी गुड, फैमिली मेंबर से, स्टाफ से। तो डायरेक्ट पेशेंट नहीं बता रहा है, हम कोलैटरल इंफॉर्मेशन लेंगे। ठीक है, तो हम कोलैटरल इंफॉर्मेशन लेते हैं डॉटर से। डॉटर बोल रही है कि पेशेंट को पहले कोई साइकेट्रिक हिस्ट्री तो नहीं थी, कोई डिप्रेशन या कुछ नहीं था, लेकिन मेडिकल हिस्ट्री बहुत सारी थी। तो पेशेंट को एंजाइना हुआ है, यानी हार्ट अटैक हो चुका है पहले, पेशेंट को हाइपरटेंशन भी है, और डिसलिपिडेमिया यानी चर्बी बढ़ी है, लिपिड्स बढ़े हुए हैं, और पेशेंट को सुनाई भी नहीं देता है, तो हियरिंग इम्पेयर्ड है। ठीक है, तो आपको ये सब चीजें पता चल रही है। पेशेंट बहुत लॉन्ग लिस्ट ऑफ मेडिकेशंस पे है। ठीक है, मेटोप्रोरोल, एटोर्वास्टैटिन, मल्टीविटामिन, एमिट्रिप्टालिन, उसमें से 2 मेडिकेशंस है जो अभी भी ऐड किए, तो न्यू मेडिकेशंस भी ऐड किए, तो दिस इज अ लॉन्ग लिस्ट ऑफ मेडिकेशन। तो अब हम समराइज करते हैं। तो 76 ईयर ओल्ड फीमेल है जो पोस्ट एंजाइना या पोस्ट सीएपीजी है, हार्ट अटैक हो चुका है। शी हैज डिक्रीज लेवल ऑफ कॉन्शियसनेस, शी इज कंफ्यूज्ड, डिसोरिएंटेड, एमोटिवेटेड, फ्लक्चुएशंस ऑफ सिम्टम्स है, पास्ट कोई हिस्ट्री है नहीं साइकेट्रिक इलनेसेस की। ठीक है, तो दिस इज व्हाट द होल केस इज। अब इस पे से मोस्ट लाइकली तो डिलीरियम है। ठीक है, इसमें कोई डाउट नहीं है। आगे हम डिमेंशिया तो पढ़ेंगे, बट डिलीरियम डेफिनेटली है। डिलीरियम में भी आपको क्या लगता है, हाइपो एक्टिव वाला है या हाइपर एक्टिव है? अच्छा, मुझे दोनों सुनाई दे रहा है, हाइपो। ठीक है, क्योंकि वो क्वाइट है, कंफ्यूज्ड है, तो शी हैज हाइपो एक्टिव टाइप ऑफ डिलीरियम। ठीक है, इतना क्लियर है? तो अब आप अगर कोई पेशेंट देखेंगे या क्लिनिकल फीचर्स आपको कोई बताएगा तो समझ में आ जाएगा। ठीक है, अब हमने डायग्नोसिस तो बना दिया। नाउ दैट यू हैव मेड अ डायग्नोसिस ऑफ हाइपोएक्टिव डिलीरियम, नेक्स्ट स्टेप क्या होगा हमारा? कोई मेडिकल कॉज, क्योंकि साइकेट्रिक कॉज तो है ही नहीं, तो मेडिकल कॉज हम ढूंढेंगे। ठीक है, मेडिकल कॉज ढूंढने के लिए हम इन्वेस्टिगेशंस ऑर्डर करेंगे। तो इन्वेस्टिगेशंस अकॉर्डिंग टू पेशेंट होता है, बट जो कॉमन इन्वेस्टिगेशंस है, सीबीसी, इलेक्ट्रोलाइट, लिवर फंक्शन, थायराइड फंक्शन, चेस्ट एक्सरे, ईसीजी, जो हम नॉर्मली पेशेंट्स का रूटीन कराते हैं, यूजुअली वो इन्वेस्टिगेशंस भेजनी है। इन्वेस्टिगेशंस के साथ साथ वेरी इंपॉर्टेंट फिजिकल एग्जामिनेशन, स्पेशली न्यूरोलॉजिकल एग्जामिनेशन। हाइड्रेशन और न्यूट्रिशन चेक करो, कभी कभी उसकी वजह से डिलीरियम हो सकता है। सेप्सिस तो नहीं है, और पेशेंट कोई अल्कोहल या कोई ड्रग्स तो नहीं ले रहे। ठीक है, ये सब चीजें भी पता करना जरूरी है। अब आते हैं रिस्क फैक्टर्स पे। तो मोस्ट इंपॉर्टेंट रिस्क फैक्टर इज डिमेंशिया। ठीक है, 2 to 3 टाइम्स वो रिस्क बढ़ाता है। तो एक तो रिस्क फैक्टर हो गया डिमेंशिया। बाकी रिस्क फैक्टर्स स्पेशली एल्डरली में है कि वो फिजिकली बहुत वीक हो जाते हैं, फ्रेजाइल हो जाते हैं। एल्डरली में मल्टीपल मेडिकल प्रॉब्लम्स होते ही हैं, डायबिटीज, हाइपरटेंशन, इन्फेक्शंस भी एल्डरली में बहुत कॉमन है, क्योंकि वो वीक होते हैं, उनका इम्यून सिस्टम ठीक नहीं होता है। पॉलीफार्मेसी, जैसे हमने वो पेशेंट में देखा था, लॉन्ग लिस्ट ऑफ मेडिकेशंस होती है उनकी। सेंसरी इंपेयरमेंट, कभी कभी फ्रैक्चर्स होते हैं, तो दीज आर द रिस्क फैक्टर्स। अब आते हैं कॉजेज पे। ठीक है, तो हमने क्लिनिकल फीचर्स कर लिया, फिर हम कॉजेज पढ़ेंगे और फिर ट्रीटमेंट। ठीक है, क्लिनिकल फीचर्स ही मेन है, कॉजेज और ट्रीटमेंट जस्ट एक शॉर्ट में हम करेंगे। ठीक है, तो एनी फिजिकल और मेंटल इलनेस which interferes with the normal metabolism and function of brain. बेसिकली ब्रेन को अगर ब्लड सप्लाई ठीक से नहीं जा रहा है तो पेशेंट को डिलीरियम का रिस्क हो सकता है। तो एनीथिंग अंडर द सन कैन कॉज डिलीरियम। एक निमोनिक हमने बनाया है, दैट इज इन्फेक्शन, विड्रॉल, ट्रॉमा, सीएनएस पैथोलॉजी, कोई भी सीएनएस पैथोलॉजी, हाइपोक्सिया, deficiencies, endocrine, acute vascular, toxins, heavy metals. So I watch death. This is the mnemonic. आप अपना भी mnemonic बना सकते हैं, पर this is the list of causes. ठीक है, पैथोफिजियोलॉजी अभी तक समझा नहीं है, बट जस्ट लाइक आई टोल्ड यू, ब्लड जा नहीं रहा है ब्रेन को, ब्लड नहीं जा रहा है तो मेटाबॉलिज्म नहीं हो पा रहा है, न्यूरोट्रांसमीटर्स एबनॉर्मल होते हैं। हमारे पास बहुत कम न्यूरोट्रांसमीटर्स है स्पेशली साइकेट्री में जो गड़बड़ होते हैं। तो एसिटिल कोलिन इज द मोस्ट कॉमन न्यूरोट्रांसमीटर जो गड़बड़ हो रहा है। डोपामिन एंड सेरोटोनिन भी है, ठीक है। तो दीज आर द न्यूरोट्रांसमीटर्स। इन्फ्लेमेटरी मैकेनिज्म्स हो रहे हैं, स्ट्रेस रिएक्शंस हो रहे हैं, ठीक है। तो रिस्क फैक्टर्स इस केस में आपको क्या क्या लग रहे हैं? जो हमने पढ़ा था, मैंने जो आपको केस बताया उसमें बहुत सारे रिस्क फैक्टर्स हैं। तो क्या क्या है जो आपको याद आ रहा है? आपकी मेमोरी भी टेस्ट हो जाएगी। एज उसकी ज्यादा थी, पॉलीफार्मेसी, वेरी गुड। इन्फेक्शन नहीं था, पेशेंट को कहा था? आई मीन वो कॉज है, मैं पेशेंट का पूछ रही हूँ। पेशेंट को हार्ट अटैक आया था तो एंजाइना, मेडिकल कंडीशन, हाइपरटेंशन भी था, है ना। तो हमेशा कॉजेज सिर्फ डिलीरियम को डायग्नोस करना जरूरी नहीं है, उसका कॉज भी आइडेंटिफाई करना जरूरी है, ठीक है। तो अब आप कॉज भी आइडेंटिफाई कर पाओगे, ठीक है। तो अब लास्ट पार्ट ऑफ लेक्चर पे जाते हैं, मैनेजमेंट, ठीक है। तो आप हमारे केस में हाइपो एक्टिव डिलीरियम है, हमने कॉजेज भी आइडेंटिफाई कर दिए। तो व्हाट इज द फर्स्ट स्टेप इन मैनेजमेंट? ट्रीट द कॉज, ठीक है। इसीलिए कॉज पे मैंने थोड़ा बहुत फोकस दिया था, क्योंकि मैनेजमेंट और ट्रीटमेंट जो है वो भी कॉज पे ही डिपेंड करता है। तो पेशेंट को अगर पॉलीफार्मेसी हो रही है तो देखिए कि अननेसेसरी मेडिकेशन जो है वो कम करें। जैसे हमारा जो पेशेंट था उसमें मल्टीविटामिन थी, दो दो एंटासिड्स थी। तो ऐसे अननेसेसरी जो मेडिसिन है वो सबसे पहले बंद करनी है। और कोई अगर कॉज है जैसे इन्फेक्शंस हो गए या हाइपरटेंशन हो गया तो बीपी कंट्रोल करो, इन्फेक्शन कंट्रोल करो। तो ट्रीटिंग द कॉज ऑफ डिलीरियम इज द फर्स्ट स्टेप इन मैनेजमेंट। अब बाकी मैनेजमेंट टेक्निक्स अगर देखे जाए तो दो है, नॉन फार्माकोलॉजिकल एंड फार्माकोलॉजिकल। फार्माकोलॉजिकल मींस हम कुछ मेडिसिन दे रहे हैं, कुछ ड्रग्स दे रहे हैं। नॉन फार्माकोलॉजिकल आर अदर्स, ठीक है। तो नॉन फार्माकोलॉजिकल में सबसे इंपॉर्टेंट है सेफ्टी, ठीक है। ये पेशेंट्स का खुद का सेफ्टी और दूसरों का भी सेफ्टी, क्योंकि पेशेंट्स एग्रेसिव हो सकते हैं तो दूसरे पेशेंट्स को भी वो हार्म पहुंचा सकते हैं। तो प्रिवेंट हार्म टू सेल्फ और अदर्स। अगर जरूरी लगे तो फिजिकल रिस्ट्रेन करना है। आप जाओगे आईसीयू में, देखोगे कभी कभी पेशेंट्स के हाथ बांधे होते हैं, तो दैट इज अ फिजिकल रिस्ट्रेन। कभी कभार, बहुत रेयरली हमें करना पड़ता है। ऑक्सीजन, इलेक्ट्रोलाइट, हाइड्रेशन, ये सब देखो, पेन मैनेजमेंट करो, दीज आर सिम्टोमेटिक मैनेजमेंट। कम्युनिकेशन करो, तो पेशेंट को एकदम काम और सपोर्टिव अप्रोच करना है। पेशेंट चिल्ला रहा है, पेशेंट एग्रेसिव हो रहा है, तो आप जाके पेशेंट को डांटना नहीं है, ठीक है। पेशेंट, आपका जो अप्रोच है दैट शुड बी वेरी काम। फ्रेंड्स और फैमिली को भी अगर इन्वॉल्व करो तो बेटर है, उसके लिए लेस थ्रेटनिंग होता है। कुछ एक्टिविटीज करा सकते हैं पेशेंट को, स्पेशली हॉस्पिटल में रह रहे के पेशेंट काफी डिसोरिएंटेड होता है, तो अगर कुछ एक्टिविटीज हो तो दैट इज ऑल्सो वेरी हेल्पफुल। ओल्ड पेशेंट है, बेड पे ही पड़े हैं पूरा दिन, तो उनको मोबिलाइज करो, थोड़ा वार्ड के अंदर ही वॉक कराओ, नर्सिंग स्टाफ से, बाकी लोगों से हेल्प लेके। सेल्फ केयर, पेशेंट का नहाना धोना, बाल बनाना, ये सब भी करना है। अवॉइड सेंसरी डेप्रिवेशन, लाइटिंग वगैरह अच्छी होनी चाहिए। फेमिलियर ऑब्जेक्ट्स भी रख सकते हैं, ठीक है। तो ये तो हो गया नॉन फार्माकोलॉजिकल। फार्माकोलॉजिकल में ऐसा है कि हर डिलीरियम के पेशेंट को मेडिसिन देना जरूरी नहीं है। इफ यू ट्रीट द कॉज, द डिलीरियम विल गेट ट्रीटेड, तो वो ही ट्रीटमेंट आपका हो जाएगा। तो इट शुड बी रिजर्व्ड ओनली फॉर पेशेंट्स जिनमें एजिटेशन है या साइकोटिक सिम्टम्स है। तो आज जो हमने केस पढ़ा, आप उसमें दोगे साइकोटिक मेडिकेशन? नहीं ना, क्योंकि वो हाइपो एक्टिव डिलीरियम है, वो वैसे ही बेड पे लेटी हुई है, तो उसमें अननेसेसरी मेडिकेशंस बिल्कुल नहीं देनी। इन द एब्सेंस ऑफ साइकोटिक सिम्टम्स, हाइपो एक्टिव डिलीरियम अगर है तो मेडिकेशंस आर नॉट रेकमेंडेड। साइकोट्रोपिक मेडिकेशंस आर नॉट इंडिकेटेड फॉर वॉन्डरिंग, तो पेशेंट बस घूम रहा है वार्ड में, उसके लिए सुलाने के लिए नहीं देना, ठीक है। एंड जितने जल्दी हो सकता है मेडिसिन बंद भी करनी है। टेपर मींस डिक्रीजिंग इट स्लोली एंड स्टॉपिंग इट, ठीक है। तो क्या क्या मेडिकेशंस है हमारे पास? एंटीसाइकोटिक्स है, बेंजोडाइजेपिन्स है, कोलिस्टेरेज इनहिबिटर्स है। अंडर ग्रेजुएट लेवल पे, आपके लेवल पे आपको अगर इतना भी पता है तो दिस इज फाइन। नॉन फार्माकोलॉजिकल मैनेजमेंट ज्यादा इंपॉर्टेंट है, लेकिन अगर किसी को इंटरेस्ट है तो एंटीसाइकोटिक्स में हम हैलोपेरिडोल दे सकते हैं। हैलोपेरिडोल के कुछ कुछ साइड इफेक्ट्स होते हैं, लाइक क्यूटी प्रोलॉन्गेशन, एक्स्ट्रा पिरामिडल, इसलिए आजकल हैलोपेरिडोल हम थोड़ा कम देते हैं। एटिपिकल भी दे सकते हैं, लाइक रिस्पेरिडोन, ओलांजापिन, क्विटियापिन, ठीक है। ये आपको नाम भी अगर पता रहे या इतना भी पता रहे कि एटिपिकल एंटीसाइकोटिक्स देते हैं, दैट इज इनफ एट योर लेवल, ठीक है। डोजिंग अगेन नॉट रिक्वायर्ड, डोज लर्न करने की जरूरत नहीं है। कब कब देते हैं एटिपिकल? पार्किंसंस एंड लिवी बॉडी डिमेंशिया में, ठीक है। अदर ट्रीटमेंट्स में वही बेंजोडाइजेपिन्स देते हैं, लेकिन बेंजोडाइजेपिन्स कभी कभी खुद डिलीरियम बढ़ाते हैं, तो अवॉइड करो तो बेटर है, ठीक है। तो वुड यू ट्रीट दिस पेशेंट विथ एंटीसाइकोटिक? नहीं, बिकॉज शी इज नॉट एजिटेटेड, शी इज नॉट डिस्ट्रेस्ड बाय द सिम्टम्स ऑफ साइकोसिस। आप तभी दोगे एंटीसाइकोटिक पेशेंट एजिटेटेड है। अगर रिस्क है कि वो बाकियों को मारेगा या खुद को मारेगा, तो उसको काम डाउन करने के लिए देना है, ठीक है। लास्ट है कि रिलेटिव्स पूछेंगे कि पेशेंट को डिलीरियम है तो उसके आगे की लाइफ का क्या या फ्यूचर का क्या। तो पुअर प्रोग्नोसिस होता है एल्डरली में अगर डिलीरियम डेवलप हो रहा है, यानी वही है कि ब्रेन को ब्लड सप्लाई नहीं जा रहा है, तो आगे भी थोड़ा मुश्किल है, आगे डिलीरियम होने का भी रिस्क है। तो ये थोड़ा सा पेशेंट्स के रिलेटिव्स को समझाना है। कभी कभी सिम्टम 6 मंथ्स तक के भी चलते हैं, तो ये भी उनको समझाना है कि कभी कभार सिम्टम्स अगर चल भी रहे हैं तो इट्स ओके, थोड़ा बहुत मेडिकेशंस देके हम कर सकते हैं। ओपीडी में आप बुलाओ, ओपीडी में देखते रहो, अगर आपको लग रहा है कि डिलीरियम वर्सन हो रहा है तो फिर उसका हम कर सकते हैं। पर मेनली तो हमको एजुकेट करना है फैमिली मेंबर्स को। 6 to 8 वीक्स कभी कभी लग जाते हैं ठीक होने में, ठीक है। तो अब आते हैं एमसीक्यूज पे। लेक्चर खत्म हो गया है, एवरीबडी कैन जस्ट एब्जॉर्ब कि क्या क्या नॉलेज मिला है, और उस नॉलेज को थोड़ा सा लगा के what are the indicators of an organic illness except? एक्सेप्ट हमेशा याद रखो, अगर आपको एग्जाम में भी कोई एमसीक्यू पूछ रहे हैं तो लास्ट वर्ड हमेशा देखो एक्सेप्ट है या नहीं है। एक्सेप्ट थोड़ा गूगली क्वेश्चन होता है, घुमाने वाला क्वेश्चन होता है, तो ध्यान रखिए, ठीक है। तो ऑल आर इंडिकेशंस ऑफ ऑर्गेनिक इलनेस एक्सेप्ट, नहीं, रैपिड ऑनसेट तो होता है उसका, एक्सेप्ट यानी क्या नहीं होगा। प्री मॉर्बिड डिक्लाइन यानी कि पहले से कुछ इलनेस उसको ना हो। एक्सेप्ट, हाँ, तो डी है, वेरी गुड, कि 23 एंड अबव अगर एमएमएससी पे आ रहा है तो दैट इज नॉर्मल, 21 से नीचे है तो एबनॉर्मल है, ठीक है। तो ये थोड़ा डिफिकल्ट वाला है, बट आई नो तुम लोग ध्यान दे रहे थे इसलिए डिफिकल्ट पूछा था। चलो ठीक है। डिलीरियम इज कैरेक्टराइज्ड बाय ऑल एक्सेप्ट, एक्सेप्ट हमेशा देखना है। नहीं नहीं, फ्लक्चुएशन तो होता है, एक्सेप्ट एक्सेप्ट, तो सी है, ठीक है। तो गुड, वेरी गुड। तो जस्ट 5 मिनट थोड़ा सा ध्यान देके, एमसीक्यूज ना बहुत अच्छा वे होता है एग्जाम में स्कोर करने का, तो जस्ट 2 या 3 मिनट या 5 मिनट थोड़ा ध्यान दो, अगर एक्सेप्ट वर्ड है नहीं है तो वो थोड़ा देखना है, ठीक है। बाकी तो जितना हम यहाँ पढ़ा रहे हैं वही एग्जाम में पूछेंगे, ठीक है। And this is something which we have covered in last class. So there is an acute organic disorder which is called as delirium. Chronic is called as dementia. Then we have other amnestic and other organic. So coming to dementia. So yes, delirium हमने last time देखा था old age में होता है, but dementia तो और भी ज़्यादा old age में होता है. तो again, whenever we are looking for cases of dementia, usually 60 plus होते हैं, ठीक है? So we'll be learning about the diagnosis, risk factors, types, and management. Okay. So let's move on, and obviously end में questions भी होंगे, तो जिसे भी मस्ती करना है, jokes मारना है, questions के लिए ready रहना last में. So what is dementia? Dementia is a clinical syndrome that encompasses difficulties in memory, language, cognitive processing, behavior. Leads to impairment in activities of daily living. I know बहुत बड़ा definition है, बहुत बड़े बड़े words है इसमें, but जैसे जैसे हम clinical features इसका सीखेंगे तो आपको समझ में आएगा कि ये है क्या. So again, diagnostic criteria में it is chronic and progressive, ठीक है. जो delirium था वो acute था और fluctuating था. So comparing it to delirium, it is chronic and progressive. Chronic का क्या मतलब होता है? Very good. तो it starts very slowly और बहुत time तक रहता है. Progressive means बढ़ रहा है, धीरे धीरे बढ़ रहा है. तो symptoms जो है उसके धीरे धीरे बढ़ेंगे. Usually it is characterized by decline of memory and intellect. तो आई एम श्योर नॉट इवन इन द हॉस्पिटल आप लोगों ने देखा ही होगा, ओल्ड एज वाले होते हैं जिनको याद नहीं रहता है या वो बार बार चीजें भूल जाते हैं, तो दैट माइट बी एक्चुअली ड्यू टू डिमेंशिया. सो डायग्नोस्टिक क्राइटेरिया अगर देखा जाए तो डिक्लाइन इन लर्निंग न्यू इंफॉर्मेशन, नई चीजें नहीं सीख पाता है. डिक्लाइन इन अदर कॉग्निटिव फंक्शनिंग लाइक थिंकिंग, जजमेंट, प्लानिंग. Then no disorder of consciousness. Delirium में क्या हो रहा था? Consciousness कम हो रहा था. तो या तो पेशेंट ड्राउजी था या कोमा था या हम पेनफुल स्टिमुलस दे रहे थे तो अराउज भी नहीं हो पा रहा था. तो कॉन्शियसनेस इज अनदर पॉइंट जो डिलीरियम और डिमेंशिया को डिफरेंशिएट करता है. अफेक्टिव डिसऑर्डर्स हो सकते हैं, दैट इज इमोशनल हो जाएगा बहुत ज्यादा पेशेंट, तो पेशेंट हंसने लगेगा, रोने लगेगा या कभी कभी चिल्लाने लगेगा, चिड़चिड़ करने लगेगा. एंड सिम्टम्स हमें चाहिए एटलीस्ट 6 मंथ्स के लिए, क्योंकि अगर हम क्रॉनिक बोल रहे हैं तो हमें चाहिए कि एक लंबे समय के लिए रहना जरूरी है, एंड दैट लंबा समय इज 6 मंथ्स. इतना लंबा तो हमें चाहिए ही चाहिए. तो अगेन मेन जो सिम्टम्स है, आइडेंटिफाइंग सिम्टम्स है डिक्लाइन इन मेमोरी, ठीक है. तो चीजें भूल जाते हैं. अब चीजें भूल तो आई एम श्योर आप भी जाते होंगे, मोबाइल कहाँ रख दिया या चाबी कहाँ रख दी, तो आप सबको डिमेंशिया है? नहीं नहीं. तो डिक्लाइन इन मेमोरी जो हो रहा है, यूजुअली हम पेशेंट से पूछते हैं कि बहुत बड़ी बड़ी चीजें भूल जाते हैं क्या, रिलेटिव्स के नाम. जैसे घर पे अगर कोई रिलेटिव आके गया तो पेशेंट को याद नहीं रहेगा कि वो आके गया था, या अगर वो आता है तो उसका नाम याद नहीं, भले ही वो रिलेटिव को पिछले 30 साल से देख रहा हो, फिर भी वो भूल जाएगा कि ये कौन है, ये तो मुझे पता ही नहीं है. कभी कभी वो अगर बाजार में जाते हैं कुछ लेने अकेले So, good afternoon, everyone. Today's topic for discussion is personality disorders. So, personality disorders, they are one of the most common conditions that we as psychiatrists we handle. Uh, by common, I would say 20 to 30 patients in the OPD and 30 to 50% patients in the IPD. So, this is something which is seen very, very commonly. And even though you must have not heard about it, आपने इतना सुना नहीं होगा कि ये exactly डिप्रेशन या एंजाइटी ये सब तो फिर भी आपके सुनने में आता है. इतने कॉमन होने के बाद भी पर्सनालिटी डिसऑर्डर्स क्यों नहीं आपने सुना है या क्यों व्हाई even after being so common they are not understood. Okay, so they are neglected, they are untreated for a variety of reasons. Let's look at the reasons कि वो क्या क्या है. ठीक है, तो सबसे पहले तो why are they untreated या हम क्यों समझ नहीं पाते हैं इनको. सबसे पहले तो diagnostic criteria. So if you look at ICD or DSM, the diagnostic criteria is very confusing. You are not able to use the diagnostic criteria because वो बहुत confusing है. ICD में अलग है, DSM में अलग है और बहुत सारे points है. And ऐसा कुछ clear cut differentiation नहीं लिखा है between normal and abnormal. Then classification systems हमने वही देखा कि थोड़ा मुश्किल है. Patients जो होते हैं वो भी काफी difficult होते हैं. So whenever these patients come to the OPD or IPD, these patients are difficult in the sense कि वो आपके साथ argue करेंगे, आपके साथ झगड़ा करेंगे, थोड़ा सा गुस्सा भी आपको दिलाएंगे. आपको लगता है कि अरे जाने दो ये तो पेशेंट है इनको कुछ बोलना नहीं है. बट अगर सामने से आपको गुस्सा आ रहा है, आपको लग रहा है कि पेशेंट डिफिकल्ट है, तो डेफिनेटली थिंक अबाउट अ पर्सनालिटी डिसऑर्डर. ठीक है, और फिर थेरेपेटिक निहिलिज्म का मतलब है कि ये पर्सनालिटी डिसऑर्डर्स का ऐसा कोई ट्रीटमेंट नहीं है. समझो आपने डायग्नोज कर भी दिया तो आगे का स्टेप क्या है कि लाइफ लॉन्ग वो थेरेपीज ले या लाइफ लॉन्ग कुछ मेडिसिन ले. ऐसा कोई क्योर नहीं है या देयर इज नो शॉर्टकट टू गेट रिड ऑफ द पर्सनालिटी डिसऑर्डर. लेकिन फिर भी why are they important, why are we having this lecture? क्योंकि they cause significant distress and impairment to patients and others. तो वो खुद तो बहुत परेशान होते हैं, बाकियों को भी परेशान करते हैं. They affect the prognosis of other conditions. तो अगर डिप्रेशन का पेशेंट आपके पास आता भी है, तो अगर उसमें ऑलरेडी कोई पर्सनालिटी डिसऑर्डर है, तो वो डिप्रेशन का भी प्रोग्नोसिस काफी खराब हो जाता है. कि वो डिप्रेशन भी कितना अच्छे से ठीक हो पाएगा उसका कोई गारंटी नहीं होता है. दूसरा है इट कैन इंटरफियर विद द ट्रीटमेंट ऑफ अदर कंडीशंस. जैसे अगर अल्कोहल डिपेंडेंस का पेशेंट आ रहा है और उसमें पर्सनालिटी डिसऑर्डर है, तो डेफिनेटली वो ट्रीटमेंट ठीक से लेगा नहीं या ट्रीटमेंट लेने में थोड़ा रेजिस्टेंस करेगा या वो अल्कोहल पीता रहेगा, आपको बताएगा नहीं, झूठ बोलेगा. ये भी पर्सनालिटी डिसऑर्डर के क्राइटेरिया में फिट होता है. सो ट्रीटमेंट पॉइंट ऑफ व्यू इम्पोर्टेंट है, प्रोग्नोसिस पॉइंट ऑफ व्यू इम्पोर्टेंट है. पेशेंट को डिस्ट्रेस हो रहा है, बाकियों को डिस्ट्रेस हो रहा है. एंड एक या दो पर्सनालिटी डिसऑर्डर्स हम देखेंगे जिनमें देयर इज रिस्क ऑफ हार्म टू सेल्फ और अदर्स. तो कुछ पर्सनालिटी डिसऑर्डर्स होते हैं जिनमें सुसाइड का या वायलेंस का रिस्क ज्यादा होता है, तो इसीलिए भी ये इम्पोर्टेंट है. सो कैन यू सी, ये दिख रहा है तो और खराब हो गया. एनीवे आई रीड इट, तुम लोग देख लेना कि पर्सनालिटी क्या होता है. तो whenever वी वांट टू टॉक अबाउट पर्सनालिटी डिसऑर्डर। पहले आप समझो कि पर्सनालिटी क्या होता है और फिर हम डिसऑर्डर समझेंगे। तो आपने चलते फिरते बोला होगा ना कि इसका नेचर अच्छा नहीं है, इसकी पर्सनालिटी तो ऐसी है। तो व्हाट डू यू अंडरस्टैंड बाय पर्सनालिटी? आपको क्या लगता है पर्सनालिटी क्या होती है? जब आप बोलते हो ना आपके फ्रेंड का कि इसका तो नेचर ही खराब है, तो क्या मतलब है? एनीवे चलो, पर्सनालिटी का देखो कोई एग्जैक्ट डेफिनेशन नहीं है, बट आपने जो बोला होगा, जो सुना होगा कि उसका नेचर खराब है, पर्सनालिटी उसकी अच्छी नहीं है या बहुत अच्छी है, दैट इज अंदाजे से वही पर्सनालिटी का अंडरस्टैंडिंग है। तो इट इज द पैटर्न ऑफ थिंकिंग, फीलिंग एंड बिहेविंग। अगर बहुत सिंपल टर्म्स में बोलना है तो पर्सनालिटी इज हाउ यू रिएक्ट टू अ सिचुएशन। कोई भी एक सिचुएशन आएगी तो आपको गुस्सा आता है, तो आप हॉट टेम्पर्ड होके सिचुएशन को हैंडल करते हो, या एकदम कामली और हैप्पीली हैंडल करते हो, या बहुत ज्यादा स्ट्रेस लेके हैंडल करते हो। ये तीनों अलग डिफरेंट पर्सनालिटीज है। तो बेसिकली हम कैसे रिएक्ट करते हैं बाकी एनवायरनमेंट से, बाकी लोगों से इंटरेक्ट कैसे करते हैं, रिएक्शन क्या होता है हमारा, दैट इज बेसिकली पर्सनालिटी। अब पर्सनालिटी जो है, इट इज बायोलॉजिकल ऑल्सो। हमें लगता है कि इसका नेचर खराब है क्योंकि मे बी इसकी अपब्रिंगिंग अच्छी नहीं होगी या ऐसा कुछ होगा, पर ये बायोलॉजिकल भी होगा। आपने देखा होगा कुछ लोग होते हैं जिनके पापा हॉट टेम्पर्ड होते हैं, तो वो बच्चे भी हॉट टेम्पर्ड होते हैं और फिर ये बोलते हैं ये तो अपने पापा पे ही गया है ना? तो बायोलॉजिकल है, पर्सनालिटी डेफिनेटली बायोलॉजिकल है, लेकिन कुछ साइकोलॉजिकल मैकेनिज्म्स भी है, कुछ सोशल मैकेनिज्म्स भी है। अब अगर बचपन से वो बच्चा देखेगा कि मैं जब तक गुस्सा नहीं करूंगा, जब तक चिल्लाऊंगा नहीं, चीखूंगा नहीं, तो मेरे हिसाब से कोई बात नहीं होगी, तो फिर वो लर्न्ड बिहेवियर हो जाता है, वो यही सीखता है कि गुस्सा करना ही ठीक है, नहीं तो उस हिसाब से तो फिर मेरा कोई काम ही नहीं होगा। सो दिस इज व्हाट पर्सनालिटी इज। थोड़ा बहुत बायोलॉजी भी इन्वॉल्व है, थोड़ा बहुत साइकोलॉजिकल सोशल फैक्टर्स भी इन्वॉल्व है। ठीक है? तो कैरेक्टर का भी वही मीनिंग होता है, टेम्परामेंट का भी वही मीनिंग होता है। तो दे आर ऑल कंसिडर्ड अंडर पर्सनालिटी। जो टेम्परामेंट होता है दैट इज जेनेटिकली डिटरमाइंड, बायोलॉजिकली बेस्ड। तो ये बचपन से दिखेगा, जो हॉट टेम्पर का मैंने एग्जांपल दिया था। तो जब भी कोई बायोलॉजिकल वे में बात करना है तो टेम्परामेंट इज अ बेटर वे टू डिस्क्राइब इट। कैरेक्टर जो है, इट इज अ रिजल्ट ऑफ एक्सपीरियंस। तो जैसे जैसे हमारे सोशल एक्सपीरियंसेस होते रहते हैं, हमारी साइकोलॉजी डेवलप होती रहती है, तो फिर कैरेक्टर डेवलप होगा। जैसे बचपन से वो बोल रहा है कि मैं जब तक गुस्सा नहीं करता हूँ मेरा कोई सुनता नहीं है या मेरी कोई बात नहीं मानता है, तो ये एक्सपीरियंस से उसने सीखा है। ये दोनों मिलके पर्सनालिटी बनते हैं। It interacts with individual, social, and cultural factors. So now that we know what personality is, थोड़ा बहुत टेम्परामेंट के बारे में करते हैं, क्योंकि दिस इज बायोलॉजिकल। बायोलॉजिकल यानी आप हार्ड वायर्ड हो, आपके दिमाग के अंदर कनेक्शंस या वायरिंग ही ऐसी है कि आपको गुस्सा बहुत जल्दी आता है, बहुत जल्दी शॉर्ट सर्किट हो जाता है। ठीक है? तो दैट इज बायोलॉजिकल। उसको चेंज करना थोड़ा मुश्किल होता है क्योंकि ये जेनेटिक लेवल पे चीजें हो रही है, तो आपके जीन्स तो कोई चेंज कर नहीं सकता है। तो इन टेक्निकल टर्म्स, टेम्परामेंट इज अ बायोलॉजिकल प्रीडिस्पोजिशन टू रिस्पॉन्ड विथ ईदर अप्रोच और विड्रॉल टू अ पर्टिकुलर सिचुएशन और स्टिमुलाई। तो आप कैसे कोई सिचुएशन को, कोई स्टिमुलाई को रिस्पॉन्ड करते हो, बायोलॉजिकली डिटरमिन्ड है, तो उसको टेम्परामेंट बोलेंगे। ठीक है? टेम्परामेंट के बहुत सारे क्लासिफिकेशंस है, पर बहुत सिंपल और इजी वाला क्लासिफिकेशन है अकॉर्डिंग टू क्लोनिंगर। क्लोनिंगर ने एक क्लासिफिकेशन दिया था, बहुत इंटरेस्टिंग है। उसने बोला था कि आप चार चीजें देखिए: नॉवेल्टी सीकिंग, हार्म अवॉइडेंस, रिवॉर्ड डिपेंडेंस और परसिस्टेंट। ठीक है? काफी पुराने टाइम पे उसने दिया था, बट ये चार मेन चीजें दिया था। नॉवेल्टी सीकिंग, नॉवेल्टी यानी कोई नई चीज, तो आपने देखा होगा कुछ लोग होते हैं जिनको हर बार कुछ नया खाना होता है, लेकिन मैं रोज सेम खाना नहीं खा सकता हूँ, मुझे कुछ तो डिफरेंट टेस्ट चाहिए। या उनको हर बार कोई नई मूवी देखनी होती है, बोलते हैं हम ये फ्रेंड से भी बोर हो गया, अब मुझे नया फ्रेंड चाहिए। तो हर बार नई नई चीजें चाहिए होती है, तो इसे कहते हैं नॉवेल्टी सीकिंग। और कुछ लोग होते हैं जो बोलते हैं कि नहीं, मुझे मेरा रूटीन ही अच्छा है, रोज मैं उठूंगा, रोज उठ के मैं सिर्फ सैंडविच ही खाऊंगा, फिर पेपर पढ़ूंगा। फिर तो उनका रूटीन बहुत सेट होता है, उनको कोई नई चीज अगर उनके रूटीन में आ जाए तो वो पसंद नहीं है। तो दिस इज हाई नॉवेल्टी सीकिंग और लो नॉवेल्टी सीकिंग। तो ये एक तरीका है किसी की पर्सनालिटी को देखने का। सेकंड इज हार्म अवॉइडेंस। आपको पता है कि ये चीज करने से कॉन्सिक्वेंसेस हो सकते हैं, इसके बाद मुझे या तो पनिशमेंट मिलेगा या कुछ ना कुछ हार्म होगा, फिर भी वो करते हैं। ठीक है, जैसे पता है कि अगर मैं लेक्चर के बीच में बात करूंगा, हंसूंगा, तो टीचर खड़ा करेगी, क्वेश्चन पूछेगी, एंड में मुझे सामने आके बिठाएगी, फिर भी वो करते हैं। क्योंकि हार्म अवॉइडेंस उनमें बहुत कम है। उन्हें लगता है कि हाँ, कॉन्सिक्वेंसेस करते हैं। ये बहुत सिंपल एग्जाम्पल है। एक थोड़ा सीरियस एग्जाम्पल देखा जाए तो बहुत सारे लोग होते हैं जिनको एड्रेनलिन रश होता है, एड्रेनलिन जंकीज बोलते हैं, कि जब तक के बहुत तेज बाइक नहीं चलाएंगे या बहुत तेज कार नहीं चलाएंगे, या उनको ऊपर से जाके प्लेन से जंप करना होता है, तो इनमें होता है लो हार्म अवॉइडेंस, कि पता है कि प्लेन से जंप करके तो मर भी सकते हैं, पर फिर भी नहीं करना है, क्योंकि उनकी पर्सनालिटी, उनका टेम्परामेंट ही ऐसा है कि वो बायोलॉजिकली हार्ड वायर्ड ऐसे होते हैं कि उनको हार्म अवॉइड करना नहीं होता है। और कुछ आपके फ्रेंड्स होंगे जो थोड़े बहुत शाय भी होते हैं, उनको बोले कि कुछ चलो नया करते हैं, या कुछ फास्ट बाइक पे चलाते हैं कुछ, तो दे लाइक नहीं, मुझे बहुत डर लगता है। जो बहुत डर लगता है बोलते हैं दे हैव वेरी हाई हार्म अवॉइडेंस। सो दिस इज ऑल्सो अ वे। रिवॉर्ड डिपेंडेंस, कुछ लोग होते हैं जब तक कि मेरा फायदा नहीं होगा मैं कुछ नहीं करूंगा। ठीक है, कुछ होते हैं कि ठीक है चलो यार पढ़ लेते हैं, कुछ तो नॉलेज होगा। और कुछ होते हैं नहीं, जब तक एग्जाम में नहीं आएगा तब तक के तो मैं ये चैप्टर पढ़ने नहीं वाला हूँ। तो रिवॉर्ड डिपेंडेंस बहुत जरूरी है ऐसे लोगों में। परसिस्टेंस, परसिस्टेंस का मीनिंग आपको पता है? लाइक इंग्लिश वर्ड परसिस्टेंस का क्या मतलब होता है? कि बार बार एक ही चीज करना, परसिस्ट करना। तो परसिस्टेंस यानी कि कुछ लोग होते हैं जो बहुत इजीली गिव अप कर देते हैं। ठीक है, वो ट्राई करते हैं, कोशिश करते हैं, नहीं होता है तो नहीं करते हैं। कुछ लोग होते हैं जो बार बार कोशिश कर रहे हैं, बार बार कर रहे हैं, बार बार करते हैं, फाइनली वो सक्सेसफुल भी होते हैं। तो दीज आर परसिस्टेंट। ठीक है, ये उसने मोर और लेस एडिक्शन पॉइंट ऑफ व्यू से दिया था, कि जो एडिक्शन वाले लोग होते हैं उनमें हाई नोवेल्टी सीकिंग, लो हार्म अवॉइडेंस, हाई रिवॉर्ड डिपेंडेंस और लो परसिस्टेंस होता है। तो बेसिकली उसको देखना था कि ऐसा टेम्परामेंट जिनमें एडिक्शन अगर बहुत कॉमन है तो हम पहले से ही उनमें ट्रीटमेंट फिर स्टार्ट कर सकते हैं। अब आते हैं कैरेक्टर पे। तो कैरेक्टर जो है वो रिजल्ट होता है हमारे एक्सपीरियंसेस से, तो ये हम सीखते हैं। These experiences can be individual, social और cultural. Individual experience ये ना कि हाँ, वो बच्चे को पता है कि जब तक मैं घर पे चिल्लाऊंगा नहीं कोई मेरा बात मानेगा नहीं। ठीक है, अब ये सेम बच्चा जब सोशल इसमें जाता है, या तो स्कूल या कॉलेज में जाता है, फिर वो चिल्लाता है, तो या तो प्रिंसिपल या टीचर्स उसको फिर पनिश करते हैं, बोलते हैं कि ये गलत बात है, तो वो सीखता है नहीं, ये तो गलत है, ये नहीं करना चाहिए। कल्चरल, कुछ कल्चर्स होते हैं जिसमें बहुत शोर मचाना, एंजॉय करना वो एक्सेप्टेबल भी होता है, उन्हें लगता है कि अगर कोई चुप बैठा है तो ये गलत बात है। और कुछ कल्चर्स होते हैं जो बहुत शांत होते हैं, जो बोलते हैं कि ज्यादा इंटरेक्ट नहीं करना चाहिए या ज्यादा शोर शराबा नहीं करना चाहिए। तो ये कल्चर डिपेंडेंट भी होता है। कैरेक्टरिस्टिक इज नॉट डिस्टिंक्ट फ्रॉम टेम्परामेंट। तो ये दोनों को आप एकदम ऐसे सेपरेट नहीं कर सकते हो, दोनों मिलके ही पर्सनालिटी बनते हैं। दोनों का इंटरेक्शन बेसिकली मिलके एक पर्सनालिटी बनता है। ठीक है, तो जैसे हमने टेम्परामेंट देखा था, वैसे कैरेक्टर को हम कैसे डिस्क्राइब कर सकते हैं? कोऑपरेटिवनेस, ये तो इजी है। कुछ लोग होते हैं जो कोऑपरेटिव होते हैं, कुछ लोग होते हैं जिनको जो भी काम बोलो उल्टा ही करते हैं। ठीक है, तो दिस इज कोऑपरेटिवनेस। सेल्फ डायरेक्टेडनेस यानी कि खुद से वो कुछ कर रहे हैं या उनको दूसरों पे डिपेंडेंट होना होता है, तो दिस इज सेल्फ डायरेक्टेडनेस। सेल्फ ट्रांसेंडेंस ये थोड़ा सा हाई लेवल का हो गया कि बेसिकली खुद को वो ढूंढने की कोशिश करता है, खुद को एक्सप्लोर करने की कोशिश करता है, और कुछ लोग होते हैं जो खुद से ही दूर भागते हैं। तो दिस इज सेल्फ ट्रांसेंडेंस कि वो खुद के साथ कितने कनेक्टेड है, या खुद से वो, कुछ लोग होते हैं वो बोलते हैं मुझे ही पता नहीं कि मैं क्या सोच रहा हूँ, मुझे ही पता नहीं कि मैं क्या फील कर रहा हूँ। तो दिस इज सेल्फ ट्रांसेंडेंस कि वो कितने इन टच है खुद के साथ। ठीक है, सो अगेन एक जल्दी से रिवीजन करते हैं। नॉवेल्टी सीकिंग का मतलब है टेंडेंसी टू रिस्पॉन्ड विद अप्रोच टू नॉवेल, नॉवेल यानी नया, टू नॉवेल स्टिमुलाई, एंड बोर्डम टू फेमिलियर। तो ये लोग बहुत इजीली बोर हो जाते हैं। यूजुअली डोपामिन न्यूरोट्रांसमीटर है जो इसमें प्ले रोल करता है। डोपामिन हमारा रिवॉर्ड पाथवे भी है, तो दैट इज व्हाई नॉवेल्टी सीकिंग इज रिलेटेड टू डोपामिन। सेकंड कम्स हार्म अवॉइडेंस. By definition, it is the tendency to avoid aversive experiences. Mostly serotonin से लेना देना होता है. Reward dependence, tendency to perform behavior that lead to reward. ये adrenaline और noradrenaline पे based है. Persistent, tendency to persist in a task. Even in the absence of reward की fail हो रहा है तो भी बार बार कर रहा है. That is persistence. इसका पता नहीं है, मोस्टली तो नॉरएड्रेनालिन है, आजकल ग्लूटामेट भी अपकमिंग है, तो सोच रहे हैं कि शायद ग्लूटामेट का भी परसिस्टेंस में रोल हो। ठीक है, कोऑपरेटिवनेस हमने देखा, इन सब का डेफिनेशन कोई डाउट है? Cooperativeness, ability to collaborate with others towards a task completion. Self-directedness, ability to set and work towards goal and targets. कि कुछ काम दो तो वो कर पाते हैं खुद से या नहीं. Self transcendence, ability to transcend the immediate material environment for a higher intangible aspects, है ना, बेसिकली खुद को ढूंढने की कोशिश. अब आप अगर गूगल करेंगे या बुक्स में भी पढ़ेंगे तो पर्सनालिटी को डिस्क्राइब करने के बहुत है, 100 से भी ज्यादा आपको चीजें मिलेंगी, पर इजी और सिंपल वाले जो है वो हम डिस्कस कर रहे हैं, और बेसिकली आपको पेशेंट्स एनालाइज करने में भी ये ज्यादा हेल्प करता है। तो जो सबसे फेमस मॉडल है पर्सनालिटी का, दैट इज कॉल्ड एज अ 5 फैक्टर मॉडल। ये 2 साइंटिस्ट ने दिया था, कॉस्ट एंड मैक्रे, एंड बहुत ज्यादा यूज होता है साइकोलॉजिकल रिसर्च में। एंड इसमें बेसिकली 5 फैक्टर मॉडल क्यों बोलते हैं, क्योंकि 5 डिमेंशंस दिए पर्सनालिटी के। ये 5 डिमेंशंस है ओपननेस, कंसेंशियसनेस, एक्सट्रोवर्जन, एग्रीएबलनेस, न्यूरोसिटिज्म। आई नो हर एक वर्ड बहुत बड़ा बड़ा वर्ड है, मैं समझाती हूँ क्या है, लेकिन इसको याद रखने का एक शॉर्ट फॉर्म या निमोनिक आप बोल सकते हैं कि ओशन। ठीक है, तो ओशन में दीज आर द वर्ड्स। और जो हमने नॉवेल्टी सीकिंग और ये सब पुराना वाला देखा था, वो आजकल इतना यूज नहीं होता है, या वो यूज होता है सिर्फ एडिक्शन पॉइंट ऑफ व्यू से। लेकिन ये वाला जो मॉडल है, ये सारे साइकेट्री पेशेंट्स में आप यूज कर सकते हैं, भले ही वो डिप्रेशन हो, एंजाइटी हो, स्किजोफ्रेनिया हो। देखते हैं ओपननेस का क्या मतलब है, ये पुराने वाले से ही थोड़ा बहुत रिलेटेड है। ओपननेस जो है बेसिकली नई चीजें जो ढूंढना, जो नॉवेल्टी सीकिंग था, बेसिकली वही ओपननेस है कि ओपन टू न्यू एक्सपीरियंसेस। तो जैसे अगर हमारे पास पेशेंट आती है डिप्रेशन की, तो उसको पूछते हैं कि आपको अगर कोई नई रेसिपी मिल गई कि ये भी एक नया तरीका है या कोई नया डिश है ये बनाने का, तो आप ट्राई करोगे बनाना, या फिर वो बोलेगी नहीं नहीं मेरे से तो होगा नहीं, मैं बस पुरानी चीजों से सही हूँ। तो दिस इज ओपननेस, बेसिकली नई चीजें एक्सप्लोर करना चाहते हैं कि नहीं। काफी बड़ा वर्ड है कॉन्शियसनेस। ठीक है, तो कॉन्शियस सुना होगा आपने कि इसमें तो कॉन्शियस ही नहीं है ना। कॉन्शियस यानी कि सही और गलत का समझ बेसिकली। ठीक है, या आपने बचपन में टॉम एंड जेरी देखा होगा, तो उसमें दो आते थे, एक रेड कलर का बनता था, एक व्हाइट कलर का कार्टून बनता था उसपे। आई नो बहुत पुराना कार्टून है, बट जब भी आपके पास ऑप्शन होता है किसी वे में रिएक्ट करने का, आपके पास दो रास्ते हैं, एक रास्ता सही है, एक रास्ता गलत है। बेसिकली आप कौन सा रास्ता चूज करोगे, दैट इज कॉन्शियसनेस, कि आपका कॉन्शियस आपको ये करने देता है या नहीं। आपका कॉन्शियस बोलता है कि ये रास्ता तो गलत है, पर ये तो शॉर्टकट है, इसमें मेरा टाइम भी बचेगा, ज्यादा मेहनत नहीं करनी पड़ेगी, तो क्यों ना ये शॉर्टकट ही यूज किया जाए। ठीक है, तो दिस इज योर कॉन्शियसनेस, कि आपका कॉन्शियस आपको क्या बोलता है। एक्सट्रोवर्जन, अगेन आपने एक्सट्रोवर्ट सुना होगा कि ये एक्सट्रोवर्ट है, ये इंट्रोवर्ट है। इंट्रोवर्ट ये ना जो शाय लोग होते हैं, एक्सट्रोवर्ट जो बहुत आउटगोइंग होते हैं, जो आते से ही सबसे बात करेंगे। अगर कोई नई जगह जाते हैं तो नई जगह भी सबसे बात करेंगे, सबसे घुल मिल के रहेंगे। और एक्सट्रोवर्जन का ही ऑपोजिट होता है इंट्रोवर्जन, जो अगर बहुत बड़े हॉल में भी बैठे हैं तो वो एक कोने में बैठे रहेंगे, किसी से बात नहीं करेंगे। तो दिस इज द ऑपोजिट। तो एक्सट्रोवर्जन समझ में आ गया। कंसेंशियसनेस, ओपननेस, एग्रीएबलनेस भी उसके जैसे ही था, पुराने के जैसा, कि कोई काम दो तो एग्री करता है या उसका उल्टा करता है। दिस इज समथिंग न्यू, न्यूरोसिटिज्म। बेसिकली वो कितना ज्यादा स्ट्रेस लेता है। न्यूरोटिक जो वर्ड है, न्यूरोटिक का मतलब होता है स्ट्रेस। तो अगर किसी को एक सिचुएशन में डाल दे, तो आपने देखा होगा कुछ लोग है जो बहुत टेंशन लेते हैं सेम सिचुएशन के लिए। एग्जाम का ही देखा जाए तो एग्जाम में कुछ लोग होते हैं जो बोलते हैं अरे क्या होगा, मैं फेल हो जाऊंगा या हो जाऊंगी, कुछ नहीं होगा। और कुछ होते हैं जो बहुत चिल होते हैं, कुछ पढ़ाई नहीं हुई होती है, वो बोलते हैं नहीं नहीं कर लेंगे, कुछ तो लिख देंगे। ठीक है, तो दिस इज न्यूरोसिटिज्म, कि में आप कितना ज्यादा स्ट्रेस लेते हो, दैट इज बेसिकली न्यूरोसिटिज्म। ठीक है, तो जब भी कोई पेशेंट आता है और हम पेशेंट की पर्सनालिटी इवेल्युएट करते हैं, हम ये 5 चीजें देखते हैं ये ना, पूछते हैं पेशेंट को, अलग अलग सिनेरियोज देते हैं कि ऐसा होगा तो आप कैसे करोगे। और इसका एक क्वेश्चनर भी आता है, बिग 5 क्वेश्चनर उसका नाम है। तो या तो आप क्वेश्चंस पूछ सकते हैं पेशेंट से, या उसको बोल दो क्वेश्चनर भर के दे दो, उसपे से आपको उसकी पर्सनालिटी पता चल जाएगी। ठीक है, तो पुराने वाले से अगर कंपेयर किया जाए तो ओपननेस थोड़ा बहुत नॉवेल्टी सीकिंग जैसा ही है, कि नई चीजें कर सकते हैं कि नहीं। ठीक है, कंसेंशियसनेस इज सेल्फ डायरेक्टेडनेस। एग्रीएबलनेस कितना कोऑपरेटिव है। न्यूरोसिटिज्म अगेन हार्म अवॉइडेंस। तो पुरानी वाली चीजों को ही लेके उन्होंने थोड़ा सा और बेटर बनाया है। और लेटेस्ट वाला जो है, हम ये बिग 5 या ओशंस का ही क्राइटेरिया करते हैं। ठीक है, तो अब हमने पर्सनालिटी तो असेस कर ली। अब देखते हैं कि पर्सनालिटी डिसऑर्डर क्या होता है। पर्सनालिटी डिसऑर्डर्स आर मैलएडेप्टिव एंड इनफ्लेक्सिबल पैटर्न्स। ठीक है, तो पर्सनालिटी अच्छी भी हो सकती है, बुरी भी हो सकती है। तो अगर पर्सनालिटी अच्छी है तो हम उसको डिसऑर्डर नहीं बोलेंगे। पर्सनालिटी अगर इतनी बुरी है कि उसको अडेप्ट नहीं करने दे रही है, फ्लेक्सिबल नहीं है, और बेसिकली अडेप्टेशन में फ्लेक्सिबल नहीं होता है, तो अडेप्ट करने में प्रॉब्लम होती है। और ये डिसऑर्डर की वजह से पेशेंट का कॉग्निशन, इम्पल्स कंट्रोल एंड स्पेशली रिलेशनशिप्स खराब हो रहे हैं, तो फिर हम इसको डिसऑर्डर बोलेंगे। ठीक है, तो अगर कोई जस्ट हॉट टेम्पर्ड है, पर उसका काम चल रहा है, फ्रेंडशिप अच्छी है, फैमिली लाइफ अच्छा है, तो फिर हम उसको पर्सनालिटी डिसऑर्डर भी नहीं बोलेंगे, कि ठीक है बस वो हॉट टेम्पर्ड है तो है। ठीक है, एज अ रूल अगर हमें बोलना है कि ये पर्सनालिटी डिसऑर्डर है, तो हमें 3 P's चाहिए: पैथोलॉजिकल, परवेसिव एंड परसिस्टेंट। पैथोलॉजिकल यानी कि नॉर्मल नहीं है। थोड़ा बहुत गुस्सा करना नॉर्मल होता है, पर इतना ज्यादा गुस्सा करना कि आप फर्नीचर तोड़ रहे हो, लोगों को मार रहे हो, तो दिस इज नॉट नॉर्मल। तो पैथोलॉजिकल इज नॉर्मल से कुछ अलग। परवेसिव यानी कि अलग अलग जगह, अगर वो सिर्फ आके काम पे गुस्सा कर रहा है पर फ्रेंड्स के साथ अच्छा है, फैमिली के साथ अच्छा है, तो वो परवेजिव नहीं है। हो सकता है उसको काम का स्ट्रेस हो, इसीलिए वो काम पे गुस्सा कर रहा है, हॉट टेम्पर्ड हो रहा है। तो अगर आपको पर्सनालिटी डिसऑर्डर बोलना है, तो वो हर सिचुएशन में सेम रिएक्ट करना चाहिए। हर सिचुएशन में या हर लाइफ के एस्पेक्ट में उसमें गुस्सा करना चाहिए, तभी आप बोलोगे कि वो डिसऑर्डर है। persistent is continuous and stable over a period of time, यानी कि बचपन से ही वो गुस्सा कर रहा है या बहुत सालों से। जैसे आप अगर पेशेंट के रिलेटिव को पूछोगे, तो रिलेटिव वही बोलेगी, हाँ मेरी शादी को तो 10-12 साल हो गए, 10-12 साल से ये चेंज नहीं हुआ है, ये ऐसे ही है, इनको तो गुस्सा आता ही है और हर सिचुएशन में आता है। इसका ऑपोजिट होगा कि अगर कोई स्ट्रेसफुल सिचुएशन से जा रहा है, किसी की डेथ हो गई घर पे या कुछ है, और तब वो गुस्सा कर रहा है कुछ महीनों के लिए और फिर बाद में वो ठीक हो जाता है, तो इसको पर्सनालिटी डिसऑर्डर नहीं बोलेंगे, क्योंकि दिस इज नॉट परसिस्टेंट। तो पर्सनालिटी डिसऑर्डर बोलने के लिए हमें ये 3 चीजें बहुत इंपॉर्टेंट है। लाइक ऑल क्लासिफिकेशन, साइकेट्रिक इलनेसेस में जब भी हमें क्लासिफाई करना होता है, हम डीएसएम यूज करते हैं, आईसीडी यूज करते हैं। है उसके बहुत सारे एडवांटेजेस भी है, डिसएडवांटेजेस भी है, बट रिसर्च पॉइंट ऑफ व्यू से अगर डीएसएम या आईसीडी यूज करा तो बेटर है, बट क्लिनिक्स में तो हम ओशंस क्राइटेरिया से भी काम चला लेते हैं। ठीक है, अब आता है पर्सनालिटी डिसऑर्डर पे। तो आई नो बहुत बड़ी लिस्ट है, पर मैं बहुत सिंपल करके बनाती हूँ, एक एक करके देखते हैं। ठीक है, तो पर्सनालिटी डिसऑर्डर को 3 क्लस्टर में डिवाइड किया, क्लस्टर ए, बी एंड सी। ठीक है, अगर आप हर क्लस्टर का कैरेक्टरिस्टिक याद रखोगे तो फिर आपको वो लंबी लिस्ट रटनी नहीं पड़ेगी। ठीक है, तो क्लस्टर ए वाले जो होते हैं ना, वो बहुत ऑड होते हैं, एक्सेंट्रिक होते हैं, थोड़े अजीब से होते हैं, थोड़े वियर्ड होते हैं। ठीक है, जो हमारा क्या कहते हैं, दिस इज नॉट अ टेक्निकल क्लासिफिकेशन, पर याद करने के लिए हम याद करते हैं मैड, बैड और सैड। ठीक है, मैड यानी कि बहुत वियर्ड होते हैं, बहुत अजीब से होते हैं। बैड यानी कि खुद के लिए तो अच्छे हैं, बाकियों के लिए परेशान करेंगे, तो बैड फॉर द सोसाइटी। एंड ये सैड यानी खुद के लिए वो बुरे होते हैं, भले ही मे बी सोसाइटी वगैरह को उनसे प्रॉब्लम ना हो, पर वो खुद ही इतने परेशान होते हैं कि वो परेशान हो जाते हैं। तो क्लस्टर ए वाले होते हैं ऑड और अलूफ, क्लस्टर बी वाले होते हैं ड्रामेटिक, इमोशनल। ठीक है, हम देखेंगे कि ये कौन और कैसे कैसे इनके कैरेक्टरिस्टिक है। क्लस्टर सी वाले जो हमेशा स्ट्रेस लेते हैं, फियरफुल होते हैं, एंग्शियस होते हैं, अवॉइडेंट होते हैं, तो दीज आर द क्लस्टर्स। ठीक है, सो अब एक एक करके आता है। सबसे पहले क्लस्टर ए देखते हैं। क्लस्टर ए में 3 आते हैं, पैरानॉइड, स्किज़ोइड, स्किज़ोटिपल। ठीक है, पैरानॉइड का मतलब है कि हर चीज उनको लगेगी कि कुछ ना कुछ गड़बड़ है। जैसे अगर कोई उनके लिए अच्छा भी कुछ करता है, नहीं नहीं ये तो मेरा बुरा, कुछ तो इसके पीछे प्लान होगा या इसने कुछ तो प्लान बनाया होगा, तो इनको ट्रस्ट करना आसान नहीं होता। जो पैरानॉइड पर्सनालिटी होते हैं, दे आर नॉट एबल टू ट्रस्ट अदर्स। उनको हमेशा लगता है कि सामने वाला मेरे कुछ ना कुछ खिलाफ ही करेगा या मेरा कुछ बुरा ही करेगा। स्कीजोइड वाले जो होते हैं, उनको ना सोशल इंटरेक्शन करना अच्छा नहीं लगता, उनको अकेले बैठना अच्छा लगता है, कि जब तक कोई उनसे आके बात ना करे तब तक वो खुश रहेंगे। तो बेसिकली दे लाइक बीइंग अलूफ, सोशल इंटरेक्शन में प्रॉब्लम है, डिफिकल्टी एक्सप्रेसिंग इमोशंस, तो वो अपने इमोशंस बता भी नहीं पाते हैं, सामने वाले के इमोशंस समझ नहीं पाते हैं, तो इसलिए दे लाइक कि मैं अकेले ही ठीक हूँ। ये हो गया स्किजोइड। ठीक है, नेक्स्ट आते हैं स्किजोटिपल। स्किजोटिपल का मतलब है कि ये स्किजोफ्रेनिया के जैसे होते हैं, या तो स्किजोफ्रेनिया के रिलेटिव्स होते हैं या स्किजोफ्रेनिया का बहुत बहुत माइल्ड वर्जन होता है। तो इनके ऑड बिलीव्स होंगे, ऑड बिहेवियर होगा, कपड़े पहनने का स्टाइल थोड़ा अलग होगा, बात करने का स्टाइल अलग होगा। तो दे आर वेरी क्लोज टू स्किजोफ्रेनिया, बट एक्चुअल स्किजोफ्रेनिया का डायग्नोस्टिक क्राइटेरिया वो फुलफिल नहीं करते। तो इसीलिए बहुत माइल्ड फॉर्म ऑफ स्किजोफ्रेनिया जो है उसे हम स्किजोटिपल बोलते हैं। ठीक है, पैरानॉइड है ना, सब पे शक करता है। स्किजोइड अकेले रहना अच्छा लगता है। स्किजोटिपल जो थोड़े बहुत स्किजोफ्रेनिया के सिम्टम्स है बट नॉट अ फुल ब्लोन साइकोटिक पिक्चर। क्लस्टर बी वाले सबसे इंटरेस्टिंग होते हैं। ठीक है, इंटरेस्टिंग क्योंकि बहुत लाउड होता है, बहुत ड्रामेटिक होता है, और अगर वो रूम में रहेंगे तो आपको पता चलेगा कि वो है यहाँ पे। ठीक है, तो सबसे पहले आते हैं हिस्ट्रियोनिक पे। हिस्ट्रियोनिक का मतलब है उन्हें अटेंशन चाहिए होता है। तो आई एम श्योर आप सब में एक तो फ्रेंड होगा जो हिस्ट्रियोनिक होता ही है, कि जब तक वो बात नहीं कर रहा है तब तक उसको शांति नहीं रहेगी, कि सबने मेरा सुनना चाहिए, मेरा बात करना चाहिए। कोई और बात करने लगता है तो वो और जोर से बात करने लगता है या कुछ शोर मचाने लगता है। तो दे आर अटेंशन सीकिंग। मोस्टली जो फिल्म इंडस्ट्री के लोग होते हैं, जो एक्टर्स होते हैं, एक्ट्रेसेस होते हैं, उनमें भी मोस्टली हिस्ट्रियोनिक पर्सनालिटी होती है क्योंकि उन्हें अटेंशन अच्छा लगता है। बॉर्डरलाइन पर्सनालिटी जो है वो बहुत इम्पल्सिव होते हैं, बहुत अनस्टेबल होते हैं। तो बॉर्डरलाइन, इनका नाम बॉर्डरलाइन रखा है क्योंकि दे आर बॉर्डरलाइन ऑन न्यूरोटिक एंड साइकोटिक, कि कभी कभी उनमें साइकोटिक सिम्टम्स भी दिखने लगेंगे, कभी कभी न्यूरोटिक दिखने लगेंगे। वो इतने ज्यादा अनस्टेबल होते हैं कि वो खुद भी अपने इमोशंस को कंट्रोल नहीं कर पाते। और इनमें सुसाइड बहुत कॉमन है। तो भले कंप्लीटेड सुसाइड नहीं, पर सुसाइड थ्रेटन करना भी बहुत कॉमन है। तो वो या तो हाथ काट देंगे, या घर पे कुछ भी झगड़ा हो गया तो जाके कुछ रैट पॉइजन पी लेंगे या कुछ क्लोरीन पी लेंगे। तो ये यूजुअली बॉर्डरलाइन पर्सनालिटीज होते हैं। नार्सिसिस्टिक पर्सनालिटी जो है, अगेन आई एम श्योर आपको कोई ना कोई आपका फ्रेंड याद होगा ही, कि उसको खुद से ज्यादा और किसी से प्यार नहीं है। तो उसको लगता हूँ मैं ही बेस्ट हूँ, मैं सेंटर ऑफ अर्थ हूँ, मैं जो भी करता हूँ हर चीज अच्छा करता हूँ, जो भी करता हूँ बुरा करता हूँ। ठीक है, एंटी सोशल। एंटी सोशल का नाम एंटी सोशल है, बट इसका मतलब ये नहीं कि उनको सोशलाइज करना अच्छा नहीं लगता। ये नहीं, एंटी सोशल का मतलब है दे आर अगेंस्ट द सोसाइटी। तो सोसाइटी के जो भी रूल्स हैं उसके अगेंस्ट जाना उनको अच्छा लगता है। तो दे हैव डिसरिगार्ड फॉर द राइट्स ऑफ अदर्स, सोसाइटल नॉर्म्स। तो अगर उनको बोला जाए कि ये नहीं करना है या ये करोगे तो कुछ कॉन्सिक्वेंस होंगे या कुछ आपको जेल हो जाएगी, दारू पी के गाड़ी नहीं चलाना है तो दारू पी के ही गाड़ी चलाएंगे वो। तो दीज आर एंटी सोशल पर्सनालिटीज। एंड मोस्टली एंटी सोशल पर्सनालिटीज में सब्सटेंस यूज या एडिक्शन बहुत कॉमन होता है। जरूरी नहीं है कि एंटी सोशल हो तो एडिक्शन हो, बट कॉमन बोल रही हूँ कि जरूरी नहीं कि हिस्ट्रियोनिक वाले फिल्म स्टार्स ही बढ़ेंगे या सारे फिल्म स्टार्स हिस्ट्रियोनिक होते हैं, बट मोर कॉमन इन दीज पीपल। अब आते हैं क्लस्टर सी पे। क्लस्टर सी वाले होते हैं सैड। ठीक है, वो खुद से ही बहुत ज्यादा परेशान होते हैं। क्लस्टर बी से बाकी लोग परेशान होंगे, वो खुश रहेंगे। लेकिन क्लस्टर सी वाले खुद आपके पास आएंगे, वो बोलेंगे कि इसका कुछ करो, मेरी पर्सनालिटी बचपन से ऐसे, इसके लिए आप कुछ चेंज कर सकते हैं, कुछ हेल्प कर सकते हैं। तो एक है एंग्शियस अवॉइडेंट, नाम से ही पता चल रहा है कि बहुत जल्दी एंग्शियस हो जाता है, और इतना ज्यादा उनको लगता है कि मुझे एम्बैरेसमेंट हो जाएगा, ह्यूमिलिएशन हो जाएगा, कि वो फिर सिचुएशन को अवॉइड करने लगता है। कि उनको लगता है कि हाँ, मैं क्लास में अगर जाके बैठूंगा तो भी मैं कुछ गलत कर दूंगा या कुछ गलत हो जाएगा, तो क्लास भी नहीं जाते। डिपेंडेंट पर्सनालिटी, अगेन एज द नेम सजेस्ट, कि उनको किसी पे डिपेंडेंट होना होता है, कि वो खुद से कुछ नहीं कर सकते हैं, खुद से कोई डिसीजन नहीं ले सकते। दिस इज डिपेंडेंट पर्सनालिटी। नाउ कमिंग टू एननकैस्टिक। एननकैस्टिक का दूसरा वर्ड ओसीपीडी भी है, ऑब्सेसिव कंपल्सिव पर्सनालिटी डिसऑर्डर। तो ये होते हैं परफेक्शनिस्ट, इनको हर चीज परफेक्ट चाहिए होती है। ठीक है, तो सारे क्लस्टर्स देखा जाए तो सब में कुछ कुछ कोमॉर्बिडिटीज होती है। डिप्रेशन तो ऑलमोस्ट सब में ही होता है। हमने देखा था सब्सटेंस यूज डिसऑर्डर्स क्लस्टर बी में ज्यादा कॉमन होते हैं, स्पेशली एंटी सोशल पर्सनालिटी। ओसीडी जो है क्लस्टर सी, ओसीपीडी एनिंकेस्टिक वाले में ज्यादा होगा। तो बाकी जो साइकेट्रिक इलनेसेस है, हर पर्सनालिटी डिसऑर्डर में कुछ कुछ साइकेट्रिक इलनेसेस होने का रिस्क होता है। तो आपको वो कोमॉर्बिडिटीज और वो रिस्क भी एटलीस्ट कॉमन वाली तो पता होनी चाहिए। इटियोलॉजी, क्यों किसी को पर्सनालिटी डिसऑर्डर होता है, अगेन बायोलॉजिकल हो सकता है, साइकोलॉजिकल हो सकता है, सोशल हो सकता है। बायोलॉजिकल में कुछ कुछ जेनेटिक फैक्टर्स हैं, जैसे स्किजोटिपल हमने देखा था कि स्किजोफ्रेनिया के जो रिलेटिव्स हैं उनमें हो सकता है। बायोकेमिकल में डोपामिन, सेरोटोनिन, नॉरेड्रेनालिन, अगेन कुछ न्यूरोट्रांसमीटर्स हैं जिनकी वजह से ऐसा होता है। आपके दिमाग में कुछ इलेक्ट्रिकल चेंजेस भी होती है, जैसे डिसइनहिबिशन और कुछ एबनॉर्मलिटीज, उसकी वजह से भी ये पर्सनालिटी डिसऑर्डर्स हो सकता है। स्ट्रक्चरल चेंजेस, स्पेशली हमारा जो प्री फ्रंटल कॉर्टेक्स होता है वो डिसाइड करता है कि सोशली हमने कैसे रहना चाहिए। तो अगर प्री फ्रंटल कॉर्टेक्स में कुछ प्रॉब्लम है, टेम्पोरल लोब में कुछ प्रॉब्लम है, तो फिर हो सकता है कि पर्सनालिटी डिसऑर्डर्स हो। साइकोलॉजिकल फैक्टर्स, बचपन में स्पेशली अगर अब्यूज किया जाए तो हो सकता है पर्सनालिटी डिसऑर्डर का चांस बढ़ जाए। निग्लेक्ट, केओटिक और पैथोलॉजिकल फैमिलीज, लैक ऑफ क्लोज रिलेशनशिप्स और अटैचमेंट, सोशल आइसोलेशन, ये फैक्टर्स हो सकते हैं, जरूरी नहीं कि हो, बट दे कैन कंट्रीब्यूट। सोशो कल्चरल फैक्टर्स में अगेन कल्चर टू कल्चर डिपेंड करता है, रिलीजियस एंड मॉरल कंस्ट्रेंट्स भी होते हैं। जेंडर स्पेसिफिक फैक्टर्स भी होते हैं कि लड़कियों ने चुप बैठना चाहिए, लड़कों ने बोलना चाहिए, लड़के आउटगोइंग होना चाहिए। लड़के अगर चुप बैठे तो उनपे भी फिर बोलते हैं कि अरे तुम क्यों चुप बैठे हो, और लड़कियां कुछ बोलती है तो बोलते हैं नहीं नहीं लड़कियों ने नहीं बोलना चाहिए। जेंडर स्पेसिफिक भी है, रिलीजियस सब कल्चर्स, ये सब भी थोड़ा बहुत पर्सनालिटी शेप करने में हेल्प करता है। ठीक है, लेकिन हम एकदम ये नहीं बोल सकते कि ये होगा तो ये पर्सनालिटी होगा। तो कॉजेटिव फैक्टर एंड पर्सनालिटी लीनियर नहीं है। पर्सनालिटी डेवलपमेंट बहुत ही क्योटिक प्रोसेस है, कम ज्यादा होते रहता है, एंड इवेंचुअली पर्सनालिटी डिसऑर्डर फिर वो जाके बनता है। ठीक है, जब भी आपके पास पर्सनालिटी डिसऑर्डर आता है, यू हैव टू रूल आउट ऑल दीज अदर डिसऑर्डर्स आल्सो, स्पेशली मूड डिसऑर्डर्स। बाइपोलर डिसऑर्डर अगर मेनिया या डिप्रेशन का सॉफ्टर फॉर्म या माइल्डर फॉर्म रहा तो हो सकता है। ऑटिज्म स्पेक्ट्रम, एडीएचडी, पीटीएसडी, साइकोसिस, ओसीडी, कभी कभी नॉर्मल कल्चरल वेरिएंस भी होता है। तो आप उनको पर्सनालिटी डिसऑर्डर नहीं बना सकते जब तक कि ये रूल आउट नहीं हो। तो ये सब रूल आउट करने के बाद ही पर्सनालिटी डिसऑर्डर का डायग्नोसिस बनता है। अब ट्रीटमेंट, ट्रीटमेंट में प्रॉब्लम ये है कि ट्रीटमेंट लॉन्ग टर्म होता है, मोर और लेस लाइफ लॉन्ग ही बोल सकते हैं कि लाइफ में अप्स एंड डाउन्स आते रहेंगे और वो टाइम पे ट्रीटमेंट आपको देते रहना पड़ेगा। ट्रीटमेंट मल्टी मॉडल है, एक कोई ट्रीटमेंट में पिन पॉइंट नहीं कर सकती हूँ कि यही इससे ट्रीट होगा। तो मेडिसिन है, साइकोथेरेपी है, एक्सरसाइजेस है, ये सब चीजें हैं। बहुत सारे नए भी आ रहे हैं ट्रीटमेंट्स जो अभी अंडर रिसर्च है। तो हो सकता है पुराने वाले ना काम करे बट नए वाले हो जाए। कोलैबोरेटिव होता है, कोलैबोरेटिव का वही मतलब है कि सिर्फ एक डॉक्टर नहीं, साइकोलॉजिस्ट, साइकियाट्रिस्ट, थेरेपिस्ट, सब लोग मिल के अगर करें तो बेटर है। बट हमेशा याद रखो कि चैलेंजिंग है, जब भी हम पर्सनालिटी डिसऑर्डर ट्रीट कर रहे हैं ये चैलेंज लेके ही ट्रीट करना चाहिए। इट इज नॉट एट ऑल इजी। हमारा मेन एम ये नहीं होता है कि उसकी पर्सनालिटी चेंज हो जाए, बिकॉज दैट इज नॉट पॉसिबल। आर एम इज टू रिड्यूस द सेल्फ हार्मिंग बिहेवियर, कि खुद को चोट ना पहुंचाए, दूसरों को चोट ना पहुंचाए, टू रिड्यूस बिहेवियर्स दैट कॉज डैमेज टू अदर्स, टू रिड्यूस प्रॉब्लमेटिक बिहेवियर्स, कि काम पे कॉलेज पे कुछ प्रॉब्लम ना हो, टू इम्प्रूव इंटरपर्सनल सोशल फंक्शनिंग, टू ब्रिंग अबाउट लॉन्ग टर्म चेंजेस। काफी बड़ा गोल होता है, पॉसिबल नहीं होता है, अगर कर सके तो अच्छा ही है। हमेशा याद रखो, हमारे पास जितनी भी मेडिसिन हैं, दे डू नॉट क्योर पर्सनालिटी डिसऑर्डर, इनका कोई क्योर नहीं है। कभी कभार सिम्टम्स को कम करने के लिए हम ड्रग्स दे सकते हैं। नए नए ट्रीटमेंट्स भी आ रहे हैं, तो नए ट्रीटमेंट भी पता होना चाहिए। कम से कम 12 to 18 मंथ्स का तो साइकोथेरेपी इनको लगता ही लगता है। तो अगर आप कोई पेशेंट को काउंसलिंग के लिए भेज रहे हैं तो एक काउंसलिंग से ठीक नहीं होगा, 12 to 18 मंथ्स का काउंसलिंग लगेगा। अलग अलग टाइप्स की काउंसलिंग लगेगी, यूजुअली कंबाइंड अप्रोच होता है। काउंसलिंग आईपीडी हो सकती है, ओपीडी हो सकती है, इंडिविजुअल काउंसलिंग, ग्रुप काउंसलिंग, फैमिली थेरेपी। तो अगेन कोई एक स्पेसिफिक साइकोथेरेपी नहीं है, सबको मिलजुल के काम करना है और पेशेंट को ठीक करने की कोशिश करना है जितना कर सकते हैं। प्रिकॉशंस लेना है, स्पेशली ये पेशेंट्स थोड़े मैनिपुलेटिव भी होते हैं, कभी कभी झूठ भी बोलते हैं, तो वी हैव टू मेंटेन प्रोफेशनल बाउंड्रीज। अपना कोई पर्सनल इंफॉर्मेशन उन्हें नहीं देना है, ठीक है। तो वेन एवर दे आस्क समथिंग अबाउट यू, आप लोगों को कुछ नहीं बताना, ठीक है। यू आर सपोज टू टेल कि पेशेंट आप है, हम आपको हेल्प करना चाहते हैं, तो आपके बारे में बताइए। और डॉक्यूमेंटेशन बहुत जरूरी है, जो भी आपके साथ इंटरेक्शन हो रहा है पेशेंट का, डॉक्यूमेंट करो। मेंटेन कॉन्फिडेंशियलिटी, साइकेट्री में वेरी वेरी इंपॉर्टेंट, कि जाके गॉसिप नहीं करना है, बाकी लोगों को नहीं बताना है कि ये तो आया था और ऐसा हुआ था। मेक अ डायग्नोसिस बेस्ड ऑन क्राइटेरिया, नॉट पर्सनल इंप्रेशन और प्रेजुडिसेस। तो अगर आप डायग्नोसिस बना भी रहे हो तो आपके पास एक सेट ऑफ क्राइटेरिया होना चाहिए जो फुलफिल होना चाहिए, तभी जाके ये पर्सनालिटी डिसऑर्डर बन पाएगा, ठीक है। तो विद दिस आई एंड दिस लेक्चर, थैंक यू सो।
Good afternoon to all. So we have gone through the series of lectures which were pertaining to adulthood psychiatry. Now we will look what are the disorders there in the childhood, infancy and adolescence pertains to psychiatric disorders. So this is the first lecture which consists of disorder of psychological development. The chapter F80 to F89 is prescribed for these disorders. In introduction, what is the background of these disorders are? There is an onset that is invariably during infancy and childhood. So, onset is usually occur in the earlier period of lifespan. An impairment or delay in the development of functions that are strongly related to biological maturation of CNS. A steady course that does not involve the remissions and relapses that tends to be characteristic of many mental disorders. So this is a continuous course of illness in these disorders, and there is no episodic course, and somewhat fluctuations may be there. These disorders pertains to language, visual spatial skills and motor coordination disorders. So impairment shows a gradual reduction as children age, although some milder deficits may persist into adulthood. So gradual reduction in the area of language, motor skills and others may be found, and which is gradually worsening as the child ages. Generally, the developmental history indicates a delay or impairment that has been observable without any preceding phase of normal development. So there is no normal developmental phase before the symptoms are actually found. These conditions are significantly more prevalent in boys compared to girls. A prevalent family history of similar or related condition may be found in the family history, and this suggests a genetic contribution to these disorders, though not found in all the cases. Environmental influences can affect the developmental functions involved that typically do not play a dominant role. So environmental influence does not have any dominant role in development of these disorders, but they may contribute. The specific cause remains largely unknown. In the continuum of disorder of psychological development, there are 4 types of disorders related to speech and language, scholastic skills, motor functions, and pervasive developmental disorder, which consist of autism, Rett syndrome, Asperger syndrome, and others. Let's start with the specific developmental disorder of speech and language. Just look at the category. There is word specific developmental disorder. So these disorders are specific to speech and language, and other impairments of cognitions are not usually found. So these are divided into specific speech articulation disorder, expressive language disorder, receptive language disorder, acquired aphasia with epilepsy, known as Landau-Kleffner syndrome. In specific developmental disorder of speech and language, so the first difficulty to diagnose these disorders are differentiation from normal variations in development. You know that as the child grows, there are certain impairment and there are some mistakes in their language and speeches, which is expected as per their age. So this is a difficulty to differentiate this speech and language disorder sometimes. Most of the children ultimately acquire a normal level of language skills and have multiple associated problems. So as these children ages, they can have multiple associated problems also, like abnormalities in interpersonal relationship, emotional instabilities, and behavioral disorders. So how to differentiate these disorders from a normal development? So one have to look for the severity, course, pattern, and associated problems with these children. The second challenge in diagnosis is distinguishing between language delay and mental retardation or global developmental delay. So in mental retardation, there is a global developmental delay in most of the areas of cognition and motor skills, but as this is prescribed as a specific developmental disorder, the specific problem is found isolated in these children. If global developmental delay is found as a diagnosis, the appropriate coding is F70 to 79, which is meant for mental retardation rather than F80. The third challenge involves distinguishing this condition from the disorder that arises due to severe hearing loss, specific neurological or structural issues. So if a child is having hearing loss, that deprivation can lead to development of speech and language disorder because of deprivation of senses. Any speech issue caused specifically by cleft palate, which is a surgical problem, or by dysarthria related to cerebral palsy would not be included in this category. Now in language and speech, there is a specific problem which is known as speech articulation disorder. What is the normal about articulation is by age 4, child makes error in speech, sound production, yet they can still be easily understood by strangers. By age 6 to 7, most children will have mastered the majority of speech sounds. This typically does not hinder communication. By age 11 to 12, children should have nearly completed mastery of all speeches sounds. Now what is abnormal in articulation is the acquisition is either delayed or atypical for sounds, resulting in issues such as misarticulation, like omissions, distortions, substitutions of sound, inconsistency in sound production. So this diagnosis should be considered only when the severity of articulation disorder exceeds normal variation for the child's mental age. The child's mental age should be considered for diagnosis. Non-verbal intelligence is within the typical range. So non-verbal intelligence like gestures, smiling and other uh, bodily uh, cues are within typical range or within normal range. Expressive and receptive language skills are also normal. So specifically articulation problem is there. And it is not linked to any sensory, structural or neurological problems. So there should not be any physical problem or neurological problem or structural problem of development. The mispronunciations are clearly unusual within the context of child's cultural language use. The cultural language use should also be kept in the mind. Here are the examples of these problems. Like for substitution, the word is pronounced for red. Distortions, changing a sound which might seem like a lisp when S sounds like tha. So for sounds, example for sounds, it may be pronounced as thouns. Deletion, leaving certain sounds of their speech altogether. For example, never using SC in school and scratch. Addition, adding sounds or syllables to words that do not belong there. For example, to play instead of play. So UH is added to the word play. Now come to the expressive language disorder. This is a developmental disorder where a child's ability to speak expressively is significantly lower than what is expected for their mental age, while their understanding of language remains normal. So the child is not able to express his thoughts, but his understanding of language remains normal. Means if someone is speaking to him or her, they will able to understand that, but they are not able to express. This can be indicated by the absence of single word by the age of 2 years and the failure to generate simple 2 words phrases by 3 years should be taken as significant signs of delay. Difficulty include in diagnosis of this expressive language disorders are uh, the difficulty the children face because of this expressive language disorder are they have restricted vocabulary development. So vocabulary of these childs are very less. They will overuse the small set of general words. So vocabulary is less, then they will use lesser amount of words. Difficulties in selecting appropriate words, word substitutions, short utterance length. The length of sentence will be short and not descriptive in details. They will have immature sentence structure, syntactical errors, especially omission of words ending or prefixes, misuse of or failure to use grammatical features such as prepositions, pronouns, articles and verb in their language. Noun inflections may be there. For example, the base word is fox, which is inflected as plural foxes. The run will be inflected as present participle as running. So what is syntax? Syntax in English is the arrangement of words and phrases in a specific order. If you will arrange the words in a specific order, then only the sentence makes a sense. The additional points are the diagnosis should only be considered when impairment is significantly beyond for their mental age. So mental age should be considered, while their receptive language skills remain mostly within normal limits. Non-verbal communication methods like smiles and gestures should generally be functioning well. The child will still try to communicate despite their language challenges, often using demonstrations, gestures, miming or non-verbal sounds to express themselves. So they are not able to express by means of language. Challenges faced by these children are difficulties in peer relationships, making good friendships, emotional issues, behavioral problems, hyperactivity and inattention are often seen, especially in school age. They have limited participations in conversations, or a lack of stimulating environment can significantly contribute in developing expressive language skills. So if the environment is less stimulating, if the activities are less, for example, in nuclear families, if both the parents are working and a child may remain at home alone or in with the maid or in the crutches, so there the interaction between the two people or more people are less with these children can lead to expressive language disorder. Now, receptive language disorder. This is a developmental disorder where a child's language comprehension is lower than what is expected for their mental age. Now, they do not understand, they do not receive what is spoken to them. This is indicated by not responding to familiar names by first birthday, by 1 year of age, not being able to recognize a few common objects by 18 months of age, not following simple instructions by age 2. So challenges they face in future involving struggling with grammatical structures such as negatives, questions and comparatives, as well as not grasping more subtle elements of language like tone of voice and gesture. So if one speaks, they have certain tone and gesture associated with that. They are not able to understand the tone, whether the tone is lovable, threatening or otherwise. This is outside the normal range of variation of child's mental age. The requirement for a pervasive developmental disorder are not fulfilled. So this is also a feature of pervasive developmental disorder. Pervasive developmental disorder consists of autism, Rett, Asperger syndrome, etc. But not fulfilling the criteria for those disorders. In almost all cases, the development of expressive language is also severely delayed. They have a problem in reception, can have problem in expression also. Socio-emotional and behavioral issues include hyperactivity, inattention, social awkwardness, isolation from peers, anxiety, sensitivity, and excessive shyness. When severe receptive language impairment is present, they may experience delays in social development. Social development means reciprocal relationship in the society. Repeat language they do not comprehend, they used to repeat the language, exhibit limited interest in subjects. They typically differ from autistic disorder, in which they will demonstrate a normal social reciprocal interaction which is not present in autistic child. They engage in imaginative play. This is about the child who is having receptive language disorder. They engage in imaginative play. What is imaginative play? A child imagines a companion which is not present there, and the child used to talk with them and might be playing with a toy, and as if he is having another child along with him or her, but actually this is not there. So this is called as imaginative play. Seeking comfort from parents is present in receptive language disorder. Using gestures appropriately, which is not in the autism. Having only slight difficulties with non-verbal communication, which is more pronounced in autism. Now moving to acquired aphasia with epilepsy, a condition where a child who had been developing language skills normally suddenly loses both their ability to understand and express language while still maintaining overall intelligence. Abnormality in EEG readings are present, usually present in bitemporal areas. The onset between age 3 and 7, but it can occur earlier or later too. In about 25% of cases, language loss happens gradually over several months, but more frequently, it occurs suddenly within days or weeks. In this syndrome, difficulties in understanding spoken language often emerge as first sign of condition. Some children may mute, while others may only produce sounds resembling jargon. In few examples, they lose normal variations in tone. Behavioral and emotional issues are frequent. The exact cause remain unknown for the syndrome, but clinical signs suggest a possible inflammatory brain process. So what is the prognosis for this syndrome is? The progression of disorder varies significantly. Approximately 2/3 are left with varying degrees of receptive language difficulties, while about 1/3 of these children fully recover. Now moving to specific developmental disorder of scholastic skill. Scholastic skills means the skills which are required in schools. Further classified as specific reading disorder, specific spelling disorder, disorder of arithmetic skills. So the common point for these subclassifications are these issues are not just the result of limiting learning opportunities. If someone does not get learning opportunities, they should not be diagnosed as having disorder of scholastic skills, and also not caused by brain injuries or illnesses. These disorders are believed to arise from irregularities in cognitive processing, primarily linked to some form of biological dysfunctions. So biological dysfunctions are there but are not exactly known. So there is problem in cognitive processing. The cognitive processing for psychology, you will have a lecture tomorrow. How a person perceives and what are cognitive process. This is more common in boys than girls. Again, to diagnose the scholastic difficulties, there are five types of challenges. The first challenge is it is essential to distinguish between disorder and normal differences in academic performance. We must consider the developmental timelines for two main reasons. For example, for severity, if a person is having language, the scholastic skill problems at the age of 7 has a different impact than the same delay at age 14. The delay is there, the child has come to assessment at the age of 7 and at the age of 14. The problem of these scholastic skill will be presented differently for both the cases. The changing pattern. The language delay in early childhood may improve in spoken language but can lead to specific reading difficulties later. So pattern may change. The difficulty in reading maybe later may be present, but other problems are resolved. The third one is the teaching and learning scholastic skills are not solely based on biological growth. It also depends on the family situation, the education and personal traits, what kind of environment the child is having. Fourth one is it is important to distinguish between factors that lead to reading difficulties and those linked to poor reading skills that are not due to cognitive issues. Cognitive issues like neurological problems, cerebral palsy and others. And the fifth problem is how to categorize them. There is a debate and about the diagnostic category, to develop diagnostic category to diagnose specific developmental disorder related to scholastic skills. Similarly, the impairment are not directly caused by other disorders like intellectual disabilities known as mental retardation and significant neurological issues, unaddressed vision or hearing problems or emotional challenges. These should be ruled out to diagnose. The cause of these disorders are unclear, but is believed that biological factors play a key role, interacting with non-biological factors such as learning opportunities and teaching quality. Children may experience a decline in academic performance later in their education due to factors like disinterest. In later period of their life, they may develop disinterest in studies, and this may be because of ineffective teaching also, emotional issues they are facing, or changes in workload. However, these issues are not included in the definition of diagnosis of these disorders. So diagnostic guidelines are, first there should be a significant level of difficulty in specific academic skill. The difficulty must be specific, is not generalized. The difficulty must be developmental, means it should have been evident during the early school years and not something that developed later. Fourth one is there should be no outside factors, for example neurological problems, biological problems, or social problems. The specific learning disorder should not be directly caused by unaddressed vision or hearing problems. Now come to the subclassification, specific reading disorder. This disorder is characterized by specific difficulty in developing reading skills. Children with specific reading disorder frequently have a history of specific developmental disorder of speech and language. If the child is having problem of speech and language, that can be reflected in the reading disorder also. Along with academic struggles, issues like low school attendance and difficulties in social adjustment are common challenges. The diagnostic guidelines are, there may be error in oral reading skills such as shown by omission, substitution, distortion, or addition of words or parts of the words. Now these difficulty in the reading, which we have learned in the language before, now this is found in the reading part of the child. Slow reading rate, false start of the paragraph, long hesitations in starting reading, or loss of place in the text and inaccurate phrasing. Reversal of words in sentences or of the letters within words while the child is reading a book, paragraph, or some written material. There may also be deficits in reading comprehension as shown by, for example, an inability to recall facts read. The child has read the paragraph, but he is unable to recall the facts what was there in that paragraph. Inability to draw conclusion or inferences from material read. You know, they may read, but they may not able to conclude what is there in the written material. Use of general knowledge as a background information rather than of information from a particular story to answer question about a story read. The child has read a story, but he used his general knowledge to answer the questions pertaining to that story. Emotional and behavioral issues are often seen in school-age children. Emotional problems tend to arise more in early school years. Conduct disorder and hyperactivity are more prevalent in later childhood and adolescence. Many children experience low self-esteem and difficulties with school adjustment and peer relationships. Specific spelling disorders. The child's spelling ability should be considerably lower than what is expected for their mental age, overall intelligence, and school level. This is best evaluated through standardized spelling test given individually, known as Spell2 or test of written spelling 5. The child's reading skill should fall within the normal range. The child is able to read, but there are specific spelling disorder in writing. The spelling difficulty should not primarily due to poor teaching or be directly linked to major issues like with the vision, hearing, or neurological function. Nor should they have developed due to any neurological, psychiatric, or other conditions. So other conditions which may mimic specific spelling disorder should be ruled out. Specific disorder for arithmetic skills. This condition is characterized by particular difficulty in arithmetic skills. Arithmetic skills are skills in mathematics. The issues lies in the understanding of fundamental operations only, such as addition, subtraction, multiplication, and division. It is not related to mathematical concepts like algebra, trigonometry, geometry, and calculus. This is for simple arithmetic skills. The skill should be significantly below the level expected on the basis of age of the child, his or her general intelligence, and school placement, and is best assessed by means of an individually administered standardized test. Reading and spelling skills should be within the normal range expected for the child's mental age. So what kind of finding you will find in specific disorder of arithmetic skills are: the child will fail to understand the concepts underlying particular arithmetic operations like addition, subtraction, division, and multiplication. Lack of understanding of mathematical terms or signs. Failure to recognize numerical symbols. Difficulty in carrying out standard arithmetic manipulations. Difficulty in understanding which number are relevant to the arithmetical problem being considered. Difficulty in properly aligning numbers or in inserting decimal points or symbol during calculations. Poor spatial organization of arithmetical calculations and inability to learn multiplication tables satisfactorily. Now, specific developmental disorder of motor functions. The child's motor coordination, whether for fine or gross motor skill, should be noticeably lower than what is typical for their mental age and overall intelligence. So you are seeing that mental age and overall intelligence is the important aspect to diagnose these disorders. Developmental motor milestones might be reached later than usual. They may appear uncoordinated while walking and may take longer to learn how to run, hop, and navigate stairs. Learning tasks like tying shoelaces, fastening and unfastening buttons, and throwing or catching balls may be difficult. The child may show general clumsiness in both fine and gross motor skills, often dropping items, tripping, bumping into things like table and furniture, and having messy handwriting. Their drawing abilities are typically weak. They may struggle with jigsaw puzzles, construction toys, model buildings, ball games, and interpreting maps. And you can see that these requires a good motor coordinations. Significant neurodevelopmental delays are present, including coriform movements, mirror movements, and other. These are known as soft neurological signs. Tendon reflexes may be either heightened or diminished on both sides, but will not show any asymmetry. There is no identifiable neurological conditions like cerebral palsy and muscular dystrophy. Despite the signs and symptoms are seen as pertaining to some kind of neurological condition, but on imaging and other tests, these disorders are not identifiable. Complications during perinatal periods such as extremely low birth or significant prematurity may be found in the history. Now come to the pervasive developmental disorder. Pervasive developmental disorder consists of autism, Rett syndrome, Asperger syndrome, and other syndromes also, which I have not included, but these disorders are important to know. Starting with autism. Autism spectrum disorder is a developmental condition that affects how individuals understand and interact with each other, which can lead to impairment in social communication and interaction. What happens in autism? There is a qualitative impairment of these interactions, but what happens in others are there is a quantitative impairment. Like in mental retardation, the quantity of interaction is reduced, While in this developmental disorder, known as pervasive developmental disorder, qualitative impairment is there. The quality of interaction is impaired. How the child is interacting with others. So it starts in early childhood and can lead to difficulties in social interaction, education, and employment later on. Many children display signs of autism within the first year of their life. A few children may seem to develop typically during this time, but experience a regression between 18 to 24 months. This is also seen. So how this social communication and interaction are qualitatively impaired. The example and signs are not responding to their name or seeming to not hear at times, resisting physical affection and preferring solitary play. What happens in a normal child? They usually enjoy the physical affection of others, but these are not fond of these physical affection, and they prefer play in solitary situation. Having limited eye contact, they won't make eye to eye contact while interacting with the other person. For example, if you interact with a child and the child will look into your eyes and may laugh or giggles, this is not present with the child having autism. They show little facial expressions. They have delayed speech or losing ability to use words or sentence previously known. They struggle to initiate or maintain conversations, often speaking only to make requests or label objects, using an unusual tone or rhythm in speech, which may include a sing-song quality or robotic speech, repeated words or phrases without understanding their context. They can repeat the words what they have heard from the person around him, but they do not understand the meaning or context of those words or phrases. Having difficulty comprehending simple questions or instructions. They do not express emotions or recognizing the feeling of others. They seem to be cold emotionally, failing to point out or share objects of interest, approaching social situations inappropriately, like passively, aggressively, or they may become disruptive in their behavior. Struggling to interpret non-verbal signals such as facial expression, body language, and vocal tones of others. In behavioral pattern, they will engage in repetitive actions like rocking to and fro, spinning movements, and flapping hands, participating in self-harming behavior such as biting themselves or banging their head, establishing strict routines or rituals. They follow a strict routine. For example, if one is going to school with a specific route, and if for a reason somehow their route is changed because of some reason, they will become upset even with the minor changes. They will experience coordination issues or displaying unusual movement patterns such as clumsiness or walking on tiptoes. They will walk on the toes, not with the flat foot, along with stiff or exaggerated body language. They seems to be stiff. They show a strong interest in specific details of object, like spinning wheels of a toy car without grasping the overall purpose of that car. So uh, they will limit their attention to a specific part of a whole object. Being highly sensitive to light, sound, and touch while showing little reaction to pain and temperature. Not participating in pretend or imitative play. Focusing intensely on a particular object or activity. Having specific food preferences, such as only eating a limited variety of foods or avoiding those with certain textures. Now Rett syndrome, again the cause is unknown, and this is primarily observed only in girls. Initially, children may appear to develop normally, often followed by a partial or complete loss of hand skills and speech, along with slowed head growth, typically starting between 7 and 24 months of age. So the development at the age of 7 to 24 months, usually normal, then the child regresses. Their head skills and speech regresses and head growth becomes slowed. The key features include hand wringing movements, hyperventilation, and a decline in purposeful hand use. Social and play development halts within the first few years, although interest in social interaction usually remains normal. They will also have truncal ataxia and apraxia, often accompanied by scoliosis and kyphoscoliosis, and sometimes chorioathetoid movements. Severe intellectual disability is common, and seizures often are arising during early and middle childhood. Have you learnt about the Rett syndrome in your syllabus? The syllabus of BPT. Rett syndrome. No? Now, Asperger syndrome, a condition with unclear classification. This disorder features similar qualitative issues in social interaction as seen in autism. But the difference is the absence of significant delays in language or cognitive development. Language and cognitive development are intact, but they have qualitative issues in interacting with other peoples around him. Most individuals have average intelligence, although many may exhibit noticeable clumsiness. This is commoner in boys. The ratio is 8 is to 1. The symptoms often continue into teenage years and adulthood. You must have seen the movie Lal Singh Chadda. Have you seen? No. That character resembles the Asperger syndrome. He had difficulty in social interactions, but language and cognitive development was intact. And he also had average intelligence. And so for conclusion, we have learnt about the disorder of psychological development in infancy, childhood and adolescence. This has main four classifications which pertains to speech and language, scholastic skills, motor functions and pervasive developmental disorder. In speech and language, we learnt about the specific speech articulation disorder, expressive language disorder, receptive language disorder, acquired aphasia with epilepsy, specific reading disorder, spelling disorder, arithmetic skills. Mixed disorder of scholastic skill means if components of reading, spelling and arithmetic skills are found together, then can be diagnosed as mixed disorder of scholastic skills. In pervasive developmental disorder, we learnt about the autism, Rett syndrome and Asperger syndrome. Thank you. So, good afternoon to all. So this is the part 2 of disorders of infancy, childhood and adolescence. In the first part, we had learnt about the disorders of psychological development. And in today's lecture, we will going to learn about behavioral and emotional disorder with onset usually occurring in childhood and adolescence. So in this part, we have some sorts of disorder. For example, hyperkinetic disorder, conduct disorder, emotional disorder with onset specific to childhood like separation anxiety, phobic anxiety, social anxiety, and siblings rivalry. Disorder of social functioning with onset specific to childhood and adolescence like elective mutism, reactive attachment disorder, disinhibited attachment disorder, tic disorder, and other behavioral and emotional disorder like non-organic neurosis, non-organic encopresis, stuttering, and cluttering. We will go through one by one, first starting with hyperkinetic disorder. is also known as attention deficit hyperactivity disorder, in short ADHD. So there are three types of ADHD. First is predominantly inattentive type, predominantly hyperactive type, and third one is combined type. So inattention, hyperactivity, and impulse has some sort of behavioral projection presentation, which are as follows. In inattention, the child fails to pay close attention to details or make careless mistakes in schoolwork. The examples are missing details such as dates, instruction while writing, not reading the question correctly and answering the question before completely reading the question, spelling or grammatical errors, missing words and spelling errors in writings. These are because of inattention. These are not because of specific uh, disorder of language or writings. They have trouble staying focused on task or play, seem not to listen even when spoken to directly. They will see here and there while you are directly interacting with them. They have a hard time following through on instructions and not finish schoolworks and chores. So there is a problem in following through on instructions what have been given to the child by either parents or teachers. Have trouble organizing tasks and activities. Their tasks will be disorganized. They stay away from or not like tasks that need focused mental effort, such as homework, usually the study material. Lose items needed for tasks or activities. For example, if some sort of toys are needed to play a game, they will miss. And school assignments, pencils, erasers, uh, they will lose items which are needed for certain type of activity. They are easily distracted by other things, thoughts or activities rather than finishing a task. For example, a child is doing his or her homework and some sort of distraction or sound is there, which is not ample enough to distract normally. They will get distracted by those subtle stimulus. They forget to do some daily activities, such as forgetting to do chores, household chores, or school activities. The second set of symptoms are hyperactivity, and impulsivity. So this will be seen in the behavior of the child, like they will fidget or tap hands or feet on the furniture or squirm in the seat. Squirm means seat में बैठे बैठे हिलते रहना. Have a hard time staying seated in the classroom or in other situations. This may be complaint of class teacher also. The child do not sit quietly in the classroom. Be on the go in constant motion. Be on the go means they will constantly keeping themselves moving in the environment. They run around and climb in the situation where it is not proper. For example, in classroom or in the relative's house which they have been visiting. Have trouble playing or doing an activity quietly. They will make lots of noise and cannot play or do activity silently. They will talk too much, blurts out answer. Blurts out answer means before listening to the whole scenario, they will give the answer while the question is not complete. Interrupting the questioner. Have trouble waiting for a turn. They will not wait for their turn. For example, they will not wait what is being brought by the uh, father, and they will not. They cannot keep their turn among their siblings. And similarly, in school, they may break the line. They interrupt others' conversation, games, or activities. When two adult person are talking, they will interrupt between them, or some game activities going on. They will interrupt into that game. So what is the difference between typical development and child having ADHD? So it is common for healthy children to exhibit behavior such as inattention, which is a common trait or behavior, and hyperactivity and impulsivity is also a normal finding because young children are inherently energetic and may continue to display high energy levels long after their parents have become fatigued. Children who experience academic challenges but maintain positive relationship at home or with peers may be facing issues unrelated to ADHD. So what requires to diagnose a ADHD is that symptoms should be severe, out of context of mental age, out of context of a single situation. This will happen almost in all of the situations like home, whether it is relative's house or school. Now moving on to conduct disorder. Conduct disorders have two parts, conduct disorder and oppositional defiant disorder. In conduct disorder, what happens is this disorder manifests before the age of 10 and frequently between the age of 10 and 19 years. It is prevalent in male. There are four primary behaviors associated with conduct disorder. The first is aggression towards individual and animals, as well as the infringement of others' fundamental rights, property destruction, deception, including lying and theft, significant breaches of established rules. So indicator of aggressive behaviors may be bullying other children, showing physical aggression towards other and potentially involving weapons. There will be verbal altercations among the children group, threatening behavior to the others, coercion into sexual activities, and shifting blame onto others' personal actions, inflicting harm on animals. Indicators of property destructions encompasses deliberate starting fires at places they are fond of setting fires, vandalizing or damaging the property of others. Indicators of deception, lying, and theft may include lying to gain favor or evade responsibilities, stealing from individuals or retail establishments, breaking into residence or other business premises. Indicators of rule violations consist of disregarding rules without justification, skipping schools means truancy, running away from home and stay in night at other places, frequently contravening parental rules. Additional sign which may present in conduct disorder may be excessive consumption of alcohol or drugs, engaging in frequent and hazardous sexual activities, exhibiting a low tolerance of frustration, displaying aggressive behavior without attempt to conceal them. They do not regret or feel guilt about their aggressive behavior. Lacking remorse of their action, lacking guilt feeling. Experiencing difficulties in forming and sustaining relationships and friendships. These symptoms of conduct disorder in an adult may be diagnosed as antisocial personality disorder, which you may have learned in personality disorders. So you may have found that these behavior are found normally in the child and adolescence group, but there is a set of criteria for diagnosing conduct disorder. Means presence of any one of the symptom is not leading to diagnosis of conduct disorder or any of the psychiatric disorder. So set of symptoms and constellation of symptoms must be present there to be diagnosed. Now oppositional defiant disorder known as ODD. It has main three areas. The first one is anger and irritability. They are argumentative and having defined behavior. They have vindictive nature of their behavior. What is vindictiveness? Vindictiveness is to take revenge. Additionally, many children diagnosed with ODD exhibit moodiness, mood swings, a tendency to become easily frustrated, and having low self-esteem. There is also a possibility of substance misuse, including drug and/or alcohol. What is there in anger and irritability is having a low tolerance for frustration and lose their temper quickly. Experience frequent episodes of anger and resentment. Be overly sensitive and easily irritated by others. Display consistent anger and disrespectful behavior towards others. The basic theme is defiance. In argumentative behavior, they engage in excessive arguments with authority figures like class teachers and elders. Actively resist following rules and requests. Shift blame onto others for their own errors. Having blaming tendencies. Intentionally provoke or upset those around them. So they intentionally poke others to upset them. They exhibit spiteful behavior and desire for revenge, making hurtful and malicious comments when feeling angry or upset. Now moving on to anxiety disorders of childhood period. First one is separation anxiety disorder of childhood. So young children frequently exhibit signs of anxiety or distress when parting from their parents or primary caregivers. This is a normal behavior. But this phase begins to diminish around the age of 2 to 3 years and object permanence start establishing at this age. There are intense and recurrent anxiety when contemplating separation, when distance from home or loved one is observed. Intense fear of losing a parent due to illness, death, disaster, or potential harm. There will be an ongoing apprehension about adverse events such as the possibility of being lost or kidnapped, which could lead to separation. A reluctance or outright refusal to be away from home due to the fear of separation. May also express discomfort with being alone, particularly if they have reached an age where being alone is generally expected. Refusal to sleep away from home or to fall asleep without presence of a parent. They have recurring nightmares related to separation and frequent complaints about physical symptoms to gain attention, not to be separated from their parents or primary caregivers. Now, phobic anxiety disorder of childhood. So children, like adults, can develop fear that is focused on a wide range of objects and situations. Some of these fears or phobias, for example, agoraphobia, are not normal part of development, so it should be coded in the separate category for that is for uh, agoraphobia with or without panic attacks. In these children, some fear shows a marked developmental phase specificity and arise in a majority of children. This would be true, for example, for fear of animals in the preschool period is a normal behavior. To diagnose phobic anxiety disorder, the diagnostic guidelines are the criteria A is the onset is during the developmentally appropriate age period. For example, some sort of fear is expected at 2 to 3 years age and which persists at the age of 6 and 7 years, then it should be considered in the diagnosis. The degree of anxiety is clinically abnormal. The anxiety does not form part of more generalized disorder and should be diagnosed as generalized anxiety disorder or GAD. Social anxiety disorder of childhood. So children diagnosed with this disorder exhibiting continuous and recurring fear and or avoidance of unfamiliar individuals. So they have social anxiety for strange persons. This fear may predominantly manifest in interactions with adult peers or both. It is linked to a typical level of selective attachment to parents or other familiar figures. So they are attached to parents or other closed one, but not to the distant person or strangers. So significant challenges in social functioning are expected in social anxiety disorder of childhood. This social anxiety have different behavior at different developmental ages. For example, in preschool children, they may have fear of new things. They may show irritability, crying or whining, freezing or clinging to the parents, refusing to speak. In school age children, the symptom may be there may be fear of reading aloud or answering questions in class, talking to other kids, being in front of the class is avoided, speaking to adults are feared of. They may have fear of musical or athletic performance activities. They may have fear of ordering food in a restaurant, fear of attending birthday parties, fear of having friends visit. They may worry about being judged by others for their behavior. They may have refusal to participate in activities or school. What happens next in teenage? In teenage, they may be quiet, keeps to him or herself. They may become more withdrawn if encouraged to talk. They are hesitant and is passive, is overly concerned about negative evaluations, fear being embarrassed or humiliated. They may found to be having crossed their arms, keep their head down, displays few facial expressions, have nervous habits such as hair curling or fidgeting. They may have poor scholastic performance also. They may potentially does poorly in school activities, studies, doesn't raise his or her hands in class, avoids classmate outside the class, fears performing in front of others like public speaking, fear speaking up in class, is uncomfortable in the spotlight. Do you know about the spotlight? The light which is projected on someone on a stage. They may sit alone in the library or cafeteria. They may afraid to ask the teacher for help. They may be afraid to walk into class late. They may refuse to go to school or they may totally drop out from the school. Behavior with peers means colleagues, friends, or classmates. They may become uncomfortable in group settings. They may have few friends. They may afraid to start or participate in conversations. They may afraid to ask others to get together. They may afraid to call others. They avoid eye contact. They speak softly and mumbles. Appears to always be on the fringes. Reveal little about himself or herself when talking to others. So they have such an intense kind of anxiety for social situations. Now coming to the siblings rivalry disorder. This refers to a persistent discord that occurs among children who are brought up within the same household. Manifestation of sibling rivalry may include verbal and physical altercation with each other, insults and name calling of each other's, reporting each other's misdeeds and petty disputes, ongoing competition for parental attention, expressions of jealousy. You can say this is a kind of discord among the siblings. There are postulated causes of sibling rivalries like significant life transitions, for example, relocating to a new residence, anticipating the arrival of new child, going through a divorce of parents. The developmental phase can have children are under the age of 4 or when there is significant age difference between them can exacerbate sibling rivalry. So age gap should be uh, more. The more the age gap, the more the development of rivalry is there. Feeling of jealousy, for example, desire of individuality, insufficient conflict resolution skills, and impaired family dynamics may also contribute to siblings rivalry. Parental action that may intensify the rivalry includes frequently commend one child while disparaging another, encouraging competition between children, designate specific roles within the family. For example, Julia excels in math while Benjamin is a creative one. Show a marked preference for one child's need and interest over the others. Now moving to disorder having onset specific to childhood and adolescence. The elective mutation. This is marked by a selective way of speaking that is influenced by emotions. The child may show their language skill in certain situations but remain silent in others that can be clearly identified. The disorder usually appear in early childhood and affect boys and girls equally. It is linked to significant personality traits such as social anxiety, withdrawal, sensitivity, and resistance. Generally, what happens is the child will talk at home or with close friends but may not speak at school or around unfamiliar people, although other speaking patterns can also happen. So, elective mutism means in a selective situation, the children do not speak at all. Tic disorder. You can recognize by the picture what are the tics. So tics are involuntary repeated muscle movements that can happen anywhere in the body. There are different types of tic disorder, including motor tics, vocal tics, and Tourette syndrome. Movements of the limbs and other body parts are known as motor tics. These movements are involuntary repeated movements, and the tics can be of vocal type also. For example, the grunting, sniffing, or throat clearing are common vocal tics. The tics can be categorized into motor tics or vocal tics and further classified into simple tics and complex tics. In simple tics, engage only in few muscle groups, example nose, darting the eyes or clearing the throat. In complex tics involve multiple muscle groups, for example, hopping or stepping in a particular manner, making gestures or repeating words or phrases. The other disorders are neuresis, encopresis, stuttering, and cluttering. Non-organic neuresis. This is the condition marked by the involuntary release of urine occurring during the day and or night that is inappropriate for the person's mental age. It is not caused by the lack of bladder control or due to the neurological issues, seizures, or any other physical abnormalities in the urinary system. This may be present from birth or may be acquired and may develop after a time of acquiring the toilet training. Emotional issues can develop as a result of distress or stigma associated with the condition. This is typically not diagnosed in children younger than 5 years or in those with the mental age below 4 years. So this is diagnosable after the age of 5 years when the bladder control is expected normal. Similarly, encopresis, repeated act of passing stools, whether voluntary or involuntary. in unsuitable locations within a person's cultural context typically involves feces that are normal or nearly normal in consistency. So there is no signs of gut problem. The situation can indicate in an unusual persistent of typical infantile incontinence or a loss of bowel control after it has been learned. The issue can exist on its own and be associated with broader conditions, particularly emotional disorders. So emotional disorders are common in neurosis and endocrinosis. Stuttering is speech that involves frequent repetition or elongation of sounds, syllables, or words, along with regular hesitations and pauses. So hesitation and pauses are the central theme for this stuttering. In cluttering, what happens is there is no repetition or hesitations, but there are quick, abrupt bursts. So the speech seems to be cluttered. So we have learned about the hyperkinetic disorder, conduct disorder, anxiety and phobic disorder, sibling rivalries, elective mutism, tic disorder, non-organic neurosis, encopresis, stuttering, and cluttering. So these are the disorders of childhood and adolescence, with onset usually occurring in their childhood period and adolescenthood. Thank you.
Good afternoon to all. I am Dr. Snehangi, Junior Resident in Psychiatric Department. Today we'll be discussing about geriatric psychiatry, which is one of the very important topic in psychiatry. So first we'll discuss about the normal aging. So what is aging? Aging is a progressive deterioration of physiological function and intrinsic age-related process of loss of viability and increase in vulnerability. So aging is a normal process. No one can stop aging. It is going to happen to everyone. And aging itself does not mean that you are going to have any physical or mental illness. It is just that there is a loss of viability and there is increase in vulnerability. Normal state in the age is physical and mental health, not illness and debilitating. Old age or late adulthood begins at the age of 65. The aging process is characterized by gradual decline in functioning of body systems, especially CVS, cardiac, respiratory, central nervous system, gastrointestinal tract, genitourinary tract, endocrine, immune system. The dimension of healthy aging is acquired when there is a social activity, increased social activity, a good diet, no, good genes, productive pursuit, and healthy and exercise. This together contribute to an healthy aging. Indicators of healthy aging: no physical disability over the age of 75 as rated by the physician, or there is a good subjective health assessment, length of undisabled life, good mental health, objective social support, and self-rated life satisfaction in different domains. It may be in marriage, with children, with friends, social contacts, hobbies, sports, even income-related work. Concern or life events of elderly which cause distress to the elderly. One of the most common factor being retirement, then comes economic insecurity, decreasing health, dependency on others, chronic illness, lack of caregiver, decreased lower self-esteem, which result in decreased lower self-esteem, loss of control, abuse or neglect, isolation, loss of loneliness, many medication, boredom. Aging and diseases. So, with aging, there can be diseases related to the physical health, which includes cataract, osteoporosis, Alzheimer, nerve deafness, glaucoma, bronchitis, rheumatitis, dental problem, and many more problems. In mental health, the major health problem with older adults may be organic disorder, late life functional disease like mood disorder, neurotic, stress related, and somatoform disorder, schizophrenia, schizotypal delusional disorder. These are rare. Mostly it is neurotic stress related or mood disorder. Psychoactive substance use disorder can be present. Suicidal behavior in elderly is common, and this all also loneliness in them. So, what are the things that the elderly fears the most? Uh, it, most feared things are pain, disability, abandonment, dependency. Abandonment is one of the biggest fear that their loved one will not give them as much time as they did before, or they'll leave them because they have aged. Because of the aging and disability, their dependency increase, which somehow lead to decreased self-esteem of the elderly. So mainly today's focus will be on 3Ds, which are the most common disorder in psychiatry in elderly, that is depression, delirium, dementia. This is a short overview of the three diseases in which there is given the onset, duration, course, consciousness, attention and memory, and affect. In delirium, the onset is acute, duration comes to days to week, course is fluctuating, consciousness is impaired or fluctuating, attention and memory has poor memory and inattention, affect is variable. Dementia, it is a slow progressive course. Its onset is insidious, duration from months to year, consciousness is clear till the late in the course of illness. Poor memory without mark in attention, effect is variable. Depression onset is variable, duration is variable. Course in adult, diurnal variation is common, that is worsen in the morning and improves during night, during the passing of the day. Consciousness is unimpaired, attention and memory difficulty, concentrating, memory intact, minimally impaired. Affect is depressed. Other psychiatric disorder in old age can be psychosis, anxiety, phobia, alcohol use, high risk of suicide. Risk factor which include in the psychiatric diseases loss of social role, as the progressive age slowly they don't have any much responsibility in house or their work, loss of autonomy, death of loved ones. As the age increases, the death of the nearby also increase, declining health, increased isolation, financial constraint, decreased cognitive functioning. So coming to depression, there can be a late onset depression which starts after the age of 50, post-stroke depression, psychotic depression and vascular depression. We'll be discussing about all of them in the following slides. The symptomatology or phenomenology that is seen in elderly people in depression. Depression without sadness, as it is said, because they try to hide it with a smile. They hide their suffering. Lack of feeling or emotion, prominent cognitive complaints, prominent somatic complaints, preoccupation with bowel function, which is very common complaint from elderly, unexplained health worries, unknown fear, heightened pain experience or complaint. They become hypersensitivity to pain, multiple physician and hospital visit without resolution of problem, irritability, problem in initiativeness, self-care, household maintenance, transportation and communication. Social withdrawal can be seen, avoidance of social interaction, prominent loss of interest in pleasurable activity, sign of functional impairment or otherwise unexplained functional decline. Epidemiology, classical major depression has a less frequency in older adult, prevalence of 1%, but 15 to 25% experience depressive symptoms that do not meet criteria for a specific depressive syndrome but cause distress and significant dysfunctioning. Theories behind low prevalence of major depression in elderly is resilience, their capacity to adjust and recover from the stressful without loss of equipment. Flaws in diagnostic approach and interview technique. Risk factor of having a depressive disorder in elderly is medical illness like Parkinsonism, stroke, Alzheimer, hypothyroidism, malignancy, or there is a past history, there is a social lack of social support, a spouse death, separation, death of loved ones, bereavement, or there is a history of staying in nursing home, cognitive decline, pain problem, undernutrition. Coming to the suicide, the rates are high. The risk factor of having a suicidal tendency in elderly is if there is a first episode of major depression which was not diagnosed or untreated, psychotic depression, alcohol use, recent loss or bereavement, loss of spouse, abuse of sedatives and hypnotics. Major depression in elderly, same criteria as for the young population. Disturbance in sleep, appetite for sexual functioning are not always reliable indicator in case of elderly major depression. Use of HAM-D, MMSC and GDS are useful in elderly in primary care setting for screening. Symptom favoring major depression, guilt about things other than action taken or not taken by the survivor around the time of death, thought of death other than the survivor, feeling that he or she would be better off dead or should have died with the deceased person, morbid preoccupation with worthlessness. Marked psychomotor retardation, prolonged and marked functional impairment, hallucinatory experience other than thinking that he or she hears the voices or footsteps or transient sees the image or deceased person. Age of onset, early versus late. Early onset depression, there is a strong genetic family history, high rate of personality disorder, less cognitive or neurological issues, generally seek treatment for depression, greater drug or alcohol use, express depressive symptoms, at risk for suicide. In late onset depression, structural changes in brain is one of the cause, high rate of vascular risk factor, more cognitive and neurological issues, do not realize they are depressed, greater comorbid physical illness, express somatic then depressive symptom, high rate risk of suicide. Early onset depression occurs in childhood, adolescence, and early adulthood. Late onset is with first onset in the second half of life at the age after 50. Early onset depression has more first degree relative and depression. Late onset depression have more chronic physical illness, less complete response to treatment or chronic course, poorer prognosis, increased mortality, and frontal and temporal atrophy on scans. Depression with reversible dementia. Depression in elderly is associated with cognitive impairment. Pseudodementia depression or depression with reversible dementia is now considered obsolete. Brain dysfunction is unmasked by depression or it is just beginning of the dementing process. Vascular dementia followed by depression, cerebrovascular disease both cortical and subcortical, frontal striatal disconnection, executive dysfunction, reduced interest in activity, psychomotor retardation, cognitive impairment and impaired sight, impaired in the instrumental activities of daily living and poor prognosis. Post-stroke depression, depression developing a year or more after a stroke is strongly influenced by impairment in social and physical functioning. Depression after 3 to 4 months period of stroke have more vegetative features and large lesion volume. Depression with psychosis. Delusion in psychotic depression involve guilt, jealousy, paranoia, or somatic symptom. Example, beliefs in suffering a serious or fatal medical illness. Patients frequently complain bitterly of somatic symptom without medical explanation and can express profound nihilistic belief and hopelessness, but hallucinations are relatively infrequent. Some patients are unable to urinate or defecate and require urgent separate intervention for these problems. In depression with psychosis, response not all to placebos, poorly to antidepressant use alone, and more often combination of antidepressant and antipsychotic medication is required. Hospitalization is typically indicated and ECT is the treatment of first choice for agitation, starvation, dehydration, or suicidality threatened survival. Chronic medical illness, increased medical burden, increased depressive symptoms, and long-term depressive symptom increase medical burden and mortality. Depression lowers self-rated health and intensify physical symptoms, including amplifying the perception of pain, and chronic pain worsens depression. Management of treatment for depression. Firstly, in elderly, psychotherapy is first-line treatment for depression. In psychotherapy, there can be cognitive behavioral therapy, problem-solving therapy, interpersonal therapy, as which suits the patient's major problem will choose the therapy likewise. Various obstacles to use psychotherapy in elderly. In pharmacology, SSRI is the drug of choice. Common side effects are GI distress, agitation, akathisia, insomnia, sexual dysfunction, and occasional Parkinson-like motor side effect. Risk of serotonin syndrome. Also risk of hyponatremia, inappropriate ADH, or urinary retention. TCAs are mostly avoided because of its side effect, which is mainly anticholinergic side effect. Non-triptyline and desipramine has less side effect. TCA better for chronic pain management. Venlafaxine, desvenlafaxine, mirtazapine, bupropion, duloxetine, and MAO inhibitor can be used. ECTs was one of the important non-pharmacological treatment for somatic complaints. It is the treatment of choice for certain older patients with severe depression due to poor tolerance of psychotropic medication, psychotic features, significant comorbid condition, or marked disability or urgent risk to life. Course and prognosis. If left untreated, late life major depression tends to remit spontaneously after 12 to 48 months, but patients with first episode depression with onset after age 60 have 70% chances of recurrence within 2 years. Now coming to delirium, as discussed earlier, it is usually acute and fluctuating in course. Altered state of consciousness, reduced awareness of and ability to respond to environment. Cognitive deficiency in attention, concentration, thinking, memory, and goal-directed behavior are almost always present. Incidence of delirium during hospital admission. After hip surgery, rate is 28 to 61%. After any major surgery, 15 to 53%. During hospitalization, 3 to 29% incidence of having delirium. In ICU setup, the chance is up to 70%, roughly 83% patient near death. So the symptoms in delirium: agitation, confusion, sedation, compulsive searching, distraction, hallucination, or combination of all. Features of delirium may be accompanied by inattention, hallucination, illusion, emotional lability, alteration in sleep-wake cycle, evening worsening of symptoms, fluctuation in symptoms, psychomotor slowing or hyperactivity, searching and picking behavior, removing clothes, life supports equipment like IV line, catheter, NG tube, ventilator support. Usually abrupt, and resolution is also rapid when underlying cause is corrected. There are three types of delirium: hyperactive, hypoactive, and mixed. In hyperactive, there is commonly seen hallucination and delusion. Hypoactive, there is decreased psychomotor activity, and in mixed, there is fluctuation between hyperactivity and hypoactivity. Causes of delirium can be infection, withdrawal from any substance, acute metabolic disturbance, trauma, CNS pathology, hypoxia, deficiency in any of the micronutrients, endocrinopathology, acute vascular cause, toxin, drugs, heavy metals. The mortality of delirium, the mortality outcome of delirious patient was 3 times higher than general patient. 25% of delirious post-operative patient had a lethal outcome, control population 13%. What is the burden of the delirium? There is increased mortality, increased nursing care, increased length of stay, increased risk of cognitive decline, increased risk of functional decline. Treatment of delirium is always look for the underlying cause, a close supervision, especially by family, reorient frequently, and adequate lighting. Try not to use restraint as it can worsen confusion. Medication only if behavioral attempts fail. Avoid polypharmacy. Low dose neuroleptic is treatment of choice unless the delirium is due to withdrawal. If due to alcohol withdrawal, use short acting benzodiazepine, which can be lorazepam. The treatment for excessive agitation and delirium is always a low-dose antipsychotic, mainly haloperidol, dosing between 0.25 mg to 1 mg, risperidone, olanzapine, and quetiapine. This all is given in a low dose for delirium. Now coming to dementia. Dementia, there are several types of dementia. One of the most common is Alzheimer's, followed by vascular, then Lewy body, and frontotemporal. So, what can be seen in dementia are change in memory, poor short-term recall, frequent lost items, get lost easily, fails to recognize familiar person, poor attention and concentration, does not appear to listen, get confused in conversation, does poorly in complex situation, changes in language functioning like aphasia, agnosia, dysfluency, change in visual spatial ability, difficulty drawing, difficulty navigating, misperceiving the environment, impaired executive function, perseveration, poor judgment, rigidity in thought, change in emotional functioning, increased anxiety, increased depression or psychosis, fluctuation in mental state, especially disorientation. So what is dementia? Dementia is a syndrome due to disease of brain, usually of a chronic or progressive nature. There is disturbance of multiple higher cortical function, including memory, thinking, orientation, comprehension, calculation, learning capacity, language, and judgment. Dementia produces an appreciable decline in intellectual functioning and usually some interference with personal activity of daily living, such as washing, dressing, eating, personal hygiene, excretory, and toilet activities. Epidemiology: Alzheimer's disease is the most common cause of dementia amongst the people aged 65 and older. Prevalence among people over 60 years is 5 to 8%, starting with 0.5% prevalence at 55 years. It goes on doubling every 5 years. 60 years 1%, 65 years 2%, 70 years 4%, and so on. Risk at the age of 80 years is around 15 to 20%. At present, nearly 35.6 million people worldwide with dementia, expected to double by 2030 and triple by 2050. About 7.7 million new cases of dementia each year. A new case detected in every 4 seconds somewhere in world. So the type of dementia, as discussed earlier also, there is Alzheimer dementia, vascular dementia, Lewy body dementia, Pick's dementia, and other dementia. Risk factor is age 60 to 70 years, more common in female, prior stroke, atherosclerosis, heart disease, high blood pressure, diabetes, poor diet, uh, difficult cholesterol problem, atrial fibrillation, smoking, low education, and family history. Etiological classification of dementia: neurodegenerative diseases, under which comes Alzheimer's disease, Parkinsonism, diffuse Lewy body disease, progressive supranuclear palsy, multisystem atrophy, Huntington disease, frontotemporal dementia. Structural disease of or trauma, the in which there is normal pressure hydrocephalus, neoplasm, dementia pugilistica. Vascular disease like vascular dementia, vasculitis, Heredometabolic disease like Wilson disease or late onset lysosomal storage disease. Demyelinating or demyelinating disease, multiple sclerosis, infectious disease like HIV type 1, tertiary syphilis, Creutzfeldt-Jakob disease, progressive multifocal leukoencephalopathy, Whipple disease, chronic meningitis like cryptococcal meningitis or other bacteria. In nutritional deficiency, there can be vitamin B12 deficiency, folate deficiency, thiamine deficiency. Organic failure like uremic and hepatic encephalopathy. In endocrine disease like diabetes, hypothyroidism, Cushing syndrome also leads to dementia. Now there are two types of dementia, irreversible and reversible. In irreversible, mostly the neurodegenerative classification of dementia comes on. along the irreversible and reversible dementia are the other causes like drug or delirium related dementia, emotional like depression or endocrine disease dementia, metabolic disturbance dementia, iron air impairment dementia, nutritional disorder, tumor toxic trauma to head, infectious disorder, alcohol and arteriosclerosis. These are the causes in which the dementia can be reversible. Other tests of dementia, complete blood count (ESR), serum urea creatinine, thyroid function, serum B12, ECG, chest X-ray, CT scan, lumbar puncture. We have to do all these tests so that we can know the cause of the dementia and can treat it likewise. In the neuroimaging of Alzheimer patient, we can see a diffuse brain atrophy, enlargement of ventricles, widening of sulci or gyrus, atrophy more prominent in hippocampus. There can also be evidence of stroke, uh, uh, atrophy more prominent in the hippocampus. There can also be evidence of stroke, lacunar infarct, and white matter hyperintensity. This complicates the picture. If this kind of finding is present, like stroke or lacunar infarct and white matter hyperintensity, then the picture of the dementia has a complication. So, if we compare the Alzheimer and the vascular dementia, in Alzheimer, it is most common in women, but vascular it is common in men. Generally, over 75 years in Alzheimer disease. In vascular, it is near about 60. Onset is gradual and progressive. In vascular, it is episodic and with stepwise deterioration. History of hypertension is less common in Alzheimer, but very common in vascular dementia. History of stroke, TIA, or other focal neurological symptom is less common in Alzheimer and more common in vascular dementia. Hypertension is less common in Alzheimer, more common in vascular. Focal neurological sign is uncommon in Alzheimer disease, common in vascular. Emotional lability is less common in Alzheimer but more common in vascular dementia. Cognitive deficit is uniform in Alzheimer disease and patchy in vascular dementia. Treatment of dementia is multimodal approach. Pharmacological therapy mainly by central cholinesterase inhibitor like donepezil, rivastigmine, and galantamine. NMDA receptor antagonist like memantine, which is given in moderate to severe dementia. Along with there is treatment also involve diet and nutritional supplement, caregiver support, psychosocial intervention. So this is about the seminar today. Thank you, and these are my references.
Good afternoon to all. So today's lecture of psychiatry is on therapeutics. We will learn what are the modalities available for the management of or treatment of the psychiatric patients. So we will cover